Good morning, Representative Nuccio.
Good morning. How are you?
I'm good. How are you?
I am well. Thank you for asking.
No problem. We're almost there.
Okay.
And I'm really talking about spring.
All right. I can go with that one. If you're talking about spring, let's go there.
Yeah, really.
Because I'm sitting here looking at my calendar going, Diane, it's March. From what I understand, we're going to June.
Is that Senator Looney and ex-Senator Fasano?
Yes, it is. That's us.
So I could recognize you even if you both were robbing banks with your mask.
Yeah, that shows that we the mask wouldn't help us if we went into a bank then, huh?
Yeah, exactly. Just as an advice. Welcome, gentlemen.
Thank you.
So,
Good morning,
gentlemen, I'll take
Representative.
advantage before we go online to ask you, would it be completely inappropriate of me to use this platform to wish my mother a happy birthday for her 90th when we go live?
Absolutely. It's okay. God bless her.
Yep, today.
How beautiful. How beautiful.
And that would be bipartisan, I'm sure.
Yes, it would be. And Mascars, you and I, we usually tag team these things. You go, I go, but I can't do that one with you. You got to do that one on your own.
I'm doing it. Not to
I'll
worry.
I'll come. I also wish her a happy birthday.
Morning, everyone. How are you?
Good morning, Chairwoman.
Morning.
How are you?
Morning, Rep Wood. How are you?
We're both doing that. Look.
Oh my God, this is my first coffee, and I'm very much enjoying it.
My daughter made me for St. Patrick's Day yesterday because, I'm Irish and it was a terrible all-day meeting day. I got homemade macaroons dipped in chocolate to go with it. I'd send you
nice.
one if I could.
I
Chocolate.
this right now.
Oh, they're so yummy.
Good morning, Senators Looney and Fasano. How are you? Very nice to see you.
Nice to see you. Good morning. Great to see you.
I'll take advantage between Looney and Fasano to repeat what my mother, since today is her birthday. So you're wrapped around St. Patrick's, which is the 17th, and St. Joseph's, which is the 19th.
Right. Well, there you go. Green tie yesterday, red tie tomorrow. That's
There
it.
you go. Good morning, Chair Lesser.
Good morning.
No baby in arms today yet.
Not at the moment, but subject to change.
Morning, Mr. Chairman.
Good morning, Senator Looney and Senator Fasano. It's quite the crowded kitchen there.
Yes.
Matt, how old is your baby?
6 weeks.
Holy moly. Just a little one, huh?
Yeah.
You getting any sleep, Matt?
A little bit, not a ton. And my baby's entire experience of life consists of the insurance and real estate committees. So
Well, he's going to
a
grow up to be
very strange view.
Yeah, he's going to grow up to be well educated on insurance.
He certainly, his first word is going to be medical loss ratio.
MLR.
Imagine how much money he can make as a lobbyist if somebody put a badge on him right now.
I think there's some sort of revolving door provision, though. I think unweaned, you can't. I think we're waiting. Are we, Representative Wood, I believe you're chairing this morning. Are you ready to?
Yep. And you can be all set, Carrie.
Great. Good morning, everyone. Welcome to the Insurance and Real Estate public hearing on March 18th. We are going to convene the public hearing. My name is Carrie Wood. I am the representative from the 29th District serving Rocky Hill, Weathersfield, and Newington. At this time, we'll pass it over to co-chair Senator Lesser for comments.
Thank you, everybody. This is our last public hearing of the Insurance and Real Estate Committee. It's also a very long public hearing, so please bear with us. We have an awful lot of folks who are here to testify in support of a great many bills. I'm excited that my leader and an old friend of ours is have joined us as the first speaker this morning, but we have a lot to get to and a lot of important business before us today. So with that, I'd like to thank the members for being here and to turn it back to the chair.
Thank you. And Senator Anwar, ranking member, do you have any comments?
Thank you, Madam Chair. No, but just wanted to listen to everybody's perspective. Thank you so much, Madam Chair.
Thank you. And ranking on the House side, Representative Robin Comey. I'm sorry. Do you have any?
No, thank you. No, thanks for all your work. We're going to plow through the rest of these bills, and I'm looking forward to hearing the testimony. And I thank everybody on the committee for their commitment to hearing this work. Thank you.
Madam Chair, could I just do one more thing, if that's okay?
Please.
No, I would just note that due to the Senate session on Tuesday, we will have to pick, we will likely pick an alternate day, Monday or Wednesday, for the purpose of JFing bills. I know that that's not the usual committee practice, and I apologize to the members for the inconvenience, just simply due to a scheduling conflict.
And I apologize, Representative Comey is my vice chair. And do we have, I don't see our ranking members on. So at this time, we will jump into our speakers. Our first speaker here today is Senator Marty Looney. Marty, the floor is yours.
Thank you, Madam Chair. Good morning, Representative Wood and Senator Lesser and vice chairs and ranking members and members of the Insurance and Real Estate Committee. It's a pleasure to be before the committee this morning to testify on a number of bills, and especially to be with my close friend and collaborator on so much good legislation over the years, former Republican Senate leader Len Fasano, who's going to be testifying on some of the same bills. So just to begin with, I'll list the bills that I wanted to speak about. Senate Bill 1045, 1048, 1049, and House Bills 66, 22, and 66, 26. Briefly, 6622 would protect patients from formulary changes during their policy terms. And it's really unfair that if a patient buys a health insurance policy that includes prescription drug coverage for a specific drug, that the health insurer can change the formulary during the policy term and exclude that drug. In fact, some people are attracted to policies only because of certain coverages, and they may have chosen the policy because of that coverage and then have risk having the rug pulled out from under them during the policy period. So there are times when a physician and patient knowingly choose a drug, for instance, that has some documented side effects, but despite these dangers, it appears to be the best course of treatment for that patient. And an insurer, of course, could contact a physician to share any safety concerns it had rather than denying coverage as the first step. Senate Bill 1045 would provide a number of innovative protections for patients. First, it would create a presumption that treatment that's ordered by a physician is medically necessary treatment. And this would allow physicians to practice medicine and limit the ability of the health insurers to interfere with patient treatment by making medical decisions which they are not qualified to make. Generally, in most contexts in the law, the burden of proof is placed on the party that has the relevant information and knowledge. And Senate Bill 1045 would bring appeals of adverse determinations in line with most areas of the law. Here, the insurer is the only party with knowledge as to why a claim was denied, and in appeals of adverse determinations, neither the patient nor the provider know why the payer declined to cover a service. So it's a matter of simple legal justice. Despite this reality under the current framework, the burden of proof on these appeals is on the patient and the provider. In fact, prior to Public Act 12-102, which Senator Fasano and I worked on together back in that 9 years ago now, the patient and provider prior to that didn't even have the right to access the record that the insurer used to make the decision. and that practice was changed by that law. In addition, an insurer is not licensed to practice medicine, and its judgment as to what's medically necessary for a patient should really be weighted far less than that of the treating physician. The insurer could still, of course, deny claims under the framework, but it would have to prove that the treatment was, that denial was justified and there was some problem with that treatment, and that it was not medically necessary. So that, in addition, if an insurer has concerns about the treatment practices of an in-network provider, that concern should be addressed with the provider, and the patient should not be used as a pawn caught in the middle here. Also, Senate Bill 1045 would strengthen patient protections vis-a-vis insurers' use of step therapy. While there are legitimate uses of step therapy, too often it's implemented in a manner that interferes with patient care, leads to insurers preventing physicians from providing the best care for patients. And the protections in the bill this year apply to behavioral health as well as chronic diseases, and that's an important expansion. Again, in 2014, Public Act 14-118, an act concerning requirements for insurers' use, like that Senator Fasano and I worked on together back then, that created certain patient protections regarding insurance carriers' use of step therapy. But there have continued to be situations in which carrier step therapy policies prevent the patients from receiving the treatment that their healthcare providers have decided is the most appropriate. In some cases, this is delayed effective treatment that can leave patients with diminished health outcomes. Again, a couple of years ago, 4 years ago now, Public Act 17-228, an act concerning step therapy for prescription drugs prescribed to treat stage 4 metastatic cancer, recognized that these continued patient struggles and further regulated the use of step therapy in certain cancers, but not in a broadly applicable way. So the use of step therapy continues to be particularly problematic for various chronic diseases, including behavioral health and cancer patients. And Senate Bill 1045 would enable the physicians to be able to best provide treatment for their patients. In addition, that bill would create a more stringent definition of clinical peer in the appeal process for adverse determinations by including peer-to-peer conference that the health carrier is required to offer, and requiring that the clinical peers used to evaluate adverse determination reviews be certified specialists in the same subspecialty would result in more accurate and appropriate determinations, and would also require that the peer that is provided for the peer-to-peer conference have the authority to overturn the adverse determination. Otherwise, you have a series of non-conclusive bureaucratic hearings, and the result remains in limbo. So this would benefit all parties involved and make our healthcare system more effective. So at this point, it's my great pleasure to turn it over to my friend and colleague, Senator Fasano, who provided such leadership on this and so many other issues during his 18-year tenure in the state Senate.
Thank you, Senator Looney. First of all, let me say it's a pleasure to sort of be back into the building. I miss it a lot, I got to tell you, in all honesty. But I think Senator Looney covered a lot of the 1045 and other bills. I just wanted to add a few things. First of all, in 1045, with respect to the burden of proof, basically, Marty is right when he says legal justice, but there's also practical justice. The insurance companies certainly can rely upon the fact that they deny certain drugs to patients. One, you're interfering with the patient-doctor relationship. But number two, they recognize that doctors have a limited amount of time dealing with patients. And I think Senator Anwar knows a lot about this from his wearing his other hat, that they have a limited amount of time. And if a doctor had to keep on following every patient for the burden of proof to determine and prove to an insurance company that the medicine is the appropriate for that patient, they know there's only a limited amount, they being the insurance company, knows there's only a limited amount of patients that a doctor could put that effort for. And that's simply not fair. This is about healthcare and doctor-patient relationship. And if they have an objection, they can raise the objection, but then they have to prove the objection. It is unfair. They recognize the odds are that doctors can't follow through on all of these. And that's why this is being done this way. And we need to change. It is only the most way of dealing with, apparently there's somebody in the background complaining about my speech here, but anyway, that there are people here who are going to be treated unfairly and doctors who are not going to be able to provide the best medicine. And that's what this is about. Also in 1045, if the child turns 26, leave the person on the insurance until the end of the calendar year. I would add, we do that in the state of Connecticut. When my daughter turned 26 in June, she was allowed to stay on the health care plan for the state of Connecticut until December 31st, so that she didn't have to switch halfway through. And that makes sense. So that should be adopted as well, that as soon as the child turns 26, wait for the end of that calendar year, and then the person makes the change. So we just be adopting state policy that we have in our state contracts. In 1049, basically that just allows the deductible to be calculated on a calendar year, which would give the opportunity of people to make fair choices so that their plans don't change mid-year. Once again, it's just equitable. The other one that is on there that I don't believe is Sarah Looney's mind, which is House Bill 6626. Sarah Looney and I some time ago did surprise billing for emergency rooms. That is, you go into emergency room and a patient or a doctor at a network, you can't get surprised by a bill. I would add that emergency room surprise billing is now being looked at in Washington, D.C., and it's going to be modeled pretty much after the language Senator Looney and I started here in Connecticut. What this does, it limits it to or extends it to ambulance services. We've heard a lot of issues with respect to ambulance services where people are getting these huge bills. So we want to have the surprise billing also apply to those emergency transports. I'm not going to go through the rest of it. I think Senator Looney covered a lot of the information here. And I think these bills are a step which this committee has endorsed over the years to improve healthcare to patients and also improve doctor-patient relationships that we all value so much as a public policy.
Great. Thank you so much. I just want to say to the committee that when people can't log in, I forward my link. So when people log in and you see Representative Wood, it's because I'm sharing my link. So Senator Wong, you are not Representative Wood if you just want to change your title. Any questions from the committee? Senator Lesser.
Thank you, Madam Chair. And I will say I've often wondered how Senator Looney and Senator Fasano were able to cook up so much legislation. And I can see that they're in the kitchen right now. So I'm sure they will share their bipartisan recipes with all of us. But I just wanted to thank you both for both the suggestions that we're hearing today, but also for the long work that you both have done to strengthen consumer protections in Connecticut. I know we've worked with both of you in the past to pass a great many items. I don't know if you have more information you can share about the changing definition of clinical peer that you're requesting. That was one question, and the other was about the frozen formulary bill. I know that there were some questions about how to do that in the past, and just didn't know if there were. I think Senator Kelly had said some sort of different approaches. I didn't know if you had a specific suggestion for us about how to tackle that issue.
I think it is an issue that sometimes there may be the clinical peer that might be assigned by the insurance company for review may be in the same specialty, but not necessarily the same subspecialty. So we want to make sure there really is an apples to apples meeting here, that the two physicians talking are actually experts in the same subspecialty area, not just the same general specialty.
Great, thank you.
Senator Anwar.
Thank you, Madam Chair. Thank you, Senator Looney and Senator Fasano. It's so good to see both of you together again. And Senator Fasano, we miss you as well. And if you change your mind, it would be a blessing for our state again. I just wanted to mention about this issue that you've alluded to in 1045 about some of the challenges with the medications. It's really impacting the well-being of our patients, and especially in the healthcare facilities, but also the impact on the patients and the side effects. And as many of the patients who are on the medications are of the older age group. Navigating the system is having a big impact. So I wanted to thank you for this well thought out legislation and the wisdom around it, and then some of the other legislations that the two of you have worked on together. So it's such a blessing and refreshing to see the leadership that you have both shown and the work that you're still doing to help the community at the grassroots level. Thank you so much.
Thank you.
Thank you,
Senator
Senator.
Thank you, Madam Chair. I apologize for being late in this Zoom world that we have, but it is absolutely fantastic to see both senators together. It seems like the good old days. I wanted to acknowledge, and I apologize for coming in late, but obviously the good work that you all did in 2014 regarding the step therapy. Where have you seen that progress, and where do you see your bill right now taking that as a continual basis to provide quality patient care and giving decision-making back to the physicians rather than, in some cases, the insurers?
You know, I will say this, we know in this building, you can't take a huge leap, right? Everything is done incrementally, and that's the best, and that's how Senator Luna and I have approached all these healthcare bills. You have to go incremental, and that's the reason why this is year, what, 6 or 8 or
Yes.
something?
Yeah.
Because we always felt that, look, you need to ease in the change. A dramatic shift doesn't work. And if you've been in the building long enough, you know each time you do something, you see how it works, it's accepted, and then you try to push it the next step. And that's what these bills have done over the years, is show that we do have an idea of a plan ultimately, but you get there in a step progression. And the feedback that we're getting, you know, there's going to be certain industries who are going to push back because that's their nature. But after it's in, the bills that this committee, as well as public health, have passed, that Senator Looney have put forth, as well as others, have been accepted, and there's been no negative ramifications. And that's because we're doing it very slowly.
If I might add, I think what we've been doing, as Senator Fasano said, incrementally over the years, is a strong argument against term limits, because it takes a while to do these things sometimes and to build on them incrementally. We've been working on these things since 2012, when I was a majority leader and Senator Fasano was the deputy Republican leader at the time. So some of it has a lengthy germination period, and as he said, you have to build consensus gradually. On the step therapy issue, again, that legislation that we passed in 2014 was focused on in some limited areas of step therapy. We want to expand that, and the main concern about some of the mandates of using step therapy is that it delays the most effective treatment in some cases against the judgment of the treating physician, who may know that patient well enough to know that what is being suggested in terms of step therapy as preliminary treatment is not appropriate in this case, and should be able to go to something different sooner.
No, and I appreciate that. And Senator Fasano, I want to share with you that my gratitude and appreciation for your leadership and mentorship in me means the world. And you are a continuing example of that even as a private citizen, that you continue to engage in public policy. And that may be a lesson for all of us that may go through the cycle of public service, that even if we're no longer in office, the commitment to your community, to making our state better, is always present within you. So I wanted to acknowledge and thank you on that. Now, where are the hospitals on these conversations? And I apologize if it's been said already. You know, we looked at the insurers, but I look at healthcare from an entire ecosystem. And one of the biggest impact points are our hospitals, and as a source of providing these critical care and decision-making processes. Can you share with us, you know, what the engagement and what the need is for the hospitals to play a part in this as well?
Well, I'll just say that I'm sure you'll probably hear from them today in one way or another in regard to some of these bills. I think there are probably some that they're certainly supportive of, because they have been concerned about insurance mandates in areas where they believe that they represent the interests of physicians and patients. There'll probably be others that they may not be as pleased about, but in general, I think that what we have tried to do is to create greater fairness for everyone. In some cases, we think that in past years we identified some areas where we thought that that hospitals were perhaps making profits in areas that weren't justified. So, for instance, the issue of trying to find a site neutral payments, that's an issue I think that's somewhat controversial. But it is true that that certain treatments and provided in certain settings are far more costly than in other settings. I imagine that's something that the insurance industry would most likely support, because of they are paying a lot more for coverage in certain areas than they are in other settings.
You know, we have bills, as Senator Louie was saying, we're going to have bills that there's not going to be somebody who's going to be totally on our side on all the issues, or totally against us on all the issues, because it's driven by, you know, there's a money issue involved as well as patient health care. So I think Marty summed it up perfectly by saying the hospitals are going to be in favor of some of these and not others. And the insurance companies going to be in favor of some of these, but not others.
Absolutely, and I think that fits perfectly well with one of the ideas that we're contemplating in the General Assembly and in this committee is the idea of benchmarking, being able to use comparable data points to make sure that one facility is not charging disproportionately different from another. So it is a concept that I think Senator Looney articulated very well, addressing one of the biggest problems in regards to cost containment. So again, I want to thank both of you. I'm sure there's other people who'd love to talk to you, but I certainly am so happy to see you, Senator Fasano, and you look great, and maybe there's a testament for maybe life after the General Assembly. So thank you very much for joining us today. And again, thank you, Senator Fasano, for your many, many years of public service. The state of Connecticut owes you a great debt.
Thank you.
Thank you, Madam Chair.
Thank you.
Representative Meskers.
Thank you, Chairwoman Wood. I want to thank the senators. I cleared this before. I want to take a shout out to my mom, who turns 90 today. God bless her. Carolyn Elvira Panuco Meskers. Stuck between St. Patrick's and St. Joseph's Day. So the bookends of Looney and Fasano are there in front of us. God bless you, both of you, for your work. I wanted to speak particularly to the issue you mentioned about the formularies, and to address the issue, which I think was personalized to me in the last 2 years with a constituent who came to my house after I'd been out. I'd canvassed aggressively. I spoke to a lot of people, and the particular individual who you know, I want to keep privacy of the person of their names, is a person suffering from multiple sclerosis, and you know, it's a progressive disease, and there's stabilizing moments in it, and it requires, and the medication is particular to, I guess it's whether it's the bios of the medication that stabilize a person's position. And she came to me with a strong advocacy for this, because for exactly the reason you mentioned. So to personalize it, she had selected the insurance, the medication was covered, and she said, I need to know that that medication is going to be available for the life of the policy. I can't afford to have the formulary changed, because the impact on that formulary change is a marginal or significant decline in functionality under multiple sclerosis. And what happens, as she's told me, in the disease is that it's progressive. And when you move the baseline with a change in medication, you don't reset back up, you basically stabilize. So when she gets kicked out of one level, the chance that she has a significant drop in her functionality, and that becomes her new baseline, is a reality. So I want to tell you that I wanted to personalize that story, in that people need to know that they can get the drugs that when they pick a policy, because it's for the efficacy of that drug, and kicking them out or changing the formulary midstream is not the right thing to do. So I really want to thank you for that.
You know, and to that point, you're absolutely right. It's a bait and switch, right?
Mhm.
Buy this policy for this, and then after you're in, we're going to change it. And nothing stops, the insurance companies are going to balk at this, but there's nothing that stops the insurance company from calling the doctor up and saying, hey, we've got another drug and this is what we think it is. That conversation could take place between the insurance company and the doctor makes the ultimate decision for the patient. And that's fair. But to do a bait and switch just really is not fair, to your point.
Thank you. Representative Nuccio.
Thank you, Madam Chair. Good morning again, senators. How are you?
Can you?
Very well. Good morning.
Good, thank you very much. You have a lot of bills here and a lot of stuff that you're talking about. And for the most part, I don't really have a lot of questions about the majority of them. I'd like to kind of focus my questions in on 1045 and on, oh boy, which was the other one? 1049. So I'm going to do the easy one first with 1049. The deductible on a calendar year, do you see that as something that would happen regardless of enrollment date of or the start date of a plan?
Did you want to?
Well, I think we're talking about the basically the 12 month period, so that we want to make sure that patients aren't subject to multiple deductible costs in a relatively short period of time, and being in a position where they may be prevented from meeting their deductible because of a shift, and yet they would have paid overall enough to meet what would normally have been a deductible.
So I'm assuming you mean if they change jobs or something, because any policy is a policy calendar year. So regardless of it's the majority of policies in the state of Connecticut are 1/1 policies. The next biggest bump is a 7/1 policy, and then the next is a 10/1 policy. And those are all decisions made by employers on what their effective dates are going to be. But regardless, even if it's a 10/1 policy, that policy is for 12 months. So their deductible would be from 10/1 of the current year to the 10/1 of the next year. So from what I heard, it sounded like you were talking about a 1/1 deductible calendar year, regardless of enrollment date. That's what I'm trying to figure out.
Right. Well,
There's no possible way for somebody to pay a deductible twice in one calendar year unless they change jobs.
Right. Well, that's the concern, is trying to provide some relief from people who, for whatever reason, may be in a situation where they wind up having a highly significant amount of out-of-pocket costs in a short period of time because of a policy change, and this we know is a hardship in a number of cases.
Okay, so but a policy change because of a job or a policy change because of an employer? I don't know that I've ever heard of an employer changing a plan mid-year to another company, because they're contractually obligated for a 12-month period. So I guess what I'm getting at, I'm confused, because if you have a 7/1 period enrollment date and you decide that you want to have your deductible by 1/1, that is pretty much costing a nightmare from an insurance perspective, because that person could have a policy effective 1/1.
Yeah.
And I don't know how you would administer a prior company or a prior policy from somebody else for the first 7 months, the last 5 months, and then say, but 1/1 your deductible is going to start over. And then if they leave that insurance company to go to another one, you're back in the same situation. So deductibles are on policy years. So I guess my question is, are you aiming that all policy years be a 1/1 and no off-cycle policies? Or I just don't know that what you iterated in your beginning there is something that is doable in the market without extreme cost and administration, like malarkey.
I think your point.
I think there's certainly a point there, but it would apply to a relatively small universe of plans, only those defined as high deductible plans. I think that's the effort, to try to provide some relief for people who are in that category.
Right, but even high deductible plans, which I would actually argue are probably a bigger majority of plans, especially considering 80% of 70 to 80% of plans in the state of Connecticut are ASO, and most of those are high deductible. The I guess the only way I see that somebody would have to pay a deductible twice in a 12-month period is if they changed jobs, and I don't think you can tell one company that they have to eat the deductible and the other company doesn't because somebody paid something somewhere else and they made a decision to change their job. So I'd be interested to talk to you about the language that you have in here. I understand what you're trying to accomplish. I just don't know that this piece of legislation would actually do that, I guess. So glad to sit down and talk about it, but I think that's enough on that one from me. On 1045, this is a pretty complex bill with a lot of different things in there. And I wanted to focus in a little bit on what I believe it was Senator Lesser started with the change of the clinical peer language being from similar to same. That kind of loops into your medical necessity also, because typically clinical peers are used to help determine prior authorizations and stuff like that. So is this ask then that an insurance company would have to have availability to every specialty of every doctor to review every prior authorization or every claim of medical necessity? Because that is a structure that I don't know how anybody could ever actually implement.
Well, I think the intent is to try to make sure that the peer is truly a peer. Otherwise, the peer review process or the peer consultation process is not as accurate as it should be, because it is supposed to be somebody who really is competent in the same, not general area, but this would say in the same subspecialty.
So my only real concern with that is if any insurance company does not have available accessibility to a provider that provides every single type of service that we can have imaginable, you are going to be building in a significant delay in prior authorization process. So that's something, I think there may be some fine tuning to the original language that's there, but changing from similar to same, I think you are going to have a lot of legislated unintended consequence on that, just from the perspective of prior authorization and the amount of time that it takes. And that kind of got me into the medical necessity piece that you had. So medical necessity is an important tool. It really is. And is there a way we can do it better? Probably on all sides, but medical necessity was built into the insurance realm because of abuses and as a protection to insurers, and also as a way to contain the costs of healthcare for providers who prescribe things that are excessive or not needed. You know, if you can get an X-ray rather than jumping right to an MRI, you know, medical necessity is not the bad guy here. Fine tuning, looking at things, maybe changing some of the expectations of medical necessity, they are, but my concern is the more you tinker with it, you know, if you understand insurance's role in this, it's to try to contain the costs. Like I said, you know, there was a reason that it was put into place. So I'm a little concerned with making it harder for medical necessity to be determined. And the step therapy, I understand, I absolutely get, and I know in Connecticut we're already legislated that it's 60 days, but a lot of that too gets back to the employer deciding the benefits that they want to offer. You know, insurance is a contract between an employer and an employee, and insurance companies administer. So I think there's room in there to talk. And then you had one comment, you said that doctors have less time. They don't have the time to track their patients and their care plan, and that the burden of proof should be on insurance. And I would challenge that, as doctors have less patients than insurance companies have members. And ultimately, it's the doctor's responsibility to understand and track their patient's treatment plan. You know, if there's something that that needs to be validated. I would want my doctor to do it and not my insurance company. So that burden of proof there on who has to have the burden of proof of medical necessity. Again, I think I'm a little concerned with the language mixed in there and making sure that we're actually protecting all of the partners in this and understanding the actual roles of what they are.
So there's no, sorry.
No, go right ahead.
So, there's no question that the idea is cost containment, and that's obviously have to be balanced against medical care and public policy. That's the scales that I look at.
Right.
And what I was saying is that not if a doctor prescribes I was talking to a heart doctor out of a major hospital the other day about this because he was calling me up saying that for some reason he was getting a lot of medicine that he's prescribed for his patients being rejected as not being covered by the insurance company. And he said to me, Len, here's the problem. You call the insurance company and say, why are you doing this? Send me the stuff. You get the stuff, you call them, then 45 days they get back to you. You send more stuff. You're chasing something that they know you don't have time to chase. And if I've got to do that for 12 patients, that's all I'm doing all day long. I'm not giving patient care. I'm fighting a bureaucrat insurance company over an issue that I have to figure out. They'll give me the stuff, but I got to figure exactly what their issue is. And then I got to prove almost a negative to them. Why don't they prove to me what their real concerns are? Let the burden be with them, and I react to it, as opposed to me reacting to their saying no on some study. And his argument was, sure, you're tracking your patient as a doctor, no question about it. But when you're being denied a drug and you've got making up 500 patients because you work for a hospital and you're the cardiologist for that hospital, and so you got all sorts of people coming in and out of that hospital every day, and the medicine's being rejected, and it's up to you to take on the burden of 10% of those patients to go through the insurance company. It is extraordinarily time-wise not the best interest of using a doctor for that. So then you say, well, then I'll have to hire a nurse or some practitioner to chase it all down. But that doesn't really get you very far. Now you're adding more costs to the hospital that we all pay for. So why not, if someone is complaining, why not make it, as I think Senator Looney said, the legal procedure generally followed throughout all our cases, and we're, as lawyers, is you have an objection, state your objection, make it clear, put the burden on them, and then let the doctor react to that burden. But the way it is now, it's too scattergun. And the odds are, and the insurance companies know this, the odds are you're not going to fight all of them because you haven't got the time. So you got to pick 2 or 3 as a doctor, and the rest you got to just say it is what it is. I don't think that's good policy, in my view.
I 100% see where you're coming from, and I guess maybe that's a good delineation to make. If you're talking about this from a prescription drug perspective or a formulary perspective, then I see that. I can agree with you on pretty much most of what you said there from a formulary or a drug perspective. I don't know a single person who hasn't had an issuance of a drug and then say try something different and this one works, but now you got to try 5 ones to get there. And I absolutely agree with that. My concern is when the language is written vaguely and it now covers medical necessity in every aspect or burden of proof on every aspect.
I'm with you. I understand. And if you want to narrow that language down to a drug issue and see, once again, these are inches. So yeah. And see how that flies. I think yes.
I would definitely be in favor of that because that would also help us contain the cost of drugs, which understanding that sometimes the drug that they want you to try is a more expensive drug than the other. So absolutely, if we could narrow that language down to be more honed into the drug formulary or the drug aspect of medical necessity, I definitely think there's language there that we can work on that would accomplish what you want to do without broadening it so wide that it starts to hit all medical necessity and prior authorization. So I appreciate that. And I'm the new girl, so I don't know how I would even go about doing that with you, but I would very happily sit down to look at trying to find a way to improve that language. And thank you very much, both of you, for coming in and answering my questions. I appreciate it.
Thank you. Thank you.
Thank you, Rep. Nuccio. Next up, Senator Anwar.
Thank you, Madam Chair. I wanted to start with a disclaimer. I do not work for an insurance company. I'm a physician, and I look at things from a lens of consumers. I think the language, the way it is accurate and appropriate from the consumer's perspective. Look, here's the reality, what happens. I'll give you some examples, and then I'll go a little bit deeper into it. And I would respectfully ask that we do not change the language and water it down, because that will just kill the entire purpose of saving or taking care of our consumers. My secretary a few years ago left, who had been working for me for 16 plus years. And she left because she was on hold on the phone literally the entire day, just to get approval, prior authorization of a rescue inhaler, the most basic inhaler for respiratory asthma patients, to get a rescue inhaler. And the insurance companies would make her hold on the phone for 45 minutes. And it was either me on the phone to get the basic rescue inhaler, or it was her. And she said, look, I wanted to greet people, I wanted to interact and smile at them, and I'm listening to this music on the insurance company side. So this is the bureaucratic disaster that has been created, because some of the people give up and they say to the patients, sorry, we can't do it. Go buy your medicines from Canada, and then you will not be able to do anything. And that's what's happening. And that is actually a financial benefit from an industry that has actually mastered some of these technologies to restrict people from getting the medications. The other thing about the burden of proof is the physician, the clinician who has spent many years specializing in that area is writing a prescription. So they have already, he or she has already made a decision about what the patient needs. There is industry that is saying, no, we refuse to give it. So the burden of proof should be the one who is not giving it, rather than actually putting it back on the clinician and trying to claim that, well, they still have to prove that they need it, is not accurate. And I think Senator Looney and Senator Fasano, you're on the right track. The burden of proof is supposed to be on the insurance industry side, because the physicians have already done it. Other thing is that if you talk to the neurosurgeons, you talk to ophthalmologists, retina specialists, they would have their medications, some of the things, and they are refused by a retired family practice doctor, a retired surgeon, who actually is an MD or a DO, who's actually said, well, sorry, we can't do it, because he does carry or she carries the name of an MD at the end of their name, except they don't have the information and the depth of what is going on at the current time. And then that's part of the challenging thing that we have seen in the industry. And then that is actually just filling a checkbox. Yes, there was a doctor who said no to you. And you're absolutely right, Senator Fasano, for a cardiologist, for a arrhythmia issue and a medicine that they need for the arrhythmia, they're not looking at the cost of the medicine. They're trying to look at how they can save the life of that patient, because the arrhythmia is going to kill that patient. And having to wait and fight with somebody who does not even understand the impact of that specific medicine, it is unfair to the patients, and it's life-threatening to the patients. So I believe the way you have written this legislation is going to save patients' lives, and then give them time to be able to spend it with their loved ones, and also allow the clinicians to see more patients. So I just wanted to put my perspective and thought in there as well. And again, I start with the disclaimer that I don't work for insurance companies. I don't plan to, because I think that I'm more interested in consumer support. Thank you so much.
Thank you.
Thank you, both Senator Looney and Senator Fasano. It was, thank you for your time here this morning.
Thank you very much.
Thank you so much to the chairs and members of the committee. This committee does very important work on an annual basis, and much of its work has been recognized nationally over the last several years as being at the forefront of consumer protection and making good healthcare insurance policy. So thank you very much.
Thank you. Next up, we have Senator Berthel, followed by Representative Bohr.
Good morning,
You want to leave? Oh, do they have more questions for us? No, I guess we're done.
Chairman Lesser, Chairman Wood, Ranking Member Huang, Ranking Member Pablo D'Amato, and distinguished members of the Insurance and Real Estate Committee. I am State Senator Eric Berthel. I am testifying today in support of Senate Bill 1007, an act requiring health insurance and Medicaid coverage for the treatment of severe obesity. I have submitted my written testimony, which I would encourage you to please take a look at, and I will not read that to you because you can all at your leisure take the time to do that. What I did want to share with you today, and this is, I think, the third time that a bill of this legislative intent, if you will, has been proposed. First of all, I want to thank you for creating a committee bill and incorporating the language from my original bill of Senate Bill 90 into this. I'd also like to thank Senator Anwar for your interest in this bill again this session. As a physician, I know that you encounter in your practice individuals who are suffering from the disease that is obesity. But I sit before you this morning, not only as a legislator, but also as an obesity survivor. I am a patient who has previously had bariatric surgery. It was a procedure that dramatically improved and changed my quality of life. Obesity has officially been classified as a disease by the federal government. It is not, the surgery that corrects morbid obesity is not glamour surgery or something that people do because they just want to feel better. The end result in reality and in practice is that individuals who undergo proper bariatric and metabolic surgery end up getting their lives back. They get rid of many of the common comorbidities that come with obesity, things like diabetes, hypertension, other forms of cardiovascular disease. Can all be properly mitigated and even reversed as a result of successful and proper bariatric surgery. Today, you will hear from many doctors who I know are signed up to testify before you. They are the medical experts with respect to how this surgery changes lives and improves outcomes. And I think based on the written testimony that they've submitted, you're going to hear about their results, not only with children and adults and seniors, but also how COVID has affected people with morbid obesity. People of color are victims of higher incidence of comorbidities because of morbid obesity. And I think all of this will prove to you at the end of the day today that this is something we should be doing. Connecticut is one of a few states in the nation that does not require coverage for bariatric and metabolic surgeries. And I would encourage you to, you will get a fiscal note back on this for sure. I know Senator Lesser and I have talked about that in the past. And Senator, thank you as well for your continued interest in the bill. But I think that when you look at what will ultimately come back as a fiscal note, and you look at how this positively changes and affects lives, and the long-term cost savings when we can possibly prevent a stroke, we can prevent reliance upon certain medications that are very costly going forward for treating those comorbidities, you'll see that there's actually a pretty good return on the investment. So thank you again for a few minutes of your time. I think I may have gone over my 3 minutes. Thank you for the indulgence, and I'm happy to answer any questions of the committee. Thank you to the chairs.
Thank you, Senator. Senator Lesser.
Thank you, Madam Chair, and thank you, Senator, for coming back before us with this proposal. And you and I have worked on this in the past, and I thought it made sense previously, but it's impossible to ignore the crisis of the moment, the fact that we are in a global pandemic, and the overwhelming evidence that that severe obesity is a risk factor for COVID-19 outcomes, bad COVID-19 outcomes. So making sure that we're giving doctors the tools that they need to serve their patients and make sure that they are safeguarding public health seems like a worthy goal and something we're focused on in the committee. I know we're going to hear from an awful lot of members of the medical community today, and it's going to be a long hearing for us. But I'm glad of our bipartisan work on this issue in the past, and I know that there's a fiscal note, but perhaps we may be able to tackle it this year. So thank you for coming back before us, and I'll look forward to hearing from the real experts, the doctors who are and patients who are going to share their stories, and thank you in particular for sharing your story. I know it's really important and powerful, and hope to work with you on this.
Thank you, Senator. And I will tell you that one of the individuals who has submitted written testimony, I believe he signed up to speak with you this morning, is Dr. Neil Flock from Norwalk, lives down along the shore. His written testimony provides all of the scientific and statistical information as it relates to the, among other things, as it relates to the impact of COVID-19 on people who are suffering from morbid obesity. So I would encourage the committee to take a closer look at his written testimony in addition to whatever he may say before you today. But thank you for your support and understanding of this very important piece of legislation.
Thank you. Senator Anwar.
Thank you, Madam Chair. Senator Berthel, third time is a charm.
Yes,
So
sir.
This is going to be, hopefully. Thank you for your advocacy on this, and thank you for your persistence. I think the last time around was the COVID that got this bill stopped. But like I've said before, this is an excellent bill, much needed. And there is a cost. Every time, if we are going to look at it from the lens of how much is it costing us, we should look at how much is it going to cost us if we don't do this. And that's where there's so much saving in the chronic illnesses that are there. I, who have witnessed numerous patients get their lives back, passionately agree with you. And I want to thank you for your leadership in this effort, and I look forward to supporting it.
Doctor, thank you very much. I appreciate that. And I look forward to working with you and the committee to do what we have to do to get the legislation passed. Thank you for your support as well. I appreciate that very much.
Thank you.
Thank you. Senator Wong.
Thank you, Madam Chair, and welcome, Senator Berthel, and thank you for your courageous advocacy of this important issue. And as you know, there's always a cost-benefit analysis, right? And before this committee this year, we are addressing the concerns in regards to healthcare and insurance costs in our state. But I want to take a step back, and what I've learned from you as a colleague is the fact that you have educated me that obesity, challenged by the societal perception and the stigma, it is not an issue of, you know, a lack of willpower of individuals. It's not an issue of cosmetic when you're looking at bariatric surgery. It is a health and well-being issue. And what I also learned from you is the fact that not only is it a issue of a cost to do the surgery, but also the savings that will result from the other bits of health challenges that you described earlier. So it's really important that when we do this cost benefit analysis, and for those that challenge the fact that we may be yet imposing another health mandate, I think this may be one that significantly is a value added for those that are looking to take control of their health. And it's never easy. That being said, what are your thoughts in regards to your personal experience from a cost benefits and health benefits basis of what you have gone through?
Senator, thank you. And as my good friend, I appreciate your question this morning and sharing the relevance of our relationship as senators and a lot of the time we spend together in our caucus and what have you. And thank you for the question. I'm pretty open about my experience because I'm so passionate about wanting to do what's right here and helping others who currently don't have access to bariatric and metabolic surgery procedures. But in direct response to your question, when I prior to my surgery, I was looking at what would have been now in my life, 4 or 5 years ago, probably being a diabetic, probably being hypertensive, on medications to treat that were really just treating the symptoms and not the cause. And that's where occasionally medicine can go off the track, if you will, because if you don't actually get to the systemic cause of something and fix it, then you're not necessarily changing the quality of life. You're not changing outcomes. You're just helping someone to survive in that moment. And that would have been for me probably a very different quality of life. And in a longer term, maybe 10 years or 5 years from now, it might have taken my life. And that's something that that a lot of people face in a lot of different medical conditions that they have. But for me, it was a profound change, and it gave me my life back, quite honestly. And it is, let me be perfectly clear, it's a challenge every day. It's not a one-time fix-all kind of procedure. Nothing is. It's something that you have to be, that as an individual, I have to be cognizant of and aware of and conscious of for the rest of my life in order to take advantage of the gift I was given, which was a change to my anatomy to fix a disease that I had. So yes, the return on the investment is large, much larger than the initial cost, and it absolutely takes that kind of foresight to look at this and say there's initial cost today, but the long-term benefit is really amazing.
Well, absolutely, and you are a incredible role model in that perspective. But you said a key word that sometimes we need to fully understand this issue and why you're looking to have some financial support through the insurance products that we all buy. Is ultimately, you said this was a disease. This is not a reflection of people's lack of willpower. This is not a cosmetic means of making a change. This is a medical procedure to address an illness, and an illness that is not, wished upon by many by people. So, does that change the pivot for you as an experience? I mean, as an acknowledged fiscal conservative advocate, I know you respect the taxpayer dollars and insurance premium dollars. I know that, but what does that mean to you when you start repositioning this as not just simply helping people with lack of willpower, people looking for cosmetic improvements, but it is a disease?
Thank you for the question, Senator. That is absolutely 100% correct. There is a stigma that's attached with people being overweight and being obese, and I think that the stigma boils down to this. You look at someone who walks into a room who's overweight, and whether you think this consciously or subconsciously, you say, wow, that person just can't control how much they eat, and that's why they're so big. And I can assure you, having been that guy, that it's not a matter of not being able to control it. If you look at, and I think there's a couple of people signed up to testify before you today that are the medical experts, doctors, that actually deal with the metabolic side of obesity, that will tell you that this is a psychological issue. This is actually the way their genetics are programmed, okay, and how they overeat. So the ability to go and make a change to the anatomy, an anatomical change, gives that person a tool, if you will, as that's how it was presented to me. It's not going to necessarily cure me of the desire to eat too much, okay, but it prevents you from doing that. Okay, and that's part of what bariatric surgery does and metabolic surgery does, and that's where good medicine and good practitioners come into play, and they're so important. And you're going to hear from some of them that they can provide the tool, but they also have to provide the education and the support going forward. And some of that may require the use of some pharmaceutical products in the long term to help the individual control the disease. It's not a one fix. But to your point, this is absolutely not something that is done for glamour. This is not getting a facelift or having chin bones made higher or whatever, cosmetic surgery. This is something that truly saves lives. And I am a living example of that sitting before you this morning. And I think that there are many others out there. I don't know if we have any other patients that will be testifying today, but I'm living proof that it works, and it gives people an opportunity to take back control of their life with good medicine, proven medicine. And as I said before, the return on the investment is tremendous over time, and it does change people's lives.
And I appreciate that. And I thank the chairs for the indulgence at times, but it's not only just a physiological impact, there's a mental health impact as well. And it's not just the mental health of you as an individual, as you have taught me so much, but it is also the mental health perspective of how others react to you.
Sure.
And we have to acknowledge, as we talk so much this year in this building, and rightfully so, about the perception and bias that we have in our culture. We also need to acknowledge that we have bias against people's body shape and sizes, and that we also need to recognize that it forms and shapes us. So that being said, what you have demonstrated as a colleague, but also an individual that have the courage to step up and be a role model for so many others that may be contemplating this, to take this step forward for their better health, is something that I greatly admire. And I'm so glad that you and Senator Anwar on a bipartisan basis is working on making this go through the process. But also I want to acknowledge that for those that may be concerned about the cost benefit analysis of health mandates, this one in the long run may end up saving healthcare costs. So through you, Madam Chair, I want to thank you for the indulgence of the time with Senator Berthel, but I'm truly impressed and always proud to call you a friend. So thank you,
Senator. Thank you, Senator Huang.
Thank you very much. I'll be jumping in right now to chair the meeting. So our next Rep Farr, you're up.
I think Representative Delnicki was before me, so I'll yield to him.
Okay, that's very nice. Representative Delnicki, please.
Thank you, Madam Chair, and thank you, Representative, for yielding. You know, when I first met you, Senator, I never would have guessed that you had that issue. And then I went back into my memory bank here, and literally I could remember the first time I met somebody who I hadn't seen in probably a year and a half, that went through the procedure. And when I saw them, it was a totally new person with a high amount of energy, with such a positive outlook on things. It was amazing. And I've got to tell you, there has to be a tremendous savings in the long run. Just avoiding diabetes in and of itself would easily pay for the front end cost of having the surgery, not to mention other maladies that you can end up with. But to see the emotional and physical well-being in and of itself was truly amazing with a friend of mine years ago. And of course, to hear you testify here so enthusiastically about in essence, a new lease on life.
Yeah.
And that kind of energy and stamina and positiveness in and of itself proves the point. And I wholeheartedly support it. I know we've had the conversation in the past, and I truly hope we can get that law passed and that coverage provided, because I do believe at the end of the day, it will save a substantial amount of money when it comes to healthcare costs. Not to mention the benefit to you and to friends that we all have that surgery, and how it benefits them and society as a whole. And I thank you for coming forward.
Representative Delnicki, thank you. Thank you for your kind words. Thank you for sharing your perspective on that. And I agree with you. I appreciate your support. And thank you. That's I think all of that is very is spot on. It really makes good sense. And I appreciate your support of the bill as well. Thank you.
And again, thank you, Senator, and thank you, Madam Chair.
Representative. Representative Farr.
Thanks, Representative Comey and Chairwoman. Hi, Senator. Thank you for being here. As a new legislator and new to this committee, I'm really thrilled to see this bill, and I appreciate you coming before us. And as someone who has worked on a whole range of preventative mechanisms at the community level to change, really, as you noted at the outset, the systemic causes that can be at the heart of obesity in our communities, I appreciate you highlighting that in your testimony. I think what I just wanted to ask you about, since some of my colleagues have really eloquently allowed you to share your story, is I just wanted to ask you a bit about, how we in our state right now might compare to other states and what we can learn from other states and how they've approached this very issue. That would be helpful to me, especially seeing and hearing from you for the first time. Thank you so much.
Sure. Thank you, Representative. Congratulations on your election to the General Assembly. And thank you for the question. So I am absolutely not the expert with respect to other states, but I can tell you what I do know from a very general standpoint. I believe from the last time I looked at this, Connecticut was one of 8 states in the nation that does not require insurance companies to provide coverage for bariatric and metabolic surgeries. So Connecticut generally is a leader in healthcare and medical coverage for procedures. And I think some of the doctors that will come before you this morning, and I'm certain into the early afternoon, will be able to speak much more eloquently to that. But I guess I would say to you that since you have some awareness and cognizance with respect to how programs like this and coverage like this affect community and what have you, that it's time for Connecticut to make this change and to bring some good additional medical coverage to our residents. As a point of reference, we have parts of our coverage under various state programs that include paying for metabolic and bariatric surgery. So at some point in time, a decision was made to include that as part of our state-sponsored plans, and it was, I'm certain, done for the right reasons, all of the same reasons that we're talking about today. But I hope that the people that come after me this morning and testify will be able to perhaps provide you a little more detail in answering your question. But I thank you for your comments as well, and again, welcome.
Thank you, Senator. Yeah, I appreciate your brief commentary on that. And as you said, we don't want to leave our Connecticut residents behind. And I appreciate your advocacy and really look forward to hearing from others today about this important issue. So thanks for being with us.
Thank you, Representative.
Thank you, Representative. And thank you, Senator Berthel, for sharing your story. I know that the work does not stop at all at the surgery, and that it is an ongoing job, second job, if you want to call it.
Indeed.
To continue to maintain that the health of your body. So thank you so much, and we will go to you if we have any other questions on this. Thank you.
All right. Thank you very much. Thank you for the opportunity to speak with you this morning.
Okay, so next we are going to, it's been a little bit over an hour. We are going to jump in with Representative Bohr, the next, and then we will rotate into the public. The next person after Representative Bohr will be Jan Kritzman, followed by Ted Doolittle, and we will alternate from there. So, Dorinda, Representative Bohr, go ahead.
So good morning, everybody. Senator Lesser, Representative Wood, Vice Chair Senator Anwar, Representative Comey, our ranking leaders, Senator Huang, and Representative Pavlak-Tamano, and all the members of the Insurance Committee. Thank you for allowing me to testify in support of Bill 6623 today regarding acknowledgement of claims for property damage. Currently, there are timeframes for which you are required, the insured, to report damage to your home. And I'm going to use the example of which we saw a lot of in 2020, a tree hits your home. You have 60 days to notify the insurance company and provide proof of that claim. And then you work out what the damage is with the insurance company. And then on the back end, the insurance company has a certain time frame once you agree to an amount as to when they have to pay you out. But there are no time frames in the middle of that process. So as the insured, you would report the damage within 60 days. There is no time frame of which the insurer, the insurance company, needs to acknowledge your claim or needs to resolve and agree to the amounts of your claim. So technically that process in the middle can take an extraordinary long time. So you can report your claim within 60 days, but it can be a month. It could take a month for the insurance company to come out, assess, acknowledge, and agree to the amounts of that claim before they agree to pay it out. So the National Association of Insurance Commissioners has recommended timeframes for those steps, and a number of states have adopted those timeframes. And what they are is after you provide proof within 60 days, the insurance company has 15 days to acknowledge your claim. And they have 21 days to resolve what the value is of those claims. And then the time frame for paying you out begins. So we have folks that incur significant loss and financial damage, but that time frame of waiting for the insurance company to respond and let you know that those damages will be covered is a waiting game, and they're left, in the dark, no pun intended, not knowing that the insurance company has accepted their claim and what the value of that claim would be. So it's very consumer friendly. I think it's very reasonable timeframes for the insurance companies to adopt here in Connecticut, as they've adopted in so many other states. And I know, I look back at Storm Isaiah, and I know the insurance companies were overwhelmed. But like our utility companies, they need to be prepared, and they need to have assessors in the queue, and they need to be able to go out, assess that damage, and be able to respond to you timely.
Thank you very much, Representative. Do we have any questions? Seeing none, I will say that, we as representatives, as we hear from our constituents all the time when there's big storms in our community, and it's taking forever for them to, sometimes they have to move out of their home and then it all depends on them fixing
Right.
issues and moving back in. And just had a couple of those with the big Mr. Branford. So
I think just the acknowledgement gives them some assurance that, yes, you've received my claim. Yes, you're going to pay for my claim. And then they could get started on the work. If you have a broken window or roof damage and you're trying to figure out how you're going to pay for that, at least some assurance that it's acknowledged, it's going to be paid for, and you can start the work and get going on repairing your home. We saw several of our constituents in this situation back in the fall.
thank you so much. And thanks for bringing this pro-consumer bill forward.
Okay. Thank you, everybody.
Okay, thank you. So next we are going to go to members of the public, as we do after we hit the hour mark. We have Jan Kritzman and Harold Kritzman as a double whammy here. Welcome to the Insurance and Real Estate Committee.
Hi, I'm Harold Kritzman of Newington. I'm going to introduce my wife, Jan Kritzman of Newington, who's going to do all the talking.
Greetings, Chairman Lesser and Chair Lady Wood and members of the Insurance Committee. My name is Jan Kritzman. I live in Newington. I'm an 8.5-year breast cancer survivor, and I'm a patient advocate for dense breast tissue awareness and the early detection of breast cancer. I support HB 6626, especially sections 24 through 27. Here's a terrifying statistic. Connecticut is #2 in the nation per capita in cases of breast cancer. Some years we're #1. 3,500 plus newly diagnosed cases of women annually, plus some 250 men. Now let's talk about section 24 first. Since the essence of this bill is to provide for the early detection of breast cancer, it's only logical to conclude that the earlier information and awareness is taught, the better. I suggest that this information should be part of the state of Connecticut guidelines for health education in the schools, starting as early as perhaps middle school, when girls become women, develop breasts, and notice changes in their bodies. I think it's a good time to start teaching them about breast self-exam. And, by the way, young men to learn about testicular cancer and self-exam also. In class, they would receive uniform, standard lessons with an opportunity for Q&A with a qualified educator. Both of these diseases are known to occur at a very young age. And also I have particular concern for young women of color because it's been reported in several medical journals recently that quite young, they develop breast cancer, often triple negative, which is the most difficult to treat. Outreach and early detection in that demographic are of critical importance. Another suggestion, how about more funding for community outreach programs, for example, the Witness Project in Bridgeport? It distresses me no end that I'm here testifying on breast cancer legislation for Connecticut without my mentor and lifesaver, the late Dr. Nancy M. Capello, PhD of Woodbury, Connecticut, founder with her husband of RUDents.org. Nancy passed away in 2018 from complications from the treatment she received 14 years prior for her late stage 3C breast cancer. Her mission, with the help of you, our Connecticut legislators, resulted in 2009 with mandated notification, first state in the nation, to women of their breast tissue density, which clouds mammograms and hides small early stage breast cancers, and urged the need for essential follow-up testing with breast ultrasound or MRI. By the way, 40% of women have dense breast tissue. This legislation, because I do have dense breast tissue, saved my life. Today, I'm asking you, my Connecticut legislators, to repeat your enlightened legislative performance of 2009. HB 6626 will expand insurance coverage from just screening to both screening and diagnostic testing with no out-of-pocket costs. For the record, breast tissue density notification became federal law in 2019 because of Nancy's state-by-state global efforts.
Your time is up. If you can please summarize your testimony.
I am 10 more seconds. Now, granted, other states have some bits and pieces of HB 6626, but Connecticut would be the gold standard in the nation for early detection breast cancer legislation, as well as recognition of other predisposing conditions, which we'll see in other sections, without any out-of-pocket costs for essential follow-up testing. Is there any other questions you'd like to ask me?
Sure.
I have some more. Yeah.
Thank you, Jan. Thanks for your testimony, and you know, Connecticut being the gold standard and something is certainly that saves lives would be certainly something we can all get on board for. I'm going to open it up to the committee. Senator Lesser.
Thank you, Madam Chair, and Jan and Harold. It's good to see you. Full disclosure, you are constituents of mine, and I know that you worked as well with Representative Wood, Representative Turco on this really important legislation. So it's good to see you. And yes, you are a force of nature. I think we had a lot of trouble saying no to your requests in the past, and you are one heck of an advocate for all people facing breast cancer. So I want to thank you for all that you do. You mentioned a few things, and some of them do go beyond our cognizance as a committee. We obviously focus on insurance coverage, and that's what we can do. Some of the things about education and outreach are a little bit trickier for us to address in this committee. There are other committees that are probably more focused on that aspect. But I specifically wanted to ask you about the issue of diagnosis versus screening, because, you know, I like to talk about some of the important work we've done, the bipartisan work we've done to expand mammogram, breast ultrasound coverage. And then we get some surprised and sort of upset phone calls from folks who thought that their procedure was covered and then discovered that it wasn't. And in some cases, it's because they have insurance that's not regulated by the state because it's a self-insured plan or it's Medicare. In some cases, though, it's because of this diagnostic versus screening issue. So could you tell us a little bit more about that and why some things are covered and some things aren't?
In 2019, Representative Dorinda Borer actually contacted me because she knew I had some knowledge about this. And a bill was proposed and passed in 2019 to cover just screening mammograms, ultrasounds, and MRIs. And that's a lot of confusion, I think, began with that, because if the coding isn't proper and the coding was for diagnostic ultrasound or so forth, the woman would get a surprise bill, it wasn't covered. So this happened quite a bit. And I was talking to my State Representative Gary Turco, and we discussed it. And I said, I've got to come back again this session to point out that screening and diagnostic testing for mammogram, ultrasound, and MRI has to be, the law has to include diagnostic also. And I think that would eliminate a lot of the confusion, and it would definitely help in detecting early stage breast cancer. Take note, there's no prevention for breast cancer, and there's no vaccine, and there's no warp speed. And the only tool we have in the toolbox really is early detection. And this bill reaches far and wide to provide this. I want to do some simple arithmetic, if that's okay with you, for the insurance company lobbyists who may be interested. Early detection may involve, very simply, lumpectomy and radiation. It's not really simple, but it's, how shall I say, that's early stage treatment most often. Cost to the insurance company, maybe $30,000 to $60,000 for testing and for doctor's visits and medication, and the surgery and the radiation. Late stage detection, like stage 4, which is a terminal diagnosis that shortens lifespan, involving most often what they call slash, poison, and burn, clinical trials and more clinical trials, chemotherapy, scans and more scans, maybe about $500,000. So ignoring the vast difference in the costs between early and late diagnosis is very bad business. Insurance companies, you have to listen. Don't be penny wise and dollar foolish. The bottom line is early detection not only saves lives, but it saves money. For the record, I hate pink. Never was my color. And I get exhausted talking about breast cancer all the time. But if it will help pass HB 6626, I will wear shocking pink, and I will never stop advocating for this most life-saving mission. So give a damn, get a mammogram, because all breasts matter.
Thank you, Jan. I don't have a whole lot to add to that. You are a force of nature. So thank you for gracing us with your presence and for doing what you're doing to try to save lives.
If anybody wants to be on the other side of this, my son-in-law bought these for me a while back, and they're my shocking pink Everlast boxing gloves. And I'm willing to use them against of this legislation. We're Connecticut. We have to be the gold standard. We have the #1 girls basketball team, and I want the #1 protection from women of early stage breast cancer.
Thank you, Jan. Thank you so much. Will you come back at the end of the day when we're tired and we need a little pickup?
This is very important. I have one more thing, and then really, unless you have any questions, I will be quiet. This is a picture of Nancy Capello, the late Nancy Capello. She did not invent dense breast tissue. She invented dense breast tissue awareness. This is a picture of Sandy Casanelli, my breast friend. She is stage 4 breast cancer. She's 45 years old, and she's been battling this for 7 years. And she wants very desperately for women to get early stage diagnosis, unlike what she's had to go through. And the girl in the middle, I don't know who that is. I think maybe somebody said it was me.
Thank you, Jen. Representative Nuccio.
Thank you, Madam Chair. Good morning, Mrs. Kritzman. I absolutely love your energy, and you may not like pink, but you look darling in it. So.
Oh, I look like this when I wake up in the morning. I can't help it.
I can only aspire to be as wonderful. It's funny. This is something that I kind of came to legislature and said what I was a little frustrated with the bill that was passed in the prior legislation, because it only affects people with fully insured insurance, and it doesn't mandate it across the board. And I know there's about 1,000,002 reasons why it is like that, and I'd be looking to try to find a way to get around it, because I am too one of your members of your group with the dense breasts, and I have issues myself, when I would go for my required mammogram, and every single time they want me to then go for an ultrasound, and then they want you to go for another mammogram and another ultrasound. And quite honestly, I never could do it because I could not afford the cost of the ultrasound. And then the second mammogram and then the second ultrasound, it was it was over $1,000 easily. It was for all of those extra things. So I just go once a year and keep track of the items that are of concern, and just go for it, because that's how it is. So I'm definitely a supporter of trying to find a way, and I fight with myself on this because I'm always trying to find ways to keep healthcare costs down. And I love that you brought up the cost of identification early and the cost of identification late, because I think that's what we have to do. We have to look at the ROIs on these things. And I know people don't like to talk about ROIs when they're talking about healthcare, but if we can definitively show this is going to save us money in the end, there are some people that are emotion-based and some people that are fact-based. You can swing the fact-based people that way. And then the emotion comes along with it. So I just want to thank you for what you're doing and for putting a little pep in my step to try to go back and fight a little bit harder for this, and to make it a more broader reaching piece of legislation that doesn't just cover the 30% of people who have fully insured, but as a full insurance wellness and health initiative.
May I say something?
You can say anything you want, dear.
Oh, thank you. Never skip a mammogram or an ultrasound. Never. COVID-19 this past year, a lot of women say, well, I think, I don't want to go out, and I don't want to go to a mammogram radiation center, and I might catch COVID, and I don't want to get a mammogram and be wearing a mask, and I don't know how safe it is, and blah, blah, blah. So I think I'll skip it. Now they're gone 2 years. Yeah. Without having the mammogram, without being tested. An early breast cancer, do you know what an early breast cancer can do in 2 years? It can go from early to very late. For example, I have been going to the same mammogram radiology center for 25 years, starting when I was 40 until I was 65. And when I was 65, this is 8.5 years ago, the radiology technician said to me, oh, you have to get an ultrasound. You have dense breast tissue. And I said, I've been coming here for 25 years. You've never mentioned that to me. Is that bad? Is that a problem? No, it's very natural. 40% of women have dense breast tissue. The problem is we just can't see anything on your mammogram because of the density. It's like looking for a snowflake in a snowstorm. So please step into the next room and get an ultrasound. It's a different contrast. So I said, what's an ultrasound? She says, you'll see. I went into the next room and I got an ultrasound. And guess what she found? A very tiny, early stage breast cancer. Very aggressive breast cancer. Fortunately, I was one of the lucky ones. But we can't base breast health purely on being lucky. It's got to be mandated legislatively that a woman doesn't have any obstacles, no burdensome having to meet your $7,500 deductible to get proper testing, both screening and diagnostic.
I agree, and I think there's medical necessity that can show that, because as you said, I'm one of those people who, well, you got to come back for an ultrasound. Yeah, well, I also got to pay the bills. So that's out of pocket, and it's hard because it's it's just like anything else, you ration it. How often can you go? And it's not you can't go every 6 months and this and that. So, I 100%, I understand what you are. I'm an advocate for your cause in this, and I hope to speak to you in more detail at some point about it. Thank you so much. I really appreciate you coming and testifying today.
Thank you,
It's my most important mission.
Thank you, Representative Nuccio. I share a lot of your stories, your similarities with your story. So thanks for sharing that. Senator Wang.
Thank you, Madam Chair. And Jan, I do love your energy. And I want to compliment you. And it is all about early diagnosis and constant testing and prevention, right? So I really, the stories that you're hearing right now are important for people to hear and to make the extra effort to go get tested. The other thing I wanted to acknowledge and thank you is the fact that I want to compliment Harold. Harold's right on the side. He made the intro, but it's a total team effort. And I can see the kind of effort that you both put out. It's inspirational. So I want to thank both of you. And as a husband and as a father of a daughter, these are important issues for men as well, to ensure that their loved ones are continue to be healthy and not be just absolutely impacted by the illness of breast cancer. That being said, I also want to acknowledge your mention of those with metastatic and stage 4 cancer. I think we have to do a much better job in recognizing the unique challenge of that, as well as to emphasize additional research support to support individuals that are impacted by that. The courage that those individuals, as you mentioned, your friend, have displayed are just, it's hard to describe, but having been influenced and been impressed by so many of those courageous women, it really is important for us to address that as well. And I appreciate you mentioning that. So Jan, you're full of energy, and you've given us some of it, but more important, you've shared an important message. So I've become a huge fan after this exchange. So thank you very, very much.
You're very welcome. And another thing I'd like to say, if you folks get behind me on this and pass this legislation in Connecticut, gold standard in the nation, I take this piece of legislation to Congress and I get, I don't know, an invitation, or I get through whatever to get to as many senators and congressmen as I can meet in the lobbies, in the hallways, and I will tell them all about my breasts. That stops them dead in their tracks. But I say, no, I'm not going to show you my breasts. I'm just going to tell you about them. They're extremely dense breast tissue, and so on and so on. And this is what we've done in Connecticut because we're the gold standard.
Jan, you're making me blush, okay? So stop right there. That being said, I think it's important, as we said, the other people who testify, like Senator Berthel, we need to do a cost-benefit analysis, right? Because the idea of prevention is penny wise and a better approach to cost savings. So I think you will bear out, and as you've advocated so effectively, the initial costs, the habits of testing are so important for the inordinate costs that people may have to endure, not only from a financial cost, but the emotional is incalculable. And I want to say again, Harold, you're a smart man to support this lovely lady, and you're a smart man to stand right beside her. So Jan, thank you.
You know, we're newlyweds. We've only been married for 54 years.
God bless you. Happy anniversary.
Thank you. Thank you.
Thank you very much, Jan and Harold, and we hope to see you back here soon and to do your cause justice. So, and I appreciate your direct ask. It's very productive. So thank you so much. Have a nice day.
Thank you.
Okay, next we are going to Ted Doolittle. After Ted Doolittle, we will go to Ms. Joan London and then to Representative Turco as we back and forth. Thank you.
Thank you very much. Oh, good to be here. Thanks so much for having me. I am with the Office of the Healthcare Advocate. My name is Ted Doolittle, and I'll be testifying today regarding Bill 1045. I also am accompanied today, Madam Chair, by two attorneys from my office, Adam Prizio, and Adam Prizio will be speaking to Bill 1049, as well as Sean King, and Sean King will be speaking to Bill 1041. First, for those of you who don't know, the Office of the Healthcare Advocate is a state agency. We offer free expert assistance to anyone who is having trouble with their health insurance. We can help with claim denials and so forth. So anybody who is out there who has an issue with their insurance, or a friend or a loved one, we'd be happy to assist you for free. Please contact us at the Office of the Healthcare Advocate. I want to associate myself with the comments on Bill 1045 in the burden of proof regard with Senator Looney and Senator Fasano. I just want to mention that, again, my name is Ted Doolittle. Senator Looney's name is Marty Looney. Senator Fasano's name is Len Fasano. My insurance company knows me as Theodore. Senator Looney's insurance company would know him as Martin. And Senator Fasano's insurance company would know him as Leonard. And that's just to say that our treating physicians know the first thing about us, but frankly, our insurers and the insurance doctors operating in other states who have never examined a patient don't. They know me as Theodore, they know Senator Looney as Martin, and so forth. It was mentioned quite rightly earlier in this hearing that the role of insurance is to contain the costs. I would submit to this committee that our costs are 2 to 3 times the cost of any other advanced economic nation. It's been a 40-year record of not being able to contain costs, so we really do need to try to look at this in a new way. With respect to utilization review, that is the review of medical claims and so forth, let me mention that utilization review is a cost, a very heavy cost that is almost unique to this country. So in terms of trying to get the cost down, we need to rethink as a community the way that we negotiate prices. That includes actors, minor actors like the patient, but also the insurance company and the providers. I would mention that I don't think that this burden of proof, this idea to shift the burden of proof, if the insurance company wants to deny a claim onto the insurance company, is actually revolutionary. I believe it's evolutionary. And in fact, I believe it goes right along with many things that the industry is working on right now, such as Centers for Excellence, which is a program where, for instance, an employer like Walmart will require all of its folks who are getting hip transplants to go to a center of excellence. Well, that claim's not going to be denied because that's a trusted provider that Walmart has selected. There's folks will be familiar with tiers, where if you might have a lower copay if you go with a tier, a preferred provider. That again is a provider that has been vetted by the carriers and is a more trusted provider. The reversal of the burden of proof goes right along with those innovations and says that let's take the status of our good treating physicians seriously. Let's treat their judgment as the default judgment. Let's presume that it's valid. In fact, I would encourage this committee to think along the lines of what I've been calling even deeper than reversing the burden of proof, but what I've been calling plans, new types of plans, building on centers of excellence and tiered providers that I call no denial health plans or low denial health plans. And that would involve minimizing the number of actual individual claims that get reviewed and instead reviewing the patterns of practice of individual providers. If you spend hundreds of dollars reviewing one claim, that's an expensive endeavor. If you're looking at your providers and determining which ones need education, which ones have many, many claims that need to be reviewed and perhaps rejected, then you can educate that provider. And if you educate that provider and change their practice pattern, you haven't saved just one claim, you've saved many, many claims. If you educate that provider and they don't change their practice pattern, you can escalate and go up to termination and kick them out of the network. But anyway, again, I want to be brief, but I do want to associate myself with the comments of Senator Looney and Fasano. The reversal of the burden of proof is appropriate. The consumers have paid for the insurance and they are using presumably vetted in-network providers. And my comments, by the way, on reversal burden of proof, it should, in my view, probably be limited to in-network providers who have been vetted and are trusted. If there is a way, as Representative Nuccio was groping for or thinking about earlier to narrow it down and do a baby step rather than going full hog on reversing all burdens of proof, I'd be open to that. But those are my comments. Happy to answer any questions. As I say, after me, I would like Adam Prizio to direct some comments to 1049 and Sean to direct his comments to 1041. Thank you for your time, Madam Chair.
Thank you, Ted. Senator Lesser, would you like to ask a question about this and then we move on to his colleagues? Or shall we go forward with everything?
I have a question for Mr. Doolittle. I will hold the question for later, or what you tell you're the chair, so you tell me when would be appropriate.
Okay, well, let's go forward in an effort to since I only see your hand up in an effort. Let's do Adam and Sean, and then we will hit them all with questions. 1, 2, 3. Thank you.
Sounds good.
Go ahead. Go with Adam.
Thank you, Madam Chair, Senator Lesser, Representative Wood, and members of the committee. I'll be brief, but I'm testifying in support of 1041, the bill to regularize high deductible health plan deductibles to a calendar year. And the Office of the Healthcare Advocate supports this bill because it simplifies things for consumers who honestly, the concept of a deductible is one that is, we see a lot of consumers who have challenges understanding how a deductible interacts with their coverage, and anything that can be done to simplify it is beneficial. We also appreciate this committee's attention to high deductible health plans generally, and the way that they serve as barriers to care. This committee, the full legislature convened a task force which concluded its work last year, looking at some of those issues of high deductibles and barriers to care. And I want to raise to the committee's attention 2 proposals which also affect the high deductibles and which connect with some of the concerns that were raised by Representative Nuccio earlier on this bill. The specific issue that we were talking that was being discussed was people who change a healthcare plan partway through the year and how that causes a deductible to reset. So a majority of the high deductible health plan task force supported 2 ideas to address this, to sort of establish some fundamental fairness for people who maybe have met a deductible or have contributed significantly to a first deductible, and then either they change jobs or they lose a job, or they, maybe they were having a subsidized plan on the exchange and then they start a job, that the deductible in their new plan starts at 0. So they have to meet 2 deductibles in a plan year. So the task force examined the ideas of either prorating the deductible, so that, for instance, if you start on July 1st, just to make it simple, your deductible would be prorated to half of the calendar year or half of the plan year, and that would give people who have already put skin into the game, which is the purpose of the deductible, a little bit of the benefit of having already put that skin into the game. And then the second idea was similar, which is to give people a credit for the money that they've already contributed toward the first deductible in the second plan. We think that this would not affect a ton of people, but it does significantly affect those who it affects, because high deductible health plans are, deductibles are significant, many thousands of dollars, and it's not fair to ask people to meet 2 high deductibles in a plan year. It's also worth raising to the committee's attention that a very small number of people actually meet their deductible in a plan year. A recent Access Health committee meeting showed that for almost all of the plan designs, the 75th percentile or higher of consumers in the Northeast have an annual out-of-pocket contribution that even comes close to the deductibles for most of the plan designs in Connecticut. So we support the regularization of the high deductible to 1/1 of the calendar year, but also want to raise these two other ideas as ways to address some of the additional issues surrounding that. Thank you.
Thank you very much, Adam. And we will hear from Sean. Sean, you have some comments?
Thank you, Madam Chair. Thank you, Senator Lesser, Representative Wood, members of the Insurance and Real Estate Committee. I appreciate the opportunity to share the stage with my colleagues this morning. My presentation is on SB 1041, which is addressing healthcare sharing ministries and looking to put some type of regulation in place about access to those types of health coverage arrangements that don't really exist in great market share in Connecticut, but potentially growing here in Connecticut. I just want to highlight at first that under federal rules, healthcare sharing ministries have a fairly narrow definition. Among those parameters, they have to be tax exempt organizations. They must be grounded in religion or faith where the members share a common set of religious or faith-based beliefs. They have to have been in existence since December 31st of 1999 to actually meet the federal definition of a healthcare sharing ministry. And they have to subject themselves to an annual independent audit that they make publicly available. As I mentioned, there's a limited number of these types of organizations that exist across the country. There's very few of them that presently operate in Connecticut. One source has mentioned to us that there's maybe 5,000 members of healthcare sharing ministries in the state of Connecticut at the current time. These particular coverage arrangements are not technically insurance. They are not subject to regulation by the state of Connecticut at the moment. There are no rules in place. The insurance department does not regulate true healthcare sharing ministries in the state of Connecticut. And so without any regulations of that nature, they're free to sort of operate according to their own rules that they set up. Again, they're grounded in faith-based and religious beliefs, but they don't have any of the normal requirements that insurance companies have in terms of having to provide certain coverage of essential health benefits, of preventive services, of emergency care, things like that. They have opportunities to discriminate against people in terms of whether or not they may be enrolled in the healthcare sharing ministry, whether or not they may cover certain things based on their health condition instead of following the federal rules where those types of discrimination are not permitted. In fact, these arrangements they're not contractual arrangements at all, and healthcare sharing ministries really don't have any obligation to pay any type of claims at all. It's all subject to the discretion of the folks who are part of the ministry who make those decisions on what to cover and what to not. And they describe this not as coverage, but as sharing of expenses among their members. Our office has received complaints over the last couple of years from members of these healthcare sharing ministries fall into two buckets. One is complaints that we receive from folks who belong to what I'll call a legitimate healthcare sharing ministries that meet the federal definition that I described before, where perhaps they had a claim that they thought would get paid, but it wasn't shared by the healthcare sharing ministry. And they come to realize that, as I described before, the ministry doesn't really have any sort of legal or contractual obligation to pay for those claims at all. And so these are things that they may not have realized at the time that they were shopping for these plans or enrolled in these plans, and things that weren't adequately explained to the members prior to their enrollment. And they end up having to learn the hard way in some cases that what they thought they were signing up for isn't exactly what they were getting. We've also received some complaints from folks who belong to an organization that presents itself as a healthcare sharing ministry, but is currently subject of a cease and desist order by the insurance department. And the insurance department has alleged that this particular organization does not meet the federal definition of healthcare sharing ministry and is in fact operating as an insurer, operating improperly as an insurer in the state of Connecticut. And that's the subject of some further proceedings before the insurance department that are still pending. But I just mentioned that to highlight the fact that there are other actors out there that are acting as healthcare sharing ministries, but perhaps may not be actual healthcare sharing ministries under the federal definition. The reason why I do that is just to call your attention now to the text of the bill and some of the concerns that we have about the actual text. And as we look at it's really section 4 of the bill that appears to be an attempt to regulate healthcare sharing ministries. The way that it reads, it kind of looks like it's really only regulating the broker community and kind of putting some limits on those folks' ability to assist consumers who are interested in healthcare sharing ministries in getting them enrolled and earning a fee for it. And as part of that assistance, hopefully the brokers would also educate consumers. And so if this bill were to pass as written, some of our concerns include the fact that number one, consumers would still end up having access to healthcare sharing ministries without having adequate education about the risks involved, the real world risks that are involved with enrolling themselves in this type of plan, because now they would not have the ability to seek professional advice from a broker or somebody similar to make sure that they learn as much as they can about their options and what they're buying and what they're not buying. We're also concerned about the loosening of the definition of healthcare sharing ministry that's contained in this language, because in essence, Section 4 defines a healthcare sharing ministry basically as any organization that calls itself one, without putting further parameters on it, like having a common set of religious beliefs, being an actual tax-exempt organization, having to subject itself to an audit. None of those requirements are in this definition. And the concern there is that it invites other potentially nefarious actors to create these types of arrangements that essentially, again, provide nothing in terms of the guaranteed protections for consumers in the state of Connecticut. And that leads me back to the example of the entity that is currently subject to the cease and desist order before the insurance department. That organization, under this definition, would be free to act as it had been acting, and probably would no longer be subject to any cease and desist order. And this would expose its members and potentially other new members to a lot of financial hardship if some of their requests for sharing expenses were denied on a discriminatory basis or any arbitrary basis whatsoever. As an alternative to what's been proposed, our office would prefer probably to see more direct regulation of actual healthcare sharing ministries, requiring them, again, to fit the federal definition of what a healthcare sharing ministry is, and imposing some parameters on how they operate in terms of mandating that they cover certain essential health benefits like the ACA does, prohibiting them from imposing pre-existing condition exclusions, those types of things. Try to have them regulated, maybe not equivalent to insurance companies, but on a par that protects consumers. Make sure that consumers who are interested in these types of arrangements have adequate notice about what they're buying and what they're not buying, what the limitations are. So those are our suggestions for potentially modifying this bill as a way to provide further protection for consumers who are interested in joining healthcare sharing ministries. Thank you for your time.
Thank you very much, Sean. Your testimony was very helpful, and we will definitely revisit the language as it's written. We'll go on to some questions for the three of them from the Office of the Healthcare Advocate. Senator Lesser.
Yes, thank you, Madam Chair, and good to see all three of you and for your work on behalf of consumers. I'm going to confine my questions actually to Mr. King's testimony regarding the healthcare sharing ministry bill, because I guess I see it very differently. I think this was a very narrow product prior to the Affordable Care Act, where I think a throwaway sentence in the ACA has been taken as license by a new industry to spring up and sell insurance, unlicensed insurance to consumers. And I know that the Office of Healthcare Advocate has gotten complaints about this. I know the Department of Insurance has, and I know that I have personally heard from constituents who have been sold insurance by these so-called sharing ministries and have been harmed by it. And so I guess the first question I had, Sean, you suggest that these are not, in fact, insurance products. I agree that they are not licensed insurance products. But in 2019, the Department of Insurance found that they are, in fact, insurance products, that the companies are holding themselves out. You go on the websites of the companies and you see them advertising provider networks. You see them talking about premiums. You see them talking about all sorts of insurance-y terms. But the one thing that they don't do is provide any of the consumer protections or any requirement to actually pay the costs. So to my mind, that is holding yourself out as an insurer, and that's something that the Department of Insurance has found. And I was just curious, in what, do you disagree with the department's finding? And if so, what benefit do these provide to consumers the way they're currently constructed?
Thank you, Senator Lesser. I appreciate the question. I don't know that we disagree with the Department of Insurance in the sense that, if an organization is in fact holding itself out as providing insurance and they have a web page that looks like insurance, I think we may be speaking about the same entity that I described earlier in my testimony that they were concerned about. But I'm not sure that, and this may be a better question for the insurance department itself, I'm not sure that they consider those healthcare sharing ministries that are subject, that fall squarely within the definition of the federal rules, whether they consider those particular entities subject to regulation under current statute and current regulation, although they could be if that was the preference of this legislature to establish some of those rules.
And the bill before us doesn't outlaw health sharing ministries. That is not a thing that the bill does or seeks to do. I understand it prohibits insurance brokers from selling non-insurance products, because I think there is, I can speak from personal experience talking to my constituents. There are an awful lot of confused consumers out there who see insurance-y products and they are sold them in some cases by licensed insurance brokers. So the bill does not outlaw the ministries, but it does limit the ability of people to, if you wanted to come up with a GoFundMe to share your health expenses with friends, colleagues, family members, co-parishioners, that is a thing that you can do. You can set up a ministry for the purpose of sharing health expenses under this bill. But the bill does not seek to outlaw that. That's correct, right?
That's my understanding of the way that the bill reads. Yes, Senator. Thank you.
But it does prohibit licensed brokers from steering consumers who are seeking insurance into a product that does not provide any of the consumer protections you talked about, or even a promise to pay any expenses at all. And the problem that I'm hearing is one after another, I'm hearing about consumers who walk into a doctor's office and they think they have coverage, and it turns out they don't have coverage because there's no contract, there's no requirement that these companies pay $1 for anything. And they get stuck with a surprise bill. I had a constituent, it was actually in the papers, who wound up getting stuck with hundreds of dollars for a COVID test, because it turned out that her health sharing ministry, which she thought was an insurance company, just decided they don't want to pay for COVID tests. And, this happens every single day. So I guess I'm not sure why we would treat these folks with kid gloves or with any fewer restrictions that apply to, to other products in the insurance marketplace.
Yeah, thank you for that comment, Senator. I don't know that it is necessarily wise to treat them any differently than an actual insurance product either. The only thing I can think of is that because of their roots in religion and faith, that there may be actually some limitations on a state's ability to do so. But in the interest of protecting consumers who may not know the difference between a healthcare sharing ministry and a regular insurance product, our office would advocate, putting regulations of those arrangements on parity to the extent possible with an actual insurance product. Put them on the same level playing field. That's the best way to protect consumers from these arrangements, to the extent that that's permitted under federal law.
So thank you for that, and that's actually very helpful. And through you, Madam Chair, then I have a question, because I don't know if you've reviewed some of the testimony. We got a small amount of testimony in support of the ministries, but they have some. I don't know if you've reviewed any of that, but doing a little bit of research, it appears that the majority of the testimony we got was in support of new rebrands of one of the companies that was subject to the 2019 cease and desist letter. So I guess they've changed their names and are now marketing this prohibited practice through a new business name. Is that your understanding? I'm looking at trying to Google the evolving names of these ministries, but it turns out that it's the same company that existed in 2019 that ran afoul of the enforcement arm of the insurance department.
Senator, I did review briefly some of that testimony. I did not explore the origins of the particular ministry that they mentioned in that testimony, so unfortunately I can't really speak to that at this time.
And is there any value that you see to having licensed brokers or licensed insurance professionals steering customers to unlicensed products about which there have been a large number of consumer complaints?
Yeah, as I tried to articulate earlier, it's a little bit of a double-edged sword. We would obviously prefer not to have consumers steered to those unlicensed products. They should be enrolling in products that are subject to the same rules that insurance products have to play by in terms of consumer protections, especially. But to the extent that somebody may come to a broker and express some interest in one of these products, we would hope that brokers would be allowed to educate the consumer who is interested in that about what it is that healthcare sharing ministries offer and do not offer, so that they can be fully aware of the risks of going that route before they enroll in that type of an arrangement.
So just drilling down here, do they offer anything? But there's no promise to pay. So if they if you're paying premiums to a company, but they're not paying you for anything, right? If there's no promise for them to pay you back a nickel, what are you getting? If you pay $500 a month to a company and they say, hey, we've got this provider network, we provide healthcare, et cetera, and there is no promise for them to pay you a nickel, what am I missing?
To be fair, folks who are in these arrangements often do receive contributions towards their healthcare costs from the healthcare sharing ministry, but it's a matter of complete discretion for the folks who are running the ministry to determine whether or not to pay and how much to pay for a particular service. So there's no contractual obligation that exists under these arrangements.
So, I mean, you described it earlier as, a religious organization, and this is an act of faith that people are engaged in. And obviously, we all have enormous respect and deference to bona fide religious activities. People can practice their faith however they want to in this country. But when a product, I mean, if this were a case where a minister or a priest or a rabbi or an imam were going to their congregation and saying, we're going to come up with whatever the equivalent of a GoFundMe is to take care of members of our flock, that would be one thing. But that's not what it looks like when you have an insurance brokerage that's in the business, a for-profit business, in the business of selling insurance to people, saying, hey, we've got insurance regulated by the Department of Insurance. They go through all of the rigmarole of that. But now they're in the business of pastoring to Connecticut residents. To me, it seems odd that you would go to an insurance brokerage for faith-based practice. To me, there's a connect. I mean, those two things seem like they're juxtaposed, and that raises questions as to whether or not that is actually what's happening when you're calling up your insurance broker. Because I don't usually call my insurance broker for the great life questions about here and the hereafter. I ask them about insurance coverage, and so that's why I'm cocking a little bit of an eyebrow when you're telling me that this is a faith-based operation, because you go to your faith leader for that. You don't go to your insurance broker. Unless I'm missing something.
Well, I guess to your point, Senator, I'm not entirely sure how individuals find themselves in a position where they are enrolling in one of these particular health plans. In some cases, in my recollection of folks that we've spoken to, they're just out on the internet shopping for low-cost insurance, right? And for whatever reason, a Google search pulls up a healthcare sharing ministry. They read something about it, it looks like it costs less, and so they decide that they're going to sign up. I frankly am not sure how many folks end up discussing it with a broker, or how often somebody goes into a broker and says, these healthcare premiums are killing me. You got any other ideas? And a broker turns around and says, well, there's these healthcare sharing ministries.
But if it happens at all, they're making really good, because there's no, unlike regular insurance, you are paying a premium just like you are with any other insurance company. But in a regular insurance company, you're going to get your money back if you get sick. And with these, they're not. And the reason they're not is because they are religious communities that are supposedly focused on obligations to one another. And it just, unless these brokers are all graduates of divinity school, it seems like they're just selling folks unlicensed insurance products. And maybe I'm missing something, but I don't see why we would want to connect those two things unless they really are what I suspect they are, which is unlicensed insurance products.
Yeah, I mean, I understand your point. I guess the knowledge gap that exists is just, what really is happening on the ground in terms of how people end up in these insurance arrangements. I don't. I mean, I think I agree with the idea that we would want to limit again how much brokers are steering folks towards these arrangements as a potential alternative to regular insurance. But I'm not sure how much more deeply I can answer your question, Senator. I apologize.
Thank you. Thank you, Madam Chair.
Thank you, Senator. Representative Nuccio.
Thank you, Madam Chair. My question is for Adam. You had mentioned something about the high deductible health plan, and I was hoping maybe we could kind of get a little bit more information. So the high deductible health plan task force, you said, addressed the issue of the copay if somebody leaves a job. And you said the two options would be prorating the deductible and then a credit for money paid in for the second plan. You had also mentioned something that I didn't get to write down 100%, that very small number of people meet their deductible. That I agree with. And then you said something about the 75th percentile in New England. And I was wondering if you can first start out with maybe repeating that so I can get it down.
Yes, I'm happy to do that, and I can be a little bit more precise. The March 12th of this year meeting of the Access Health Plan Benefits and Qualifications Advisory Committee was presented with data that included the out-of-pocket expenditures for, and I believe I said New England, but I wish to correct myself, for members in the Northeast region. The data, and I'm happy to submit this to the committee after this meeting to submit the presentation. The data shows out-of-pocket expenditures for consumers in the gold, silver at various cost share variations, and bronze plans. And for each of them, it's you have to exceed the 75th percentile of expenditures, meaning for almost every plan, you're spending more than 3/4 of people in that at that who bought the plan at that metal level to even come close to the deductibles that are being proposed for the different metal levels this year, which is merely a way of putting a figure to the claim that folks don't tend to meet their deductibles.
Okay, because you're saying two things there that aren't the same in industry. One is out of pocket max, and then one is deductible. So do you know if they were delineated?
This shows the the data is for the maximum out-of-pocket annual costs.
Okay, I'd like to see that.
You're right, that the deductible is
yeah, they're separate, but I'd like to see that data to understand it, because I think that's interesting. I'm not a fan of high deductible health plans, never have been. But I want to get back to the question regarding the deductible and splitting it. So if somebody changes, deductibles are set by employers, not by the insurance companies. So if somebody is at job A for half of the year and they pay $2,000 of their deductible there, and then they go to company B for the other half of the year, I'm trying to understand what the mechanism is, because company A will have paid, will have gathered that deductible against the expenses that they directly have to be paid to a doctor, and then they go to the second one. So what was the mechanism that they were using to take like the money that was already paid at one business to another business to apply towards their deductible? Because then company B, their deductible part is not going to be met. So I guess I'm just trying to track the dollars on how they're doing that. And I was wondering if you know if they got into the mechanism for transfer of the money from the paid expenses from one to another.
No, I can say that these were sort of discussed at a higher level of as a concept that would relieve this pressure on the consumer. And my recollection is that the task force did not get down into the specifics of the mechanism. I'm also, no, I think I'll leave it at that. Yeah.
Okay. Yeah, I think that there's conversation to be had there, because the whole point of the deductible is after you meet this amount, then your company starts to pay their portion of those expenses. So if you're going to use what somebody paid at company A to company B is going to be responsible for the expenses quicker than the other company because you didn't meet the deductible on their side. So they're going to be paying quicker, than the other. I think it's just that might be a contractual thing. And I think that may actually be a fiduciary thing also, because, but I all right. If you don't have the answer, if they did not come up with an answer, but just an idea, then I can accept that.
Thank you.
Thank you very much. All set, Representative Cho? Thank you. Go ahead, Representative Wood. Sorry.
Thank you, Representative Comey. Next up, we have Joan London, followed by Dave Jones. Is Joan London on?
I just promoted her to panelist, so she should be on.
Okay.
I am on. Okay, there you go. I think I had been muted or something. Hello, everyone. I really appreciate this opportunity today to speak to all of you on the Insurance and Real Estate Committee about Bill number 6626. The reason why is because I heard those words that no one ever wants to hear: you have cancer. It was in June 2014. I was diagnosed with stage 2 triple negative breast cancer. And on the day of my diagnosis, I had had a 3D mammogram, the latest and greatest, and it was clean. Fortunately, only because I had been sent on a story and knew to do this, I followed that mammogram with an ultrasound, and that ultrasound showed that I had a tumor back against my chest wall that hadn't been seen on the mammogram. And why did that happen? Because dense breast tissue, which I learned that I had, shows up white on a mammogram, just like cancer. And as we've already heard today, therefore, it can easily mask a tumor. Thankfully, due in part to the tireless efforts of the late Nancy Capello, it is now mandatory for all women to be notified if they have dense breast tissue. Nancy's the one who fired up the advocacy in me, took me to Washington to testify before Congress and FDA hearings, because getting these tests and getting them early, it's so important for women. Right now, mammogram screenings are still the most effective way that women can protect themselves against breast cancer. But the costs that are associated with the tests can be overwhelming to some women. As a breast cancer survivor who had my cancer found in an ancillary test, I know how important all of these tests are. And I all too often hear from women who find it difficult to bear the expense themselves, and therefore they forego these important diagnostic tests and end up with late stage diagnosis cancer. And when a woman is worried about whether she has breast cancer, this isn't a time to be weighing the pros and cons of her finances. And this is why insurance companies should cover the cost of screening and diagnostic exams so that breast cancer can be found early at a more treatable stage, and thereby limiting late stage diagnosis with the exponentially higher medical costs. In the 7 years since my diagnosis, there have also been a lot of new tests and cancer treatments. So there are now tests for women with early stage breast cancer, which can study our biomarkers.
Excuse
and
me.
Yes. Yes.
Joan, please continue.
Okay. Which can study our biomarkers at the time of diagnosis. And that allows oncologists to determine which therapies will work best. And that means we can eliminate a lot of the chemotherapy and a lot of the aggressive, expensive treatment. And of course, that also means that we can save lives. And that is why I ask you today to pass Bill number 6626, which would expand insurance coverage for both screening and diagnostic mammograms, breast ultrasounds, and MRIs with no burdensome out-of-pocket costs. This bill can help protect your wives, your mothers, your daughters, and yourselves, because every woman should be able to benefit from all the new advances we have without having to make sure that her health fits into her budget. I thank you for the consideration and for allowing me to testify today.
Thank you, Joan. We have questions from the committee. Representative
Sure.
Lesser. Sorry, Senator Lesser. I apologize.
That's quite all right. Well, it's good to see you, and it's not every day that we get a long time Good Morning America host in front of this committee, but appreciate your work, being a voice for all the folks around the country who are battling breast cancer, and appreciate your strong advocacy and gracing us with your presence this morning. So I don't really have a question, but I do know that it is really important to see you and to have state legislatures like ours doing everything they can to support ensuring that health insurance covers the health care that so many people need. So thank you very much, Madam Chair, and thank you, Joan, for your testimony.
And I must just say, I'm a Connecticut resident, and I'm so proud that our state has really been kind of the gold standard when it comes to this. Nancy Capello reached out to me when I was diagnosed, and I must say, I mean, I'm a journalist who asks medical doctors the questions, and I didn't know about the risk of dense breast tissue. I didn't know it was a thing that I should be worried about. And it was only because I was sent to interview a breast cancer expert, Dr. Susan Love. And, you know, between changing the lights, she said to me, you know, you do get all your annual mammograms, don't you? And I said, yes. I said, and they're always nerve-wracking because they always call me back in for more pictures. And that's the moment that a woman says, wait, did you see something bad? And they would always say to me, no, it's just hard to see anything because you have such dense breast tissue. And with that, Dr. Susan Love said to me, oh my gosh, then you have to also be getting ultrasounds. And had I not been sent on that interview, I wouldn't have known to get that ultrasound that day. And I'm not being dramatic, but I probably wouldn't be here giving this testimony today, because I was diagnosed with a very aggressive kind of cancer, triple negative, which didn't have any treatments at that time other than a year of aggressive chemotherapy. And when I realized that I didn't understand the risk of dense breast tissue, which, just under 50% of women in America have dense breast tissue, I realized that there was a real need to go out and educate women. But this, to me, what we're talking about today, from your standpoint, you have to look at it as an expense issue. And the expense of taking care of women with metastatic breast cancer who got their breast cancer diagnosed in late stage because they didn't have any of these diagnostic tests early on when we could treat them, it just makes no sense at all from an expense point. The more we can find women's breast cancer early on, the less insurance companies will have to pay for that long, expensive kind of medical therapy to try to keep women alive later.
Great, thank you very much.
My pleasure.
Thank you. We have Representative Meskers.
Joan, I want to thank you for your testimony. You probably don't know it, but we've probably been chasing each other for a number of years. I grew up in Mamaroneck, and now I represent Greenwich on the shoreline. So I thank you for the advocacy. I already mentioned, and it's funny, I mentioned and threw a shout out for my mother who turns 90 today. But when I was in high school, she was diagnosed and had a radical mastectomy. And today she turns 90. And when I think about the importance of the healthcare in avoiding the risks, I mean, you know, she suffered horribly, and thank God she's been a survivor of it. But anything we can do to preventative medicine, I think is so important. And to make the testimony you did, it meant a lot. So thank you very much.
And if I just may take just a moment, one of the things I will tell you that really set me on this path of advocacy is that my father was a cancer surgeon. But back in the 50s and early 60s, we didn't have chemotherapy, we didn't have radiation. All there was a radical mastectomy. And I always thought I would grow up to be a doctor just like him, because people used to always stop us on the street and they'd hug him and they'd thank him for saving, you know, their wife or their mother or daughter. And to me, that's what I wanted to be. But I went to work in a hospital that he had helped to found. He was actually killed in our private plane coming back from speaking at a cancer convention when I was only 13. And I learned pretty quickly that scalpels were not going to be part of my career. But in becoming a journalist, it became my passion to disseminate information, to help others stay healthy. That was kind of my way of carrying on my dad's legacy. But when I was diagnosed with breast cancer, that was like an opportunity dropped in my lap to really take the baton from my dad and go out and help other women who were diagnosed with cancer. And I've been all over the United States speaking. And I have found that most women, when I would go into a luncheon, didn't know anything about dense breast tissue. So, you know, this is important education. And I know that's not your mission here with this particular committee, but again, the more women we can get diagnosed in early stage and the more we can find out and allow them to have an ancillary test, since you can't always see breast cancer on a mammogram if they have dense breast tissue. It's the smart thing to do, in addition to the fact that it's the human thing to do to save lives.
Well, thank you very much again.
Thank you.
Thank you, Representative, for sharing that. Senator Wong.
Thank you, Madam Chair. Ms. London, thank you for joining us. Personal stories are really the most powerful. And thank you for taking your time to share your thoughts and experience. And it is important that women of all ages and husbands, sons, and support significant others need to understand that it's a total team effort. And it's the support and the encouragement, the allay of fears. You know, you saw Mr. Kritzman, who's a big supporter. He was as happy as could be, but he was smart right beside her. But can I ask of you, you began your testimony by saying the words that none of the people want to hear is, you have cancer. It's a jolt. And it's something that I don't think anybody ever wants to be a club of. But can you share what you did afterwards to the resolve, the redirected focus that you were going to go through the painful chemo and whatever was necessary with a the triple stage 2 triple negative?
Representative Meskers,
if I may, just if you could share what your resolve was as you went through that difficult journey.
Well, I think it's actually an important question because, you know, here I was a journalist, but I had actually not gone through this journey with a friend or a relative. So I didn't really know that much about it. And in fact, when I went to meet with my breast cancer surgeon, Dr. Barbara Ward, right there at Greenwich Hospital. So amazing. She saved so many women's lives. And she said to me with kind of a doom and gloom, well, have to tell you, you have triple negative breast cancer. And at first I thought, well, that's good. At least I'm negative to 3 things. And then she informed me that that meant that I didn't have any of the 3 normal kinds of breast cancer for which there was targeted treatment. And this meant that I was going to have to undergo months and months and months of aggressive chemotherapy and then radiation and surgery. And so I went to one oncologist and got one kind of diagnosis, which was kind of the standard of care. And then I went to another doctor and got a very different kind of suggested treatment. And that is the one I went with because I felt that it was really the latest and greatest. And it wasn't necessarily the standard of care. Fortunately, in the past 7 years since that diagnosis of mine, which left me, in a year of treatment, you may have seen me on cover of People magazine, bald. And I admit that the first question I said to her, chemotherapy, does that mean I'm going to lose my hair? But, when you go through that kind of aggressive treatment, I just realized immediately that I needed to share my story. I think every time one of us shares our stories, other people learn, whether you're on a committee like this that can actually do something about it, or just with women all across America. They started learning from what I was going through. And since that 7 years ago diagnosis, the treatments that have come down the pike, the new tests that we now have we've had more advancements in research in the last 5 years than we've had in decades. And so now women can avail themselves of these new tests if they just get in and get that mammogram. And if we just make sure that every woman understands that if the mammogram can't see her cancer because of dense breast tissue, that she needs that ultrasound or that MRI that found my cancer, the ultrasound did, then we can help these women. They can then get this new test which studies their biomarkers, but that test is only good if it's at an early stage of their breast cancer. So again, the importance of getting all these women in and getting that early testing. Not only are we going to save so many lives, and we're going to save women from long, horrible treatment from metastatic breast cancer, but we're going to bring down the cost of healthcare, which is so incredibly important to this country. So to me, I'm out here as an advocate on a lot of different levels. And I went and testified in Congress. I walked the halls of Congress with Nancy Capello. And Nancy was the same as me. She didn't know she had dense breast tissue. She didn't know that was important. Consequently, her breast cancer got found at a late stage. She dealt with metastatic breast cancer and finally, was taken so young because she was just like so many other women and didn't understand what needed to be done. So we can help every woman from here on out if we just get them screened, whether it's for screening or diagnostic, and that's really important. And if they need that ancillary test, if they need that ultrasound or that MRI, let's make sure they're covered, because I have too many women who reach out to me all the time that say, I couldn't afford it, so I didn't get tested. And now here I am. Now I had to go in and I'm getting diagnosed in stage 4. It makes no sense at all.
Sorry, the mute button in Zoom is always tough to get a hold of. It was important that you said everyone, right? Because obviously the barrier of testing cost as well as travel and convenience is a prohibitive. Then there's a psychological aspect. There's some people just say, I'm too busy, or they just don't want to know. I know it sounds silly to say that, but I've learned and heard that as well. But when you say everyone, it's important that this bill considers being able to provide the aspect of testing, some of the mobile testing units that we've advocated in our cities, to be able to get access to communities that may not normally have access to these kind of pre-testing. So it's really important when you say everyone, that this kind of insurance coverage affords everyone in our society to get to the coverage, because there may be a socioeconomic divide if you put these barriers to testing at costs, right? Because, and then you talked about the genomics, which is another methodology that technology has afforded us, but without support and financial offsetting, you're not going to do that test, right?
You're absolutely right.
So I really appreciate and applaud you using your celebritydom to testify in front of us, beyond all the other medical experts and stories that, you know, I was so touched by Representative Mesker wishing his mother happy birthday, but also his willingness to share what impact that she has on him in regards to healthcare priorities, importances. So happy birthday to your mother as well, Representative Mesker. But when you talk about your celebritydom, not only are you talking to us as a legislator, but in this broadcast, you are touching people who would otherwise not want to listen to us, because sometimes I don't want to, right? But you're able to kind of articulate that so that someone says, oh, Joan London is on the committee. Let's go watch her. That they could hear the story and perhaps be motivated to get tested, to not only do the mammogram, to say we could do the ultrasound, and for other people to see, well, she went through it, and look at her as vibrant and as beautiful as ever. You know what? For those that may have been impacted by breast cancer, they have the belief to know that they will get better. And you also accounted for, and I don't know if you mentioned about the metastatic cancer process. It is a difficult story for many of us to want to acknowledge. But I have seen such incredible bravery of women at that advanced stage and metastatic. And I don't know if a lot of people understand is the fact that there is no cure. There is management. But the courage that those women and their family and loved ones go through, and knowing that there is no cure, is something that I have been touched by. Because in these kind of vitriol world where pettiness seems to sometimes take precedent, those are people that value every precious moment that they have. So I can't say enough how much I appreciate being able to meet you, but also you taking the time so that other women and other families, as they go through this experience, know that they can connect with you and do what's necessary for their best health. So, Ms. London, thank you so much. I really appreciate the opportunity to interact with you.
Thank you very much.
Next question is from Representative Farrar.
Thank you, Chairwoman. Ms. London, what a pleasure to have you. And I just wanted to comment in solidarity as a fellow woman with dense breasts. I hear you. I know so many friends and family in that same circumstance. And I have to say, to your point, if, you know, one of the things I've heard, and I'd be curious what you've heard as well, is for those of us that go for our first mammogram, which I was in that circumstance a couple years ago. And to tell you the truth, I started my mammograms a few years early because my wonderful aunt passed away after many years due to a fight with breast cancer. And that's why I started, as you noted, you know, screenings early. But when I had the conversation with my doctor about pursuing that follow-up test, even with these, you know, potential genetic factors, right, that I have, you know, there was still that additional cost, right, that I had to look into, and someone was brought up before. It wasn't just calling my insurance company, it was calling the provider, you know, going back and forth several times. And I think, you know, I'd be curious to hear, I think in my case, you know, I saw firsthand how much effort really went into what was a necessity to get this follow-up test and really understand, you know, what the financial and, you know, barriers were for me and my family. And I just wanted to hear from your perspective, what you've seen, particularly for and heard, particularly for women who are finding this out for the first time, and those barriers that can get in the way of them really pursuing that test. Because I know for myself, it took a while, to figure that out and to really make sure that I could pursue getting that follow-up testing that was needed.
There's so many barriers of getting women tested, and I'll just lay a couple of them out. I went because I know I was supposed to. However, I didn't think I was ever going to be that, 1 in 8 women that will be diagnosed with cancer in their lifetime, because I didn't know of any breast cancer in my family. And had I known that less than 15% of women diagnosed with breast cancer ever had a family history, I would not have felt so immune. So while it's really important that we know our family history, it's also important to know that just because you don't have it in your family does not mean that you can't get it. And besides that, back in the day, this used to be a situation where when women got breast cancer, they wouldn't tell everybody. I mean, I know women who have not told their children that they went through radiation and a lumpectomy. And, now that their children are older, I mean, I've gone to them and said, you must tell these young men, because when they get married, when they have children, it's not only up through the mother's line of heredity, it's up through the husband, the father's line as well, that tells you what your risk is. So the second thing is that, it's been shown that women don't want to, the number one reason women don't go to the doctor is because they don't want to take their clothes off and step on the scale. I think maybe we need to take scales out of doctors' offices just to get women in there. There's also cultural barriers, and we have found, it's been found that in certain areas of the US that there is a reluctance to go in and have your breast examined. So just to make something known, dense breast tissue cannot be determined by how your breasts look or feel. If you have lumpy breasts, that does not equate to dense breast tissue. It can only be found on a mammogram. And we've seen mammograms recommended that they be started at 40 years of age for a long time, and many do a 35-year-old kind of screening before. And then in the last 2 years, we saw the American Cancer Society kind of bend to pressure to move that back to 45 and saying that if you're over 50, you should only have it every 2 years. That's a terrible recommendation, because we are seeing women diagnosed with breast cancer younger and younger and younger. And I hear from women all the time in their early 40s being diagnosed with breast cancer. So if we followed that recommendation to wait until 45, I mean, don't their lives matter, from 40 to 45? And the idea of waiting every 2 years, if you had an aggressive cancer like mine, that would be a deadly recommendation. So we need to start those testings at 40 years of age. And if you have any kind of family history or any kind of risk factor involved, you will very likely need to be tested and screened far earlier than 40 years of age. So our whole effort here should be not to try to not pay for this or to delay testing. In order to bring down the cost of healthcare when it comes to women's breast cancer, we need to get women tested sooner and take away as many barriers as we can. And certainly the financial barriers are the ones that really hit women the most. So we gotta let women know that they can come in, that they can get tested, it will be paid for, and we will do everything we can to try to find that earlier, because otherwise it's the healthcare industry, it's the insurance industry that's going to pay, so much more later on. It's what ROI, the ROI makes no sense whatsoever not to test earlier.
Thank you, Ms. London. And to your point, my aunt was one of those women who was, diagnosed in her early 30s, right? And to your point, you are really in a scenario, as you said, that it should be about preventing breast cancer in our lives, in the lives of our friends, our family, our community members. And I also appreciated your comment, particularly on, how this is really about making it as affordable and accessible and as easy as possible. I mean, that's what we want healthcare to be for all of ourselves, but as you noted, so many folks who might have greater barriers to care. And I just want to thank you for being you, your authentic and passionate self. And I'm grateful for you taking time to be with us today.
Thank you.
Joan, thank you for spending time with the committee and sharing your story. We appreciate your testimony.
Bye-bye. I appreciate it.
Next up, we have Dave Jones, followed by Representative Gary Turco.
Thank you very much. Madam Chairperson, members of the committee, I just want to make sure you can hear me.
Yes, we can hear you.
Thank you. My name is Dave Jones, and I appreciate the opportunity to testify before you today. I served as California's insurance commissioner for 2 full terms from 2011 through 2018. And in that role, led the California Department of Insurance and was responsible for regulating an insurance market in which insurers collect over $340 billion in premium annually. The views I'm expressing today are my own, but I serve as the director of the Climate Risk Initiative at the UC Berkeley School of Law. I'm testifying today in support of Senate Bill 1047. Climate change poses physical and transition risks and potentially liability risks to insurance companies. And as California's insurance commissioner, I concluded that climate change in particular poses transition risks to insurance companies' investments in oil, gas, coal, and utilities. As the United States, through market decisions, technological changes, and policy decisions, transitions away from reliance on fossil fuels in order to address climate change, investments in fossil fuel enterprises face a significant risk of declining in value or becoming stranded assets. One of the responsibilities of an insurance superintendent or insurance commissioner is to make sure that insurance companies are investing in ways that hold value so that reserves are available to pay future claims. So the transition risks associated with climate change in particular have significant potential implications for the value of investments held by insurance companies. As a result, I required insurance companies transacting insurance in California to report to the California Department of Insurance annually their investments in oil, gas, and coal enterprises, as well as utilities. The department then made public the insurer's fossil fuel investments by insurance company in an online searchable database so that consumers, investors, and other regulators could have insight into the exposure of insurance companies' reserves to transition risks related to those fossil fuel investments. The purpose of this disclosure requirement, again, was to give my department, as the insurance regulator, but also the insurers themselves, greater insight into what they were holding in the fossil fuel sector and a better ability to address the transition risks associated with those investments. In 2020, the United States Commodity Futures Trading Commission issued its seminal report, Managing Climate Risks in the U.S. Financial Sector. This is the first time a U.S. financial regulator has looked comprehensively across the entire financial sector of the United States, including the insurance sector, at ways in which climate risks are posing systemic risks to the financial sector, as well as risks to individual financial enterprises. That report recommends that state insurance regulators require insurers to disclose and address climate risks, and that insurance departments at the state level take up as a part of their ongoing supervisory practices consideration of and addressing climate risk. SB 1047 requires insurers to report and disclose fossil fuel investments as well as their underwriting of the fossil fuel industry, and will provide the state's insurance regulator with information to evaluate insurers' exposure to climate-related risks on both sides of the insurer's balance sheet. SB 1047 also supports including climate risk considerations in the Department of Insurance's supervision of insurers, whether it's capital adequacy requirements or supervisory tools such as enterprise risk management and own risk and solvency assessments. This is critically important. So I appreciate the opportunity to testify and urge your support for SB 1047. Happy to take any questions that you might have.
Thank you. Any questions from the committee? Senator Lesser.
Yes, thank you, Madam Chair. And I'm still trying to figure out where my raise hand function is only a year into operating with Zooms. Mr. Jones, thank you so much for your testimony. This is a fascinating issue. And I know that Connecticut's insurance department has been long at the forefront of trying to scrutinize climate risk. This industry is more on the front lines of climate change than I think any other. And Connecticut's insurance department, I think, understands that and has worked with partners in places like California and also Washington State, where there are really visionary insurance commissioners who are looking to try to understand that. And I know my understanding is that we're well behind as a nation our partners in Europe, where there's been a lot of action on this front. A lot of the sort of the pushback we've received from the industry has been not on the subject, because I think the industry understands that climate change poses a huge risk to their underwriting, to their ability to do business. But there's been some question about uniformity. And so I just wanted to know if you had a chance to look at the language that we have and sort of understand how we can best work with organizations like NAIC to sort of move this conversation forward, while also championing our domestic insurers like the Hartford, who've really taken bold steps to try to address this issue. But how do we sort of standardize the reporting while also working to make sure that what we do is uniformly applied across the country?
That's a great question, Senator. And I do want to acknowledge the Connecticut Department of Insurance and your insurance superintendent's partnership with me and my department in administering the NAIC Climate Risk Disclosure Survey. The challenge with that survey is it's now about 11 years out of date. And what you're proposing in this bill would enable your department to embrace disclosure frameworks that have evolved considerably since the NAIC first put together its climate risk disclosure survey. For example, the Task Force on Climate-Related Financial Disclosure, which was a industry formulated framework, is now recognized internationally as the leading standard for climate risk disclosure and has been taken up by a number of global insurers, banks, and other financial institutions. So your legislation enables the Connecticut Department both to lead, but also to embrace disclosure frameworks that are more universally applied, and would enable Connecticut to continue to position itself as a leader within the NAIC in trying to encourage more uniformity across states in this regard. So I think the legislation does a very good job of setting a expectation with regard to what the department needs to do, but also giving the department the latitude as standards evolve, and also to pursue greater uniformity in reporting across states.
And would you agree, and through you, Madam Chair, would you agree that while there are a lot of states and non-state actors sort of asking for disclosure, that uniformity reporting is actually may be a benefit to the industry in terms of understanding reporting guidelines and understanding how to best understand their own risk? This is something that could be a potential benefit to insurers as they're scrutinizing their own risk, but also in managing regulatory compliance.
Absolutely. I mean, there's no question that what the bill does in requiring disclosure is a benefit to the individual companies as well as the sector as a whole. what I found when I was California's insurance commissioner and required disclosure was that many companies didn't know what they were holding on their books. They were relying on third-party investment managers, and this really elevated to the C-suite of the company the issue of climate risk and how it might manifest on their balance sheets. And so we got a lot of favorable feedback from companies. And I think also, if you look at what's happening internationally, global insurers are embracing not only disclosure, but commitments to address the risks they're facing, both on the underwriting as well as the reserving side. So I do think it's a benefit to the industry and the sector as a whole.
I saw something interesting on the news this week. I guess the state of North Dakota is now exploring creating a public option for coal mine insurance, because coal mines in that state are having trouble purchasing insurance because insurance companies have made the decision not to underwrite coal mines on a voluntary basis. Is that something you know anything about? I just thought it might be an interesting thing for those of us on this committee to consider.
I saw the same report, and there was apparently a hearing in the North Dakota legislature on the issue of the declining availability of insurance for coal. I think what that represents is an increasing number of insurers concluding that insuring coal also helps to continue an industry that's a major contributor to greenhouse gas emissions, which in turn is driving catastrophic weather events and other perils, wildfire, drought, flooding, sea level rise, you name it, which then are showing up on the underwriting side of the insurer's balance sheets. And so a growing number of insurers are concluding that it's really not in the industry's best interest to continue to provide that insurance.
Thank you, Mr. Jones, and thank you, Madam Chair. And I understand you may have a tight time constraint, so I appreciate your time.
I'm happy to stay on and answer as many questions as the committee might have.
Thank you. We do have another question from Representative David.
Thank you very much, and Madam Chair, and thank you, Mr. Jones. I'm a former California resident and Bay Area person. So thank you for your work that you've done to California over the years. I am very intrigued by this bill as well. And I guess I grew up in the auditing world. And so in looking at some of the things, they're easy to be able to, assess how we can how this bill would work. But some of the questions I would have, and just wanted your expertise, are some of the more subjective things. Things like, it says the degree in which such insurance investments are exposed to climate risk. Coming out of the audit world, you would probably just give a huge blanket statement saying, climate risk is an issue, but how would you suggest for, like in California, for example, how would you suggest that insurers quantify this so that people have a real understanding? Because it's one of my concerns about this bill is it's pretty subjective.
That's a great question. So there are forward-looking tools that enable insurance companies as investors, as well as banks as lenders and other financial institutions, to essentially run climate change scenarios against their investment or lending portfolios and ascertain, based on those climate change scenarios and a number of important models that basically translate those climate change scenarios into financial impacts and physical impacts with financial impacts, to see to what extent the lending portfolio of the bank or the investing portfolio of the insurance company is aligned or misaligned with the climate change scenario. And that provides insight then into the degree of risk that particular asset classes might face, whether it's coal, oil, gas, utilities, or cement, or the automotive industry, for example. So there are tools available. And one of the things that we did at the California Department of Insurance was we partnered with one of the leading international developers of those tools, which has developed a model called the PACTA model and ran it against the investment portfolios of the insurance companies, and then provided to the insurance companies' CEOs a report that identified the alignment or misalignment of their investment portfolios with different climate change scenarios. The practice is evolving. It's not perfect, but the tools are getting better. And I think there's a general consensus, certainly internationally, and a growing consensus in the United States amongst the regulatory community that we don't want to let the perfect be the enemy of the good. And we have enough tools available to at least begin to assess to some extent what these risks are and make disclosures about them. So excellent question.
Great. Thank you so much. I wasn't aware of these tools, but I guess, like in other parts of the insurance industry, there's actuarial models that, run scenarios through things, and it was probably just a matter of time. Are you familiar, are any other governments around the world running these sort of models to help combat climate change in their jurisdictions?
Yes. So a number of other insurance regulators globally have begun to take up climate risk scenario analysis and disclosure. So the Bank of England and its Prudential Regulatory Authority, for example, in its 2019 general stress test of insurers included a climate risk stress test. The French Central Bank, which also regulates insurers, is implementing, as well as the French government, a broader climate risk disclosure law, which applies both to corporates and financial institutions. And that law, Article 173, has been in effect for about 3 or 4 years now. The European Central Bank, the Dutch Central Bank, the European Occupational Insurance Pension Authority. There's a growing list of national or international financial regulators that are requiring disclosure and are also taking up these tools. I think in the U.S. we've, as the senator mentioned a moment ago, we've been a bit behind in this regard, but you're starting to see considerable increasing interest and statements of moving forward by the Federal Reserve, the SEC, the Office of Comptroller of Currency, and others. And so this bill would position Connecticut, I think, where it should be. It's had a leadership role in the past in this issue, but also in alignment with what is happening both at the national and international level in terms of trying to make sure these risks are better understood and addressed.
That's great. I really appreciate you providing testimony today, because this is something that, I think there's so many of us on this committee want to explore more. And I think this bill is a good start, and hearing your testimony is really helpful. So thank you, Mr. Jones, for your testimony today, and hope you have a good rest of your day. Thank you, Madam Chair.
Thank you, Dave Jones, for joining us. We appreciate your testimony. Next up,
Thank you, Madam Chair, members of the committee.
Thank you. Representative Turco, followed by Robert Schoenberger.
All right. Good to see everybody. Representative Wood and Senator Lesser and Ranking Members Wong and Pavlak D'Amato and all the members of the Insurance and Real Estate Committee. I am State Representative Gary Turco. I represent the 27th House District, which comprises most of the town of Newington, where Senator Lesser also represents, and Representative Wood represents. So it's great to be here with you all. And I'm testifying here today in support of House Bill 6626, an act concerning required health insurance and Medicaid coverage, ambulance services, and cost transparency. And my comments for that bill are reserved for sections 24 to 28, which are the sections that have to do with early detection test for breast cancer. And you've heard from the great Jan Kritzman, who is a Newington constituent of mine and champion on this issue. And you've heard from Joan London. Both gave incredible testimony. It is a tough act to follow. But I'll fill in some details of maybe some things that they didn't cover, or some other things that I think are interesting for committee members to know about this bill and what we're trying to do here. And my mom is a 3-time breast cancer survivor. So, I grew up watching breast cancer and what it can do to families and to a woman, and seeing her struggle and surviving through it. And my mom was lucky because my mom was able to catch this breast cancer at a stage, even though she went through chemo and surgeries and a lot of difficult things, but catch it at a stage where it wasn't terminal, where she was able to defeat it and be a survivor. But many women do not. Now, here in Connecticut alone, in 2021, we will have over 3,000 women that will be diagnosed with breast cancer this year. We'll have a couple of hundred men that will be diagnosed with breast cancer this year. And it's estimated, going off of past year's data, that over 400 women in Connecticut will die from breast cancer this year. So we have more to do. And I know I worked with many of you, including the chairs, Minority Leader, former Minority Leader Themis Claridis, who was a leader in this issue, Representative Dorinda Mbora, and others. We passed landmark legislation in 2019 to mandate that there's insurance coverage with no out-of-pocket cost for ultrasounds and MRI tests for women. And these tests are used a lot, which you've heard from previous testimony, to detect breast cancer when a mammogram is not sufficient enough. And that's usually because a woman has dense breast tissue. And without these additional tests, a woman may not have the breast cancer detected at an early stage. And when it is detected at a more serious stage, it could result in death, obviously. As you learned, from Jan Kritzman, the bill we passed in 2019 was great. We've saved lives in the state of Connecticut. We've also saved a lot of money in healthcare costs. Insurance companies saved a lot of money because, as you heard, when you detect cancer in the early stages, the treatment and the surgeries and the hospitalizations and all of the costs that go into it is significantly less than what it will be when you end up detecting cancer at a much later stage. So we're saving money all around, and we're saving lives. That's a great thing, right? As legislators, I mean, that's what is more important than saving money and saving lives together? That I feel like if we can continue to do that, we're all doing our jobs well. Well, after passing that legislation, I got a lot of phone calls from women throughout the state and in my district of Newington saying, hey, I'm still getting a bill. I'm still getting a bill. It's still applying to my high deductible of thousands of dollars, or I'm getting thousands of dollars of a bill for co-insurance, or I'm getting my whole high copay. What happened here? So what this bill aims to fix, among other things, is making sure that we're mandating not just screening mammograms, MRIs, and ultrasounds, but diagnostic MRIs, ultrasounds, and mammograms. And the difference I've learned is screening is when you go in and you have no symptoms of breast cancer and you get a screening, and diagnostic is when the doctor already has seen something a little wrong, seen something wrong in the mammogram, something suspicious, or maybe there's a lump, and says you need an ultrasound. Now, does it make any sense to have insurance covered with no out-of-pocket cost when it's a screening, when a woman has no suspiciousness, and not cover it fully by insurance with no out-of-pocket costs when there is something suspicious? No, they both should be covered with no out-of-pocket costs. We don't want to give anyone a reason not to go get their ultrasound, MRI, or mammography when a doctor asks them to because they can't afford it, because it's only going to be more expensive. There's other things in this bill as well that are very important, such as making sure that those high-risk individuals, and this could be men and women, are able to get these important screening and diagnostic tests at an earlier age as well. So that's another important thing, looking for these preventative tests at an early age. So again, we've done some great work together in 2019, but we have more to go. There are loopholes here where women and men are not getting these tests covered, and therefore they're putting them off. And as a result, it could cost in things being more expensive. It could cost of death. And I don't want to see that for anyone else here in the state of Connecticut. So I urge this committee to please take a really good look at this bill, sections 24 to 28 especially, and pass it out so we can save more lives and save more money. It's a win-win for the entire state of Connecticut. Thank you for allowing me to give my testimony. And if there are any questions, I welcome them.
Thanks, Representative Turco, for your leadership and your work on this, and really bringing this issue to light in 2019. Questions from the committee. Representative Nuccio.
Good afternoon, Representative. How are you? Thank you, Madam Chair.
Thank you. Good afternoon.
I wanted to kind of talk a little bit about what you said about your residents coming forward with bills, and just point out the legislation that passed. The true problem with it is the legislation that passed is only applicable to fully insured plans. And that's about 30% of the people who are insured in the entire state of Connecticut. The majority of people are insured under ASO plans, and the legislation did not extend to that. So even if we were to make these changes here, I still think it's just applicable to fully insured. So that's where I struggle. Like, how do we expand that out? Because ASO plans are not administered by the Department of Insurance, and you can't dictate that. So the legislation that we're passing is affecting such a small portion of the people who need the services. So I just wanted to give you that little bit of information, because I was really happy when I saw that we had passed something too, and the press was that we passed, the payable for the whole process, but it's not, and that's part of the struggle. So that may be helpful to you with your constituents, and as we work to try to figure out how to make this applicable to everybody who needs it, and not just a certain selection of insureds.
Yes, Representative Nuccio, you are so correct. That is another issue, that despite the landmark legislation we passed here in Connecticut, those on self-insured plans instead of fully insured plans will not be able to benefit from this unless there, and my understanding is, a federal change. And that's what was so important about the Affordable Care Act, Obamacare, was that it mandated the requirement on the federal level for mammograms to be covered by all 50 states in insurance with little or no out-of-pocket cost for women. It did not go far enough and do some other things that are very important, like ultrasounds and MRIs. So you're right about that. There's still going to be women that are going to, and men that are going to be left out from this. But there were women that I spoke to that, again, and this bill will fix it for at least the fully insured, that they got their mammogram, MRI, and ultrasound, and it was coded as being diagnostic and not as a screening test. And regardless of fully insured, self-insured, that was not covered without any out-of-pocket cost.
Yeah, I agree with you. If we could get something federal, that would help with that, because it's hard to legislate the ASO plans, but I'm fully in agreement with you. So thank you very much for your testimony today.
Thank you for your questions.
Thanks, Representative Turco. Have a wonderful day.
You too. Thanks, everyone.
Next up is Robert Schoenberger, followed by Christopher Gallagher. Is Robert Schoenberger coming on? I know he had some technical difficulties. All right, is Christopher Gallagher available? Christopher Gallagher is up, followed by Deborah Kritzman.
Yes, thank you. Co-chairs Lesser and Wood, Vice Chairs Anwar and Comey, and the honorable members of the Insurance and Real Estate Committee. I'm Christopher Gallagher, Federal and State Affairs Consultant for the Obesity Action Coalition, which is the largest patient organization representing those affected by obesity. We have 75,000 members with over 1,100, which are Connecticut-based. Today, I'm going to talk about SB 1007, which would require broader health insurance coverage for bariatric and
Now, how are you going to get on? Later, but I can't get, I don't know.
and FDA approved anti-obesity medications. The OAC very strongly supports SB 1007. Throughout the past decades, the prevalence of obesity has skyrocketed across our country, with now nearly 30% of Connecticut citizens affected by obesity. Despite this fact, some policymakers continue to view obesity as a lifestyle choice or personal failing. These perceptions and attitudes have allowed health insurance plans to take vastly different approaches to how they cover obesity treatment, even in the age of COVID-19. I wanted to talk a little bit today about some of the policy statements that have been made by a number of groups, including the AMA, which declared obesity a chronic disease in 2013, and further policy encouraging that patients should have access and coverage for all obesity treatment avenues. This catalytic move helped spur other federal and state policymaking groups to do it. Following that, for example, in 2014, the Office of Personnel Management basically prohibited federal employee health plans from denying coverage for obesity treatment avenues on the basis that care, either obesity is a lifestyle or that treatment is cosmetic in nature. In 2015, the National Council of Insurance Legislators adopted its first ever disease-specific policy, urging Medicaid, state employee, and state health exchange plans to update their benefit structures to improve access to and coverage of treatments for obesity, such as pharmacotherapy and bariatric surgery. 2018, the National Lieutenant Governors Association basically said the same thing. And then late last year, the national organizations representing the Black and Hispanic caucuses of state legislatures adopted policy recognizing the health inequities in communities of color that have led to a disproportionate impact of COVID-19, and that states must address the high rates of obesity to improve the health of racial minorities and prepare for the next public health epidemic. And they encouraged legislators to take steps to address obesity in their own states by ensuring that their constituents, including those using Medicaid, have access to the full continuum of treatment options for obesity, including—
Excuse me, your 3 minutes has ended. Please consolidate your testimony.
Thank you very much. In summary, we support SB 1007, and we encourage the committee to support patient access to the full continuum of obesity care.
Thank you, Christopher. We have questions from the committee. Representative Dayton.
Thank you very much. Mr. Gallagher, I didn't see your written testimony. Did you provide any?
I did. I'm sorry.
Maybe I'm just missing it. I will have another look. Do you know if there's any studies about the cost of some of these longer term issues as a result of obesity, in terms of how much it's cost for, apart from obvious loss of life, for COVID, for example, for diabetes, other heart disease and other things? Do you know if there's any studies that show quantify the cost for us?
Yeah, I know we looked at some studies, for example, in Medicare program where anti-obesity medications are denied coverage. There is studies showing that if these medicines were to be covered over a 10-year period, the Medicare program could save between $18 and $23 billion. And in the sense of bariatric surgery, there are studies that show basically you can recoup the cost from a bariatric surgical procedure in roughly 3 years. And I'm happy to provide the committee members with copies of those studies. And I know people going after me are going to talk more in depth about that. So thus I was focusing my remarks on the policy statements of other groups.
Okay, yeah, I always get very interested on the sort of ROI, if you will, on these surgeries. I mean, obviously, you know, you can preserve someone's life, and we've seen how people who are obese have been adversely affected by COVID in the last year. But it is also interesting what these hospital stays and other sort of lifetime of medication and treatments for chronic diseases are costing America. So thank you so much for doing that. If you would forward that to our clerk, I'd greatly appreciate it. You can just send it to the same testimony email. Thank you for your testimony, and thank you, Madam Chair.
Thank you, Representative Dathan. Christopher, we appreciate your testimony. Have a great day.
Thank you.
Next up, Robert Schoenberger. I see that you have joined. It is your turn to speak. Hi, Robert. We can see you. Can you just take yourself off mute and we can hear you? Robert, you're still muted. Any of the staff can help him get off mute?
I am hitting the ask to unmute. It should pop up at the bottom for him.
Robert, look at the bottom of your
wait a
screen.
minute.
Yep, there you go.
Okay, you just got to do the right thing. I have this in regards to bill number SB 1046. And it's in regards to the long-term care insurance. And my name is Robert Schoenberger. I'm 88 years old. My wife is 87. And we purchased this insurance originally through Travelers, and then it got changed to Metropolitan, and then went to Bright House, or they separated it. And our premiums were level at $5,140 per year until 2017. After 2 rate increases of 18 to 37%, our premiums cost rose to $11,556. This does not include future overlapping rate increases or additional 25% that was approved last month. We live on a fixed income. This has caused financial and emotional hardship and stress. The rate increases are a calculated effort by the long-term care industry to force us to reduce our benefits or relinquish our unprofitable policies. We bought our policies promoted by the state of Connecticut partnership program. We bought the policies in good faith, believing that we were approved by and somehow guaranteed by the state of Connecticut. We attended several meetings locally in 2019 where the insurance company claimed insolvency. They have claims of insolvency been investigated to be true. If they are true, they should be the responsibility of federal government, and a significant number of seniors in my LTC advocacy group have dropped out because of the relinquished their policies for the past year. They gave us hope that a legislative solution would be passed and solve the skyrocketing rate increase. For every senior, that gives us up their LTC policy. The state Medicaid program would be responsible for pay for the costs of the LTC. I had peace of mind. I worry every day if I will be able to keep our policy. I don't feel that this program does enough to provide relief for the future rate increases. I would like to add some ideas to the included to strengthen the bill for consumers. They should have a cap on proposed to increase a cap on the rate increases of maybe 3%, eliminate some of the overlapping
Your
previous.
time is up. Please consolidate your testimony.
Thank you.
We won't listen to you anymore.
Robert, thank you very much for coming on and sharing your testimony. I have one question for you. When you say you bought policies that were promoted by the state of Connecticut, did that mean that you're a former employee of the state and that you found this policy as an employee?
No, this we did on our own. It was bought through a financial advisor back then, and they said that the state was well, they did some good things in it about not taking all your property if you didn't have insurance. So you would not lose your homestead.
Okay.
But the insurance is getting so high as you retire. You obviously know that the increases in we don't get that much extra every year from Social Security. So it becomes, these percentages get pretty high when you think of how much the bill is. I know it costs a lot for taking care of the people.
Nursing care.
The nursing care, I know that. But that's why I bought it, to save what I had.
Right.
And save the state to take care of us. So I'm lost for words, because I think the insurance industry or a company is not being forthright. I don't think they can say that they're going to close business, because they don't have all good insurance policies. They have some, like everybody else. You got some bad, you got some good, and they should cover each other. But these seem like they're just trying to close out the business. It seems like. So I don't know. Every year I go through the same problem of, should I reduce it? If I reduce it, I won't have enough. The problem that comes about is people with Alzheimer's or dementia. It becomes a longer term situation in a home. So that's where it gets important to us, because I certainly would have not like to use up all your assets totally. I know some people do, but we did do the right thing, we thought, in the beginning. So we've lost all the premium. If we decided to cancel, get out of the.
Right. Well, thank you for sharing that with us. We do have another question from a committee member, Representative Dathan.
Thank you very much, Madam Chair. And thank you, Mr. Schoenberg, for your testimony. I know my parents invested in this as well. My father ended up dying very early in life, so never got to use it, but it was really beneficial for my mom, who, as you pointed out, patients with Alzheimer's, which she had, it really did help her. But I think you raised some important suggestions, and I just wanted to thank you for your suggestions. And I do think this is something that we need to address in our state. And I appreciate you taking the time to highlight these things for us, because we do need to make sure that we protect seniors who need to use this insurance, and other seniors who are using this as what it's for, an insurance policy, so that you can have your costs covered. So I just wanted to say thank you. So thank you.
Thank you for listening.
Sure, of course.
Okay.
Thanks, Robert.
Bye.
Have a
Bye
wonderful day.
Bye now.
Next up, we have Deborah Kritzman, followed by Martin Hoyt. Is Deborah on? I don't see Deborah. So we will move to, I do see Martin. We'll move to Martin Hoyt, followed by Pavlos Papasavas.
Good afternoon, Representative Woods, Representative Pavlak D'Amato, Senator Lesser, Senator Wang, and all the other hardworking members of the committee. My name is Martin Hoyt, and I represent Christian Healthcare Ministries, or CHM. We are the largest and longest serving of the healthcare sharing ministries. We have over 800 members in your state. I want to thank the committee for raising Senate Bill 1041 and the critical issues that it addresses. Likewise, CHM is very actively committed to cleaning up the healthcare sharing lane, and we are appalled at some of the abuses and outlandish behaviors that are occurring by bad actors across the country in the name of healthcare sharing. And with that, I'm here to strongly support Senate Bill 1041 with a proposed clarifying amendment that I think would enhance the bill. Specifically, what we'd like to do is add a new paragraph C to section 2 that clarifies paragraph B, basically stipulating that selling, soliciting, negotiating, or administrating a healthcare sharing plan does not apply to a salaried person who's employed by a sharing ministry and does not receive any form of commission, compensation, or other valuable consideration based on enrolling new members. And then secondly, that a new member referral program limited to no more than 12 referrals would also be exempt. In short, we agree with the bill, and we see the agent issue and perverse incentives as contaminating sharing and creating consumer confusion. So our amendment simply clarifies the intention of the bill to ban practices that incentivize individuals acting in the name of the ministry to sell, negotiate, or operate a sharing plan. And we think it's excellent public policy, and perhaps the most important component of the bill to prohibit the use of insurance agents to sell memberships in a healthcare sharing ministry. We also are concerned or would like to clarify that as it applies to administrating a healthcare sharing ministry, that there are no, you should be allowed to draw a salary provided that there are no incentives to production or to enrollment or to negotiation of prices. I think there's a simple distinction. Otherwise, ministries would have a problem ceasing to exist if they were not able to pay a salary. So our amendment simply clarifies paying a salary is not included in the public policy prohibiting incentives tied to production of new members or any other aspect of sharing operations.
Briefly, 3 minutes is up. Please summarize your testimony.
All right. Well, I'd be happy to answer questions, but in close, for the reasons that have been addressed, CHM opposes the use of insurance agents by any healthcare sharing plan. We also oppose plans' use of incentivization of employees and frankly, anything tied to membership growth. And we strongly urge the committee to support 1041 with the amendment. And I'm happy to answer questions in detail.
Thank you, Martin. We have questions from the committee. Representative Pavlock D'Amato.
Thank you, Madam Chair. I know I spoke to you prior, Mr. Hoyt, and maybe this bill, the way it's drafted now, I think I'm just a little confused and maybe have to get some clarification from the chairs. People have been a little concerned that it prohibits them from existing these plans altogether. And I know that you had referenced another state's laws, and I mean, do you feel that this is prohibiting healthcare sharing ministries altogether, or is it?
Thank you. That's an excellent question. First of all, with the clarifying amendment that we're asking for, this would not prohibit that at all. The issue is whether you can operate with insurance agents or not. And some of these ministries are claiming that, oh, we're out of business if we don't use an insurance agent, and that's not correct. You have neighboring states that have similar requirements, and some of these ministries are continuing to operate in those states. It's a question of revenue flow and whether it's worth their while to be in the state if they're not using agents.
Okay. Well, I know it also it's not insurance, so it's not necessarily falling under the insurance statutes. So maybe it's the language we have is covering what we possibly can in the insurance committee as opposed to consumer protection. But I see your point with the agents. But do you think that the language as written, as far as plus your amendment, doesn't confuse people if they're using an insurance agent? I mean, to me, that's.
Well, if you're using an insurance agent, it's already confusing because, first of all, as Senator Lesser pointed out, how many of them have a divinity degree? And secondly, how many of these insurance agents really know whether the prospective client is going to be compatible with the ministry and what their spiritual outlook is, which is diverse. And then you have the monetary incentive, which I don't know if you've reviewed these across the country, but they're perverse. Some of these commissions go as high as 70%. And most of them are well above what an agent will receive for selling a qualified ACA plan. So there is a lot of incentive to direct them to a sharing ministry, regardless of whether they fit. And the training is not up to par to help the agents do that. The folks that are best trained to help someone join a ministry and answer questions are the people employed by the ministry. They can operate without agents.
Okay, I know I think I have your contact information, so I'll probably be reaching out for a little more clarification, but hopefully, I don't know if anybody else has any questions that maybe can help me and some others with some of this language. That would be appreciated. Thank you for your testimony.
Thank you.
Martin, thanks for joining us today. Have a good day.
Thank you.
Pavlos Papasavas, followed by Megan Moskowitz.
Good afternoon, members of the committee. Thank you for the opportunity to provide a testimony in support of Bill 1007. My name is Pavlos Papasavas, and I'm the president of the Connecticut chapter of the American Society for Metabolic and Bariatric Surgery. I've been a bariatric surgeon since 2001. And in my 20-year career, I have seen, talked to, examined, and provided treatment for thousands of patients with obesity. And I came to understand how complicated this disease is. This is a recalcitrant, chronic, understudied disease that affects millions. And unfortunately, some members of our society have a simplistic and naive approach to obesity and its treatment. There is no cure for obesity, but there are effective treatments. And some of our citizens do not have access to these treatments. I was talking to a medical director of an insurance company a few months ago who was denying care for one of my patients. And he said to me, tell your patient to go out and exercise and follow a diet. If I can do it, she can do it. And that is naive. That is ignorant. It ignores the underlying mechanisms of this disease. And we have to do a lot of work to change this kind of attitude. Bariatric surgery is extremely safe. It is as safe as gallbladder surgery, and it's very effective. It is the most effective treatment for obesity and its comorbid diseases like diabetes, hyperlipidemia, sleep apnea, fatty liver disease. We ask to provide access to this effective treatment for obesity that affects our minorities disproportionately. It affects people of color. It affects people in low income. And these are the people who are affected the most from the COVID-19 pandemic. We know that these minorities, these vulnerable populations of our state suffered the most from COVID-19. These are the people who have a higher rate of hospitalization and a more severe disease. And COVID-19 is very strongly linked with obesity. So this pandemic that we're dealing with now brought in the forefront the other pandemic, the pandemic of obesity of the last 40 years. I feel confident that we'll have your support in this very important bill, and will provide the gift of life, because these surgeries and these treatments provide more years of good quality life to our most vulnerable citizens of our state. Thank you for your time.
Pavlos, thank you for that testimony. Do we have questions from the committee? Great, thanks for joining us, Pavlos. Next up, we have Megan Moskowitz, followed by Peter Konchenberger.
Hi, good afternoon, everyone. My name is Megan Moskowitz. I am addressing the members of the Insurance and Real Estate Committee today in support of Senate Bill 1007, an act requiring health insurance and Medicaid coverage for the treatment of severe obesity. I work in the field of bariatric surgery. My background is that I am a registered nurse. I currently work for a bariatric surgery program for Hartford Healthcare. And prior to that, I worked as a floor nurse on a medical and surgical floor, taking care of both medically sick patients, many of who suffered from the disease of obesity and those corresponding comorbidities, as well as taking care of post-op bariatric surgery patients. My previous experience working on the floor in the hospital, we did sensitivity training, education on caring for the patients with the disease of obesity, education on weight bias, all to prepare us for working with that patient population. As a nurse, I did my best to practice with empathy, care, compassion, but looking back at what I know now, I realized that I did not have a complete understanding on what weight bias and stigma really mean. Now that I've worked more in-depthly in the field of bariatric surgery and I've had more interaction with patients with the disease of obesity and have heard so many stories, struggles, and journeys, I now have a better understanding of the daily struggles and what weight bias really does mean. Prior to COVID, I ran a monthly support group for patients both before and after bariatric surgery. In these support groups, we would have a post-op patient come and speak about their journey through weight loss and the surgery. Listening to those countless inspiring stories really showed me the amazing opportunities that bariatric surgery can provide for patients. In addition to all of these medical comorbidities that are improved or resolved as a result of weight loss surgery, what really inspired me were stories from patients on what we call non-scale victories. From being able to garden again, to playing with grandchildren, to being able to comfortably sit on an airline seat. Many everyday activities that we take for granted are real struggles for people with the disease of obesity. And hearing how much their quality of life improved as a result of bariatric surgery is truly inspiring and really highlights the importance of providing the opportunity for all patients who suffer from the disease of obesity to undergo bariatric surgery. Thank you for your time and consideration for this bill today.
Thanks, Megan. Any questions? Great. Thanks for coming and testifying.
Thank you.
Next up, we have, looks like Sabrina Marie. Oh, Peter is there. Sorry. Peter Konchenberger, followed by Sabrina Marino.
Thank you. Good afternoon, Madam Chair, and thank you and the committee for this opportunity to testify in support of Senate Bill 1047 on insurance and climate change. I'm an associate professor at UConn Law School, where I teach insurance law, and I help direct our Insurance Law Center. I am also a consumer representative at the National Association of Insurance Commissioners, and I have been in that capacity for 10 years. I am speaking today, however, in my personal capacity based on the work I have done in this area, and not on behalf of these organizations or any other association. I support this bill for three primary reasons, based on the vital role that insurance and insurers play in addressing climate change. First, and this is insurers' role as investors. As we know, insurers collect billions, many billions in dollars of premiums each year, and they're required to set aside a significant amount of this money to pay for claims that may occur months, years, and sometimes many decades later. These investments are closely monitored by state insurance departments, and they have been for many years. And like other financial institutions, insurers therefore are major investors in our nation's economy, as well as the state of Connecticut, certainly, in addition to the employment. Since these reserves are closely reviewed These new reporting requirements that are in SB 1047 will provide essential information that otherwise is not available, and to determine how insurers are managing their risks. And it's also well in line, as I mentioned, with regulatory practices. While these particular requirements may be new, the ability of states and the need for states to understand how insurers are investing their money is not. The second reason is in their role, insurers' role as the world's risk managers. I wish I had coined that term, but I didn't. But I think it's very well, I think it's nicely characterizes the role insurers play in this area, but in many areas, but also characterizes that insurance is different. It's unique in this area, unlike other financial institutions. Insurers, as we know, are the experts in evaluating pricing and underwriting risks, and can do so with increasingly greater precision, whether through their own modeling or working with companies that can model down to the individual homes or businesses at times for risks of flood or other natural catastrophes. How they underwrite, however, is both a powerful tool for addressing climate change, where you can, for example, where will we insure a home? And at what cost will we insure a home? So a powerful tool for addressing climate change, but it is also essential for post-disaster recovery. The third, and former Commissioner Dave Jones addressed this much better than I can, and that is the insurer's role in addressing climate change has been well recognized throughout the world, as increasingly in the United States, including by the Federal Reserve Board and the NAIC.
Your 3 minutes are up. Please summarize your testimony.
Thank you. My only two suggestions are, as much as possible, is to align the reporting dates with the NAIC's Climate Risk Disclosure Survey, to reduce, the burden on insurers. And secondly, Connecticut Insurance Department, I think, will need additional funding or the ability to retain consultants to make their reporting possible and, fulfill the purposes of this legislation. Thank you.
Thank you, Peter. Did you submit your testimony?
Not yet. I will.
Yeah, if you could submit testimony, that'd be really helpful to us.
Thank you. I will, Representative.
Any questions from the committee? Seeing none, thanks for joining us, Peter.
Thank you.
Next up, Sabrina Marino, followed by Craig Floch.
Good afternoon. Thank you so much for having me. I just want to pull something up. Excuse me, I'm going to have to read from a prompt just because I do have a bit of an emotional story to share. My name is Sabrina Marino. I'm a mom, stay-at-home mom to 2 little boys, and my husband is an emergency department RN at the Hospital of Central Connecticut. I'm here today on behalf of our family and many like our own to urge you to consider this bill before us. Particularly the sections including insurance company coverage for cochlear implant surgery for individuals, including children struggling with appropriate unilateral and bilateral hearing loss. I am very confident that this will positively impact the lives of so many families, and especially children in Connecticut. My own son was implanted just before Thanksgiving, and we've already seen tremendous improvement and growth in his communication and motor skills. It is a little known fact that children with hearing loss also have balance and walking gross motor problems attributed to the vestibular aspect connected to their hearing loss. So he has made tremendous growth since then in all aspects. In addition to our own personal experience, I just ask you to consider that cochlear implant surgery is a necessary component of treatment to prevent further communication delays for individuals who have chosen listening and spoken language as their preferred communication. And I hope that you'll take the following into account with open minds and open hearts. I did submit in my written testimony a very detailed version of our story, but in short, my son was born hearing. He was born with congenital CMV, and due to that, he does suffer from profound hearing loss, which is progressive and lifelong issue that we have to worry about. 20 to 30% of children born with CMV will demonstrate mild to moderate loss, and 70 to 80% will demonstrate profound hearing loss. So this is something that many families struggle with. By the time my son was 1 year old, his hearing loss had progressed to the point where he was no longer receiving sufficient sound from a hearing aid. I think it is very important to note here that hearing aids are not equivalent to cochlear implants, which is something that insurance companies can't seem to understand. They believe that they are equivalent devices. And that was one of the reasons that some of the families that I've talked to have been denied, along with the fact that their children are under 5, which is why my son was also denied, and only deaf unilaterally. So because he was not bilaterally deaf, they felt he had sufficient hearing. It's crucial to note that it is acceptable and practice for children as young as 12 months of age who are not receiving benefits with hearing aids to be considered for cochlear implantation. And it actually is recommended for them to be implanted as early as possible since their brain is...
Please summarize your testimony.
Okay, in short, I'd just like to point out that other states are already putting these practices into place. In fact, there's also a federal act being considered, Allie's Act, with similar goals. Mandating this coverage would change the lives of so many families and children in Connecticut. And I am very grateful to be here today. And thank you for the opportunity to share our experience and hopefully answer any questions you may have.
Thank you, Sabrina. It's nice to meet you after emailing back and forth. I was wondering if you could share your insurance coverage story with us. Did you have to meet a deductible? Tell us about the cost to your family for this.
So at the time, the deductible actually is something that wasn't an issue. Our deductible had been met. Actually, we ended up paying a little more because it reset by the time that he got his approval. The issue was solely that he qualified for a hearing aid. They thought that he had enough struggle to give him a hearing aid, but he wasn't struggling enough to get an implant, I guess, because 1 year was sufficient. And he wasn't considerable for eligibility for an appeal or anything because he was under the 5 years of age, which confused our doctors because all of the surgeons and therapists and everyone we worked with suggested that between 12 and 24 months was the ideal time to implant him to allow his brain the time to adapt and learn around hearing the way that he would be. As hearing with a cochlear implant is not an amplified sound like you would get with a hearing aid, how we hear. It bypasses that part of the ear, the damaged part entirely, and stimulates your nerve in your brain. So it's more of a mechanical way of hearing, and your brain needs to learn how to do that. It doesn't just, you put on your cochlear implant and you're off with your life. It's a very intense process and needs to be started as soon as possible.
Great. And other families that are going through this, are they having to cover a lot of this cost themselves? Have you shared this with other families, or do you know any other stories that you can share with the committee?
There are a number of families who unfortunately would have liked to be here today, just couldn't make it work. But we did have a lot of testimony sent in. The biggest issue is getting it covered to begin with. There were so many families that are just straight up denied. It's not, for us, it wasn't a matter of what was left over to pay. It was not covered at all. And no surgeon is going to go ahead with a surgery that big and not get paid. And for other families, there is the struggle of maintenance and therapy after the initial implantation, because like I said, it's not a one and done deal. You don't get surgery and then you're hearing from then on out. the individual needs to go through extensive therapy to learn how to hear, to learn, in my son's case, because he's so young, how to speak. These are not things that happen overnight. And unfortunately, a lot of them are not covered, even if the initial surgery is.
Well, I'm glad to hear that your son is doing better with this implant, and I really appreciate you coming and sharing. Do we have any questions? Great, thank you. Thank you for being here this afternoon. Next up, we have Craig Flock, followed by Diana Good.
Hi, this is Julie Schoblum at Dr. Craig Flock's office. Unfortunately, he cannot be on this afternoon due to him being pulled into the OR.
Okay, did he submit testimony that we could read?
Written, yes, he did, and
Okay.
so did his entire staff.
All right, so we will do that. Thank you for sharing that, and we're sorry that we missed him.
Okay, thank you.
Diana Good, followed by Tom Swan.
Hi, everyone. Senator Lesser, Representative Wood, and members of the committee, thank you for letting me testify today. We are offering our support for House Bill 6626. Section 13 of the bill creates a requirement for insurance companies to provide treatment for gambling disorders, which addresses what we think is a huge loophole in the problem gambling safety net. My name is Diana Good. I'm the Executive Director of the Connecticut Council on Problem Gambling. So I want to start by saying that the Connecticut Council doesn't advocate for or against gambling. We are not the fun police. We are not here to tell people how to spend their disposable income. We just want to make sure as gambling becomes easier and more accessible, that there are safeguards in place. And one of those safeguards is definitely access to treatment. There are plenty of people who gamble and don't have a problem. We are not concerned about them. We are concerned about the people who gamble and develop a problem. One of the statistics that we use is if you live within 40 miles of a casino, the odds double that you will have a problem with gambling. Once the proposed gambling expansion becomes a reality and you can gamble on your phone, everyone will have a casino in their house. We currently estimate that there are about 100,000 people in Connecticut who have a problem with gambling. And if you include the impact to their families, that number increases to about 275,000 people. The way we break that down is approximately 735 individuals in 1,900 family members in each House district, over 3,000 individuals and almost 8,000 family members in each Senate district. With the proposed expansion, we think those numbers will just keep growing. So the issue for us is that although gambling addiction is recognized in the DSM-5, insurance companies can still choose to not cover that treatment. So a lot of times when a problem gambler finally raises their hand and says they have a problem, they are emotionally at rock bottom, they are financially at rock bottom. And then to have the insurance company deny their treatment and deny their claim is just another really devastating blow to them. We are hoping that this issue will be addressed before gambling expansion instead of after. So thank you for letting me talk today. If you have any questions, I'm here to answer.
Diana, thank you. Senator Lesser.
Yes, thank you, Madam Chair, and thank you, Diana, for your testimony. I guess I'm a little confused about your testimony. Certainly, I understand the problems of problem gambling. Innumerable constituents who've had their lives destroyed by it. But we have a number of laws around mental health parity. We passed one in 2019. We're actually getting new parity data from insurance companies starting March 1st of this year, and we'll probably be holding hearings on compliance. I guess I'm not sure, based on what you just said, that this is covered by the DSM-5, why coverage isn't already required by our parity laws.
We don't know either. All we know is that when our therapists are trying to get coverage, trying to get their claims covered for people who are problem gamblers, that the insurance company can deny it if it's used as a primary diagnosis. So we don't know the answer why insurance companies can arbitrarily decide to not cover problem gambling.
Okay, and have you had any conversations with the Connecticut Insurance Department to try to get to the bottom of that?
No.
Okay, maybe we could sort of set up those conversations to sort of get a good answer off of that. That would be great.
Thank you.
Thank you, Diana. Have a great day.
Thank you.
Next up, we have Tom Swan, followed by Diana Cantiello.
Good afternoon, Senator Lesser, Representative Wood, and other members of the Insurance and Real Estate Committee. My name's Tom Swan. I'm the Executive Director of the Connecticut Citizen Action Group. And on behalf of our thousands of members, I want to voice our support for Senate Bill 1047, an act concerning insurance and climate change, and Senate Bill 1043, an act concerning the Hartford Current. We believe Senate Bill 1047 is an important bill that will protect shareholders, policyholders, and the general public. We're not the only ones to think this. Last week, Moody's released a report that I'll link in my testimony I'm submitting. It says closer regulatory scrutiny of climate risk is positive for health insurers because it will push the industry to better evaluate and monitor climate-related risks. It will also support insurers in making difficult choices in response to climate risk, such as reducing exposure to certain profitable but carbon-intensive sectors. Our insurance department is already part of a compact with several states that insurers report their potential risk from climate change through the NAIC. We believe this legislation will have that information more readily available to Connecticut residents and stakeholders here, and hopefully in a more user-friendly manner. We also know that the California Insurance Department has successfully required, as you heard from Dave Jones, the disclosure of investments in fossil fuel companies. Their most recent data, though, is from 2017, and we know that the industry's approach to fossil fuels change on a daily basis. Last year, we did a state-based report that I'm linking in my study on the 2017 data. Our discussions with insurers leave us hopeful that they're beginning to see the need for change themselves. Just today, Bloomberg reported on a study from the International Energy Agency that found global portfolio of renewable companies posted an annual average return of 18% in the decade to 2020, compared with 4.7% for fossil fuel stocks. The total return for renewables during the period was 426%, more than 7 times the figure for fossil fuels. This is a fiduciary issue that stakeholders have a right to know. We applaud what is a groundbreaking clause in this legislation, where property casualty insurers will be required to report the fossil fuel projects they are underwriting. We believe this is a crucial step forward that can help guide future policy initiatives in both the private and government sector. We were happy to see a representative from the Hartford play an active role in the recent GC3 process, including advancing ideas
Your
for
time's
how
up.
we
Please summarize.
Okay, I'm just about that. How we finance efforts related to climate change. The irony was not lost on us. Well, they were looking at items financed by means other than insurance, while at the same time underwriting some of the most destructive projects and companies in regard to climate change. This is similar to what I said. In closing, I want to also voice our support for Senate Bill 1043 related to Hartford Current. What Alden Global Capital have done and will do if left to their own devices is unconscionable and a threat to the public's right and need to know. We believe the fact that the corporate charter is included in state legislation, you have additional leverage than over most companies, and we urge you to use that in every way possible to protect the public's right to know and a free media. Thank you.
Thank you, Tom. I was wondering if you can elaborate a little on the Hartford Current piece. Do you know, can you elaborate on any sort of layoffs or moving services out of Connecticut that you can share?
I mean, I did. If we were in session and going to testify in person, like most years, we could be seeing the big for sale sign on the Hartford Current. They've cut down on staff, I believe, since Alden Capital by about 20%. There are others that can speak about that. They're not covering local communities. They're not offering the same level of coverage of the legislature. I remember when I started, I think there were 4 or 5 reporters dedicated full-time to here. And what they're doing in terms of just ripping it apart and selling it, it represents the worst practices that that hedge funds are feared for doing, and it's doing it at a real public cost. And I want to really commend this committee for elevating this issue and giving people a chance to talk about it. It's really important. So thank you.
Thanks for that. Any questions from the committee? Thanks, Tom. Have a great afternoon.
Thank you. Cute baby, Matt.
Next up is Dana Cantiello, followed by Penelope Abernathy.
Hello. Hi, everybody. Thank you, Madam Chairwoman, and the rest of the Insurance and Real Estate Committee. Appreciate this time to come forward to you guys. I was part of this last year, and you know, obviously we had to kind of put things on hold because of COVID, so I appreciate this coming forward once again. My name is Dana Cantiello. I'm the nurse, I'm the nurse practitioner in Middlesex Health Medical Weight Loss and Bariatric Surgery Program. As a medical professional, I've met many patients affected by obesity. In the state of Connecticut, 29.1% of our residents are affected by the diagnosis and complications associated with it. That's up from 26.9% just last year. According to the Obesity Action Coalition, 1.7 trillion is being spent each year to provide care in this country towards obesity-related healthcare. Healthcare costs for individuals affected by obesity are 34% higher than the rest of the individuals. The obesity epidemic will continue to get worse as our children and adolescents are affected by this disease. Children in Connecticut, 2 to 4-year-olds, 14.5%, and 11.5% for ages 10 to 17 are affected by obesity. The Center for Disease Control provides funding to 15 states for training to help early childhood education settings with obesity prevention. Connecticut is not one of those 15 states. So if we can't prevent it, how can we treat it? So here's a fact I want to bring to your attention. There are several insurance companies in Connecticut choosing not to cover its insured population with an obesity diagnosis, and they will not approve life-saving procedures and medications. Again, let me repeat that again. Several insurance companies in the state of Connecticut are choosing not to cover its insured population with an obesity diagnosis and will not approve life-saving procedures and medications. So being a nurse on the front lines of obesity medicine, my professional opinion, this shouldn't be tolerated. This is not inclusive of coverage for all diagnosis. This is a prejudice of diagnosis. This is discrimination and exclusion because of a patient's weight and appearance. The state of Connecticut can become a proactive problem solver for its residents by mandating these insurance companies to suspend any practices of discrimination or exclusion based on size, weight, or appearance relating to obesity. There's a threefold increase in mortality for these patients. People living with obesity, 28.2% of their annual healthcare costs are spent treating obesity-related conditions. So why are insurance companies still denying access to treatment or surgery? I mainly work with medications, and I see a lot of post-op patients too. Medications approved for obesity treatment to reduce weight lead to a greater weight loss and increased likelihood of meaningful weight loss outcomes. And that's from the Journal of American Medical Association. So offering medical treatment for obesity makes economic sense as these individuals are at risk for developing additional costlier chronic diseases. Insurance coverage from medical weight loss management is not sufficient. These places an economic burden on the healthcare system as costs increase with disease progression. Some medications are completely excluded from insurance plans despite
that's 3 minutes. Your time's up.
Okay. Despite showing effective results. These medications can give you a 5 to 10% weight loss along with other lifestyle modifications. In this year, we as a state and country were dealt hard conditions associated with COVID. We know COVID and obesity are highly linked. So it is so important for us to treat the disease of obesity as a chronic condition, and it will help with those other comorbidities that these patients are dealing with. You're going to hear from a lot of our patients from our program today. They're going to tell you their stories. But truly, utilization of obesity treatment will generate Medicare budget savings. And I believe someone else had said this, 18 to 23 billion. We're going to get that money back in a 10-year period. So we need to act now. So again, this population is being readily stigmatized and now they're being denied life-saving care. So I urge you to support SB 1007, enabling this segment of our population to be fully covered by their insurance in order to obtain treatment for obesity, reduce or eliminate comorbidities, and to have a better quality of life. So thank you for letting me talk. I appreciate it. Thank you so much.
Thank you so much. Your testimony covered a lot of great points and we appreciate it.
Thank you.
Any questions? Dana, thank you. Have a great afternoon.
Thank you so much.
Next up, we have Penelope Abernathy, followed by Ellen Andrews.
Thank you for the opportunity to provide testimony regarding Bill number 1043 that seeks to prohibit the Hartford Courant from incurring debt or issuing dividends that are not in the public interest. By way of introduction, I'm Penny Muse Abernathy, the author of 4 recent widely referenced reports on the state of local news in the U.S. and the author of 2 books on digital business strategies for news organizations. Prior to becoming the Knight Chair in Journalism and Digital Media Economics at the University of North Carolina in Chapel Hill in 2008, I was a senior business executive at the Wall Street Journal, the New York Times, and the Harvard Business Review. I'm currently a visiting professor at the Northwestern University School of Journalism. Extensive research has shown that from our very earliest days, strong newspapers have played a vital role in nurturing our democracy, binding us together as a nation while also building a strong sense of community and regional identity. However, successive technological and economic assaults have destroyed the business model that sustained our newspapers for 2 centuries. Local newspapers today are in a perilous financial state. In response, hedge funds and private equity owners have swooped in to purchase newspapers at bargain basement prices. They then employ a standard management formula focused on aggressive cost cutting and financial restructuring, including bankruptcy. Most of these acquisitions have been financed with significant debt, usually underwritten by other investment firms. Profits from cost cutting are not reinvested in the newspapers they own, but instead used to pay loans, management fees to principals in the firm, and shareholders. Newspapers in the country have historically been equal parts business enterprises and civic institutions with special constitutional protections. Newspapers need to be profitable in order to stay in business. However, unlike the newspaper barons of the 20th century, many of whom were journalists, the hedge funds and private equity owners lack an appreciation for journalism's traditional civic mission. Their sole focus is on the finances. They view their newspapers as investments to be bought, sold, traded, harvested, or shuttered in order to maximize financial return. Over the past 15 years, we've lost 1/4 of our newspapers, 2,100, and at the same time, lost half of our newspaper journalists, with round after round of layoffs, greatly diminishing the newsrooms of the country's largest regional newspapers, including the Hartford Courant. Investment firms like to say that through aggressive cost cutting, they have saved local newspapers. While that may be true in some cases, many of the survivors are ghost newspapers, mere shells of their former selves. There is another way to save newspapers. My research tracks a growing number of independently owned newspapers, regional media companies, and digital sites that are investing in their communities as well as their newspapers by developing sustainable for-profit, nonprofit, or hybrid business models that embrace journalism's civic mission. Massive consolidation in the industry and the dominance of hedge funds and private equity owners has shifted local.
2 minutes, if you could please summarize. Thank you.
Yeah, I will. Has shifted local editorial and business decisions to owners without a strong stake in the communities where their businesses are located. Newspapers such as the Hartford Courant have historically provided the information that builds trust in our democracy and in our institutions. Reviving local newspapers in whatever form and medium they are distributed in the 21st century requires investment and long-term commitment to the communities where they are located. By placing limits on the use of debt, Bill 1043 attempts to reassert a balance between the Hartford Courant's profitability and its journalistic mission, between its business interest and its public interest. Thank you.
Thank you very much for your testimony. Questions, Senator Lesser.
Thank you, Madam Chair, and thank you, Professor Abernathy, for your testimony. I'm looking obviously this is a tricky issue because we are obviously dealing with an institution that, in the case of the Hartford Current, predates the United States. It's been around for over 200 years, and there is this question about the First Amendment, and I think the First Amendment is actually really important because when I see the U.S. Constitution, it puts the protection of newspapers, of the press, at the very front of the list of rights that we have. And looking at the legislative history of the Hartford Current in particular, in 1887, we as a legislature, at the Current's request, gave the Current a charter, again, because we saw as a legislature public value, overwhelming public purpose in having the residents of our area get access to timely and accurate news about events of the day. I mean, it seems like we have, throughout our country, seen the news as something we need more of, for informed citizens to be able to vote in elections, to know what's going on in their state. They need access to news. So I get the concerns that some folks have about us saying, reopening a charter that's been in effect for 150 years and encourage public purpose. But I'm also concerned that the problem with Alden Capital Management isn't that they're running their newspaper badly or that they're not selling the news. It's that they're not interested in being in the news business. That what they're really seeking to do is to sell off all of the assets of the newspapers that they're buying up. Is that really the concern that this bill helps to address? Is whether or not a newspaper wants to sell newspapers, or if they see themselves, in the case of this company, as being a real estate firm that happens to own some land that's valuable and having some presses that might have some value, having other assets that they can sell off. Because it seems like our business isn't in telling a newspaper how to operate, but it is in telling folks that we really want news of some kind, that the people who live in Greater Hartford should be able to know what's happening in the world.
Well, I think you raise a good point, and I think part of it depends on where Alden Capital is in its cycle. I mean, historically, they have used the massive number of newspapers they acquired in the early teens to basically offset losses they had on everything from investing in Greek debt to pharmacy chains in Canada. They have been one of the few investment firms that's been willing to sell off properties as long as you meet their price. Unlike many of the private equity firms that want to just sell them all en masse. So I think there is a considerable notion within various communities that are currently owned by Tribune that they want to try to buy back the papers and put them back in local ownership. And as I stated, there are some an increasing number of successful examples we can point to where that has happened. I think that it is I think it's also interesting that you're attacking it from the debt function, because leveraged debt has been, leveraging a company has been a tactic for both hedge funds and private equity companies since the 1980s. And that with a leveraged company, that increases the risk that you're paying off interest, you're paying off debt, and you're paying the management fees, the way this is structured, so that there's nothing really going back into investing in the newspapers. So, I mean, to me, I love the way that you have phrased it, public interest. There's extensive research out there now that shows that when you have strong local newspapers or lose a newspaper because it's very diminished, you have a decrease in voter participation because people just can't find the information they need. You have the cost of business going up for the governments, both locally and at the state level, because there's a lack of transparency and people questioning what you're paying for bonds and the like. You have a spread of misinformation that, because there's a vacuum on the social media, and into that goes misinformation. And then there's also a notion that when you lose a paper like the Hartford Current, that you actually lose the connection in the state. that people depend on the Hartford Courant as a regional newspaper to kind of bind together, not just Connecticut, but the region, in order to come up with policies that at the state and national level that save lives and avert disaster.
Thank you. And I do note that in addition to the accumulation of debt, there's another provision of it that allows the issuance of dividends if they're acting in the public interest. My understanding is that Tribute, the corporate parent of the Courant, has a large amount of cash saved up, which should be going into investment in the business, but that there is a fear that Alden may loot that in the form of a dividend. Is that something that could ensure the financial viability of the various Tribune papers, I guess, including the Courant? Something that
you're correct. Thanks for pointing out the large accumulation of cash. Right.
All right. Well, thank you very much. And I'm sure, I know we have a lot of folks who are interested in this bill, and there may be other folks. Thank the chair for this.
Thank you. I'm not sure who raised their hand first. Senator Anwar, are you available to speak? It looks like you might be testifying in another committee.
I can speak, Madam Chair. Thank you so much. I actually will quickly share with you. First, thank you so much, Professor Abernathy, for your testimony. I truly appreciate you sharing your experience. This is a phenomena that is at a risk of happening across the board. And because the news industry has become somewhat challenging in the print form, even the digital form has its challenges. So what would be the impact on a community when that happens, when we lose out on local and statewide news?
As I just mentioned, there's been tons of research over the last 5 years by many scholars in the university as well as industry researchers that have shown that voter participation has gone down steadily when you lose a newspaper. When you lose a newspaper, or when a state newspaper is significantly diminished. We have depended on our state newspapers, for instance, to vet the candidates for state office. And I mean, I don't know about you, I feel pretty comfortable as evaluating the person running for governor based on where they stand, even the attorney general. I'm less comfortable in North Carolina assessing who makes a good agricultural secretary, who makes a good auditor. So that has been a traditional function that we have relied on papers like the Hartford Courant to do. The second thing is that whole notion of just oversight, transparency, shining a light on it so that we know when there is an issue that we need to be concerned about. And then finally, there's the whole issue that newspapers have historically encouraged not only political growth and political resonance, it's also helped regions grow economically by identifying the issues that are important for long-term sustainability. So there are a whole raft there's a whole raft of research that says why every one of us should be concerned about the loss of a newspaper or the diminishment of a long-standing newspaper like the Hartford Courant.
Thank you so much for that. And right now, the challenge we are also having is that because of, as I touched on, the fact that this news business has become financially less sustainable. What are the models that are out there? Because the private equity model is not a sustainable model. Right. So what are the other models that make?
Well, my research has shown that there are three things that you need in order to construct or increase your chances of putting together a sustainable business model, whether that's for-profit, nonprofit, or hybrid. The first thing you need to do is in a community that has above average economic growth or population growth prospects, or is relatively, you can piece together a number of affluent businesses, individuals in that area. The second thing you need is you really need an owner or a publisher who has a mandate to identify and address the needs and expectations of both the residents in that area and the businesses in that area. That's real important because what we don't want is to get into a situation where you have to be wealthy to pay for access to the news. We want everyone in the community to be well-informed, and businesses play a key role through their sponsorships, through their marketing and the like, have historically done that in providing the news and information. And then thirdly, one of the mistakes I see of groups that, local groups that come together to buy a newspaper is that they tend to focus on the cost of acquiring the newspaper and not realize they need at least 5 years worth of capital to invest in transforming the business model so that it is delivered to meet the changing needs and expectations of the residents and businesses in that area.
And thank you so much. And my final question, Professor Abernathy, is now in the current era where social media has taken a twist in a direction which is pretty concerning about the external influences, and outside of the country, people are trying to influence opinion right here through various groups, and the town groups literally have influence from out of country. And in that situation, we need a trusted source. So, and historically, trusted sources have been very few, and Hartford Current has been one. So can you speak to that and the value for that for the communities?
Well, there's also abundant research over the last 2 or 3 years that points out how much of the information that flows on Facebook, on social media, even on Google, is aimed at the national level. So it contributes to, in many ways, the polarization that we have in this country. It's very easy to find more than 90% by some estimates of what circulates on the internet is of national consequence. We need to understand how a bill in Congress has local relevance to us. And that's the key role that a Hartford Current would have played. I have done analysis of local news that theoretically ran on Facebook's feed back in 2019 and 2020. And we found that it was preponderantly crime news that was kind of one-off, interesting, crazy crime, or it was kind of feature stories, of which none of that helped us make wise decisions about the quality of our lives that day, whether it was safe to go to the grocery store or not. And one of the very important functions of a trusted source like the Hartford is you have professionally trained journalists who adhere to professional standards and provide context around the news. So it's not just a rumor that appears as fact, it comes from a trusted source. So, you know, some people have said, why do you want to support a dying industry? And I said, I'm not supporting print newspapers, I'm supporting the important function that newspapers have played in our democracy in whatever form they're delivered.
Thank you so much, Professor. Thank you, Madam Chair, for allowing me to ask the questions. Thank you.
Thank you.
Senator Wong.
Thank you, Madam Chair. And Ms. Abernathy, thank you so much. I was reading through your resume and it's doggone impressive. And I guess you would retire, so congratulations on retirement.
Thank you.
Can you talk a little bit about the crisis on local news? I think you penned the phrase local news deserts.
Right.
What do you mean by that? I mean, I think we all see it as legislative leaders and running for elections in multiple towns. We see it, but can you kind of articulate it for our audience to really put it into kind of a clarity for us?
Well, my own definition has changed of what is a news desert. And let me just say, I'm not wedded to news deserts. It seems to have taken off. Some people call it news poverty. I initially defined it, a news desert, as a place that lacked a local newspaper. And as I said, we've lost a fourth or 2,100 of our newspapers in just 15 years. That's how dramatic the decline has been. And the reason I did is because newspapers have historically been the prime, if not sole source for most people of local news and information. Newspapers have historically had many more people employed as journalists than any other medium. So we depended on them to cover the local school board, to cover the county commissioner meeting that the regional televisions didn't hit, or that the radio stations didn't have someone to do. My definition has evolved considerably as I've mapped out where digital sites are located, what kind of coverage comes out of public broadcasting, and also where ethnic media are. And what I've come to determine is that a news desert is a place where residents have limited access to the kind of credible news and information that feeds our democracy. Does that help a little? I mean, so limited access can be in terms of lacking digital infrastructure to receive it. It can be limited access in terms of the information that comes across. And it can also be limited access in terms of not being able to afford it. I mean, cable bills can be $200 a month. And for many people, that's just not an essential part of what they are. So that forces them to their cell phones, where that forces them into looking for news on the internet.
The reason I asked that question is the Alden Global Capital business model is to leverage. And with the changing revenue dynamics that papers and news media outlets are experiencing, the first thing to go is local news.
Yep.
The local reporter that's reporting on Joe and Jill's school dance and things like that, they're the first ones to go. And we've been seeing that when, and going back to the purpose, the obviously germane issue to this bill is the fact that these big hedge funds with a different business model really have created and exasperated this local news desert that people have all of a sudden realized overnight. Boy, I miss that newspaper reporter coming down to the Girl Scouts cookie sale and the Boy Scout luncheons, you know? So that's why it's important for us to address this bill from that context. The other part that I wanted to ask of you is well, I'm going to make a pitch for you. People should take a gander at your major report. News deserts and ghost newspapers. Will local news survive? I think you did an incredible job in scaring people, in understanding what they realized they had. They will never know it when it's gone. And that's important. Your paper talks about not only from a local paper perspective, but also feeding the next generation of journalists and people who will read the news and understand that there is a much higher standard in regards to journalistic integrity, journalistic validation than what gets thrown onto a Wikipedia or a social media post. So we're losing that, and you put that beautifully in your report. So I'm pitching that because people should read it, because it's a loss of journalists. It's also a loss of people's expectation of reading the news. The other big piece that I was really impressed, and I'm going to read that later. I didn't get to read a little bit about it, is your work on strategic digital media.
Yeah.
Which kind of segs away. It's an interesting point you said. You're not per se talking about printed newspaper, but in regards to how you get news that's validated, that is objective, that has professional and high integral journalists being able to translate that. I mean, one of the examples I've seen is the New York Times, how they made that transition into the digital medium. Paywalls is a consideration, but then that annoys people. So talk to me about how we can look at the digital media as a business model that complements the tradition as well as the objective integrity and the incredible journalists that we have developed, not only up and coming, but the ones that we value and take for granted, that write such great news content with such history. How do you suggest meshing that without the interruption of a Alden that keeps on trying to squeeze revenue without understanding the important role that news has in our society and in our democracy?
Well, first off, thank you, Senator. That was a wonderful endorsement. And if I need a PR person, I know exactly who I'm going to coming back. I want to address a couple of things. One, when I first went to North Carolina after being at the Wall Street Journal, people said, when are you going to come up with a new business model? And I think that what we have to acknowledge is there was one dominant business model for newspapers over the last 200 years. 80 to 90% of the revenue that sustained our newsrooms came from advertisers, and it came in the form of print. There are a number of challenges to morphing into what you are, but I mean, what I say is there's not going to be one business model. There are going to be many, and it's going to be dependent upon the needs and expectations of the residents and businesses in that community. So I can point to several, as I mentioned, independent newspapers, smaller regional chains, or even digital sites that have done a really good job of understanding where they are located, understanding their community, understanding how people want to receive news, and what sort of news they're missing. It was very encouraging to me that in 2019, when the Pew Research Center asked people what they thought of what news was missing, more than half of the people said they noticed that there was much less local news that had occurred in the last 5 years that was relevant to them. And that syncs with what we've also seen from scholars who've looked at 100 different communities and found that on a typical week, at least 20 of the 100 had no local news whatsoever. So for me, as a researcher who's been banging this drum for the last 5 years, it's very encouraging to me that we finally got public awareness that something is slipping away. It's also very encouraging to see historians like Timothy Snyder talk about how our democracy depends on local news. The FCC, when it did a report back in 2011, estimated as much as 85% of the news that makes it into national headlines originates with local newspapers. And having worked at the New York Times, that makes perfect sense. So the newspapers that I have seen that have evolved into a different model, they're not just going for a digital model. They often have print products. They often have e-newsletters. They often have in-house digital ad services that help with the local businesses get on the internet and do a whole range of things. One of them, he actually owns an independent bookstore that has done quite well. It was losing money. And from that has encouraged him to think about e-commerce. It's encouraged him to think about being a community gathering place again, being kind of the town square, where you bring people together to discuss and debate important issues that are going to affect the quality of our lives and as well as future generations. So it is you really taking a holistic approach of what your community needs and what your civic responsibility is. That's what distresses me so much about the shift in what we've seen in the last 10 or 15 years in terms of newspaper ownership.
And your conversation is not just simply about the Hartford Courant, which this bill is germane to, but any of the numerous local papers that have all dried up, and it's such a painful loss. You lost a very good friend in some ways, and I will share with you, your national reputation notwithstanding, for you to take the time and do this, it's important for us to ask the question of why this bill is in the Connecticut Legislative Committee on Insurance, right? And I got to share with you, it's a really good question as I was debating it myself. And it is important to recognize the unique history that the Hartford Courant has in this country's founding and the ethos of journalism in this country. And if you will indulge me, the fact that to understand a brief history lesson, the Connecticut Courant was this country's oldest newspaper, right? It was actually founded before this country's origin. And in fact, the date was 1764. And the other interesting part is it had one of the first female publishers in the business.
It did.
And it had such an important role in the Revolutionary War. And if you studied history, as I love history, you realize what a special Connecticut gem we have and a great source of pride in the Courant. When you think about the important role they have in informing the public, going all the way back to 1764, talking about public, they published the Stamp Tax Act, which got people kind of getting started about our revolt against England, taxation without representation. Then we had the tea tax, which led to the Boston Tea Party, which is in our annals of history. That was reported by the Courant. And the fact, as I was reading through and doing my homework, that the Courant actually published the entirety of the Declaration of Independence after its release. Now, considering the act of uprising, if we had lost the war, they would have been considered treasonous. for publishing such a document.
Yeah.
That was, to me, even back then, the independence of the press to get the news out. So when we think about that power, the founding of this country, and the important integrity that we have for journalistic objectivity and transparency, it begins right with the current. And it's funny because we talk, well, it's a legislative issue, we shouldn't get into it, right? It's a private enterprise, etc. But would you believe in the same 1700s, the Connecticut General Assembly actually enacted a lottery to pay for the burnt down paper mill so that they can continue to publish and inform the people during the Revolutionary War. Can you tell I love history?
You've actually informed me. I thought I knew a lot about the Hartford Courant, but I've actually learned a few things here.
And we're so lucky that when we're in the General Assembly, it's right across the street, and the reporters are living legends in regards to. So to me, this discussion and you know, is so important beyond the third rail or a free market enterprise. I think we have an important responsibility to use the symbol of what the current stands, to preserve democracy, transparency in the news that dates all the way back to our founding of this country. And you would ask why, you know, perhaps maybe even as a Republican, why I wouldn't want to cater to the market forces. I will share with you, I look at the press as a treasured third rail. For me, growing up in a country where a supposed democracy was under martial law, we didn't have freedom of the press, freedom of the election, freedom of really understanding what opposition viewpoints are. We as an individual did not know any better, Ms. Abernathy. And perhaps we've been spoiled in this country because we've had the media to keep some degree of objectivity, whether you like it or not, right? The fact that there is an opposition viewpoint is something that we in democracy have a responsibility to protect and to maintain. So that's maybe for me, when I look at this as an issue, it's not just simply a business decision, it's protecting the integrity and the objectivity and the transparency of what goes on in our government. Because without sunlight, you know what? You know, power corrupts all. And we have a bad habit of trying to do it my way or no way. And the newspaper is our only tool in some cases when there's an overwhelming majority to be able to let people know that there are other choices out there. So I'm a big fan of the media from the standpoint of transparency, but I'm an even bigger fan what the current means to the state of Connecticut. And I really appreciate your time spent this afternoon sharing your perspective, but I would encourage other people, go read your report. It's really a compelling read. So thank you, Ms. Abernathy.
Well, thank you for the opportunity to talk with you guys.
Thank you, Madam Chair. I see you smiling there.
Thank you. No, this is a great discussion. Representative Nuccio.
Thank you, Madam Chair. Good afternoon, Mrs. Abernathy. How are you?
I'm doing fine, thank you.
I think I'm going to be the semi-opposition to my good friend Senator Wong here and ask for some clarification. It sounded like you were talking about, you know, to me, and I think you actually even mentioned the business model, you know, the matter of whether or not the industry has come up with a good business model. And I understand that local newspapers have struggled to switch to the online media format, which is just so sensationalized. And as you said, you know, it's so divisive. You know, I struggle a lot with where media lives and breathes right now. But so my question here is, I'm struggling with trying to understand what this piece of legislation is doing. So if the Hartford Courant is a business in and of itself, and it has been purchased by another business, that's a business transaction. And I guess I'm trying to figure out how legislators can get in here and then tell that business owner what they can and cannot do with the business that they purchased. So I'm truly, honestly reading the legislation. It's one page, and even reading it, I'm still not sure what it's trying to do. In essence of trying to protect the Hartford Current from something. So I was wondering if maybe you could give me some insight in your mind how this works.
Yeah, thank you for asking that. And the devil is always in the details. And my testimony is around the notion of what you're trying to do. So let me back up philosophically and make an argument philosophically, because I leave it to you very wise legislators to figure out the unintended consequences of things like this, because I think you always have to. I think that one of the things that has separated the press in this country has been that it is what I mentioned. It has been both a business enterprise and a civic institution with constitutional protections. So those constitutional protections have been used over time to support the press through subsidies that are enacted in the U.S. mail system, through supporting NPR and for what it does in news gathering. And so what I like about the way it is worded, and I leave it to you with the details, is that what you're really saying is, I want you to honor the tradition that a press has had in this country. It has had the ability to be both a business enterprise and make money. And it's also had a civic mission. So one of the ways to think about this is when the Hartford Current was owned by the Times Mirror Company, they were publicly owned and traded on the stock exchange. So many people worried, okay, there goes the business, right? All they're going to do is, there goes the press, all they're going to do is satisfy their shareholders. But as a shareholder, I had the option of knowing exactly how because it was publicly available information, thanks to the SEC, of knowing how the money was spent and invested, because they had to file quarterly reports, they had to file annual reports. So if I really cared about good journalism and cared about the newspapers that the chains owned, I would invest in Times Mirror versus some other options that I had. I would invest in the New York Times versus some other options. So what this is doing is simply asking that the hoard of cash that the Tribune Company currently has, because it sold off its TV stations, right? So it's debt-free there. That with Alden buying the stock, that it not undervalue the price they're actually paying for the Tribune Company, and then start selling off all the assets, but that any debt that is incurred or built up should be going back to the public interest. It's not saying that you can't do it for profit, because as long as it's a for-profit model, it needs to go for profit, but there needs to be some justification that it's honoring public interest. And if you look at the history of what Alden has done with large newspapers at its own, such as the Denver Post, there is a history of it going from a staff of 300 in a newsroom to down 2 years ago, it was about 60 in the newsroom. So, and that's a larger metropolitan area than even Hartford, I think, if I'm remembering correctly. And there are a lot of issues there. I mean, we have historically relied on state newspapers to not only deal with the local issues, but to kind of bind a state together by covering those big major issues around education policy, around environment, the whole things that kind of trickle across arbitrary political lines and kind of help feed that back up into the national system. So I understand what you're saying, but I would also say there's a 200-year history in this country of treating newspapers very differently, or treating the press very differently, because it is both a business enterprise and a civic mission.
So I guess then do you feel like this piece of legislation then is asking us to take additional steps beyond what we have constitutionally for free press to protect the not only the industry, but like if you look at the Hartford Current and the fact that they may have been flagging in the past and not doing as well, and maybe they don't have a good business model or whatever, but for the state to step in and then protect that entity, even though it's a private owned entity because of its civic obligation?
Let me answer that as I would when I was a senior business executive of the New York Times. When I had to make presentations to the board of directors at the New York Times, I made arguments not only based on why it was good for the business side and what it was good long-term, but for how that also was good for the mission of the New York Times, the journalistic mission and the civic mission that the New York Times felt to inform the country or inform people around the world. So, I mean, I don't see why the way it's currently written that it's asking a newspaper to do anything than what newspapers have historically taken on as their dual mission, that of making enough money to support journalists at the same time, or having enough money to support journalists at the same time, doing it in the public interest because it's a civic institution protected by the Constitution.
Okay, so then I guess the last thing I have then, because I really I'm not trying to be obstinate. I'm just really trying to understand it.
Questions, yeah.
So are we then just looking to tie the hands of Alden to not pillage the company? Is that what you kind of maybe see this as?
I think if Alden can make Alden has his own record, and I wish I could remember the exact quote, that they cared about the quality of the journalism that was produced in their papers or something, or they were the bastion of producing that. I think you're just simply asking them to live up to the statement that they made, and I'll be glad to send that to whomever, the statement that that came straight from Alden about why they wanted to buy the Tribune papers. It's something about how they cared so much about journalism in this country. I will even attach the editorial that came from the publisher and owner of the Little Rock, Arkansas Gazette, doing the same thing that I think your legislation is doing, is asking them not to strip mine its newspapers, but instead invest in the newspapers and care about the quality of the journalism.
Did they do that there? Did they respond well to that, or did they just
what's that? Well, the Little Rock, Arkansas Gazette is independently owned and operated, but has had the ability to go in and buy some of these newspapers and revive them that have been owned by private equity and hedge funds. It looks, that person is, I think he's third generation newspaper owner in Arkansas, and has watched with some dismay the management of newspapers, especially by the chains owned by the private equity and hedge funds, which by the way dominate 4 out of the 5 top largest chains in this country.
Yeah, I definitely think that there's a lot of oddity in media and news media across the whole spectrum, with only so many companies owning pretty much every news outlet out there. So diversity is definitely the better way to go, so you can actually get the news in an unbiased way, in my opinion. So which specific part of this legislation do you think is going to enable us to be able to hold Alden to that?
Well, I think it's simply asking them if they want to take on debt, or like the board of directors, simply to ask them if they're going to take on debt or pay dividends, that they show how it's in the public interest to do that.
If they're going to take on debt or pay dividends.
Yeah. And I think there is a danger, given that cash hoard, that, you know, Tribune has been very attractive because it does have a substantial cash from having sold off the television stations that have not been invested in the newspapers either.
Okay. Thank you. Thank you very much for helping me try to understand this. I appreciate it.
Great.
Penelope, thank you for your testimony and spending so much time with us today. We appreciate it.
My pleasure.
Next up, we have Ellen Andrews, followed by Jennifer Yu.
Thank you. Thank you very much for this opportunity to share the Connecticut Health Policy Project support of SB 1004 and 1051, acts establishing task forces to study insurance and healthcare in the state and to study medical practice ownership models. These bills are address important issues with profound implications for healthcare in Connecticut. They need deep focused study to measure the impact of changing market forces and make recommendations to protect consumers and taxpayers. One of the main drivers of rising healthcare costs in Connecticut is consolidation in the healthcare market. Consolidation is complex and it's getting worse. Connecticut's hospital markets are among the most consolidated in the US, and we have growing concentration in our physician market in Connecticut. The trend toward consolidation is accelerating because of the pressures of the pandemic, but it started long before COVID. There's considerable evidence that provider consolidation drives up prices for healthcare without improving quality. I won't go through that in my 3 minutes. While Connecticut has adopted some measures to promote competition in the marketplace, it isn't enough. And there are several legislative options available to improve the competitiveness of Connecticut's healthcare market. Other states have adopted many of these options, and it makes sense to convene a task force to consider them. Contracts are governed by state law and can have anti-competitive provider payer contract clauses and also provider health system contract clauses. Things like all or nothing contracts, exclusive contracting, anti-tiering or anti-steering clauses, gag clauses, I love that term, non-compete clauses, and in-network referral requirements all restrict competition. I did send in my testimony that describes these in more depth. It didn't get up on the website, but I'm sure it'll be there soon. There are regulatory options to promote competition. The state could require notification and approval for all proposed mergers and acquisitions, regardless of size. Multi-agency approval could be required for more complex approvals. And the review should include the impact on prices, volume of care, impact on market competitiveness, self-dealing and conflicts of interest, access to care, quality implications, referral patterns, consumer choice, community benefits, impact on underserved communities, health disparities, and the impact on state and local budgets and local economies. Too often mergers are approved with promises of improved, better outcomes, but there's no follow-up to ensure that those things happen or to monitor for unintended consequences. Even if harm is found, it's too late to do anything about it. Merger approvals should include enforceable conditions on the mergers as necessary to address potential harms identified in the review. Other policies that new payment reforms can carry incentives for provider consolidation. In fact, the accountable care organization model promoted by Medicare and others relies on consolidating providers into large health systems to save money.
Excuse me, your time is up. Please summarize your testimony.
Sure. Private equity is also a concern, not just for newspapers, and price transparency can help. In some, Connecticut's healthcare markets are increasingly consolidated and less competitive. Both the causes and policy remedies are complex and risk unintended consequences. The problem needs thoughtful public study and discussion in a task force of independent minds with diverse perspectives to find the best policy options to make healthcare more affordable. Thank you.
Thanks, Ellen. I'm always happy to support a task force that is functional and that actually comes back with suggestions for us to do the good work the following year. But I'm concerned that some of these may be redundant to work that is already being done out there. And I was wondering if you can't answer it now, maybe you can provide us with some other working groups that are, working on these things that we could look to for this, research, or maybe, you think, no, let's, bring that working group into this task force. I just want to make sure we are doing the right thing with the resources that we have going forward.
Right. The healthcare cabinet did just have a presentation by Katie Goodixon, I'm probably messing that up, from the University of California's Hastings School of Law. And she was excellent, and she helped me a lot with the testimony that I provided. But that's all that's happened. And there's been nothing, now it was just last week, I think, and nothing's come of it. This isn't really something that, unfortunately, it isn't really being talked about. We have a lot of task forces and a lot of committees, and I get that. And I'm not a big fan of task forces or committees. And it has to be done right. Like you said, it has to be functional and thoughtful, and it has to have good people around the table with lots of input from the public, Or it's, and I've been a member of these many times, and talking to friends, it's like, can we cut and paste from the last one we just did on this? But I don't think that's really the case here. I think this is a new problem, and I don't recommend a task force easily, quickly, or happily, frankly. But I do think that there is a need for it in this case.
Okay, and these are two very separate issues, so consolidating this wouldn't make any sense, correct?
With the healthcare cabinet, because the cabinet looks at so many other things, they might convene a work group. We did that on drugs at one point, but nothing came of it.
Great.
But it doesn't
Thank
exist
you.
right now.
All right, Senator Wong, you're up.
Thank you, Madam Chair. And Ellen, great to see you again.
Good to see you.
You said it very quickly. So you're testifying and not having your testimony. Just wanted to double check. Your comments were related to Senate Bill 1044, correct?
Is it 1044? Did I mess that up? I think it was 1004 and 1051.
Okay, I it's not on the agenda, so I'm.
Oh.
So, but let me make it easier. So you're talking about the task force to study insurance and healthcare in the state.
Yes.
So that's 1044.
Okay.
Okay. So and just your thought in reading the other testimonies, would you be opposed to having a Connecticut Hospital Association representative as well as other shareholders on this task force?
No, I think it's actually really important to have them engaged.
Great. Thank you for that input. And because that was one part of the testimony, then I believe your other bill was 1051, an act establishing a task force to study medical practice ownership models.
Right.
Right. So obviously there was a testimony feedback in regards to health insurance companies who also purchase medical groups. And what are your thoughts on that as a prohibition, or do you think allowing it is a good idea?
Yeah, it's definitely consolidating in, we have horizontal consolidation between hospital systems, and then vertical consolidation, with practices and nursing homes and such with hospital groups. I don't know, I guess we're going to need a third dimension to talk about this kind of consolidation. So it troubles me, I'll be honest. And it also, you'd probably need a spreadsheet at least to figure out the incentives when you have, part of the way the health system is supposed to work is that insurers represent payers and the people paying for it, and providers, want to provide care. And the natural tension there, when insurers start buying practices, that does get it's another form of market. I don't want to call it a failure. It's a market just distortion. And so I'm not going to say that it automatically is a problem, but I'd be watching it really quickly.
Well, I think as we've had many debates in this committee talking about how we contain health costs, I think you've been consistent as an advocate in saying that consolidation has not always been in the best interest of the consumer. And unlike business models, healthcare is a uniquely different model. You would think that with the vertigration of consolidation across the board, you would get efficiencies, but nonetheless, we see costs continually increase. And that's why I want to plug again and thank you for your advocacy and some of the suggestions for cost containment. And I know you come it from a consumer side and an objectivity side. And so your comments and thoughts are always valued. But I do wanted to point out that the two bills you're commenting on, that there are opportunities to make it better so we can get some better data points to address the issue at hand. So I want to take a moment and also thank you for your always committed work on behalf of healthcare consumers. So I'm a big fan. So thank you very much, madam.
And I apologize if I got the wrong agenda. I apologize.
That would be a rare time where I get you for me to be right than you wrong. So I'll take that. But nonetheless, I think that's the challenge, right? There's so many bills with numbers. I always say to people jokingly, when you start referring bills by numbers first, then you got me, because you're way over me in regards to being delved into these issues. So, but again, I want to take a moment to thank you for your tireless work, and it is remarkably consistent that we may not always agree, but I know you always have the interest of the consumer in mind. So as we move forward on future issues in this committee, your thoughts and insights are always valued. So thank you, Madam Chair.
Thank you, Senator. Next up is Representative Nuccio.
Thank you, Madam Chair. Good afternoon, Ellen. How are you?
I'm good. How are you?
I'm thriving. So I have a couple of questions for you. I was looking at the two bills that you talked about, and they're kind of different bills. And I was wondering if you could weigh in a little bit. The first one, I understand what everybody's saying about a task force, but I think if there's one area that we truly need to kind of focus in on, it's actually how to control the costs of healthcare. It's funny because we're the insurance committee. And we tend to talk an awful lot about insurance, but the actual driver behind insurance is healthcare costs. So the first one, 1044, is basically studying healthcare in the state. And I was wondering if you have an opinion on how you think benchmarking would help with that, and if you think that would be something that would really kind of help us hone in on the costs and how to improve those.
Yeah, two thoughts. I mean, I've raised concerns with the benchmarking. I love benchmarking, and I'm always big on getting new reports and data. However, I've had and so I was I didn't have a position on benchmarking before it started. I've been very concerned with how it's been implemented, how it started with the end in mind, and then it's trying to back into getting to a particular goal that was predetermined. And I still don't have, and I've talked to the people who were drafting it, and I still don't have a good sense of how they picked those numbers, how they picked those specific pieces. For instance, in one piece of it, it includes controlling costs, but then expanding, doubling primary care spending. They chose to exclude primary care that is provided by OBGYNs, women who choose to go to an OBGYN for their checkups, their primary care. I think women should have that choice. The OBs are trained and licensed to provide that care, and it's care that's being provided, so it ought to be counted. They chose not to count it. And the reason given was that if we counted it, we'd already be over the 10% that the governor said in his executive order. That's a stupid, I'm sorry, no, I'm not bad.
I got you.
If we have a problem with primary care, we should look at what those problems are and then get back to it. Just because places that do a good job with primary care spend more than 10% doesn't mean that throwing money at the problem is necessarily going to get us to a better primary care system. So I benchmarking, I don't have a problem with. I have a problem with this particular process that's happened. The second part of it is they are not looking at consolidation at all. Trust me, if they were looking at that, I'd be good. I would not be up for another task force I've got enough meetings that I already monitor. It's that they're really not looking at that as a cost driver. And when you look at the literature, it's really hard to miss. The other piece of it is that people get drug costs. They get that. Everybody gets that. They're out of control and they need to come down. That's easy. General public gets it. Policymakers get it. The implications of consolidation are more hidden, and hospitals are just different than drug companies. We all, go there. They save our lives. You birth there. You have friends who work there. They're huge employers in the state. It's different in terms of how people feel about it. Hospitals, that shouldn't blind us to the fact that their consolidation is having impacts on the premiums. We see premiums going up, but we don't necessarily connect it. And a task force can not only do a lot to drill down into these issues, because I've only spent the last week or two working about them, and I've learned that these are very complicated, and you could make big mistakes if you don't think it through well with really smart people. But it's also, I also think task forces can raise awareness about issues.
So I find what you said very interesting, because I think I am the least science person in my family. I'm a math girl, but even I know that when you're conducting research. You don't go in with a predetermined. You have a hypothesis and that's it. So, for us, the hypotheses should be what is driving healthcare cost, and then gather the information and then be able to delineate in that data what it is. So I'm a little concerned that you say that you feel like that's not happening, because I don't think we should be trying to drive an ending here. I think we should be striving to understand all of the levers and then how we can move them to make things better. So that's a little concerning for me now that you say that. And I wholeheartedly agree with you. A lot of these consolidations, I hate to use a word that people don't like, but they create monopolies. They create entities that dictate what their reimbursement is going to be. And if you do not comply, they pull their network and leave you without providers, a significant amount of providers in major metropolitan areas, in outskirt areas. So, and they are a main driver in healthcare cost. I don't think we can look at just insurance on this, or just the providers, or just drugs. We need to kind of look at a holistic plan on what we can do to bring the care of the cost of healthcare down. So if this task force could get at that, I don't know how you change what's already happening if there's already a task force. So you've given me a lot to think about with that one.
Actually, I think this is parallel to the cost cap. The cost cap is completely silent on consolidation. And what I'm talking about is actually focusing on just that part of the market. So it should be complementary to what's already going on. It doesn't have to be, duplicative.
Yeah, I do think there's a lot to look at there with the consolidation. We've got ample data to show what happens when you start having these consolidations across the country, not even just in Connecticut, but literally major areas, Florida, California, everywhere. So the information is there if we want it. And then on 1051, this one here, if I'm reading this correctly, is this the implication that, like, if you have a clinic that is run by an insurance company or something like that, is that what this is kind of going after?
I don't know what the intention of the task force was. The reason that it called out to me was medical practice and these clauses that are not only driving up costs, but also within, like, the AMA and the American College of Physicians are creating concern about the practice of medicine, and how, keeping referrals within a network. Suppose you need a particular kind of pediatric cardiologist and that person isn't in the network. They have really strong clauses in your contracts that you have to refer within the network. That might not be the right thing for the patient. It's also very obviously not competitive, but it's also harmful to patients' needs and choices. So I think that it's a bigger issue, and I think it is part of medical practice and ownership models. I understand now, talking about it like ownership by an insurance company, but I think that the contracts and the private equity firms, as well as some of the stories that I've read about that, are really disturbing, about how they are really decreasing and starving practices for resources to make profits, and then they end up being gobbled up by somebody else. They make them much more susceptible to consolidation. And I think that's another problem, but maybe it belongs somewhere else. I just saw these two bills, and this is something that's been bothering me, and it sort of seemed like it fit there, but.
Well, actually, what you just said makes a really good connection point. If you look at these models, and you're talking about, like, the medical practice ownership model and being able to only refer to in-network, et cetera, it's exactly what these major hospital consolidations are. Right. When they can say, we're going to pull us and every single one of our providers, including radiologists and labs and primary care physicians, it's a medical practice ownership model also. So you just made a good connection that I don't necessarily think the legislation was intending to make, or maybe it was and I'm just reading it wrong, but I think that's a really good point to bring up, Ellen. I appreciate that.
Well, that's my job, stretching.
You do it very well.
Thank you.
That's it for me. Thank you very much.
Thanks.
Thank you. Representative Comey, ready to to chair.
Yes, hello, thank you. Okay, so we are on number 25 out of 80 something, and we've been at it for 5 hours, so I'll go down for a long night. Next on the list, we have Jennifer Yu, followed by Robin Rourke.
Hi, good afternoon, members of the Insurance and Real Estate Committee, Representative Comey. Thank you for this opportunity. My name is Jennifer Yu, and I'm testifying in support of HB 6589. I am a general dentist and have been practicing dentistry in Connecticut for over 15 years. And at the end of 2013, I actually became a practice owner and a small business owner in Connecticut. Being a small business owner in and of itself is a challenging proposition, and the learning curve is steep. And during the first couple of years of owning my practice, I gained knowledge about dental insurance companies and the various strategies they're able to implement that can make it nearly impossible to provide great dental care for my patients in a timely manner. One of these strategies is called network leasing. Network leasing refers to a mechanism by which a preferred provider organization, or a PPO, can sell or lease access to their contracted provider networks and their discounted fees. So ultimately what happens is that a dentist who has signed with one PPO can find his or her name is part of an entirely different PPO. So they inadvertently agree to participate with potentially hundreds of PPO plans from across the nation. And generally, we are only made aware of this network lease after the patient has already visited the office, received treatment, and we therefore then receive their explanation of benefits. Currently in the state of Connecticut, network leasing happens without our knowledge or our consent. So not only is this unfair to practice owners, but more importantly, it can put our patients at risk. So when my office is unfamiliar with the new dental insurance that we've never encountered before, we are almost paralyzed because we have a lot of difficulty in giving our patients accurate estimates of their out-of-pocket portion for their dental care. Sometimes hastily, it can result in the office providing incorrect out-of-pocket expenses for the patient, leaving them with a surprise bill later. Or we can be completely transparent and we can tell the patients we don't know their out-of-pocket for a given procedure. And when this happens, when either of those two scenarios happens, patients are reluctant to move forward with their prescribed dental care. I have personal experiences of both situations in which we have told patients incorrect out-of-pocket expenses, or where urgent care was delayed because we could not accurately tell the patient their financial obligations. So either situation, in my opinion, does not serve the patient's best interest and can be damaging to the trust in the patient-doctor relationship. And I can share more about these particular situations if you'd like to hear more. So I am proud of the care that I give to my patients, and great care includes education and transparency in all aspects of their care, including the patient's financial obligation. If we could provide our patients with accurate information, we would have the confidence to tell patients what their out-of-pocket expenses are, make arrangements.
Excuse me? Can you please summarize?
Sure, and provide the care they need. So I'm speaking in support of the proposed bill HB 6589. It will give us a chance to have transparency, and it will give us an opportunity for us to approve or reject proposed insurance network leasing contracts. Thank you for the opportunity again, and I'm happy to entertain questions.
Thank you, Jennifer. It's good to see you.
Good to see you.
Giving great input on a lot of the bills that come before either this committee or public health in the past when I've been on that. So thank you very much. I have a question. Well, I'll jump right in. You did mention that you were concerned about the patient care aspect of that. Can you give me, besides transparency and billing, which of course with dental care, I think it's probably your number one issue with patient care, or choosing to get procedures done. What else? What sort of other situations have you?
Well, like I say, I like to be very transparent with my patients because it establishes trust, and that's what all of our relationships are based on. So in many instances, when we meet a new patient on an emergency basis, we're squeezing them into our already full schedule. And when we're unfamiliar with them and their dental insurance, we always have some homework to do on our end so that we can accurately tell them what their out-of-pocket is. So imagine being a patient, you're in pain, you have a tooth that either needs to potentially be extracted or potentially root canal treated, and you're having to wait to find out what your out-of-pocket is because you're on a budget. When we call these dental insurance companies that we are unfamiliar with, that we may have been network leased out to, a lot of times well, first of all, you have to try to reach a live person to speak to. So there's a lot of waiting on hold to speak to someone live just to get information about a patient's insurance benefits and what kind of coverage they may have towards certain procedures. So there's a lot of waiting time as far as finding that out. And, it's not always easy to treat these emergency patients and alleviate their pain same day if we cannot get this information to them. So that is something that we do encounter pretty frequently, and it's unfortunate that we're beholden sometimes to a patient's dental insurance when all I want to do is to help a patient. So I hope that answers that question.
Absolutely. And I know that when I get a procedure done, it's, I certainly don't know what will be covered and what won't be covered. And I rely heavily on the office, the professional staff to let me know what my options are as far as going forward. You had an impressive number, or there was a pretty impressive number of pieces of testimony, written testimony, I should say, on the website. And I was
Oh, that's great to hear.
Yeah.
It affects pretty much every dentist in the state, that because there are very few offices that are fee for service, meaning we can bill what our office fees are. We have to accept plans in order to be viable, and when we sign on with one PPO, the last thing that we're even aware of, in our day-to-day of running a business, is that we could potentially be opening ourselves up to a whole host of other PPOs that we're unaware of. And like I said, a lot of times we aren't, this information is not disclosed to us, and we don't discover it until after the procedures have been done and then an explanation of benefits comes to our office. So it's
PPOs would a typical office be accepting?
That's a good question. And I think that ranges depending on the type of practice the type of practice and what the provider chooses to participate in. But I am a part of a couple of PPOs, and even just being a part of that, again, it opens me up to many more that I'm not always aware of. So it makes giving our patients care in a timely manner really challenging. So
when you go to sign a contract with a PPO, I imagine the selling point is the amount of people that are on their plan, and do you negotiate your price as an individual business owner, or are you part of a larger group?
That is a good question, and I actually don't know a complete answer to that. But what I do know is that there are particular dental insurance plans in the state of Connecticut that have a set fee schedule for the whole state. So you don't get a say, or you don't have any negotiating rights or power. So what they offer as their fee schedule is what you accept. And again, I fully understand that when I sign on to a PPO plan with one dental insurance company, but I feel if I should at least have the opportunity to know if they're going to lease out our networks, and have the right to say yes or no to increasing my PPO patient base. So.
Thank you. I don't see any other hands, so I'm just going to keep asking my questions because this is fascinating. One of the testimonies that I saw was from the American Society or something of life insurance, American Council of Life Insurers, and they had some suggestions on. I think they understood the transparency issue, and they certainly see this happening across the country, is what the testimony said. They had a couple of suggestions on the notification requirements, and I'm just wondering, like they're saying something about you get notified every year when it gets renewed. And that should be enough. Is that
I know. I apologize. I don't have that testimony in front of me, but I think that is true that we renew every year. We renew annually, and we are able to review our contract. But it is still not disclosed to us as the healthcare provider whether or not our network has been leased. Does that make sense?
Yeah, I mean that's
yeah. So that's.
I don't mean to say it's a bait and switch, but it is sort of a transfer of services. So.
Right. So again, we are asking for transparency so we can be transparent with our patients. So I'm not, I just want the opportunity to at least know if something like that could happen, and also the potential to say yay or nay.
Okay. So I'm gonna, so if you could just, when you get a chance, take a look at that piece of it, the first piece of testimony on the list. They suggested a couple of changes to the policy.
Okay. Yes, I'll be more than happy to take a look, and I'll submit my comments.
Okay, thank you.
Yes, thank you so much. I appreciate it. Have a good day.
Thanks, Jennifer. Okay, next we have Robin Rourke. Is Robin Rourke here?
Yes, I'm here. Thank you.
Hi, Robin. Can I turn your camera on, or?
It keeps telling me you can't start your camera because the co-host had stopped it.
Let's see what we can do. All right, go ahead. You can continue on.
Okay. Oh, start my video. Okay, here we go. I'm okay now.
A nudge there. Thank you, Robin.
Hi, thank you. Good afternoon, Senator Lesser, Representative Wood, and all members of the Insurance and Real Estate Commission. My name is Robin Rourke. I'm from Ellington, Connecticut, and I am testifying in support of the Senate Bill 1007. I'm nervous, I'm sorry. I had bariatric surgery for the first time in September of 2008. I was slowly killing myself with food. I probably had about 200 extra pounds on my body. I had tried every diet and every plan sold to the masses. I had failed at everything I had tried. And then I had met Dr. Darren Tischler, and my life had changed. Dr. Tischler performed my lap band surgery in 2008. Prior to surgery, I had PCOS, type 2 diabetes, sleep apnea, high cholesterol, you name it, I had it. Within 6 months of my surgery, almost all my comorbidities had declined or disappeared altogether. Over the last 13 years, I've had to have 2 revisions due to medical complications, including reflux. Every day is a decision for me. Every day I must decide to eat correctly. Every day I must decide to exercise. Every day I must decide to put myself first. Obesity is a disease that is slowly killing people daily. Because of Dr. Tischler, because of bariatric surgery, I am healthy, I am focused, and I am fit. I have gotten my life back, and I've gotten my health back. Sometimes the saddest part is I am the same person 13 years ago, But being 150 pounds smaller now, I am treated so much better by strangers, by coworkers, by medical professionals, and the world on a whole. Obese people are made fun of, disrespectful, labeled lazy, and lacking of self-control. I am the same person I was 13 years ago, still driven, still as focused. Dr. Tischler knew he could help me. I decided with his help to save my life.
Thank you, Robin. Thank you for sharing your personal experience. Those things, it sticks with us, and this is one of those pieces of legislation that we hope can change lives for so many people. And thank you for taking the time to come and share your story with us. Do we have any questions? Seeing none, thank you very much, and we'll see you on the other side.
Thank you.
Okay, next on the list we have Rosanna Ruiz, and after that we'll have Dr. Flock.
The next person we have is number 29.
Oh, 29. Okay. Susan Regan, Professor Regan, you're up. I see her down there in the corner. I'm going to call again. Susan Patricelli Regan. You can unmute and put your camera on.
I'm here.
Hi, welcome.
I'm here.
We hear you. Go ahead.
Okay, all right. Thank you very much, Madam Chair, and the Real Estate and Insurance Committee for the time afforded me today to testify on House Bill 6626, specifically lines 74 through 81. The testimony today is for an act requiring insurance coverage for equine therapy for veterans suffering from PTSD. As president and founder of Foxfield Farm Corporation, a 501c3 nonprofit established in April 2016, I wish to testify to the value of equine therapy to be of substantial benefit to veterans with PTSD as a supplement to traditional clinical approaches. The website is www.foxfieldrecoverymission.org. The cathartic advantages of working with horses has long been established through successful results as experienced by those who have special needs and physical disabilities. I refer to the document that I sent to the Real Estate Insurance Committee on February 2nd, 2021, for which I provided in my written submitted testimony, which outlines the objectives of our trademarked equine groundwork program that offers a healthy alternative to treat PTSD and a prospectus relative to your committee's consideration. The benefits to the participants and Connecticut families are providing optimum options for our brave servicemen and women who suffer from PTSD and related mental issues, is fiscally oriented and prudent in our budget challenged state by capping the outside cost, lower cost approach that can supplement or even replace more costly clinical therapies and prescription methods. There is less risk, there is less stress, educationally trade-oriented, and functionally more enjoyable for the participants. For your current 2021 legislative session, we have provided a constructive financial solution to PTSD. And I did provide a proposal in my written testimony that outlined that exactly. In summary, our veterans deserve better than only one recourse because it's easier to keep medicating the patient, which only masks the issue, but does not solve it. An alternative equine approach may make all the difference between life and death. Thank you, and I welcome any questions.
Thank you, Susan. I know that you have some fans up here in the legislature for the work that you're doing with the veterans, and I know how important. I've done a little bit of work with and heard some stories from ECAD, which is the King Service dogs, and how they have been lifesavers for for our veterans. So it's great to hear that your farm is set up to do the same with horses. And I know it's really effective for kids as well, because we've
Yes,
seen
it
that
is.
as well.
Yes, it is. It's been a well-proven fact. We know that animals help everyone, particularly dogs, of course. But the horses are a special, there are special nurses that reach people. We've had people come here, we've had veterans come here, and literally within 3 weeks, their lives have been turned around and changed. They have had the ability, they've gained confidence. And I want to emphasize the fact it is a groundwork program. People ask us how about riding? I've taught hundreds of people to ride over the years, but you need to understand how to work around horses, how to work with them personally. From understanding them, then comes the confidence, because when you have the confidence, the horses relax, you relax. The therapy works. It's not something that's easy to explain, but it is easy to experience.
I love that, we're talking about alternative routes to better health. And I think that is definitely something that we should be continuing to explore as a healthcare system and as a committee here. So
I will share with, yes, I thank you for that. I will share with you that they have said that being with people with white coats on makes them nervous, and they have shared stories with us about their personal lives that they said they have never shared with any of their therapists or their doctors.
Wonderful. Thank you so much. Is there any questions on that or comments? Okay, well, thank you so much. And we appreciate the time you took.
Thank you.
Okay, next on the list, we have Mr. Nelson, Fraser Nelson. I think I saw him here, and followed by Darren Tischler.
Yes, it's Fraser Nelson, female. That's okay. So,
Sorry.
Oh, no worries at all. I'm here to testify on behalf of Senate Bill 1043. So my name is Fraser Nelson, and I'm reaching you all the way from Salt Lake City, Utah, where I led the transformation of our newspaper, the Salt Lake Tribune, to a nonprofit organization, the first such conversion in the United States. I'm now helping to build a new nonprofit called the National Trust for Local News, which is doing some of the work that Dr. Abernathy explained to you earlier today. Like the Hartford Courant, the Salt Lake Tribune has a storied history. And in Utah, as in Connecticut, local facts and stories and voices can and do change the way we live and work. From schools to elections, from the faiths we follow to the businesses we grow, from the laws that pass and the voices that are overlooked in the process, no community can know itself, and no democracy can function without a shared understanding of what is true and what isn't true. And like the Courant, the future of our trusted and local independent newspapers in our civic life was uncertain when Alden Capital purchased and immediately began dismantling the Salt Lake Tribune. Fortunately, we were purchased by a local philanthropic family, the Huntsmans, and Paul Huntsman several years ago made the decision to transfer the ownership of the Tribune to the community, and its survival is now the responsibility of all those in our state who value accurate information and the accountability journalism crucial to Utah's success. Paul's gift to our state is tremendous, but the future of the paper is in our hands. And I can assure you that the Tribune is thriving, and the community has taken its ownership to heart and to its wallets. We may have been the first to make this move to become a nonprofit, but we're far from the last. Just recently, we saw Stuart Bainium Jr. lead the nonprofit acquisition of the Baltimore Sun from the Tribune chain, which is itself being overtaken by Alden. Other very successful models of community ownership exist as well, from the benefit corporation model of the Philadelphia Inquirer to, as Dr. Abernathy explained, many small nonprofit digital first newspapers that are starting up around the country. The legal status, the revenue model, and the size of these examples vary, but we all share a common commitment, just like the Hartford Courant, to serve our communities. This is fundamentally the difference between community ownership and ownership by out-of-state fiscal interests. For too long, we have let the fate of established local journalism to financial firms focused on optimizing profitability, not serving communities. Urgent action is needed and solutions are emerging. Connecticut, no doubt, has plenty of residents able to financially support a nonprofit newspaper, and maybe a few of them are listening now. And as the legislature has the ability through this law to start that deeper community ownership by allowing any subscriber to sue the current if the company takes on debt or pays out dividends in a fashion that harms news coverage. I encourage your passage, and I appreciate the time today.
Thank you very much, Fraser. Senator Lesser.
Yes, thank you, Madam Chair, and thank you for your testimony. It's one of the nice things about Zoom is that you get to hear people from Salt Lake City a little bit easier. So can you talk a little bit about how the Huntsman family founded takeover was engineered? How does someone go about making sure that a local newspaper?
Sure. So what happened was the Huntsmans entered into a lengthy negotiation with the owners and bought the paper outright. So they owned it for a number of years, and Paul looked very carefully at the business models. And you can imagine it's the same thing that Dr. Abernathy explained so brilliantly to you earlier today. And he realized there really wasn't a financial future going forward. Now, the Huntsmans have a long history of philanthropy in Utah and understand well the nonprofit model. And Paul asked me if I would come on board and help figure it out. And what we did was we created a new nonprofit organization called Salt Lake Tribune, Inc. And the assets from Tribune LLC, which was the corporation that Paul created when he purchased the paper, moved into that new nonprofit. None of the liabilities were transferred, including pension, just the assets. At that point, we began business and as a new nonprofit organization, but we kept subscribers. We kept advertising. We were the first paper that the IRS approved as a nonprofit, and it proved it with both of those things in place. On the advertising side, we pay unrelated business income tax, but any paper will tell you they'd rather have 60 cents than none. And on the subscriber side, that is a program-related income. Just like when you sell tickets to the opera or the symphony or a ballet, you sit in the seat and you realize, hey, it's not just my ticket that's underwriting this. There's a lot of other money that's coming into it. So we also raised a real substantial amount of philanthropic dollars from readers, as well as private foundations that help support the transformation of the paper to the nonprofit and gave us that important piece of runway that Dr. Abernathy spoke about as well.
You have any, you mentioned Mr. Bynum's proposed purchase of the Baltimore Sun, and I guess there's been a little bit of uncertainty about that and about the whole deal. Obviously, we're focused on the Hartford Current, which is a Tribune property. Do you have any information about how that came to pass, or how that specific deal, became part of the conversation? Because I assume members of this committee would be much more comfortable if there were local ownership of the Current as opposed to Alton.
Yeah, I mean, I think it's probably not a journey unlike the Huntsman's family, where a very critical piece of not just the way that we function as a society in terms of the way we vote and understanding elections and school boards and the rest, but the economic health of a community. You know, needless to say, I've received dozens and dozens of calls from newspapers around the country. And one thing people say loud and clear is, if we lose our newspaper, we become a second-rate city. Who are we if we don't, we won't be able to attract new industry, et cetera. And I think that Mr. Bannon might be looking at some of those same economic outcomes, as well as, of course, all the civic concerns that he's mentioned. But it's something that he's been thinking about, from what I understand, for quite a long time. And he's recognizing both the economic impact as well as the civic. And mind you, these hedge funds are scooping up these papers because there is still value in them. They're not buying them because they don't make any sense economically. But I think with the right mix of philanthropy or local ownership or a change in digital strategy, they can become profitable, or at least profitable enough to be sustainable. Certainly not the kind of money that they used to make, but the civic value remains. I think you're on mute, sorry.
Yes, no, I was going to say thank you. That's great, and thank you so much, and thank you for sharing, a way forward from Salt Lake's experience. Maybe that'll be instructive in her.
Well, I went to high school in Simsbury, so it's fun to be virtually back in Connecticut.
Well, you're virtually welcome anytime. Good to see you. Thank you, Madam Chair.
Thank you very much. Thank you, Fraser, for coming. Oh, wait, we've got another question.
Another question? Sure.
Yeah, Senator Anwar.
Thank you so much. I truly appreciate Senator Lesser's questions as well. I just wanted to thank you, Ms. Nelson, for your testimony. And I think you're giving us a lot of material to think about and strategize as a community. And I think in the last many years, Hartford has given us so much. Now we have to figure out as a community, what can we give back? And I think this is what we'll have to think about a model. So this is going to make us all think. And I hope people who are listening with the nonprofit industry can learn from your example and experience. Thank you so much.
Well, we'd be happy to. The National Trust for Local News was created really to help communities like yours move forward. And we've been in touch with the folks at the Current and look forward to being of assistance if we can be.
Thank you. We'll take you up on it. Thank you, Madam Chair.
Okay, now we say goodbye. Thank you. Bye-bye. Okay, next we have Darren Tischler, and after that we will have Tim Lee.
Madam Chair, Senator Lesser, Representative Wood, ranking members, and members of the Insurance and Real Estate Committee. I am Dr. Darren Tischler, a Connecticut native, in support of Senate Bill 1007, an act requiring health insurance and Medicaid coverage for the treatment of severe obesity. This is my personal testimony. It is a pleasure to sit before you again today, as I did last year. Unfortunately, the pandemic cut us short of the goal of passing a similar bill. I am the Chief of Metabolic and Bariatric Surgery at Hartford Healthcare and Hartford Hospital, and a bariatric surgeon who has had the privilege of treating thousands of patients with obesity in my 17-year career. I treat and often cure extremely costly health problems like type 2 diabetes, high blood pressure, arthritis, chronic pain, and many other serious health conditions related to morbid obesity. I also help to prevent many obesity-related cancers. This year, I have personally witnessed many patients in my hospital's intensive care on ventilators due to the COVID-19 pandemic. Too many of these patients have died, and the majority overweight or obese. The next time you see a picture of an ICU taking care of COVID patients, notice that the patients you see are likely suffering from obesity. Earlier this month, according to the CDC, almost 80% of patients hospitalized with COVID-19 infection are overweight or obese. Additionally, high blood pressure and type 2 diabetes are major risk factors for severity of COVID-19 infection. It has not been a surprise to me and my colleagues that COVID-19 has had a significantly greater negative impact on lower socioeconomic classes and persons of color, as they are the same groups disproportionately affected by obesity. According to the CDC, non-Hispanic Black adults had the highest prevalence of obesity, followed by Hispanic adults. All too often, I have to inform a patient of mine that they do not have insurance coverage for bariatric surgery. Unfortunately, I have to have this conversation every week in my practice. Most states have Affordable Care Act required benchmark plans that include coverage for bariatric surgery. Connecticut is the only state in the Northeast that does not have such coverage. Obesity causes more than 200 serious and expensive health conditions, including cancer, diabetes, and high blood pressure, and leads to early death from stroke, heart attack, and blood clots. Nearly 30% of Connecticut residents are affected by obesity, and nearly 10% have type 2 diabetes. The costs of obesity are staggering. Healthcare costs for those with obesity are 42% higher when compared to those without obesity. My written testimony contains information from the Office of Legislative Research on the cost effectiveness of bariatric surgery and cost savings to employers because of improvements in worker productivity after bariatric surgery. There is a threefold increase in mortality in those without access to bariatric surgery over a nearly 10-year period. As a physician, I have a responsibility to act in a fiscally responsible manner, but at the same time, do what is right for my patients and offer them the most effective treatments. I urge you to support Senate Bill 1007, and I sincerely hope that this is the year that we join our neighboring Northeast states in improving the access to bariatric surgery in the treatment of morbid obesity. Thank you.
Thank you so much, Doctor. Senator Anwar.
Thank you so much, Madam Chair. Good to see you, Dr. Tischler. Thank you for your testimony. Thank you for waiting. And, thank you for the work that you do. And obviously, I have to share with everybody that I share many patients with you and am blessed that our state is blessed with a person of your skills to be able to help our patients in our community.
Thank you.
I just wanted to know, last year, you were able to give us some numbers as well about the savings per patient, if I may remember, or if you remember offhand. In other words, the dollars spent by the state, the amount that you recover back is exponentially much more.
Absolutely. In my testimony, I have those numbers. I don't have them right in front of me here, but it's in my written testimony that I submitted. But the biggest impact is on productivity. And unfortunately, the return on investment here is not in 6 months or a year. It's in a period of a couple of years. And I think we have a lot more patients that are going to be testifying today that will tell you about how their lives have been changed and how they've been able to become more productive. And I think allowing someone to reach their full potential in their work career is probably one of the greatest gifts we can give someone with surgery.
Yes. And also, if you don't mind my asking you this question for the benefit of individuals who may not look at obesity as a disease, they may look at it as a life choice that people have made. And you know that we have stereotypes, and I think that's important to try and avoid those stereotypes. And if you can allude to that.
Sure. One of the biggest things that we fight in my career is the stigma of obesity. And in fact, there's been quite a bit of research done right here in Connecticut on the negative impacts of obesity stigma. There is a cycle of patients who are obese that have negative feelings against them that become internalized. This negative internalized biases that we see then lead to patients having a lack of desire to seek healthcare. And of course, when someone doesn't seek healthcare, the health problems get worse. So the strong bias against obesity is wrong. It has been said that obesity is the last area where it's okay to discriminate. And we're working to make sure that this is, far from the truth.
Thank you so much. And then I think many of the times I see is that people have respiratory illnesses, so they are unable to exercise. And they obviously would gain weight, and we give them steroids and make their lives even more difficult because they would have other challenges. But truly appreciate your testimony. I am also hopeful this is going to be the year. Thank you so much.
Thank you.
Thank you, Madam Chair.
Thank you. Thank you, Senator. And thank you, Dr. Tischler, for coming.
Thank you.
Any other questions? Have a good day. Okay, next we have Dr. Tan Lee.
Thank you, Madam Chair. Representative Wood, Senator Lesser, and members of the Insurance and Real Estate Committee. My name is Tan Lee. I've been practicing dentistry in Connecticut for over 25 years in the Cheshire and Hampden area. I've served on the Connecticut State Dental Association board for a number of years, and currently I'm the president. I'm here to ask for your support of the proposed HB 6589, an act concerning third-party access to participating dental provider contracts. It's also known as the network leasing bill. While the network leasing concept does have its place in serving the patients, their employers, and some dental providers, its lack of transparency, however, has caused confusions and difficulties between patients and dentists. Without network leasing laws, healthcare transparency suffers. Patients and providers should be fully informed about the cost of care as early as possible in any healthcare transaction. Lease networks often have the opposite side effect. Because lease networks operate in obscurity, the provider and the patients are unable to determine the actual coverages. This erodes the patient and dentist trust, which can lead to assumptions in treatment plans and costs based on false understanding of patient coverage. As my colleague, Dr. Jennifer Yu, stated earlier, when there's a lack of understanding between the patient and their providers with regards to the financial obligation for care, the disruption of care occurs. The Connecticut State Dental Association is advocating for network leasing laws that would expand transparency and provide an opportunity for dentists to consider their options. Currently, almost half of the states in the US have employed such a legislation. I'm here to speak on behalf of the members of the Connecticut State Dental Association and our patients, because the CSDA is the trusted leader and voice for oral health in Connecticut, dedicated to the profession and the public. I'm looking forward to collaborating with you on policy solution to help patients better understand their insurance and the use of their coverage more effectively. I urge you to join the 20 states that currently have network leasing laws in place by supporting HB 6589. Thank you.
Thank you, Doctor, and thanks for all your work you do advocating for dental health in the state and with your colleagues. We had a lot of, if you heard me earlier, but we have a lot of testimony on this bill. So thank you. You're doing good work. Senator Lesser, you have a question?
No, but I just wanted to say thank you, Dr. Lee, for your testimony. I know we've talked about this before and look forward to working with the association and sort of putting our heads together on this issue. So thank you very much. Thank you, Madam Chair.
Thank you for the opportunity.
Thank you. Okay. So I'd like to go back and see if Dr. Neil Flock is here. I see that he's in the attendees, or no, now he's in the participants. So if he is here, he can turn on his camera and his microphone and go ahead and testify.
Here.
Great.
Hi. Thank you so much for going back to me. I'm not sure what happened. I want to thank the co-chairs and the members of the Insurance and Real Estate Committee. My name is Dr. Neil Flock, and I'm a resident of Old Greenwich, Connecticut. I work in Norwalk, Connecticut. I'm a bariatric surgeon for 20 years. I'm the director of bariatric surgery in New Vance Health System here in Norwalk, and the immediate president of the ASMBS in Connecticut. I performed well over 2,500 weight loss, or what we call metabolic surgeries, because they change people's metabolism and alters the weight that the body wants to be. That's a concept that most people don't understand. I've struggled to help people who need bariatric surgery and weight loss medications obtain their insurance approval for treatments. And this has been a difficult problem my entire career. This year, countless amounts of our patients contracted COVID-19 and several died while waiting for their bariatric surgery. It has been the most tragic social experience of my lifetime, as I'm sure it has been for all of yours. When the COVID-19 epidemic began, we believed that age was the biggest and worst risk factor for the coronavirus as it struck China. But we later found out that younger patients were dying. Patients with a BMI of greater than 35 actually had nearly a 4 times greater risk of being admitted to the ICU. And patients with a BMI of 45 and above had a 2 times higher risk of dying from this disease. This year, the public became aware that obesity is a deadly disease, an immediate death from obesity from this horrible COVID-19. The CDC report from just last week, March 8th, 2021, showed that 78% of the people hospitalized, put on a ventilator, or died were either overweight or had obesity. 50% of these people had obesity. Many people of normal weight, as we're all seeing, are gaining weight during this horrible pandemic, and our problem is getting much worse. A study out of France and another study from the Cleveland Clinic by Dr. Aminian, my friend, showed that actually bariatric surgery will help you with COVID-19. The study showed that of the 4 million people they watched, 541 had bariatric surgery. And they looked at those people, the people who didn't have surgery, 15% of them were put on ventilators, 14% of them died of their obesity. Whereas if you had bariatric surgery, only 7% of people went on a ventilator, and a quarter of those people, in comparison, 3.5%, died. All patients with obesity have long been the targets of bias and discrimination of their disease. That's why you don't see more patients coming on and testifying. They're scared, they're afraid, they're ashamed, and they have tremendous courage to speak up.
Can you please summarize, sir?
Obesity is also an issue of race and color, as it is most prevalent in non-Hispanic Black adults and then Hispanics. Structural racism is a root cause for both obesity and COVID-19 among communities of color. It is a discrimination problem, and people with COVID-19 get sick because of their obesity. Black people die 7 times higher because of this disease than Caucasians. I would be happy to answer any questions. It is a horrendous problem, and I seek your support for SB 1007 to pass this year. Thank you very much.
An incredible testimony. Thank you so much, and for all those data points. Your testimony, your written testimony is in the. We have that.
It was submitted last night before 8 o'clock. I hope that it's in there. If not, I will submit it later, and I'm happy to answer any questions now. I'm very passionate about this.
Yeah. Great. Senator Lesser.
Yes, thank you, Madam Chair, and thank you, Dr. Flock. It's good to see you.
Good to see you.
You are passionate about this issue, and you're absolutely right. This is something that we were hoping to address at least last year before the pandemic hit. But no, I really appreciate your thoughtful comments about how this really connects to the pandemic. One of the things that one of my pet peeves has been all the folks out there who say when someone dies, especially a younger person that dies of COVID, well, they must have had comorbidity, as if it doesn't count, a death doesn't matter if it's somebody who has some sort of other underlying health condition, and obesity certainly is one of them. And I don't know whether it's just the lack of compassion that folks have, or a lack of awareness that we all have one pre-existing condition or another, a risk factor. But the evidence that you've laid out that obesity is an incredibly significant risk factor for COVID I find very compelling. I also remember as well that we spent a lot of time last year focused on the issue of diabetes. Help but wonder as well if bariatric surgery would be helpful in helping head off type 2 diabetes. Is that something that has been proven? Can you sort of quickly gloss over the research on that?
Yes, I can't, the volume is not so great, but the best treatment or the most successful treatment for diabetes is actually metabolic surgery. What we like to call metabolic surgery, people don't understand it. It changes your metabolism. People call it weight loss surgery, so we go along with that. But it is the best treatment. It stimulates a hormone called GLP-1 of other things, which is a drug coming out that is extremely successful. You may have heard of metformin. There's another drug coming out called Ozempic, that these treat diabetes. They're produced naturally after you perform a gastric bypass or a sleeve or a duodenal switch surgery. So this is the best treatment we have, and people keep calling it a last resort. Study just came out from Lancet. My friend in London writing a tremendous paper showing the fantastic results at 10 years, very long years for these things to work, get rid of diabetes. So when we look at diabetes treatment, we have to look at what people call weight loss surgery, what we in the medical profession call metabolic surgery, because that's what it is. It changes your metabolism, endocrinology. endocrinologically, it improves you and improves the response of the pancreas as well to sugar and keeping insulin levels normal.
Thank you. And I will point out to the committee, because I've been, since I've come to know you, I've been really impressed by how you are involved, it seems like, in everything. So if folks have Twitter accounts, you have one of the more active Twitter accounts, I think, in medical Twitter. So certainly appreciate all that you do. And I'll just note that I think you were the first doctor I remember seeing advising the general public to wear masks during the pandemic, long before mainstream, long before mainstream public health experts in this country. I noticed that, and I'll remember that. So thank you, doctor, and I'm sure there are other members who have questions.
Thank you for your support. Thank you, Senator Anwar. You've been wonderful, as well as Senator Berthel. I really appreciate your efforts and passion. Thank you so much.
Senator Anwar, you want to say a few words?
Yes. Thank you, Madam Chair. Thank you, Dr. Flock. Good to see you. Hope your surgery went well. And the question I wanted to ask you was, would you be able to speak to us a little bit about the safety of the surgery over the last many years and how 10, 15 years ago, it was a different surgery compared to where we are right now?
Yeah, so probably the biggest safety issue that has been corrected is the education of surgeons and their technique and their ability to perform this operation really close to as perfect as you can. We can never do anything perfectly, but the techniques have improved tremendously. The stapling devices have improved tremendously. And the workup and evaluation of patients has been tremendous. All these patients see a cardiologist, they see a psychiatrist, they see nutritionists. They're mandated to see nutritionists for 6 months on many of the insurance policies. So we're doing our best to technically improve safety. We've done our best to make sure that we have a healthy patient, as healthy as possible going into surgery. And many of us put patients on a diet to not lose weight before surgery, but to decrease the inflammation caused by the liver. Because, as you know, you absorb food and the first hit is through the liver, which causes and leads to the diabetes, et cetera, the high cholesterol, et cetera. So doing that is another safety measure. When you look at the data, and we're talking about hundreds of thousands of patients, the ASMBS has collected, and you compare this surgery to gallbladder surgery, which we all think is safe. Studies have shown that this surgery is either much safer than gallbladder surgery or equal safety. So we have reached the level of safety that didn't exist when I first started. 20 years ago, it wasn't as safe, but now it is very safe. It is safer for these people to have surgery than not have surgery. And it is no comparison.
Thank you so much. I just had not alluded to that with some of the other speakers. I wanted to make sure we pressed on that part too. Thank you so much for your testimony, and thank you for the work that you do. Thank you, Madam Chair.
Thank you.
Okay, we've got a couple more questions, so stick around. We have Rep. Delnicki.
Thank you, Madam Chair, and thank you for your testimony, Doctor. You know, it's interesting. A friend of mine had that surgery about 10 years ago, and I hadn't seen the person, probably for about 2 or 3 months prior or after the surgery. And the amazing difference in how they carried themselves, how they interacted, and how they had a big smile on their face and they were so happy. And quite honestly, they were more enthusiastic and able to do their job better and enjoy life more and avoid some of the pitfalls that I know they probably would have come down with. So even having been done 10 years ago, the difference has remained constant And it has stood the test of time, because I know a number of folks that asked me about it. You know, I'm not a doctor. I don't even claim to be one, and I didn't sleep at a Holiday Inn. But to see that change and how the change has been sustained over the years, in my eyes, is proof positive. Thank you, Doctor. Thank you, Madam Chair.
Thank you.
Thank you. Representative Meskers, you're up.
I want to thank you for your testimony. I came in a little late to that testimony. I've been in multiple meetings, so I apologize. I guess the only question I have is, when we talk about advocacy and we talk about bills that help promote this as the appropriate procedure, and I'm not questioning that. I guess where you want to go next is to make sure that we have in place, or do you feel we have the appropriate standards, right? Because if you think about this type of surgery, you're really looking also that it is not that the benefit and the cost, so that you're ending up with what's the general benchmark of success. Because first is the surgery, obviously, and the survival. And as you said, surgery is going down. The next question is how, like, the recidivism, I guess, is the question. Like how often, what's the success rate look like over time, over 4 to 5 years?
I don't know if you can see this graph, but this demonstrates, you look, this is the greatest study we have. You'll have to look at it more carefully.
Right.
And this is the Swedish obesity study. These patients are out now about 25 years. Sweden does a great job because they can track everybody.
Okay.
And what they show is the greatest operation, because it's been around for that long, is the gastric bypass. We haven't been able to study other things. And patients will lose a significant amount of weight, whether it's about 60 to 70% of their excess body weight. If you look at 20, 25 years and take the average patient, you're about 50% of the weight will be regained over that time. But that's the reality of it. Some of those patients will keep everything off. Some of them will regain everything. But that is the best data that we have. It's tremendous. There is nothing that compares to surgery. You can't have a medication that compares to it. We're gaining some medicines that are excellent, and there's one coming out that's outstanding. And we need these medications as well. They're very important, because what we've learned to do is the medical doctors and the surgeons, we work together. We work as one, and actually I prescribe medication as well. So what we do is we do the surgery, and then some people may become hungry afterwards, and we'll put them on medication, and that keeps them from regaining weight. It's wonderful. In the past, surgeons and medical doctors didn't always work so well together, but now we are really partners. And in fact, I do the weight loss medication. It helps. But the surgery alone is incomparable. You can't compare. You're having an irrelevant discussion if you're saying that exercise or a diet is going to cause long-term weight loss, because it doesn't. We see people on the cover of People magazine going on keto diets, and they do lose the weight. But if you look at those people long-term, they regain. Some of you have also seen a TV show called The Biggest Loser. Dr. Kevin Hall is from the National Institute of Health. And Dr. Hall did a study on all the winners of The Biggest Loser television show. And what happened is all of these people regained weight. Some of them lost weight if they had bariatric surgery again. And what happened is their metabolism changed, and they needed to eat 400 calories less a day to maintain their same body weight. So dieting, going on these diets where you diet, you lose weight, and then you regain more, it actually alters your metabolism in the wrong way. So what we found is that the efficacy in an order is really surgery, then medication, along with, these are in addition to staying on a diet, because as doctors, we put everybody on an appropriate diet. We have to push them to see their nutritionist, see their therapist, exercise. And exercise, by the way, it's a fallacy to think if you're going to lose weight on exercise, because the best studies show that if you exercise 5 times a week for 1 hour a day, you will lose about 11 pounds that year if you don't change your diet. Okay, so it's changing your diet that helps. So from an efficacy level, you have to do all those things, and then you need to add medication and or surgery if those things don't work.
So just to be clear, what you said was basically that, yeah, I heard the efficacy. That was very good. So it's about a 50%, hold on 1 second. So about a 50%, it's a phone ring. Sorry about that. So about 50% a weight loss on average over the life of it.
No, we say excess body weight loss initially. Initially, the weight loss is significantly higher. It's about 70% of your excess body weight. But if you go to 20 years, what you'll find from the graph that I put in my testimony is that patients 20 years later will regain about 50% of that weight. So you're averaging
It's about half of the excess, basically.
Yeah, of the excess.
Okay, perfect. That was my question.
That's the reality. I think we've gotten better over time, but that's the people that were studied 20 years ago and following up 20 years later.
Thank you. Very helpful.
Thank you, Representative Meskers. Representative Nuccio.
Hi, thank you, Madam Chair. Good afternoon, sir. How are you?
Great.
Good. Actually, Representative Meskers just asked the question that I was going to, because that piece of information caught my ear too. So if what you're saying is I just want to make sure that I have this right, that after surgery, people can expect to lose 60 to 70% of their body weight, but after 20 years, they'll regain about 50% of what they lost. Has all of that been calculated into the expense ratios that you guys are looking at from a savings perspective? Because I would assume that losing 60 to 70, putting 50% back on still could have you at an excess weight, which would still cause medical issues. So are we calculating in the resurgence of any of those medical issues in the savings?
So Dr. John Aronow is our expert who has calculated all this, and I hope he can put in his testimony. You've got to look at the value at 5 years, 10 years, 20 years. Some people may die after 20 years. So all this is it has been looked at shorter intervals. But you've got to then compare that to those people being alive who have severe obesity, who've developed many other medical problems 20 years later and have not lost any of that weight. So it can swing both ways. I understand your argument. Many of those studies have been done, and I don't know exactly how to answer your question directly in the state, because that study has not been done.
Okay. All right. Thank you very much.
Thank you very much. Okay, I think that's it. All right, now you've got a bunch of new followers. Thank you, Doctor, on Twitter.
Thank you very much. Very passionate about this, and it will save us money and it will help our people, and it's the responsible thing to do. So thank you.
Yeah. So next we have Linda Halpin, and after that we have Rick Hart. Linda, you're up. Thank you for being so patient. Number 33.
Okay. Can you hear me?
Yes. Go ahead.
Okay. Thank you. Thank you for letting me speak. Thank you. Thank you, insurance members. My name is Linda Halpin. I live in Bloomfield, Connecticut. I had the sleeve in 2016. In 2008, I began my journey. I originally had the lap band in 2008. That's when I was at my heaviest weight and up to 217.8 pounds. I couldn't walk up the stairs good without getting out of breath or tie my shoes or even put a towel around me. I had the sleep to improve my health. Now I would say I'm at my goal weight. I've maintained my weight for 3 years now. I'm at 116. I recently lost 2 people due to obesity complications and COVID. This is why I feel bill number 1007 needs to be passed. And I want to say thank you for letting me speak. Any questions?
Thank you, Linda. Thank you for sharing your story. And how are you feeling?
I feel wonderful. I exercise 7 days a week and I eat healthy and just feel really great.
Good. Well, hopefully we can get this bill passed and help a lot of other people as well. Do I have any questions on the committee? No, thank you so much for your heartfelt testimony.
Thank you.
Have a good day.
Yep.
Okay. Hello, Rick Hurt. Nice to see you.
Nice to see you too, Representative. Vice Chair Comey, Chairs Wood and Senator Lesser, and members of the Insurance and Real Estate Committee. My name is Rick Hart. I represent the Uniformed Professional Firefighters Association in Connecticut, which memberships include 4,000 career firefighters across the state of Connecticut. And I'm here today to testify in support of Senate Bill 1004, an act concerning firefighter training and crumbling concrete foundations. While the entire bill has merit, I'm just here to address specifically our support for sections 2 and 3 inclusive. For years, dating back to 2010, the fire school operating budgets, the 9 regional fire schools in the state of Connecticut, have been flat funded. That's 11 years of the same funding, which in today's post 9/11 world and now in our COVID-19 world is woefully underfunded. Having a well-trained fire service and EMS service in the state of Connecticut will provide a more efficient and safer delivery of services to the citizens of Connecticut. The fire service has gone from a quote-unquote fire service to an all-hazard service, which means we respond to medical emergencies, chemical spills, hazardous materials incidents, major traffic transportation incidences, along with fires as well as fires, as I said. The bill before you will provide the Connecticut will establish the Connecticut Fire Safety Fund, and I have to give credit to the person that is behind this, and that is our dear friend Linda Orange. Back in 2016, she came to me and said, as Linda can do, Rick, find me information, draw up a proposal, and let's get this done. A huge proponent of it, of the fire service. So I went to task. In creating a surcharge on the insurance policies within the state of Connecticut, it would create a fund that, based upon the $7 surcharge would, on the just residential, based upon the information in my research, would create a fund of $6.391 million, which would be a fund that $2.5 million of that monies would fully fund all 9 regional fire schools, which means it wouldn't rely on the state to have a line item in the budget to fund the schools. It would become totally independent of the state budget process. As you put in your in the bill, that DESP and the commissioner would be the guardian of this. In my testimony, I have
excuse me, sir, if you could please summarize.
Yes, ma'am. I did put in substitute language that would allow the creation of an equipment fund because, as you all know, I am huge on cancer prevention in the fire service. This would provide, on a grant application basis, providing every firefighter in the state of Connecticut a second set of turnout gear, which is the gear that we wear going into fires, in the prevention and reduction of cancer exposures for firefighters in the state of Connecticut. So I'd be happy to answer any questions. Please support SB 1042, and so we can move the Connecticut Fire Service forward. Thank you.
Thank you. Questions from the panel. Senator Lesser.
Yes, thank you, Madam Chair, and thank you, Rick. It's good to see you. And you know, as you were testifying, I could sort of hear our friend Linda Orange's voice in my head telling me how important the regional fire schools are, and I could never say no to her at any point. So it's
not many people could.
You could try, but I was never in your best interest. So just wanted, I mean, obviously I have a bunch of questions about the proposal. Obviously we've been looking for a sustainable funding source for the operations, both the operations and I guess also the capital side of the fire school. You mentioned 9 regional fire schools. Is that assuming that all are built out? Because I know that there's been a sort of a separate question about the construction of the fire schools as well. Is that right? So is it that there should be 9, or is it there are 9 right now?
Presently, there are in name 9 regional fire schools. Excuse me. The Valley Fire School has not been built yet. They are, unfortunately, they have to travel around. They're like nomads, going to firehouses and different fire departments in order to do their training. That is the next fire school to be built. I know Middlesex Fire School, excuse me, is tentatively on the list to be built after the Cheshire, which is currently the Wolcott Fire School. There is a physical plant there, but it is in dire need of replacement due to the years of usage and the potential for the burn building to collapse. So there are 8 physical schools, with the Valley School being a chartered regional school without a burn building or classrooms, which needs to be built. That is a priority for the fire service, that we receive bonding for it to be built. And then Middlesex, then it would be Cheshire, and then Middlesex.
And I'm sorry, what's the status of that though? I know that there's been a bond authorization passed by the legislature, is that right? And so it's waiting for the governor's office or the OPM to place it on the agenda. Is that the status, or where are things in terms of when that build out would occur? And does that also depend on the operating funds being made available? Are those 2 things connected?
The capital expenditure and the operating funds are 2 different issues. We get operating funds presently in the budget. We're just waiting for the governor to release the funds. They've been authorized years ago, and we're just waiting for him to put it on the bonding agenda to authorize the building. The bids are in. Representative Rochelle could probably address it better than I could, being that's her district. And then they're shovel ready.
Well, she's a member of the committee, so I'll defer to her on her fire school. Just in terms of the theory here, though, obviously nobody likes seeing a surcharge on their homeowner's insurance. I can't imagine this would be something that people would love to see, but obviously everybody also benefits from having reliable fire service and making sure that we're supporting our fire departments, both career and volunteer. And so just wanted to get your sense on what's the theory. Is that is the idea that having that funding the regional fire schools will result in lower insurance costs if there are fewer fires? Is that sort of the connection here? I'm trying to understand that. Is it that I think I can sort of see where the connection might be, but I'm just trying to make sure that I understand. If we get questions from constituents about it.
Sure. The fire service is rated based on a 1 to 10 rating, 1 being the best, obviously, and 10 being the worst, and the insert ISO rating. And a lot has to do with training. We're mandated by the NFPA to do 288 hours of training per year, and that does not include EMS training. If we do provide EMS training, that could be up to an additional 40 hours per year. And so there would be an absolute benefit to the municipality if their ISO rating goes from a 4 to a 2 based upon the training. That means their insurance rates will go down, their fire insurance rates. It's also, it's an ounce of prevention for a pound of cure. There's a serious issue in the fire service today in Connecticut, especially in the volunteers, the career firefighters. We have to be firefighter 1, firefighter 2 certified, along with all the hazmat tech, the hazmat training. But with the volunteers, they have to pay for it themselves. And it's approximately $1,200 per student to go through the training. This fund would provide training for upwards of 4,800 individuals in the state of Connecticut, free of charge. So you go to the class, you're paid for. That burden comes off the municipalities, comes off the individual if they so choose to go on their own. Any training, and that's the beauty of this, because we can get more training based upon the fire schools being funded, their operating budgets, which they have to rob Peter to pay Paul, basically, and you see a corresponding increase in the tuitions for firefighter training. And that's not just firefighter 1 and firefighter 2. You have hazardous materials, you have the EMS, you have pump operator, aerial operator. There's a myriad of training programs that are run out of the fire schools that cost money, cost time, and this would alleviate that completely.
I may have other questions in a minute, but I want to turn it back to the chair and really appreciate working with you on this issue. It's a problem we've got to solve, and I know it's been something that's been troubling the legislature for a while now. So happy to work with you and the UPFFA.
Thank you, Senator.
Representative Delnicki.
Thank you, Madam Chair, and thank you, Rick. I'm glad you're here testifying on this. Having joined the Fire EMS Caucus when it first reappeared, that was always a question that came up on how in the world are we going to ensure that these training schools are properly funded. Now, refresh my memory, was any money ever swept out of the funding for the training at these schools?
Yes, Governor Malloy, unfortunately, when we were going through the budget issues a few years ago, 2 years in a row swept the funds, which left them with zero balances. If you look at the DESP budget, you'll see in there some of the schools receive upwards of $100,000 to operate, because it, like the Eastern Fire School, I believe, receives about $100,000 because it serves all the communities basically east of the Connecticut River. So they have a large pool of students that they have to teach. So that was crippling to the fire schools. They had to, they operated at a loss. Scott Bisson, who is the chair of the Connecticut State Firefighters Association Education Committee, is scheduled to testify later, and he will have the exact figures to give you as far as the budget's fluctuated since 2010, but on average, they've been flat funded since then, with some years the accounts being swept.
Thank you for that answer. I believe earlier you mentioned it would benefit both the career fire service departments and the volunteer departments. Is that correct?
Yes, sir. This isn't a career versus volunteer issue. It is a fire service issue. Everyone will benefit from this, both career and it actually will benefit the volunteers more, because a lot of them shell out the $1,200 on the front end, and once they pass the program, then they get reimbursed by their department or their municipality. So this would alleviate all of that. So if you have from South Windsor, you have 10 people that want to go to fire school, but only the department can only afford to send 3. This alleviates that. This allows all 10 to go to this class, get certified, boost your roles in the fire department free of charge.
Well, that's a real benefit from my perspective as a former municipal leader. It was always key and critical that we funded our volunteer fire department. And we have over 100 members of that volunteer fire department. And we have a very, very robust explorer post. That, matter of fact, our chief, who serves actually as a uniformed professional firefighter in Manchester, and the chief in the South Windsor Fire Department, volunteer department, he went through that explorer post. And then as a community, their budgets could see a reduction by not having to fund those positions to pay for those folks to go to the school. Does that sound right?
Yes, and the other benefit is, like I said, I offered up substitute language to use the excess monies to create an equipment cache, which would go first to purchase turnout gear, which is approximately $1,500 to $2,000 per set per person. We can come up with a cache of a number, 1,000 sets of gear that would be handed out to the and I envision it as the smaller departments that cannot afford to purchase this, or they have to bond it, or they have to, somehow scrape together the money just to have adequate protection for their firefighters. And next we can, the self-contained breathing apparatus that we wear run around $15,000 per unit. The National Fire Protection Association puts out standards every year, and the SCBA standard changes, and departments, if they want to be NFPA compliant, have to purchase these air packs. So we could purchase a number of these air packs, and again, provide on a grant application process, these smaller municipalities the ability to get these for free. I liken it to the on the federal side, it's the Assistance to Firefighters Grant, the AFG, that's run out of by FEMA. This would be a lot faster and more streamlined than going through the federal government if we can have this administered through DESP, through the Connecticut Fire Administrator, where they know the people, they know the departments, and we could outfit and train our firefighters to the best that we can.
And that is an obligation we have to ensure that our firefighters, whether they be career or whether they be volunteer, have the tools to do their job, to be there, to be able to respond and to do it in a safe fashion, because quite honestly, nobody wants to have one of those days when somebody doesn't come back. Now, it sounds to me like this would have a significant benefit for many of the smaller municipalities in the eastern part of the state, in my neck of the woods.
Yeah, it would benefit everyone. It's going to benefit everyone. It's going to make training much more available. It's going to make the fire service second to none. I mean, other states, Washington, Massachusetts, West Virginia, among others, off the top of my head, they have a fee schedule that they use to provide training for their firefighters. So this is not a new concept. I don't look at it as having a downside. The end users of the fire service are the homeowners and the commercial building owners in the state of Connecticut. And I think it's a small price to pay for having the benefits that they are going to receive as a result of this.
And it sounded like from your earlier testimony that when the ISO ratings come out in communities, if they have a standard set training paradigm, that will in and of itself help a department in their rating.
Yes, as a matter of fact, some of you know I'm a deputy chief in the city of Waterbury Fire Department, and we're going to be going through an ISO evaluation within the next couple of months. That is the first thing that they look at is training, and it's a huge portion of their evaluation. So it's important. It will help the communities across the state.
Well, I thank you for coming forward today. I suspect there's a number of folks out there that have questions that they want to follow up on. Again, thank you, and I appreciate your input. It sounds like we've got something that makes some kind of sense here.
Thank you.
Thanks, Representative. Next up is Representative Paletta.
Thank you. Good afternoon, and good afternoon, Mr. Hart. Hope you're well. I do have more of a comment than a question, but I appreciate your testimony and the good work that you have done and that your counterpart, Mr. Carrozza, have done over the last several years for the firefighters in the state of Connecticut. As someone who represents a town that has a volunteer fire department with about 105 officers, they are a very valuable part of our community. And there was a time when, they needed new tanks and we couldn't find money in our budget to buy it, but we had to ultimately because it was a public safety issue. But I kind of correlate that to these fire schools and how important they are to the success and overall safety of our state and of our firefighters across the state from east to west. So my question, and you kind of answered it before, was what happened to the money? And the answer was that it was swept, unfortunately. So now we're stuck with this multi-million-dollar question of how do we replenish it? And I know you had run out of time there. I don't know if you have any other ideas or suggestions for our committee to consider before the bill is ultimately voted on, but I'm all ears and I want a steady streamline of funds so we can make sure, and selfishly, the Naugatuck Valley Fire School is right around the corner from me and we want to get that funded. But any suggestions you have that you want to add would be great. But thank you for all the work you're doing.
Thank you, Representative. The one ask I would have of the committee is to either through the insurance commissioner or OLR, find out exactly how many I mean, I used the 2010 census on owner occupied houses. And it came up with 913,000. I don't know if that is accurate. And I could not find any information on how many commercial buildings there are in the state of Connecticut, because once we get that those numbers, I think if we use $12 million as a ceiling that this fund would collect, we can work backwards, and based upon the number of insurance policies, we can find out we may only need $2 per policy. So we may be able to drive that down from 7. That would be my only ask.
Thank you.
Thank you.
Thank you. Representative Rochelle.
Thank you. I've been jumping back and forth between this public hearing and commerce today, so I did miss the first half of this. But I wanted to thank Rick Hart for coming today and testifying on this bill. As he's aware, I'm a huge supporter of the fire service, and think that we as a state have a lot of work to do around the issue of ensuring that our career and professional volunteer departments are funded in a fashion, both for their training, for their gear. We have a 22,000 person strong free workforce in the state of Connecticut. And I think it's something that we often don't think about. When people have a fire or a car accident, they dial 911. They don't think about who the person is, if they're, to what level they're trained, how old their gear is, all of these things that we as legislators have a responsibility to think about to make sure that those who are protecting us are protected as well and well trained and provide the resources that they need to do the job. So I want to encourage all of my colleagues to fiercely support this initiative and the good it will do for everybody across the state. Thank you.
Thank you. Any other questions from the committee? Thanks for joining us, Rick. We appreciate the testimony.
Thank you, Representative. Thank you, everyone.
Next up, we have Chris Vanderhoff, followed by Rodriguez Plank.
Good afternoon. Good to see everybody. Thank you, Chairwoman Wood, Senator Lesser, and members of the Insurance and Real Estate Committee. My name is Chris Vanderhoof. I am the Executive Director of the Connecticut Daily Newspaper Association, and I'm testifying in opposition to Senate Bill 1043, an act concerning the Hartford Courant. As most of you are aware, CDNA is comprised of the 17 daily newspapers in Connecticut, which includes the Courant, and every member paper of CDNA is strongly opposed to Senate Bill 1043. The protections provided the media through the First Amendment of the Bill of Rights of the U.S. Constitution are clear. We believe the proposal before you is government intrusion into the operation of what is otherwise free press. The Connecticut State Legislature cannot engage in oversight of the operations of any newspaper in Connecticut. Moreover, it is reasonable to assume that the definition of public interest contained in the bill varies from person to person. Allowing the Attorney General or any subscriber of the Courant to determine what that public interest is as it relates to the operation of a newspaper, we believe runs afoul of what has been taught about the protection provided under the First Amendment. You will find no group more agreeable to the underlying premise that the Hartford Courant should remain in Hartford with a robust newsroom providing up-to-date reporting on the happenings of the city, state, and region, as it has for more than 250 years, than the members of the Newspaper Association. However, the Connecticut General Assembly does not have the authority or ability to engage in determining the operations of the Courant or any other newspaper, media, or press operation. The bill references a special act from March of 1887 as approving the Hartford Courant. While acts like this were needed at the time to establish the ability to trade as an entity, it did not provide oversight authority to the legislature. Simply put, there was no stock exchange or Securities and Exchange Commission to provide oversight, regulation, or rules around the operation of business entities that we have today. By 1887, the Hartford Courant was already 124 years old, having been founded as the Connecticut Courant in 1764. The great history that the Courant enjoys as the nation's oldest continuously published newspaper is to be cherished by Connecticut, as it was in 1778 when the legislature issued a temporary lottery to raise money to help pay for the rebuilding of the Courant's paper mill after it was burned to the ground by British soldiers. Trying to legislate that the Courant may only operate its finances towards the quote-unquote public interest is a suggestion that we believe sours centuries of journalism the Courant has provided Hartford, our great state, and even the United States. Nobody enjoys the consolidation of the media, the laying off of staff, the selling of cherished newsrooms and buildings. Unfortunately, in today's digital climate, the ever-changing landscape of the media has resulted in some of these unfortunate circumstances. However, the Hartford Courant and all member papers of CDNA continue to provide integral oversight, recognition of our government, our community, and our fellow citizens. The Hartford Courant is now and continues to be dedicated to the city of Hartford and the state of Connecticut. Please reject Senate Bill 1043. We believe that it's an unconstitutional attempt to exert government influence over free press. Thank you for allowing me to testify today, and I'm happy to answer any questions.
Thank you. Questions from the committee. Senator Lesser.
Yes, thank you, Madam Chair, and thank you, Ms. Van Hook, for your testimony. I think all of us on this committee cherish the First Amendment, and I think that the reason why the newspaper industry was singled out by the framers of the Constitution was precisely because we have such a strong and compelling public interest in seeing that it thrives, it flourishes, and performs its duty to educate the public about what's happening in our country. That's something that the framers recognized as vital to a functioning democracy. That's why they put it first in the Bill of Rights. They didn't put in the other industries. They listed your industry because it was so critical to the functioning of a vibrant and free democracy. Now, you mentioned your understanding of the legislative history of the special acts of the legislature. My understanding is that the first Connecticut Corporations Act was passed in the 1830s. That companies didn't have to come in front of the legislature for validation after that point. But the legislature did, right? The legislature passed a special act in 1887 because it recognized the current had a special role on our state. And then again, the current came before the legislature in 1909, in 1917, in 1925, in 1947, 1951, and I think again in 1951 on two separate occasions, seeking amendments to its charter, coming before the legislature, asking for new roles and new ability to issue stock and organize itself. I don't see anything in this bill that talks about how what editorial line the current should adopt or any attempt to influence the coverage decisions. That isn't our role, and I don't think anybody would pretend that is the role of the General Assembly. But as a subscriber to the Current myself, and I know many of my constituents are subscribers, we're all anxious because we read in the paper about Alden and about whether or not it's committed at all to the business of journalism. And you tell me and you tell us that the newspaper association wants the Current to continue to operate in Connecticut. And I would maintain that that's all that this committee wants as well. So if we can get an assurance that regardless of the ownership of this paper, the Current is going to continue to be delivered to our constituents, I think that would address many of the concerns. I'll be honest, I have a lot of skepticism about that given Alden's history. So maybe you could speak to that a little.
Sure, I appreciate your point, Senator. I certainly can't speak on behalf of Alden or the Current as it relates to whatever deal is going to be finalized and they're working through with Tribune Publishing, other than to point out that Alden isn't buying the Current per se, they're buying the properties for Tribune Publishing. So I can't promise you that the Hartford Current would remain in Hartford. I will tell you that the Newspaper Association and all of its members shares the same concerns and hopes that the Hartford Current stays here. I will tell you now, the Hartford Current is dedicated to the city of Hartford and the state of Connecticut, and the people who are at the Hartford Current are doing their best to continue doing the great work they've done for 250 years. Unfortunately, I'm not in a position, I think, as you are aware, to promise you that the Hartford Current will remain in Hartford forever, as I simply am not aware of what Alden Capital, should that deal be finalized, has in store or has planned. But I do appreciate the concern that you and I think that many citizens in Connecticut share.
Is there anything that we can do, in your minds, to help ensure that our constituents have access to the news?
That's a good question. I don't think the legislature wants to buy the Hartford Courant from Alden. I think, earlier
seems like a
today,
pattern, yeah.
earlier today, Ms. Abernathy, I thought was very interesting in her testimony. And I think that what we're seeing and what they're trying to do with the gentleman in Maryland as it relates to the Baltimore Sun and potential nonprofit ownership of some of the properties would be something worth evaluating. The woman from Utah, whose name I forget, and I apologize, suggesting that what they did in Utah was interesting as well, and I would like to follow with her and hear more about that idea as well. Short of a white knight who's based in Connecticut with the type of funding and nonprofit status that I think would make us comfortable, I'm not sure that the legislature, unfortunately, has a lot of ability to guarantee that newspapers do what the legislature wants it to do.
And to be clear, I don't think we want, no one here is saying what your coverage should be or what the current coverage should be. I don't like that framing that we want a newspaper to do a certain thing. That to me is anathema to what the First Amendment's about and what our role is. But ensuring that our constituents get access to timely news, that if they want to, they can access news about what we're doing, what's happening in the world, I think is just critical to having an educated and informed populace so they can make the decisions about whether we're doing a good job or we're doing a terrible job. But if there's no one to cover us, who's to hold our feet to the fire? Who's to shine a light on what's happening up at the Capitol? So that's enough for me for right now, and I'll yield back to the chair.
Thank you. Questions from Senator Anwar.
Thank you, Madam Chair. Mr. Vanderhoff, I missed a little bit. You're representing a newspaper or you're a lobbyist?
I am representing the Newspaper Association. I am their executive director. I'm also the lobbyist for the association.
Oh, so you are the lobbyist. Okay, I just wanted to clarify. For a second, I thought you were a journalist who actually wanted. So I understand where you're coming from then. So you're lobbying on behalf of Alden, or who are you lobbying for? I just want to clarify.
No, sir. I'm representing the Connecticut Daily Newspaper Association, which is all 17 daily newspapers in the state of Connecticut, including the Courant.
And that is on behalf of the ownership, or is this behalf of the journalists?
It's behalf of the publishers of those papers.
Okay, so owners, basically. Okay, I just wanted to frame an understanding where you're coming. So based on your perspective, that when you have one single private entity that owns and dismantles a newspaper, that is okay as long as it's a newspaper.
That's not my perspective. My perspective is that this legislation that is before you is not runs afoul of what the First Amendment protects newspapers to be. I'm not suggesting that I think Alden Capital or anybody else should buy any paper and dismantle it and do what I think folks are concerned that may or may not happen. But what I am suggesting, and the reason I'm here representing the newspapers, is that this bill before you is of serious concern about the intrusion of the legislature in the state of Connecticut in the otherwise operation of free press.
So, because in other words, that who do you think should be able to help? I mean, I hope your position would be that newspapers are important for a community. Is that fair?
Of course, of course.
Okay. And if the newspaper are controlled by a private equity and they start to dismantle it, then we should just let them dismantle it and all look the other way because legislators should not be involved, or nobody should be involved in trying to save a newspaper which has been truly identified as a part of our state and as a part of in the entire country.
I'm not suggesting that, and I appreciate that concern. However, suggesting that a newspaper or the owner of the newspaper can't incur debt or issue dividend that isn't quote unquote in the public's best interest, public interest, I guess is the quote, it changes the operations of that newspaper, potentially changes the operations of the newspaper from a covering of the news or covering of the legislature, the community, whatever it might be. And so from that standpoint, I don't think the legislature has the ability to do that. To your overall question, do we look the other way? I would hope not, but I don't sit here today with an answer on how to solve that, given I think the protection under the First Amendment.
Yeah, no, again, of course, you are representing who you're representing, and I think you're doing a reasonable job there, but I am representing the community and making sure that we have a voice that is independent and that's a sustainable voice. And we have heard from some of the people that that voice is no longer sustainable because it's being dismantled in an organized fashion by a for-profit entity whose primary interest is to provide dividends. And we want our newspaper that has been part of our state for as long as anybody's memory can, at least around this legislature and beyond. We want to make sure it's protected and it's not dismantled by a for-profit entity. So again, I want to thank you for your testimony. I may not necessarily agree with everything that you're saying, but I respect and understand the fact that you're representing the publisher and the owners, even if they are a for-profit and even if they are a private equity. I mean, that's your job to protect them. But I feel my job is to make sure that we protect the newspapers and the independent journalists and also their ability to write without having the fear of losing their jobs. Thank you so much. Thank you, Madam Chair.
Thank you. Thank you, Senator.
Thanks for coming today, Chris, and sharing your testimony.
Thank you. Have a good day.
You too. Next up, we have Rodriguez Plank, followed by Sherilyn Sampson. Is Rodriguez available? Okay, is Sherilyn Sampson? How about Richard Zablocki?
I'm here, Richard Zablocki.
Okay, Richard, you are up.
Okay, I'm responding to the SB 1041, which is the healthcare sharing ministry bill that's been proposed. So here's my testimony. I've been a member of one of the major ones for over 9 years. I'm a family man. I have 3 children still on the plan. And I just want to report that I've had a good experience. I've been with them for 9 years. They were very upfront that it's not insurance. I tell everybody if I have to go to a doctor or my kids have to, or my wife, that it's not insurance, but I have this basically it's not a reimbursable plan exactly, but it's similar to one. So I get the bill, I tell them self-pay. The ministry tells me, ask for the self-pay price. It might be not as good as the insurance company pays, meaning low, but it's usually pretty good because they don't have to wait long for the money. And I've had 2 major claims in those 9 years. Actually, one was in 13 and one was in 18, both in excess of $25,000. I've got a $300 deductible, and the money came in once I got the bills from the people, and they sent them in the mail. To me, and then I look them over, okay them, and then I send them on to the ministry. And I got the money from about 40 different people all across the country that covered everything but $300. It was wonderful. And that's my main point. The next point is that for me, as a small business owner, I think I'm classified in the middle class. I realistically couldn't afford it with everything that goes with life, a $1,500 to $2,000 a month premium. I'd probably wing it otherwise. And so this thing really came in the clutch. My cost now is $542 a month. Now it was a little lower. It goes up every year. It started up around $425 a month. And the $300 deductible, and I tell people they can't believe it. And it's true that they don't cover pre-existing conditions, but that's not a problem for me because I'm in it for over 10 years. And the other thing is the Section 2 language. I think somebody earlier today said they're not really, it might have been Senator Lesser, I'm not sure, that he said that it's not going to close them down. But from what I can understand, the reimbursement to anybody who does administrative work will close them down. So I think somebody else brought up, that guy Hoyt from Christian Healthcare or something, that he wants an exemption for administrative staff. I agree with that. And the last thing is there are screwballs, bad apples, I think, in every industry, including this one, I'm sure. And if they are, it should be weeded out. You shouldn't condemn everybody rather than, you get the bad actors, get them out. And clearly this thing with deception is a problem if it's whoever gets that. My company doesn't do brokers. They won't do brokers, and they're pretty big. They do about $30 million a month. And the second one is they made us.
Excuse me, sir. Your 3 minutes is up. If you could please summarize.
Yeah, the bad actor should be addressed with language that says this is not insurance. It's basically a best effort thing, and it works. The things work. Okay, that's it. I'm done. I'll take any questions.
Thank you, Richard. We have questions from the committee. Senator Lesser.
Yes, thank you, Madam Chair, and thank you, Mr. Zablocki, for your testimony. You mentioned that you've had, since you engaged with one of these firms, you've had medical procedures that had bills over $25,000. Is that right?
Right, it's true. And some smaller ones too, but those are the big guys, right?
The big bills. So my understanding is that none of these companies requires a contract between you and the company. Is that a correct assessment?
Well, I'm not a lawyer. You have to apply. There's about a 4-page application, maybe some subsidiary schedules. So I don't know if that qualifies as a contract, but it might. But they're clear that it's not a guarantee to pay. But on the other hand, I actually emailed them this morning. I said, that's a good point, because I was watching this all along. And they said, last year, the fellow who contacted me back, I just sent an email, he emailed back. Last year, I have it here, because I asked that question. That's a good question. He said they got in last year, $759 million in bill charges. That's like people submitting a medical bill from across I don't know if they're in every state, but they're in a lot of states. He said their staff was able to negotiate $403 million in provider reductions. They're pretty good at that. They have all the ins and outs of that. I don't know how they do it.
Yeah.
They negotiate, and they said they sent down just under $360 million in shares. I mean, or reimbursements over the course.
I guess my concern is, you go into a doctor's office, you say, I'm okay getting a $25,000 medical procedure, but you don't know going into it if this sharing, because there's no contract, there's no requirement to pay. These guys aren't regulated by anybody. You're going in on a wing and a prayer, because you don't actually know whether or not there's going to be that $25,000 is going to be waiting for you at the end of it or not. So do you have the? I mean, I don't need to know your financial situation, but I know that a lot of my constituents, they get stuck with a $25,000 bill. That's a big hairy deal.
Yes, you have a good point that it's not guaranteed to be paid. On the other hand, the company that I'm with is getting in bills over $750 million, and they have, I don't know if they're around 20 years, but I know they're around more than 10, maybe 15 years. And my take on this is that they're trying hard for any eligible charge, which basically takes away dental. They don't cover dental, and they don't cover pre-existing. So you're going into it with your eyes open.
But they may not cover anything else either, right? They say we won't cover pre-existing conditions, but they may not cover new conditions either. Right? There's no promise to pay. That's
the one that I have. They covered according to them, they covered every single eligible charge, period. So when you say you're not guaranteed, they don't cover everything. I mean, they're saying they got $756 million of supplied bills. They negotiated discounts. I think they go over your head. They go right to the provider. You got to give them really detailed bills, and they check for liars and stuff like that. And then they negotiated discounts. I don't know how they did it, but they did it. And then they got their members, and I think there's around 150,000 of them. They got their members to write checks to me. I mean, about 40, 50 of them. And I got these checks over the course of several weeks. One of them was in December. And so what happens is I got the money to pay the bills, and everybody's happy. So you're right. It's not, I can't take them to court if they say, sorry, sucker, you're not, you got a 25 grand bill and it's your responsibility. We're going to Florida or, whatever. So that never happened. And I have a $300 deductible, which is the envy. I'm actually a tax accountant. So I see all these things. And I mean, I talk to my clients, they're pretty friendly. And that's about the lowest deductible of anybody of 400 people. I mean, I'm not complaining. I mean, then there are drawbacks. Nothing's a pure good, but there's drawbacks. But a 25 grand bill, I paid $300.
Yeah, no, I hear you. They haven't taken your money and gone off to Florida. But the reason we're looking at this legislation is because whether it's your company or other companies, folks have them, right? There are a lot of people in the state who are price sensitive. They're desperate for affordable options for insurance. They are buying or writing a lot of money to a company, and in some cases they are told to take a hike. And
I'm sure
Connecticut Insurance Department.
Right. I'm sure there's bad actors. I'm just telling you my experience over 9 years.
They're not a bad actor, right? Because they're not. You're paying them checks every month, but they're not promising to pay you anything. So that's not a bad actor. You give me money, you give me your money, and I'm not promising anything in return.
Well, that's not true. They say here, I understand that any monthly shares, but I looked up the contract, because you have good points, I receive will come directly from fellow members. By the way, if you don't make the share, they keep track of that. If you don't make the payment for 2 months, you're basically on suspension and maybe termination. It's kind of like an insurance company in that angle. If you don't pay your monthly bill, you're not going to have insurance.
But it's one way. It's only half of the insurance, because with insurance, you got to pay them, but then they got to pay you. Under this arrangement, you got to pay them, but they don't have to do anything. And that's the thing that's sort of surprising to me, that this is a process. You got to pay them, and they can take the money, and that's not any problem of ours. So, quick question for you though: how did you get involved with these guys? Did you hear about them? How did you get involved? Was this through your church? Like, what was your involvement?
No, I had a tax client, and we're talking about, it was about 2012. We're talking about he had a family too, and we're talking about how, and he's in self-employed basically. I own the LLC I work for, but it's basically self-employed, not technically, but basically. And what happened is the medical insurance bills are through the roof, $1,500, $2,000 a month. They're bigger than the darn mortgage. And so he said he found this. It was a friend of mine, not through church. It was a client. And so he said he found it. He check it out. I looked at him. I called him up in 2012 early, and they sounded good. My wife is usually the dubious one. She said, "I hope this works." And it did work. I wasn't pretty surprised, but I was pleasantly surprised. And everything seemed to be no problem. I would have paid over the last 9 years, $1,500 a month times 12, 18,000 a year, 170,000. And instead I paid roughly not even 500 a month on the average, 6,000 times 9 times 6, 55. It's a difference between 175,000 and 55,000 over the last 9 years. It's a lot of money. And you could, if you're really super careful, unlike me, you could bank that and keep a reserve like the HSA accounts that people have, and you could just shove it into something like that. Plus, two interesting things. Up in the Northeast, these aren't really that well known, but in the Midwest, in other parts of the country, they are. But it's interesting. My daughter went to Providence College, and my other daughter before that went to school in Philadelphia. They wouldn't take it when the older daughter went, it's too weird or something like that. But the younger, it's getting more popular. So they said, yep, because when your kid goes to college, you have to have insurance. Otherwise, you buy the college's insurance. And so over the course of the 9 years, one daughter, they said no, and we tried. And the other daughter, they said, yep, it's okay. So I'm just telling you my experience. I had no problem. So.
And you seem like an honest fellow, and I understand it. We have a problem that we're well aware of, which is that if you're running a small business in this state, insurance is really expensive. But it sounds like you went looking for an alternative, an affordable alternative to a regulated insurance product, which is a totally understandable thing to want to do. This wasn't motivated by a faith-based issue. You're not morally opposed to insurance or anything like that.
Yeah, it's not, I'm not against a faith-based.
No.
In fact, I'll tell you a funny story. On the application, you have to say you somehow have a connection with a church someplace. I don't think how do they enforce it, but I call it, they have like 2 rules there. On the one I use, one of them, I call it the Protestant rule, where you have to be a teetotaler. You can't drink any alcohol. And the other one, I call it the Catholic rule, where you could have alcohol, but you can't have too much. You have to in moderation. So I guess there's certain areas of the country where they're, and I checked obviously the second one, but I mean, it's a funny thing. It's like, I don't know where this came from. It reminds me, Senator Lesser, I think of the Amish. I mean, I don't know hardly anything about the Amish, but I heard they get together and they build somebody's barn in like 2 days or something like that. And this is kind of the healthcare equivalent to that. But there's one other big interesting thing. The percentage, because I researched this a little bit, the percentage of your premium dollar or share dollar, whatever you want to call it, that goes to the medical side, the medical providers in the typical large insurance company is under 60 cents. It's like 58, 59 cents. As far as I could tell, I'm no expert on that. And these guys, it's in the 30 points higher. It's like 88% or something. So on a $1,000 bill, 880 or something like that is going to medical providers with the healthcare sharing ministries, I think. And on the big boys, the traditional behemoths in the industry, it's $580. That accounts for a lot of the savings in my mind. It's just more lean. It's a lean, mean operation.
I hear that, and I want to thank you for this back and forth. And I've had some fun with it. I know you have too, and I'm very sympathetic to the decisions you had to make. We'll just say one thing on that last point, which is we know what that number that you just cited, the amount that goes to healthcare as opposed to administration. We know what it is for insurance companies in the state because they have to report that, right? Those are audited. They've got a Department of Insurance that looks over their books really, really closely. We know what those are because these are licensed, regulated entities, and if they lie to the state, they get in a lot of trouble. As far as I know, there's nobody looking at these guys' books. So they say 99% of our money goes to patient care. Maybe, I don't know. But
it's not 99, it's like 80.
I know, right? No, but whatever the number is, we're taking their word for it. There is.
That's a good point. I'm an accountant. So I asked them, I wasn't sure they were a nonprofit, but they are. They're a 501c3. And I said, well, the tax return's publicly available. So unless they're lying to the IRS, you can get your answers just by going to the IRS website and getting their 990. You can do it. I mean, I didn't do it. I got too much work to do. But the bottom line is you could actually find, I bet you could find out from publicly mandated information what their percentage that they not go to medical providers is. Probably can.
Worth an investigation. So thank you, Mr. Zablocki. I appreciate your testimony, and I will pass it back to the chair.
Yeah, and I just add the bad actors, though, the deceptors. Like my company said, I didn't know this. They don't do any brokers. They don't want any brokers, and I think that's a good point. And I think if you pursue that, that's maybe a partial answer to your problems. That's it.
Thank you so much, Mr. Zablocki. And we will see you on the other side, as I say. Okay. Thank you. Have a nice night.
Yeah. Bye.
Seeing no other questions, we will move on to William Halstead. And after that, we'll have Stina Wazer.
Good afternoon, Madam Chair. My name is Ted Schroll. I'm speaking for Mr. Halstead. He's wasn't unable to make it, so he asked me to sit in and do his testimony, if that's okay. Okay. Okay.
Yes. Thank
okay.
you.
I'm sorry. Good afternoon, Senator Lesser, Representative Wood, Senator Huang, and Representative Cavalak D'Amato. My apologies. And members of the Insurance and Real Estate Committee. My name is Ted Schroll. I'm a 40-year retired volunteer firefighter from Weathersfield. I'm also the legislative representative for the Connecticut State Firefighters Association. I am testifying on behalf of William Halstead, president of the State Firefighters Association, and he's also the fire chief of the Sandy Hook Fire and Rescue Fire Department. Connecticut State Firefighters Association represents approximately 26,000 career and volunteer firefighters in Connecticut. We also administer the operating budgets of the 9 regional fire training schools in Stamford, Fairfield, New Haven, Derby, Wilkett, Middletown, Hartford, Litchfield, and Willimantic. Our association wishes to support Senate Bill 1042, an act considered firefighter training and crumbling foundations. The fire departments have become more than just firefighters. The fire service has become more of an emergency services department. Among these emergency services could be a call for a crumbling foundation because that sometimes endangers the home's occupants. Sections 2 and 3 of this bill pertain to paying for the costs for training firefighters. The cost of operating at training facilities has risen, which drives the cost of tuition for classes. The tuition for a volunteer firefighter is now in the $1,000 to $1,200 range. It has been noted that some volunteer firefighters have had to pay their own tuition out of their own pocket. If this bill can be passed, those concerns can be greatly reduced or even eliminated. This way, a volunteer fire department obtains a new tool in their recruitment and retention toolbox. The volunteer fire service is no longer just a cat in a tree. Many fire service evolutions have become specialized. Someone smells an odd odor, we are supposed to be hazmat technicians. A hiker gets injured or stranded on a mountain hike, there is a high angle rescue. That same person gets trapped below ground, there is a confined space rescue. Vehicle batteries used to just illuminate your headlights. Now a battery the size of your back seat in an electric car can be fatal to the untrained rescuer. A residential foundation fails, we respond. Firefighters must be trained to accomplish these tasks. If we do not, we become victims. The insurance industry directly benefits from professionally trained firefighters. If you pass this bill with section 2 and 3 intact, the fire service will benefit, but the citizens of Connecticut will actually be the winners.
Excuse me, sir, if you could wrap up, please.
I am just finishing. I'm going to ask if there's any questions. I do have a couple of 1 or 2 suggestions, possibly in the text or in the bill as it stated. On page as an amendment on line 151, from 150 to 151, it mentions how the Commissioner of Emergency Services will perform several functions to get this function in operation. We would like to suggest our thoughts throughout our organization, that we should suggest that the state fire administrator or his designee be involved with the commissioners group to be sure that the fire service is represented on whatever whatever they were going to have to put together as rules and regulations. And one more thing I must make clear is you heard Rick Hart testify. He and I work rather closely together. Many states do this, so this is not a new function. This is not something new. There are a lot of states out there that do this and on a regular basis and really have been doing it for a long time. I've heard of this before in my career with more than 40 years, probably at least 20 or 30 years ago, that there were towns that were, or different states that were doing this exact same thing. So we'd ask you to consider that too. Thank you. Any questions? I'll try to entertain.
Thank you very much. You can tell Mr. House said that he had a good fill-in for him for his missing. We'll see him next time.
Thank you.
Do you have questions? Senator Lesser?
Yes, thank you, Madam Chair, and thank you, Ted, for your testimony. Certainly appreciate the language suggestions and appreciate the importance of funding these regional fire schools. So look forward to working with you and making sure that one way or the other we can solve that problem. I know that's been a problem for some time. So really appreciate your testimony today and look forward to continuing to work.
Senator, respectfully to the suggested amendment, as you realize, of course, we're very fortunate that we've had several commissioners of desks down there that work very well with the fire service. But into the future, as we all know, but we just think that we probably should have someone with a little bit of fire service experience to help, only to assist the commissioner. That's all we look to do.
That makes sense. Thank you.
Thank you.
Thank you, Senator. Representative Delmicky.
Thank you, Madam Chair, and thank you for coming here, Ted.
Thank you.
You made mention of the amendments that you would like to propose or have proposed.
Mhm.
Do you have them committed to paper?
No, I do not. We found out about this public hearing actually only last Friday when the bill came out. And there's just been some discussion back and forth amongst some of us about it. So we don't have anything, but we would like to think it would be relatively simple. That just that with the commissioner, as it's stated now, the commissioner shall establish, and then it goes into several functions that he would be doing. I guess we would only suggest that in something like in collaboration with the chief state fire administrator, and something, whatever, if there's any other people they thought should be in there, but we just really feel that someone within the fire service should be there again to assist the commissioner.
Can you provide those suggestions in writing to the entire committee so that we have it?
Sure. Give me a couple of days and make a couple of phone calls and see what we can work off with.
I think that would be a big help for all of us to know where the folks that actually do the training and run the schools and do the heavy lifting, what they'd like to see.
Yes, and in fact, Rick alluded to it. Further down your list, number 52 on your list is Scott Bisson. He's the assistant chief for training in Fairfield, and he also is the administrator of the Fairfield Regional Fire School. So he's a hands-on administrator, firefighter actually, that actually runs the school. So he's on a day-to-day basis working with fire trainees and whatever from around. Again, it's a regional school, so he gets them from all over the area. So as I say, I've been out of retired and out of the service for a little while, just trying to help out a little bit. Scotty is our guy on the ground. He knows as much as you want to know about a fire school. So I suggest, hope maybe he's listening, maybe he isn't, but pick his brain good because he's got some good ideas.
Well, I certainly appreciate you coming forward today, and thank you for your testimony. And did you say you were Wethersfield Volunteer Fire Department originally?
Yes, I was.
I had the pleasure of working with John McAuliffe years ago.
Oh, John and I were like peas in a pod for a while. Him and I rode back and forth to our chiefs meetings, so we're that close. Yeah. In fact, John and I were in high school together.
John's a great guy.
That was just a couple of years ago.
Yeah, I hear you. Take care. Thank you again. Thank you, Madam Chair.
You're welcome. Okay, seeing no more questions, thank you very much, Ted, and we'll see you around.
Thank you, Representative.
Okay, next we have Sina Wazer, followed by James Sweeney. Welcome.
Thank you. Good afternoon, Insurance and Real Estate Committee Chairs Lesser and Wood, Vice Chairs Anwar and Comey, Ranking Members Huang and Pavelakti Amato, and distinguished members of the committee. Thank you so much for allowing me this time to deliver my public testimony. My name is Sina Wazer, and I am a 17-year-old climate activist from Mansfield, Connecticut, the co-director of Sunrise, Connecticut, and a junior at UConn. I'm here today to testify in support of SB 1024, an act concerning insurance and climate change. As I'm sure you're aware, climate change is ever accelerating, threatening our state, nation, and world at large with unprecedented climate disasters. From rising sea levels to the spread of disease in new places to exacerbated food and water scarcity. You would expect that insurance companies would be divesting from fossil fuels, since otherwise they will be the ones bearing much of the cost for these climate change effects. However, quite the opposite is true. Insurance companies are invested in fossil fuels, in pipelines, and in the destruction of my generation's future. However, this bill would ensure that the public is aware of how much companies have invested their money and are able to see which companies support fossil fuels. It would allow prospective employees, especially young prospective employees of these insurance companies, to look into how the company is investing their money in fossil fuels or not in fossil fuels. Although we need much more from both insurance companies and the state in terms of climate action, having access to information, being able to see which companies support what, is certainly a step in the right direction. It is a step towards protecting communities of color and low-income communities who are disproportionately affected by climate change. It is a step toward protecting my generation's future, which is also disproportionately threatened by climate change. And it is a step towards Connecticut becoming a climate leader. As such, I hope that the Insurance and Real Estate Committee will support this bill and work to ensure its passage out of the committee and through the General Assembly. Thank you.
Thank you very much, Tina. I think I've seen you testify a couple of times this year already. So, Senator Lesser, do you have a question?
Yes, thank you, Tina. I just wanted to thank you for coming to the Insurance and Real Estate Committee. I know that you've done such all across the state of Connecticut. So obviously, I think this particular angle is really important to fighting climate change and also supporting our insurance industry, because they're not only are they involved in investments and underwriting, but they're the first to pay out when we have increased claims because of the climate crisis. And I think you're also right that companies that are really taking a lead in showing they take this seriously are also have a leg up in attracting new talent. I think it's something that a lot of younger workforce seem to care about. So my hope is that we can work together to sort of standardize how that disclosure works and really put Connecticut at the forefront. So I appreciate your testimony, and I think it's a good conversation, and hopefully we get somewhere.
Yeah, thank you so much, Senator. Yeah, I definitely think it is really important for students who are looking for jobs in these companies and want to work there, that may be concerned about where the money of these companies is. So definitely very excited about this bill.
Thank you.
Thank you very much. Okay, thank you very much. Have a good night. Our next up is Jane Sweeney, followed by Brian Anderson.
Hi there, Senator Lesser, Representative Wood, and all members of the Insurance and Real Estate Committee. Thank you for the opportunity to speak today. My name is Jane Sweeney from Farmington, Connecticut, and I'm testifying in support of Senate Bill 1007, an act requiring health insurance and Medicaid coverage for the treatment of severe obesity. I am currently the clinical manager for the surgical weight loss program with Harvard Healthcare Medical Group, and also medical weight loss as well. I just want to give you a quick background and a history in relation to the disease of obesity for myself. I am a registered nurse, and I worked for 10 years on a medical surgical floor in acute care in the hospital. This is really where the journey began for me. I had many, many patients, and even on an average day, I would say the majority of my patients were suffering from the chronic health issues that accompany obesity. These individuals were suffering the effects of not getting effective treatments for their disease, and were at the point where they were what we might call a frequent flyer. They were in the hospital for multiple visits, many, many medications. We were treating them for things like, for type 2 diabetes, congestive heart failure, chronic kidney disease. There's countless things. And I guess for me, I feel like I want to represent them here today, because having gone through that with them as an advocate for them, I just want to mention that today. I know we talk a lot about numbers, but I also want to just mention the people who have suffered and what I've seen. And really that led me to the role I'm in today, because as a nurse, I just wanted to solve this problem. And so I'm so happy in the role that I'm in, because currently what I get to do is, as the clinical manager for this program, I get this, there's this amazing treatment. And I think what I'd like to do today, because no one's really explained what the treatment is. I think we assume that it's just surgery, which is absolutely not the case. But if you ask a group of surgeons to speak, you're just going to hear about the surgery. But I just want to quickly make it clear what we do for our patients, and what other patients aren't able to take advantage of. But the treatment involves at least three levels that we focus on, which is behavior modification, nutrition education, and exercise education. So we have multiple specialists, from behavioral health to registered dietitians, some exercise physiologists that work with us, and our whole team of providers. And we have a program set up that we are working to help change their mind, as well as their body. If you don't do that, surgery isn't going to do much. It'll help with the metabolic. And I know we talked a lot about metabolic surgery, but there's a big component of this, which is also mindset. And I want to make sure I touch on the fact that these patients are treated holistically, and it's a, incredible program that, I want everyone to be able to take advantage of. So I just wanted to at least also mention.
If I could ask you to wrap up your 3 minutes.
Okay. Yep. I'm just wrapping up. So, I wanted to just mention also quickly that part of my job is I not only get to see the incredible transformations and the life-saving, measures and how people get their lives back, but I also have to talk to all the patients, or many of the patients, who are unable to get coverage. Just this week spoke with someone who she's been waiting over a year. She's got a job, she works hard, she has no insurance coverage, and she's put weight on, her health's deteriorating, and so I represent her as well here today. But basically, especially what we've seen with COVID as well, I just think now more tthan ever, this coverage is so important. And I just asked you to please pass Senate Bill 1007 in support of this coverage for the treatment of these life-saving measures. Thank you.
Thank you, Ms. Sweeney, and thank you for filling in those gaps in watching all day and filling in those
all
gaps.
Day. Yep, I've watched all day, so I thought I'd at least touch on. I think it's important to understand what the treatment really is.
Absolutely, thank you so much. Any questions from the committee? No, I think we're good. Okay, have a good one.
Thank you.
Evening. Okay, next we have Brian Anderson, and then after that we will have David Arcos.
Good afternoon, Chairman Lesser, Chairman Wood, Chairman Comey, and members of the Insurance and Real Estate Committee. My name is Brian Anderson. I'm a legislative coordinator for Council for AFSCME, a union of 30,000 public and private employees. Our union strongly supports Senate Bill 1043, an act concerning the Hartford Courant. The destruction of newspapers is a problem across our country. President Thomas Jefferson warned Americans over 200 years ago that a democracy cannot survive without a thriving free press. Jefferson believed in this so strongly that he said, "Were it left to me to decide whether we should have a government without newspapers or newspapers without a government, I should not hesitate a moment to prefer the latter." The best antidote to corruption is a body of journalists bringing truth to the public. We should know this in Connecticut. The corruption of one of our longest-serving governors, John Rowland, was first exposed by the Hartford Courant, the Journal Inquirer, and other newspapers. These papers showed that Rowland had turned state government into his own personal cash register. If not for these newspapers, perhaps Rowland would still be governor today. The Hartford Courant is America's oldest continuing newspaper. Sadly, it appears to be in the process of being destroyed by Alden Capital, a hedge fund with no loyalty to the staff or subscribers of the Courant or to the citizens of Connecticut. This was recently shown by Alden Capital when it laid off over 150 local workers who printed the Courant. Alden Capital showed this when they severely slashed the reporting staff of the Courant. Alden Capital showed this when they closed the physical plan of the Current, forcing reporters and editorial staff to work from home rather than in a central office where journalists can compare notes, share information, and form stories. Alden has shown a pattern of weakening and debasing the very newspapers that is supposed to safeguard across the country. When such an unworthy steward is in charge of such a vital function, it is necessary in a democracy for government to lend a hand. Thank you for your consideration.
Thank you very much, Mr. Anderson, taking us down memory lane there a bit.
Not such good memories.
Wow. Any questions on this? No, none from the committee today. Thank you very much for joining us. I don't see number 43, so we are going.
I'm here.
Oh, you are. I'm sorry.
Yeah,
right.
no problem. Sorry. And David, unfortunately, because of the hour, had to step out. I'm Yevgeny Shrego. I'm the other signer on the written testimony. I hope it's okay if I testify on his behalf.
Your name? I'm sorry, I missed it.
Yevgeny Shrego. So I'm testifying here today on behalf of Public Citizen, a national public interest advocacy group with more than 500,000 members and supporters. And I'm here to testify in support of SB 1047, an act concerning insurance and climate change. Adopting its disclosure and regulatory approach would establish Connecticut as a leader on climate change and insurance regulation. Climate change is already affecting the insurance industry adversely. On the underwriting side, climate change is increasing the frequency and severity of natural disasters. On the investment side, continued investment in fossil fuels exposes insurers to transition risks from falling asset prices and stranded assets. Insurers also face reputational risk from their fossil fuel underwriting and investments as campaigners pressure them to abandon these activities. And they are. Globally, at least 65 insurers with combined investments worth $12 trillion have adopted divestment policies of some kind. But unfortunately, many major US insurers, including Travelers, which is domiciled here in Connecticut, continue to underwrite coal and oil and gas without any restrictions. This behavior exposes US insurers to ever-increasing risks. US state insurance regulators are also well behind in addressing climate risk. The NAIC's Climate Risk Disclosure Survey, which is the main tool used today, yields only the bare minimum information for most insurers. To date, only New York has announced plans to supervise insurer climate risk in a deeper way. In contrast, European regulators have been adopting robust disclosure requirements and begun to incorporate climate risk into their assessments of insurer resilience. With the threat of climate catastrophe continuing to increase, this bill, 1047, recognizes that the status quo is unsustainable. The reporting requirements in 1047 use informative metrics that all insurers can provide today. Investment in fossil fuels is a good measure of transition risk. Data on fossil fuel underwriting can highlight insurers that face potentially massive liability for the effects of climate change on their clients. And as climate science advances, the bill allows new metrics to be added by the Department of Insurance. Disclosure is a good start, but it won't be enough. The insurance department will need to use the clear mandate in this bill to integrate climate risk into the many tools it uses to supervise insurers today. It will also need to align insurer activities with 1.5 degrees Celsius global target. If global temperatures exceed these targets, it's going to exacerbate the physical harms of climate change, which is going to cost insurers more money. So insurers with activities that are inconsistent with Paris targets are actually increasing the cost that all insurers and, as a result, consumers and policyholders will bear in the future. Delaying on vigorous climate risk legislation is going to harm the planet, and it's going to harm the future viability of the Connecticut insurance industry. We encourage the committee to favorably report this bill and the General Assembly to adopt it as quickly as possible. Thank you, and happy to take questions.
Thank you very much, Mr. Shrego. Any other questions from the committee? Seeing none, we thank you for coming this evening.
Thank you.
Okay, number 44, Mr. Galito, David Galito.
Good afternoon, Madam Chair, Representative Wood, fellow Realtor, Senator Lesser, always good to see you, and members of the Insurance and Real Estate Committee. My name is David Galito. I'm the first Vice President for Connecticut Realtors. I've been a Realtor for 18 years and live in the city of Middletown. I want to thank you for the opportunity to submit testimony on behalf of Connecticut Realtors in support of House Bill 6624. But before I do so, I want to thank all of you, your colleagues, and the current administration for deeming real estate as essential and allowing us to continue to work throughout this pandemic in helping our in-state residents as well as out-of-state residents realize home ownership here in the state of Connecticut, all while helping Connecticut's economy.
You guys know we have a caucus at 5? Yeah. Okay.
With regard to House Bill 6624, many of you know that Connecticut Realtors represents over 17,800 members in all aspects of real estate in the state of Connecticut. This bill proposes to modify the preconditions for issuing a real estate broker's license in Connecticut. Specifically, the bill changes the time a person has been actively engaged as a real estate salesperson from 2 to 3 years and requires that salesperson to have actively worked under the supervision of a licensed real estate broker in Connecticut for at least 1,500 hours during the immediately preceding 3 years. Current statutory requirements include that brokers having actively engaged in real estate without a clear definition or ensuing compliance with that criteria. Therefore, those who have not engaged in a manner of real estate other than holding a real estate license are deemed qualified as actively engaged. This would now define the term to require the prospective broker to have represented either a seller, a buyer, a lessor, or a lessee in at least 4 real estate transactions that have closed during the 3 years immediately preceding the broker application date. Real estate brokers, as Representative Wood knows, has the required oversight of all agents and transactions within their brokerage firms. Presently, an individual can obtain a broker's license without any knowledge of transactions and by simply holding a real estate salesperson's license without spending even an hour practicing real estate in that time period. Connecticut Realtors is concerned consumers, the most important piece to all of this, cannot be served on what is their largest financial investment when involvement or oversight includes zero experience with transactions or the practice of real estate. The Department of Consumer Protection could establish form of submission of information, which could be as easy as attaching documents showing payment for transaction services, printouts indicating listing, selling, leasing agent in a closed transaction. I would kindly—
You could wrap up.
I will, thank you. In addition, CTR also respectfully requests to submit language to this bill related to the issue of real estate teams. The Department of Consumer Protection has identified there are presently no statutes or regulations that permit the advertisement of real estate teams to the public. This amendment seeks to provide the definition of a team and requirements for the team names to ensure transparency to the public. It also establishes the supervisory relationship, registration process, annual fees, renewal fees, change fees to cover the cost DCP to establish and maintain this new reporting for team. Connecticut Realtors work closely with the Department of Consumer Protection in drafting this language that the department has approved. You'll find it in the attached testimony. This should solve past difficulties DCP has identified. In conclusion, I ask for your support of House Bill 6624. And with that, I thank you very much for your time and attention to these matters.
Thank you very much. Representative Wood.
Thank you, Madam Chair. David, it was great to hear your testimony. I would guess, but please verify that there are a lot of new agents coming into the industry now with the tremendous amount of homes being transacted on the market.
Well, I can say, Representative Wood, that over the course of even the past year or two, there have been a lot of people coming into the real estate business. In my section, which is Middlesex County and New Haven County, we have, as you know, real estate classes and people need to do they register to become an agent, and then they have to attend an orientation that our local association provides. And those, at least 4 times a year, at least 70 people in the class we've been experiencing. So a lot of people coming into the,
right.
not just because of what's happened over the past year.
Right. And are you seeing, bad actors in the industry? Is that why this was put forward, or is it really just more for the part of the consumer, more of a stronger consumer protection bill?
This has always been all about the consumers, Representative Wood. It's important. We take our job very seriously, and professionalism is very important to me, and I know to my fellow realtors. And to be able to increase not only the education, but the process to becoming a broker, because those brokers do more than just house agents under their agency. They're responsible for everything: training, the clients that each and every one of those agents represents. So there's a lot of responsibilities that a broker has, and it shouldn't. The process in getting there should include much more education, which it was changed some 8 to 10 years ago, and now to have the requirement to perform real estate and have so many transactions under their belt is extremely important, as you know.
Yeah, no, I really appreciate you guys, stepping up and bringing these stronger consumer protections, to the committee, and we look forward to working with you further. Thank you.
Thank you very much.
Thank you, Representative Wood. Senator Lesser?
Yes, thank you, Madam Chair, and thank you, David. It's been good to get to work with you over the years and come to rely on you as really a trusted source for real on-the-ground information about your industry, and you are immensely knowledgeable. So it's great to work with you and with the realtors. This is a small thing, but just looking at the testimony, I know that you said you submitted some suggested language additions that you've worked out with DCP. We don't have that listed in our online testimony, so I just want to make sure that we actually get the language that
we will get that to you.
Okay, great.
Definitely.
So we'll take a close look at it and really appreciate it.
Absolutely. We'll ensure, we'll have Jim Heckman send that off to you.
Terrific. Thank you.
You got it.
Okay, thank you very much. Seeing no other questions, thanks. Have a nice night.
Thank you.
Yes, Samantha, hi.
Hi, thank you, Representative Comey, Senator Lesser, Representative Wood, and members of the committee for the opportunity to testify today, and for the attentiveness and care you take in considering the issues before you. I am very appreciative. My name is Sam Danowski. I'm the State Director of Sierra Club, Connecticut, and I'm here to testify in support of Senate Bill 1047, an act concerning insurance and climate change, on behalf of our more than 40,000 members and supporters in Connecticut. Sierra Club is committed to solving the climate crisis with just and equitable solutions that will result in a healthy world for everyone. The science is very clear that we must significantly reduce our fossil fuel dependence in less than 10 years to avoid catastrophic warming. There is also a growing body of research on the negative health impacts of fossil fuels. As a state, we have been responding. Connecticut was one of the first states in the nation to pass a law to reduce greenhouse gas emissions in line with the science, the Global Warming Solutions Act. But while our state has taken action to address climate change, our flagship insurance industry has largely not taken action. It continues to play an outsized role in climate-destroying fossil fuel production by providing insurance to and by investing assets in fossil fuel companies. We applaud the committee for raising Senate Bill 1047 as an incredibly important step to improve the information available about investments in and underwriting of fossil fuels, as well as the risks associated. Given the current and predicted impacts of climate change, shareholders, policyholders, employees, residents here in Connecticut, and our decision makers have a real need to know this information. We urge your support of Senate Bill 1047 and thank you for consideration of our testimony.
Thank you, Sam. Anyone have any questions? No, that will be it. Thank you.
Thank you. Good night.
Okay, next we have Ms. Elizabeth Kerrigan here. Don't see Elizabeth, but I do see number 47, Laura Hawk. Thank you.
Yeah, thank you, Representative Comey, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. I am here today to submit testimony on House Bill 6622, an act concerning prescription drug formularies and lists of covered drugs. My full written testimony is posted to the committee page, but I wanted to share a few key points. My name is Laura Hoke. I'm a senior manager of advocacy at the National Multiple Sclerosis Society based here in Connecticut. I would first like to thank Senator Looney, Representative Cook, and Senator Summers, all of whom have introduced this concept for several years for their continued advocacy, as well as Senator Anwar, who introduced it this year. When someone is diagnosed with MS, their clinician will typically prescribe a medication known as a disease-modifying therapy, which is used to modify disease course, treat relapses, and manage symptoms. Finding the right disease-modifying therapy, or DMT, that's most effective with the least negative side effects is an arduous process, and these drugs are not interchangeable. Switching for any reason other than medical necessity could lead to hospitalization or lengthy stays at rehab centers, both of which are much costlier to the system than the difference in drug prices. Legislation, as Senator Looney outlined earlier, would prevent mid-year formulary changes, often referred to as non-medical switching. Something important to note is that it would not prevent insurers from adding additional drugs to the covered formulary if they choose to do so. People with chronic conditions like MS often base their decisions to enroll in a health plan on the available information about the medications they need, medications that have an average brand price of over $91,000. And allowing insurers to essentially break the contract and change the policy during the term is inherently unfair to the patients who need these medications. I would also like to touch briefly on the financial impact of this to the state. House Bill 6622 is the same legislative language that passed in 2019, passed the House on an overwhelming bipartisan line in House Bill 6096. That 2019 version of the bill was amended to the language that currently exists in 6622, specifically to decrease and limit any financial impact to the state. The potential minimal costs left after the 2019 amendment would also likely be offset by the savings seen when patients remain stable on a medication and don't have to be admitted to the hospital or rehab facilities due to relapses or adverse effects. Interfering with a person's course of treatment poses dangerous threats to their health and safety, and HB 6622 goes a long way in protecting Connecticut residents. We do encourage the committee to amend this bill slightly to require that insurers provide notice if they plan to remove a drug from the covered formulary at the end of the policy term, in addition to the rules set forth in the bill currently. This notice should be given before open enrollment begins so that the insured is aware of any changes coming and they're able to make the best decision for them in terms of coverage moving forward.
Thank you very much, Laura.
Thank you.
Any questions? Thank you for waiting around and joining us this evening. Have a great night. Okay, next we have Beverly Joliwa. After that, we'll have Sam Hallemeyer. Beverly?
Hi, I was having troubles unmuting.
Would you like to turn on your camera?
Oh, I'm sorry.
That's okay.
Okay. My name is Beverly Kaliva, and I appreciate, after you guys having such a long day, that co-chairs Senator Lesser and Representative Wood and members of the Insurance Real Estate Committee are willing to still listen. I am in support of Bill SB 1007. And I feel that bariatric surgery has changed my life in a positive way. And I am fortunate that my insurance has covered it. I had the sleeve in 2019, and then I needed a revision to bypass this past January 13th, 2021, due to severe reflux. And I think that bariatric surgery has improved my life by ridding me of, my blood pressure is better, my sense of value, it has restored my confidence. I have 5 grandchildren that are my life. My necklace around my neck is my entire immediate family. And I will be here for a long time to enjoy life with them. And I think it should be mandatory that all insurance companies afford the people that are obese to have the same surgery that I was fortunate enough to have. Dr. Tischler is my surgeon, and the surgery team has been awesome. Prior to that, I had another surgery team for the other one, but I think that bariatric surgery is saving people's lives every day. And I think the insurance companies are in the business of saving people's lives. So I think it would be much cheaper in order to do the surgery versus a long-term dealing with someone that's obese and all the illnesses that go along with that. It also, I no longer have acid reflux. I woke up without that horrible feeling. So I can, if you have any questions, I'm here for that.
Thank you. Well, thank you for your testimony, and glad to see that you're doing well, and really appreciate your testimony. Are there questions or comments from members of the committee? If not, thank you for being here today. It makes a difference.
Thank you for listening very much. I hope it passes.
Next up, we have Halmeyer, followed by Eric George.
Thank you, Chairman Lesser, Madam Chair Wood, and members of the committee. My name is Sam Halmeyer, and I'm here on behalf of the Pharmaceutical Care Management Association, otherwise known as PCMA. I'm here today to provide comments to oppose both House Bill 6622, which is the mid-year formulary changes, as well as Senate Bill 1045, which is step therapy. PCMA is the National Trade Association representing pharmacy benefit managers, which administer prescription drug plans for millions of Americans. I want to start out by saying PBMs exist to make drug coverage more affordable by aggregating the buying power of millions of enrollees through their plan sponsors and payer clients. Through these employers, health plans, and public programs are not required to use PBMs. Most choose to because PBMs help lower the cost of prescription drugs. I'll start with House Bill 6622, which would restrict the ability to make formulary changes during the contract year. By mandating coverage for specific drugs, regardless of availability or effectiveness, more affordable alternatives, House Bill 6622 will increase healthcare costs for employers and individuals in the form of higher insurance premiums and drug prices. This type of policy would cost Connecticut healthcare payers $70 million over the next 5 years. And for the state employee plan in Connecticut alone, where CVS, one of our member companies, administers the prescription plan, this legislation could raise costs anywhere between $3.3 million to $7.4 million per year. Although health plans use formularies, if a patient needs access to a non-formulary drug, health plans and PBMs have in place appeal processes for patients to request coverage. The health plan or PBM works with the patient and their provider to access these non-formulary drugs. Next, I want to move to Senate Bill 1045 because we believe it will remove one of the tools we use to provide a high quality benefit that puts downward pressure on the rising cost of prescription drugs, and this tool is step therapy. Step therapy requires an enrollee to try a medically appropriate first-line drug, typically a generic alternative to a branded product when a new therapy is initiated. Some drugs have many harmful side effects, but more often have a high list price, and step therapy encourages to use those lower, cheaper alternative drugs first. If Connecticut implements prohibitions on step therapy, projected drug costs for the fully insured employers and commercial health plans would increase by $554 million in the state of Connecticut over the next 10 years. Senate Bill 1045 also aims to reduce the use of mail service. CMS showed that drug costs were 16% lower at mail service pharmacies compared to brick and mortar stores. Additionally, mail service is a contactless method to ship medications to a patient's front door, even during a pandemic. To conclude my testimony, it is in the interest of Connecticut patients and payers to not pass these bills. So we must respectfully oppose House Bill 6622 and Senate Bill 1045. But I'm happy to work with the committee and key stakeholders on these pieces of legislation. And I'm also happy to answer any questions of the committee. Thank you.
Thank you, Mr. Hallmeyer, and I appreciate your testimony. Obviously, we have heard from an awful lot of people this year and in previous years who have felt that they've been victims of a bait and switch when it comes to formularies that change mid-year. And I understand, I understand the importance of keeping prices steady, and someone's got to eat the cost if a drug company wants to raise the prices mid-year if those dates don't align. We can't be the only state to wrestle with this. Has anybody figured out a way to hold consumers harmless so that if you opt into a plan, you don't find that you've lost access to a critical medication mid-year?
I can look into that, but off the top of my head, I'm not familiar of any state that, if a patient signs up for a plan and then a drug is removed, any penalties again. I can look into that further, Senator, but I don't know off the top of my head specifically states.
You understand what I'm saying? Like, you have a dispute with a drug company, you're trying to negotiate. We want to make sure that those negotiations happen. I don't want to limit your ability to do that. But we got consumers we got to protect who signed up for specific products. So I don't know if there's a, we've dealt with sort of analogous situations when it comes to surprise billing between payers and providers. Like this is not the first time when we've wanted to hold consumers harmless. Is there a way, is there an avenue to do that? Because that's what we're struggling with. That's what we're sort of being directed to do by folks who testify here. Because it seems to be a recurring issue that people keep on having this as an issue. So that's why I'm curious if there are any models that you're aware of. If not, we may be able to invent around.
Sure, I'm happy to look into it further, Senator.
Great, thank you. Are there questions or comments from members of the committee? I think there's a hand up. Let's see. Yeah, Senator Anwar.
Thank you, Mr. Chair. Thank you, Mr. Hallmeyer, for your testimony. So I wanted to ask you a question. I'm going to show you something from the Financial Times about the 8 best-selling drugs in the United States. I hope people can see this. And if you look at the longer blue lines, these are the prices in United States, and the smaller ones are in Canada and United Kingdom. And what is suggested is that your PBM is the causation for this. So I'm trying to understand, why do we as Americans have to pay multitude factor more price of the medications? And when I try to get people in the room and then say, what is the cause? Everybody points at you. Now you're in the room, I want you to point at somebody else, but figure it out. Why is it that we are paying about 10, 15 times more for the same medicines that we make? And then as the US citizens, we are being charged the highest amount, to the point that we're looking at getting the medicines and import them from Canada or any other part of the world if we can.
Senator, thank you for the question. I could barely see the graph, but I do understand the point of your question. It may sound like I'm deflecting here, but PBMs don't set the list price here. We solely exist to drive down those costs. We pit competing drugs against each other to get a lower cost and pass those rebates on back to the plan to lower premiums.
So when I am sitting down with the insurance, I know Eric George is going to speak, they're going to point finger at the pharmaceutical industry. The pharmaceutical industry will point finger at the insurance company. And when we get both of them in the room, they point the finger at you. So it's like, how do we get to the solution for this? Because this is the time when people retire, they're hoping to have a reasonable life. But majority of their Social Security, majority of their savings are going as co-pays or deductibles for their insurance. And it's not sustainable. And I see people in other parts of the world who actually are enjoying their retirement, and they don't have the PBMs. So again, I'm trying to make sense of it. Our interest is to make the lives of our citizens better. And we are not getting there. and the cost of drugs is a very big factor in this. And it's a complex process. I have a graph of how you guys do what you do. But it's like so many middlemen in the picture that everybody even takes about 3-5%. That's just adding to the cost of the entire process. So can you explain why we are paying 10 times the price at a minimum on some of the medicines in the United States?
Again, Senator Anwar, my answer would be, we don't set the list price. We solely exist to attempt to drive down these costs. I would point to the manufacturers who set these list prices on why your bar graph is so high compared to other countries.
Okay. So it's the pharmaceutical industry then.
The drug manufacturers, again, I hate to sound like a broken record here, but we don't set the list price. We do everything we can to get that price lowered for US patients.
Okay, thank you for your testimony. Thank you so much.
Thank you, Senator.
Thank you, Senator. Representative.
Good afternoon. How are you? Thank you, Chairman. Sorry, should have said that first.
I'm great. Good evening.
Good. So this is going to be a thing. Senator Anwar and I agree on this. So I was wondering, we've had lots of conversations with drug manufacturers, insurance companies, and everything else. And when it comes to this this drug cost, it does seem like a whole lot of not me, not me, not me. And we heard drug manufacturers saying a couple of meetings ago that that they don't set the price. So now you're saying you guys don't set the price. I know insurance companies don't set the price. So now I'm just wondering who sets the price and who's the one that we can actually sit at the table to say, and if you can also maybe talk on how rebates play into all of this and how the rebates are facilitated and how they're not applied toward customer cost.
Sure. I'm shocked to hear that a drug manufacturer representative said that they did not set the price because PBMs
retail price. I think maybe was it retail price? I can't remember exactly, but they said they didn't have anything to do with the price at the pharmacy.
The pharmacy. Okay. Again, I'm gonna have to. They set the list price. PBMs have no control whatsoever of the list price of the drugs that the drug manufacturers make. As far as rebates, the rebate discussion goes, that is a tool that PBMs have to lower drug costs for patients. So if there's two drugs of the same class, essentially PBMs will pit them against each other to see who can get the lowest rebate. And then with those rebate dollars, PBMs collect them and then pass them back on to the plan to lower premiums for patients. So while those patients may not get them at the pharmacy counter right then, it's definitely passed back to their plan sponsors to lower premiums overall.
Okay.
Representative Nuccio, I'm going to just, I'm as interested as I think anybody is in trying to figure out prescription drug prices. I just would remind all members of the committee, we're looking at specific bills here. And so while I'll grant members some leeway to talk about bigger issues, if we could try to confine remarks and questions to the bills before us, I think that would help us get through a very long agenda today. So, and I'll yield back, Representative Nuccio.
Thank you. Sorry, I was led down a path. I had to take the opportunity.
Yes, you were. Absolutely. No.
Okay, so in relation to the bill that we have in front of us with the formularies, I guess I'm not really understanding the pushback on being able to assure a patient or a customer, when they get into a plan, that plan is going to be stable for a year and or their policy period. So I guess I'm struggling a little bit with trying to understand why we would be okay with changing formularies mid-policy year.
Sure, there were some examples that I'd be happy to share with you. It's in my written testimony as well. For example, Vioxx is a drug that PBMs removed from formularies before the FDA determined that it was unsafe for patients. So that would be an example that I would use. In the Hep C space, Sovaldi versus Harvoni, those are an example of the rebate where we pitted these two drugs against each other to get the lowest net cost, which is why we would choose the lowest net cost to be put on the formulary. And again, that's also in my testimony.
Okay, well, I can appreciate the FDA piece of it. That part I obviously can, but I'm going to review your testimony in that and see if there's more in there. But thank you very much for your feedback. I appreciate it.
Thanks. Thank you, Representative. Representative Masters.
Well, if you've heard Senator Anwar and Representative Nuccio, you don't want me to go down the road about what I think about policy benefit managers. So, and I won't go down the road with begging the indulgence of Senator Lesser. Everyone's got their hand in my pocket on healthcare costs, and no one is putting any money in it. They're emptying it. So the question is, how do I stop sew my wallet shut? The issue on I'm willing to consider your concerns about FDA and efficacy and approval, but when I have constituents who come to me on multiple sclerosis medicine, where they finally flatlined on their treatment and they get a bait and switch, I'm really not interested in having that dialogue. So I have concerns about medical efficacy as well. And Senator Anwar and I are on so many different positions on where we stand on certain things, but there's a moral and ethical piece to this that I'm just not, I don't know how much flex I have. And I understand your job is to manage the cost of the healthcare, the policy benefit managers, but I'm not even comfortable where that money flows, whether it's going to the pharmacy or the insurer or my constituent. So I'm not going to accept prima facie that you're, somehow the policy benefit managers are the Albert Schweitzers of the healthcare industry, because I'm lost in that model. Every time I ask who it is, it's like when I ran at my children and said, "Who broke the cookie jar?" And they all pointed at each other and they said the other one did it. I'm reaching the end, and poor Susan has heard the lecture. At 50,000, we're in a public option. If my annual cost, which is now 36 or 34 or 26 with a $10,000 deductible, if we don't get control of the Hydra, we don't even need a good public option. We won't be able to afford a private option. So you should understand in the constructive way, I'm trying to figure out, one, what's going on. And in this case, I understand you're claiming there's a lot of savings involved. I'm compounding at 8% a year. I don't know if you save me any more money at 8% a year, I'm bankrupt. So it's a confusing exercise for me. And I'm sorry to beat you up. You are not the sole person of my ire, but I question I question whether we're getting someplace efficient. So I apologize.
No apology necessary. Thank you, Representative.
Thank you, Representative, and I hope we get control of the Hydra. Are there other questions or comments from members of the committee? If not, thank you, Mr. Hellmeyer, for your testimony. Next up, we have Eric George, followed by Susan Halpin. Good afternoon, Eric.
Good afternoon. Thank you, Senator Lesser, Representative Wood, Senator Huang, Representative Pavlak-D'Amato, and members of the Insurance and Real Estate Committee. My name is Eric George, and I'm president of the IAC, where we represent the property and casualty and life insurance industries. We do not represent the HMOs. I know that's a bit of a disappointment to some folks, but we do not. I'm here to offer some testimony on numerous bills. I'm going to get through as many as I can, going as quickly as I can. House Bill 6623, which is P&C insurance, on sections 1 and 2 that deals with other structures. This is problematic. Most homeowners have additional structures, even if they don't own a shed. Driveways, stone walls, fences, sheds also. These are other structures. And insurance policies are standardized to include some basic components. This is to make it much easier and user-friendly for consumers to comparison shop. And we also want to make sure that insureds are protected from things that they might not think of. So excluding other structures could be very problematic. Section 3 of that bill also deals with disclosures at the time of quote. It's important to understand the information that we know when we have the quick quote. We don't have all the information, and the information that we do have has not yet been validated. Carriers, even the small ones, receive hundreds of quotes every day. And out of those quotes, less than 10% ultimately purchase a policy. So that is a problem as well. Finally, section 4 would require the department to study ways to accelerate homeowners' claims. We don't think this is necessary. Expedient processing of claims is mutually beneficial to both the insurer and the insured. Delay is costly to everybody. The industry is already one of the most highly regulated industries in the state and in the country. We're under, quite honestly, intense scrutiny by our Department of Insurance, and rightfully so. We're subject to review and market conduct examinations. Moving on to Senate Bill 1046, long-term care. We understand and appreciate the desire to lessen the shock of legitimate and necessary rate increases in LTC policies. But there are impositions in 1046 that are limiting on insurance that we view as arbitrary. We are worried that if we have these limitations in place, quite honestly, the solvency of many of these companies may be put into question. If the solvency of these companies actually comes to fruition, then we have major issues that policies won't even be offered in Connecticut anymore. Some flexibility does need to be in place. I would note that back in 2014, Public Act 14-10 is where we have the current limitation on LTC premium rate increases of 20% or more to be spread out over 3 years. We think that is a pretty fair balance. Moving on to Senate Bill 1047, climate change. I want you to know that the P&C industry is very involved in the environmental risk and climate change issue. We have certain principles and policies in place that we've agreed upon. That's in my written testimony. Please review it. We are working very closely with the NAIC. We do believe that uniformity in this area, and we're happy to work with you. Uniformity in this area on a nationwide basis is critical. Moving on to 1042.
Excuse me, sir, if you could please wrap up, your time is up.
I figured I wouldn't get through it all. So there are several other bills where I have my testimony on file. Please refer to it. They deal with the surcharge for fire. Just you are already paying for that, the payment of the fire schools in your budget. We think that's the correct policy decision to make. And there are other issues as well. I'm just not going to be able to get to everything. We had 7 bills that we were dealing with today here. So I'm here for you guys if you'd like to ask me any questions.
Thank you, Eric, for your testimony. I'll just focus on the 2 that you were really able to, the non-shed bills that you were able to address in some detail. So one, long-term care insurance. You obviously understand the feedback that we've received from constituents who are seeing sky-high premium increases. The concern they have with the current use of the 3-year phase-in of increases over 20% is that if companies are able to get another bite of the apple each subsequent year, that becomes sort of a meaningless phase-in, because you have a layering of increases on top of increases. The best available information that I think we've received from the Department of Insurance suggests that they would be able to prevent that layering without risking in an actuarially sound manner. And obviously that limits their tools, but that's something that they would be able to do. And that other states seem to be moving in that direction. Is that incorrect?
Is it incorrect that the department is working on this and believes that they have a way to get to a better result?
To protect, obviously they're working on it, but to protect, a way for them to prevent the layering of increases in each year in a way that is actuarially responsible. Obviously, there's some inefficiency anytime you limit any kind of rate increase. But what I'm saying is, does that bring down the entire industry, or is that something that they can?
So I guess to your question, I talk to Paul Lombardo and his team quite frequently, and I have the utmost respect for them. While I am certain that they have initiatives in place, not only that they're working on it, but that they have the ability in place to address many of the issues. And I know that they're working on it not only on the state, but also at the national level. And the NAIC is very involved in the LTC issue. So I would say that statement is correct.
Yeah, so that's just my sort of thought, is that I will defer to the department, but Mr. Lombardo, who's helping lead the long-term care regulation issue, the rate increase issue on the national level, I believe the department can work with the language that we have, or at least the intent behind it. And if that's incorrect, I want to be very careful about proceeding, but if we can make it work, my sense is that would be a huge benefit. Is one of the most annoying things I know for people who are struggling with these increases, seeing layering year after year after year, even though the law says you're supposed to have that 3-year pause.
And please understand, Senator, I completely appreciate the position that you're in, the position that the department's in, and I appreciate where LTC policyholders are being are in a position of frustration. Our issue is that if companies can't be solvent under a system, they just won't be there. And if they're not there, then the issue goes away because there are no policies to be purchased. And I don't think anybody wants to get to that. I think what you're talking about, which is an extended conversation, we would very much like to be a part of that, because I know that your head and your heart is in the right place, as is the department's. So we would like to work with you on that if that's acceptable.
Absolutely, would love to work with the industry. We've got a lot of work to do. There are a lot of very frustrated consumers out there, and we need a long-term care insurance. It's a really vital tool for consumers out there. So I look forward to that conversation. With regard to climate change, as you know, this was the climate change working group was something that the NAIC started ago. And then it became dormant. The current disclosures, I think, date back to 2009, and they were kind of slim then. And so, the argument that we need uniformity, that we need to standardize the disclosure across the country, I think makes all the sense in the world. And I don't think it would be a good idea to have 50 different states passing 50 different laws. That said, NAIC hasn't done a whole lot with this issue in over a decade, and I think they may be starting to now again, but they are way behind the curve. So what can we do to jumpstart that process? We are a disproportionately important state nationally on this issue, but what can we do to make sure that, working with our colleagues in California, Washington, wherever, get this thing going in a way that works?
Well, I think recognizing the strength of your department is a great starting place, and especially the strength of your commissioner and the leadership position that he has over at the NAIC, because he is in a position to, if things move along, to potentially be the president of the NAIC in due course. So I think that Connecticut has been a voice that has been heard at the NAIC for many, many years, and I expect the voice to get louder.
And you don't see a role for us as a legislature. Obviously, we have a great relationship with the folks there who've been leading the country in terms of this issue. But in terms of giving both a nudge to both regulators and regulators, you don't see a role for legislation.
No, I didn't mean to infer that. I do not believe that there is no role for the legislature. If you look at my written testimony, what I think that we need to focus on are the principles that the insurance industry has endorsed. And again, we're in a later hour in the evening. I'm not going to go through and read all of these. They're there at your disposal. I think it's a longer conversation, but I did not mean to infer. If it was taken like that, then that was incorrect. That there is no role for the legislature.
Okay, great. And I would look forward to working with you again on how to best do that.
And I share that sentiment.
Great. Thank you, Eric. Questions or comments from members of the committee? Representative Delnicki.
Thank you, Mr. Chair. And good afternoon. It's still afternoon. Good to see you there.
Hi.
Couple of questions. When insurance is issued for a building, what role does the quality, and when I say quality, the ISO rating of a fire department play in the establishment of rates?
I'm going to have to say that I will not know that, Representative Delnicki. I don't have that information.
Seeing that fire is a substantial issue.
So fire is obviously a substantial risk to all structures. So
Okay.
if the point that you're making is that it is in the interest of the insurance industry to have a well-trained and staffed and resourced fire department, I couldn't agree with you more. I could not agree with you more. I didn't get to touch on it too much, but I'll say this now. Here's the issue with a surcharge. A surcharge puts the insurance industry in the position of a bailiff, and we are a bailiff for the money of the state of Connecticut. We become the tax collector for the state of Connecticut, where we conduit the money from policyholders and then remit it to you. That is not how insurance companies are structured. They were not created or ever envisioned to be a tax collector. We recognize that there's only one instance in homeowners where this is done, and we all are very well aware of it in the Crumbling Foundation's scenario. I will say that it is to see the precedent that the Crumbling Foundation surcharge has begun, because now we're talking about training for fire. I would say, and I would posit this to you, I agree that fire training is paramount. And I think it should be it is a line item in the budget. And I think it should be perhaps a more well appropriated line item in the budget. Understanding the history of Connecticut in terms of when we are in tough times that we have gone into funds, there perhaps are ways to protect those money. But I would say that a surcharge on any type of paper, and here we're talking about an insurance policy, just isn't the proper way to fund that. And I think funding is important for these fire schools.
But you would submit, if the ISO rating were better in a community, that would reflect a lowering in the cost of insurance.
I will say that what you're referring to, the ISO rating on fire, I'm not going to comment upon, because as I've said, I don't quite follow what you're asking there.
Real simple. If you have a better ISO rating in a fire department.
What I am saying is the insurance industry and insurance overall will benefit from a well-trained and well-staffed and well-resourced fire department. And we support that, but we do not think going through an insurance policy to impose a tax is the right way to do it.
So, but you do acknowledge that you already are.
We do. You imposed that upon us a couple of years ago. Yes, you did.
And have there been problems with administering that?
I mean, have there been problems? No. What we have become is we've become your bailiff. We've become the state of Connecticut's bailiff for that surcharge.
I appreciate your comments. One last comment or question. And I realize maybe this will get an answer one way or another. If a fire department had a rating of 10 versus a fire department have a rating of 1, looking at the same community, if that community had a fire department with an ISO rating of 10, which is the worst, would it be an expectation that you would have a higher premium rate for that community versus if that community had a fire department rating of an ISO 1?
Without knowing specifically how that is impacted, what you said sounds reasonable, but I would not attest to that because I don't have the information.
Well, I thank you for your comments there. I think there is a obvious connection, in my opinion, between the quality of a department and how it would reflect on the policy cost for insurance for a structure. But I think we could debate that all night, huh?
I would feel bad for the people that are coming after me, but we could.
Eric, thank you for your testimony. Thank you, Mr. Chair.
Thank you.
Thank you, Representative Delnicki, Representative Meskers. And I will just say, because of Eric's comment about staying here all night, we do have about 30 more people left to testify. So hopefully we can get to folks tonight.
I'll take that under advisement. Thank you, Chair Lesser. So I guess the issue on LTC is a mutual problem. The actuary, I guess you did a floating rate on the actuarial costs, and the costs keep on rising, and therefore the premiums keep on rising. So we're stuck in a circular trying to cover healthcare for long-term care into a system that's the prices are going through the roof.
And I mean, Representative Meskers, you're making a very good point. If you look at, so it's funny, I used to do health insurance, but I don't anymore. But my recollection, and I know that others coming after me will have a much better on the tip of the mind recollection of this, is that the overall cost of an individual's health care, you can see how the later portion of the life represents an enormous portion of the overall cost of care for that person, going from the beginning all through their other years, all the decades, and then at the end, that's where all the money is spent. And it's the way of life. That's never going to, quite honestly, that's not going to change, and I'm not going to advocate for that to change. But if we look at it, a long-term care insurance is difficult. It's very difficult. I mean, look at the way it's marketed. It's very difficult in any state, Connecticut being one too.
Okay, I'll cut you off because I accept the answer. I just wanted to get there first. Second question. In relation to Representative Delnicki's commentary and questions, the opposite. I'm not sure what the interactive dialogue is between yourselves and the insurance commissioner in the current framework. Hear me out in terms of fire insurance. Are there pieces of the code or pieces of that we should consider in Connecticut that would have a material impact on premiums? So apart from the standards that each state sets standards, I'm not sure what the sensitivity point on standards versus premiums are. So if we can reduce the incidence of fire, reduce the cost of a fire incident, presumably we reduce the premiums. Is there much iterative conversations along those lines?
So in the broad, so our homeowners insurance policies are a product and an evolution of the standard fire policy. The standard fire policy is what all homeowners insurance was evolved from. So do we have conversations with George Bradner and his team? He's the head of P&C over at the DOI all the time about mitigation and keeping structures safe and reducing costs. I won't say that it's only isolated at all to fire. I would say that it is a very broad conversation that we have in, when they have coastline issues, when you have other
Okay, I'll cut you off, Eric, again. I would suggest Representative Nuccio is dangerous as a mathematician. I'm dangerous as a banker. I would like to make sure that we're having iterative conversations about regulatory framework that might have a positive construct on premiums. So if there's stuff we need to consider as a legislature for the individual expense of the individual homeowner that will have significant impact on driving down premiums over a 20 or 30-year period, I'd love to have the conversation about NPVing some of those improvements.
I think that's a great idea. And I can tell you that at that broader level, those conversations happen a lot more.
Okay, perfect. And that was it. Sorry, Mr. Chair.
Thank you, Mr. Chairman. Thank you, Representative Meskers, for your testimony. I can't speak to this hour than I. Thank you, Representative Meskers. Thank you, Eric, for your testimony. Next up, we have Sue Halpin.
Good afternoon. I guess good evening almost, everyone. Thank you for sticking out the day here with all of us. Appreciate your time. For the record, my name is Susan Halpin. I'm here today on behalf of the Connecticut Association of Health Plans. And I wanted to address my comments to a couple of bills. In particular, Senate Bill 1045, and I apologize that some of my section references are inaccurate in my written testimony, so I will resubmit that at a different time. Step therapy is a critical tool that health plans use that support evidence-based treatment and support cost containment. I know there's been a lot of conversation about the cost of pharmaceutical prices today and what we can do about that. One thing I can tell you is that if this legislation passes and some of the other pieces of legislation that are before you, the costs will go even higher. What carriers do is try to make sure that the use is appropriate. And if you just look at the underlying statute in a couple of the bills that are being talked about today, you will see all of the things that the legislature has done to protect in this area, and it's been significant. And I will tell you also that my suspicion is that a lot of the folks that you're hearing from around formularies and around step therapy is most likely in the self-insured market. I'm going to just draw your attention really quickly to 38A-492F, and I'm reading it off my phone because I have it referenced in my testimony, but not the actual section. And it tells you that a carrier cannot deny coverage for any insured for any drug that an insurer removes from its list of covered drugs if the insured was using the drug for treatment of a chronic illness prior to the removal, the insured was covered under the policy for the drug prior to the removal or cessation of coverage, and the insured's attending healthcare provider states in writing that the drug is medically necessary. So if you look both in that instance and in some of the other instances that are in the underlying sections of these bills, you will see that the legislature has taken considerable action already. Very quickly, the clinical peer sections remove the term similar from the similar or same specialty. While that might seem like a minor change in the statute, it is significant. And it would require, I think, as some of the commentary suggested earlier, that for every specialty that's out there, that you have a peer review in that exact specialty, which really will just grind things to a halt from the purpose of prior authorization. The section that changes the burden of proof flips that statute on its head. And it really is there are matters of legitimate dispute for issues around medical necessity. And Connecticut has one of the best external appeals processes in the country that Connecticut again led the way on, and this language was exported to other states across the country. Typically, those external appeals range from about a 50-50 response when they're conducted, which demonstrates that there is legitimate disputes around this area. Just from a practical perspective, when you talk about a carrier determining or the burden of proof being placed on the carrier to determine medical necessity, the carrier does not have the access to the medical records that demonstrate medical necessity. So if you look at it just from a practical perspective, it doesn't work. And I guess this issue has been considered and at least 5.
Please wrap up. Your 3 minutes is expired.
Yes, will do. This issue has been considered a number of years in a row. I think it has never moved forward because it literally will represent the single most expensive mandate that ever passed. And I can't imagine that it will make it through. And just one last thing, if you look at the formulary bill, I did include in my testimony an excerpt from a fiscal note from 2019 that suggests the fiscal impact just for the state of Connecticut would be in the range of 7.4 million for annually. So, you know, the cost is significant, and we all know that the state employee plan has a very expansive benefit system. So that tells you what it would mean for the private sector. So thank you, and thank you for the indulgence.
Thank you, Susan, for your testimony. I was with you for most of it, but at the end, did you just say that a bill that was introduced by the Senate President you can't imagine getting through? I'm doing sure I understood what your last point there.
Well, I said I think the reason it hasn't gotten through in past years is because of the fiscal note that would be attached to it.
Okay. Thank you very much.
I would never suggest that a bill from the Senate President wouldn't make it through if it was a priority. So if I said that, I stand corrected.
Thank you for clarifying. Representative Nuccio.
Thank you, Chairman. Hi, Susan. How are you?
Good evening. Nice to see
Good. It's good to see you too. So you mentioned something there that I would like to see if you have anything that you could expand on. If you said if this portion passed, it would be the single largest, most expensive mandate on insurance. So, and a mandate on insurance means an increase in cost across the board. So, can you give a little more detail or meat behind what brings you to that conclusion and what you think it would do to healthcare costs across of the whole entire insured populace?
Sure. I mean, I think if you look at it in the context of how it would function on a practical basis, and any procedure that was put forth by a provider was presumed automatically medically necessary. First, it's hard to envision the scenario whereby, how would a carrier appeal that if they don't have the medical records, right? How would, and where would that go to at that point in time for matters of legitimate dispute? Also, when you look at, if you assume that, let's just even say the charges are there, the procedures are there, I think someone said earlier, what's the difference between getting an X-ray or an MRI, right? So you'd have to go back and you would have to justify why someone shouldn't get an MRI, but you don't have the medical information to make that justification at that point in time.
So yeah, that was me. I said that. So
it's hard to tell after a little while.
Yeah. So also, I think that this would open up doors to stuff that I think processes like medical necessity were put in place for abuse of the system, abuse of billing, which then trickles also down to the person who's actually paying for their insurance or actually paying their cost share and everything else. So from that perspective, it would also, is it your opinion that it would also cross over into experimental treatments or things that have not been proven or things that are considered to be risky across the board if there was no way for insurance to come in and to mitigate and to provide insurances for that the insured was being protected?
Absolutely. And, I've been around doing this for way too long now, and some of you may like to see me go at some point, but if you think back on experimental treatments, I mean, I remember when I think it was bone marrow treatment was being used for breast cancer. And it actually ended up being harmful. And I remember having a mandate before the legislature at that point in time where we were, making that case that, the clinical evidence did not follow the treatment pattern around this. And I think a lot of people felt it was very promising. Patients felt it was promising, but that would be a perfect instance where it was later determined that it was not. Similarly, we went through this with the opioid crisis. I do remember when the pain management momentum was at the legislature, and we were considered just looking out for the dollars when we were pushing back on some of those broad pain management proposals to cover opioids. And I remember our medical directors were at the time the ones that were really raising the red flag, saying there's going to be repercussions of this kind of legislation. And in fact, we all know, fast forward, what happened. So absolutely, I think those questions around medical necessity and and it's not necessarily abuse if people think what they're doing is the right thing, but it's a protection. It is a consumer protection at the end of the day as well.
Yeah, there's a lot in this bill. I think there's a lot of pieces of it that don't necessarily kind of coincide. Is there anything in the bill that you do agree with and think that is a good move forward?
I can tell you, we have been looking at the expansion of who's covered under, I think it's sections 1 and 2 to dependents and stepchildren. And I have not heard any response back that isn't covered. So, we've been looking into that more and more. I feel like, again, there have been numerous pieces of legislation that have passed around formularies and step therapy. And we feel very strongly that, moving these bills forward will do more harm than good at the end of the day. I'm trying to think of the other section there. I don't have it in front of me, but I would be happy to get back to you with that. I kind of focused on the things that were raising an alarm as opposed to the things we should pass, but I'll be happy to get back to you with that.
That's fine. I do think there's wiggle room in the formularies, though. I do agree that I think people who lose their medication during a policy year, that there has to be some consideration for a path that is working for them and maybe make changes on a new policy year thing. So I think there's some wiggle room in there. But as always, thank you for your input in bringing this information to the table. I appreciate it.
And if I could just respond briefly, the Department of Insurance just recently adopted regulations around formularies that provide for specific notification to members so that they have time to look at it. I think my concern about it, and believe me, I appreciate it. I've had it happen to me. I understand it. But if you look at it from the global perspective, and we have to maintain the leverage to keep those pharmaceutical prices low, because if you just play it out here, January 1, let's just say the cost of an EpiPen is $100, and in the marketplace, it's known that we have to keep it at $100 between now and December 31st. There's nothing to stop on the other end of that equation a pharmaceutical company from upping the cost of that, knowing that there's not going to be a backlash from the consumer because they're going to be covered. So I think, again, I understand the frustration. I understand Representative Musker's frustration, your frustration, Senator Lesser's frustration around these issues, but it really does, and there's a reason why everybody's, kind of pointing fingers at each other, because there are checks and balances throughout the system that aren't always working. But in this case, at least on the cost side, there's some check and balance that we believe is working. So happy to work with you always.
Thank you very much, Susan.
Thank you, Representative, and thank you, Susan. I would just challenge you, this, as I mentioned to the gentleman from the PBMs, this isn't the first time we've had to deal with consumers getting in the middle of a fight between two industry players. And I know that you aren't happy with the solution, at least that the Connecticut legislature found with surprise billing. So what I would suggest would be helpful for us is if the industry could figure out a way to resolve mid-year price increases in a way that holds most consumers that you can live with, because this is an issue, right? This is a problem that we're hearing from members of all four caucuses that are hearing about. And you can either join with us to help solve it, or trust us to figure it out on our own. And just based on experience with surprise billing and other issues, I suspect that the former will result in a better outcome just as a policy matter. And so we invite you to work with us on that.
And Senator, I appreciate that. And you've always had an open door on these issues. One of the things I just want to raise is, I do think, and I think data would help you on this, because I do think a lot of the issues that you're hearing from, and I know because I get them as constituent complaints, are happening in the self-insured market. So, we do have protections in place for the fully insured market. And what would happen if we put these in place is you're going to make it even more expensive for those most price sensitive folks that are in the small employer market that we're all trying to help, currently, because those are the guys that are going to feel it. But I hear you, and, we will look at that and respond.
But I think the tool, right, that the TPAs in the self-insured market are often companies that are also licensed as insurance companies, and it would be, if we could develop a tool to hold consumers harmless while negotiations are underway, that could be used by insured, fully insured plans and also by TPAs. I imagine it's the same issue, and you're working with the same PBMs. Finding that tool is important, but right now the folks folks who are getting hurt are consumers, and we got to figure out how to figure it out. And maybe you're right that really it's not a huge problem for the fully insured market. Forgive me, I think we've got some mail being delivered somewhere. But we need solutions here, and we're this is the umpteenth year. This issue is coming up. It's not going away, and something is going to pass at some point. I don't expect us to hammer that out now, but would certainly invite you to come to us. Representative Masters, I see your hand up. Is that for a second time?
I don't believe so, but I'm willing to be corrected by Susan.
No, first time today.
For the first.
Sorry about that. Thank you, Mr. Chair. So Susan, I want to echo Senator Lesser's comments. I think the question becomes, so we're trying to prevent the switch in the formulary, but you're worried they're going to use that as a signal that they're stuck with that and use it as the pretext to raise the price.
Yes.
So it suggests that some of the negotiations on what we call a free market, which doesn't allow me to buy my drugs anywhere in the world but from the guy who's marking them up, we need to figure out what the price control or the consumption or the contract that the insurance company has with the pharmacy, that they will commit for that period and that contract so that maybe you can't get a shop around for a cheaper alternative, but you can switch for FDA and you can't get the price jacked up on you because we forced you to continue to supply it to a constituent of ours. So we'll have to figure out a mechanism, because I understand that if I tell them you have to supply it at $100 cost and it goes to $400, we've got a problem in the system.
Yes.
But what you haven't told me is who I should be smacking. And that's probably the next level conversation, which is how do we control the cost rises, So I think that's a good conversation that I would leave to the chairs and potentially Representative Nutio. It's like, how do we get those, if we're going to want to lock in the formulary, we need to lock in the supplier prices as well, I guess is what you're saying.
Yes.
Okay, thank you.
Thank you, Representative Masters. Other comments, questions from the committee? If not, thank you, Susan, for us today. Next up, we have Scott Bisson from the Connecticut State Firefighters, followed by Anya Yastrova. I pronounced your name not completely inhumanely.
Good afternoon, respected members of the Joint Insurance and Real Estate Committee, and thank you for the opportunity to speak. My name is Scott Bisson. I'm testifying as the chairman of the Connecticut State Firefighters Education Committee, representing the educational needs of Connecticut's fire service, and the current director of the Fairfield Regional Fire School. I'm a fourth-generation firefighter. I am submitting this testimony in support of Senate Bill 1042, an act concerning firefighter training and crumbling concrete foundations. Every day, Connecticut's firefighters respond to hundreds of calls for service, including fires, chemical spills, rescues, and medical emergencies. The most important resource any fire department has are the trained men and women that respond to these calls and provide community risk reduction. Their ability to provide service safely and efficiently to the public is directly tied to the knowledge and experience gained through proper firefighter training. Unfortunately, the high cost of both initial certification training and the personal protective equipment required for each member to safely respond, as well as the operations of the specialized fire training facilities where live fire training is delivered, have negatively impacted the fire services in Connecticut. A well-trained and equipped fire service has been proven through Insurance Services Office, ISO, to greatly benefit the community and reduce overall losses through responsible risk management. This insurance-based organization sets hour requirements for firefighter training exceeding 228 hours annually, including 18 hours of required at fire training centers to receive the highest rating of Class 1. Senate Bill 1042 directly addresses these operational issues by providing aid to all Connecticut municipalities and the fire departments in their jurisdictions. The fire service has been looking for a long-term solution not only to properly fund the operations of the regional fire schools, but make fire training more affordable for local departments. Historically, the costs of this training have been borne by each fire department, where decisions are made on how many people can be sent to training or how many spaghetti dinner fundraisers they need to run to buy gear for a new member. This is a challenge that impacts both career and volunteer departments equally. Working with the bipartisan Fire EMS Caucus, I have testified more than once that this remains a top priority for the fire service. Through this bill and the creation of the new Connecticut Fire Safety Fund, we can finally fix a broken system of not just for 1 or 2 budget cycles, but for the foreseeable future. Connecticut will not be the first state to use this model to fund firefighter training. Other states such as Pennsylvania, Massachusetts, and West Virginia have already created similar accounts for this purpose with much success. This recognizes the natural correlation between having a properly trained and equipped fire department and reduced property losses from fire. The Education Committee supports the previous UPFFA request for substitute language in Section 3 that adds the state fire administrator and the ability to request funds to purchase safety equipment on a grant basis, and is included in my written testimony. The passage of Senate Bill 1042 will greatly enhance the ability of Connecticut's fire service to recruit, train, and properly equip firefighters across the state. It will ensure that the 9 regional fire schools' operational budgets are fully funded and that they can provide low to no cost training to all Connecticut firefighters in properly maintained facilities with safe equipment, as well as supporting other municipally operated fire schools, bringing basic training opportunities closer to each community. I respectfully request your support for Senate Bill 1042 and the entire fire service so we can focus on our core mission of saving lives and making a difference. Thank you.
Thank you, Mr. Bisson. Thank you for your testimony and for joining us today. I see Representative Delnicki has a question.
Thank you, Mr. Chair, and thank you, Scott, for coming forward to testify. And I'm going to ask you a question kind of out of left field. And it's the same question I asked Eric George. And I realize you're not an expert in the cost of insurance, but logically, if you have a better trained, better equipped department that ends up getting a higher or a more advantageous ISO rating, wouldn't it make sense that that would actually lower the premiums on insurance on structures?
It does, Representative, and thank you for the question. It is one of the standards that fire departments are working towards. And similar to Mr. Hart, who talked about it up in the Waterbury Fire Department, the Fairfield Fire Department is going through a similar exercise right now of reviewing our training, our equipment, our water supply, and our dispatch systems. They come in every 5 to 10 years, evaluate our departments, and rate us. And then insurance rates are derived from that, or is a part of the process through the public protection classification system. So we are all, Class 1 is the best department. There are the fewest number of Class 1 departments around in the state. Class 10 is a fire department that has no water supply, very little communications, and very little training.
Well, I certainly appreciate that answer. And one more follow-up. In your position, have you seen funds swept from the schools, a lack of any reliable funding?
Yes, as you know, because I've seen you at the Fire EMS Caucus meetings, we've had this discussion annually for many years, talking about restoring fire funds. As a matter of fact, it was the #1 priority of the Fire EMS Caucus about 3 years ago to restore funding that was completely zeroed out during the Malloy administration. It's just a sign of the times. We're trying to look for, and the Fire EMS Caucus charged us with coming up with a long-term solution for this problem, to avoid having to provide testimony every year at that caucus to try to restore funding for the fire schools. It benefits all of us, every municipality, to have trained firefighters and properly equipped firefighters in their communities.
Well, I thank you for coming forward, and I can tell you, we've been listening to you for quite a while and have taken it to heart. Thank you, Mr. Chair. Thank you, Scott.
Thank you, Representative. Other questions or comments for Mr. Bisson? I think there's one. Yes, Senator Wong.
Thank you, Mr. Chair. And Scott, how are you today?
Very good, sir. Good to see you.
Good to see you. It's been a long day for the committee, but it was great to see you, and what a beautiful backdrop of the fire school. And thank you for all the hard work you have done for the community. So talk to me about what the school does. You know, a lot of people just think the fire school is just simply training firefighters, which is an absolutely important job. But share with me what that facility does for the broader community as well. The latest example was the fact how that facility is a community resource and helped during the COVID pandemic of gathering people, collecting supplies, being a distribution center for a lot of the frontline workers and staff. Talk to me how important that facility, beyond just a training center, is a community resource.
Thank you, Senator Wong, for the question. As you know, because you came down during the height of COVID and dropped off some PPE supplies to us to put in the pool to distribute to other responders in the community, we transitioned once training kind of slowed down. We were first to be impacted by training because emergency responders that were going to training were also still responding to calls, were getting exposed to COVID, and then having to be quarantined. So we had to shift gears pretty quickly into a online or a hybrid environment to keep firefighters safe, able to continue to respond to emergencies. Additionally, we conduct a lot of medical training for new emergency medical technicians down here. We had to shift gears for that as well. One of the things we did specifically in Fairfield is we transitioned to supporting town government from a planning and operations side. Planning meetings were conducted down here. It became a logistical drop-off site and continues. Just yesterday, we had the USDA doing a food box drop-off down here and distribution to nonprofits. So we utilized the facility to support the region in that manner. We're part of the health department's POD, point of distribution program, where we receive personal protective equipment, gowns, goggles, masks, sanitizers, and distribute that out to other health departments. Just last week, I was training vaccinators, EMTs, taking the bridge class to become vaccinators to put shots in arms of people as more vaccine becomes available in the state. So we've really shifted gear that way. Fire schools provide a very unique opportunity for firefighters because it's the one place you can set a fire in a building and hopefully it remains safe while the people are training inside of it. Too many times people go out in the public and there's homes that are being donated. We call them acquired structures. And sometimes, and there's a process to try to conduct live fire training in those, but it's not the safest way to do it. So the fire schools provide that safe venue to keep firefighters safe. Unfortunately, just today, as I was online, because I've been with you all day since 9 o'clock, I was also dealing with a firefighter injury at one of the fire academies today. So it just goes to show you, even in safe locations, firefighters still get hurt, but we can manage the risk a lot better that way.
Well, let's hope that the firefighter that was injured is okay, and please extend my best wishes. And it's important. I know we're looking at insurance surcharges to fund this, and we're always looking for a steady revenue of money to be able to fund and provide adequate support for our fire schools. But wouldn't you think, as we talked about all of these critical community-based services, that isn't just for one town, it's for a region. Do you not think we should make a budgetary priority to put it into our budget instead of a surcharge?
I understand what you're saying, Senator, but our experience has been that we made that transition. We went from grants and we did put it in the budget, but it makes it extremely difficult to get proper funding for the schools without burdening the taxpayers or having it go through. Very often we see percentage cuts. Back in, I believe, 2017, it was zeroed out completely. So the answers to the fire schools were, okay, we'll close your doors and stop doing training. That's not acceptable for a service that's 24/7. So I understand what you're saying. I agree that there is some level of responsibility on the state to provide that. And they have done that for some things like responding to state highways and protecting state facilities. But this is that long-term solution that we've been looking for a very long time that will avoid us having to go back and look at this each time. It'll answer the questions as far as what's the proper number, because it places the budgets under the control of the desk commissioner and hopefully with some input from the state fire administrator.
Yeah, it is frustrating that we can't trust the budgetary process to prioritize what's important, that we have to go and reevaluate these type of strategies. This is not new. I know that. And we're always trying to make sure we fund you. I just wish we did that in our budgetary process to understand and appreciate the hard work that all of your men and women do in providing greater public safety. And I think the key is it is a community resource. It isn't just for the fire department. It is a community resource. And you point that out as well. And I think the last thing I'll leave you with is training is absolutely essential. One of the things I've learned from all of you, the great firefighters within the district, is the fact that fire safety and firefighting has changed so dramatically in the past number of years because of technology products, rubber, that fires burn differently. And in order to get our men and women to do their job, but to be safe, they need to go through that experience. Having gone through one of those dark, smoky rooms with the training that you have offered some of us, wow, you can't describe that experience. So I want to say my thank you to you for your excellent leadership and training, to Chief McCarthy, but also to all the men and women and your staff that support you all. Thank you very much. So thank you. I'm glad I caught you, Scott. Wishing you well. Thank you, Mr. Chairman.
Thank you, Senator. Representative Rochelle has her.
Thank you, Senator. And I just wanted to hop on real quick. I actually pulled over so I can speak to Scott Bisson and thank him for his advocacy on this issue. You know, for folks that are not familiar with fire training, can you just share with some of my colleagues the variety of classes that are taught at fire schools? It's so much more than fire. It's you know, car accidents, and it's ropes work, and it's hazmat. Can you just share for my colleagues the you know, that this is the amount of time that goes into these classes and the types of classes that are taught?
Sure. Thank you for the question, Representative Rochelle, and nice seeing you. And glad you're being safe pulled over. We deal with all hazards, and that really is the catch-all phrase. The fire service always responds whenever somebody calls 911. If if nobody knows who to call, it's usually us, and we'll go out and we'll troubleshoot and we'll figure out how to either fix the situation or guide the people in how to fix the situation. Some of the classes that we run, I'll leave the firefighting part out of it because that speaks for itself. Emergency medical training is going on. We conduct community CPR programs. We just ran 2 this past week. We have apparatus operator programs and driver training programs to keep people safe out there. We have outreach programs with OSHA. We've partnered with Keene State University to bring OSHA training for the construction trades and also people working out in the community to make that safer. All different levels of training come in here, in addition to the support for the fire service, for the region, and coordination of activities. Some of the other things I do down here is I'm a chairman of ESF Board, Emergency Support Function for Firefighting. We track and keep tabs on how many firefighters are quarantined on a weekly basis during the height of COVID. We're tracking how many vaccinators that are EMTs on the fire departments are going to be available for health departments as needed. So we really deal with all hazards. We deal with natural disasters. We deal with flooding. You know what the fire departments do. You can see it on the news. It's our job to provide the training to prepare people for doing that. The best way I could describe it is, if you have to go to the hospital for surgery, you're not going to go to a surgeon and have somebody who doesn't train, or maybe they train 4 times a year, which is the minimum. You know, for a firefighter, it's a lot more than that. So we're constantly training and trying to be prepared.
Thank you. And I also want to thank you for the hospitality that the Fairfield Fire School has shown to the Valley Fire School over the years, while we hope to get our school built hopefully sooner than later. But you've been a great partner at your school with letting us use your facility during that time. And, you know, I hope that this bill will go a long way towards realizing funding that is so incredibly needed to make sure that our firefighters get the training that they need to protect the community and protect themselves while they're doing their work. Thank you.
Thank you.
Thank you, Representative Rochelle. Other comments or questions from members of the committee? Seeing none, thank you for your testimony this afternoon. Next up, we have Dr. Yastrabov, if I'm pronouncing that correctly, followed by Gilbert Tartolino. And Thank you to all the folks who waited to testify for your patience here this afternoon.
Thank you, Senator Lesser. You pronounced my name exactly right. Chairman Lesser, Vice Chair Wood, and Senator Anwar, and members of the Insurance and Real Estate Committee, thank you for the opportunity to speak today. I'm very excited to be testifying today in support of Senate Bill 1007. I'm very passionate about providing the best care possible for our patients with obesity. My name is Dr. Anya Yastreboff. I'm an associate professor at Yale University School of Medicine. I'm an endocrinologist as well as an obesity medicine physician and a physician scientist. I've been at Yale for 15 years, focusing my clinical and research work on helping individuals with obesity. In my clinical practice, I specifically use combination anti-obesity pharmacotherapy to help patients reach their health and weight goals. As we know, it's projected that half of us in the United States will have obesity by 2030. That's in 9 years. Indeed, how many of us have tried to lose weight only to gain it back and then some? And as described this morning by Senator Berthel, it's incredibly difficult to lose weight and keep it off. Our bodies fight it, mistaking and thinking that we are starving, and this is the disease of obesity. Unfortunately, until recently, obesity was not understood to be a chronic disease, and patients were deplorably blamed and shamed for having obesity, and obesity was considered to be a personal choice. If a patient could not reach and maintain a healthy weight, they were considered to fail. The patient was considered to be a failure. We now know obesity is not a choice. It is a chronic metabolic disease with a complex underlying neurobiology, and that is the focus of my work. It is not the patients who failed. We failed them. Medicine failed them. But now there is hope. We have comprehensive, safe, and effective treatments for patients with obesity. You have heard from Dr. Flock and colleagues about surgical interventions, and I will share briefly about what we can do with FDA-approved anti-obesity medications. I'll share the journey of one of my patients who lost more than 100 pounds. My patient, for anonymity, we will call Mary. She was a 57-year-old woman when I saw her 2 years ago, and she weighed 250 pounds when I first saw her. Her body mass index was more than 42, classifying her as having severe obesity. She was also being treated for hypertension, hyperlipidemia, obstructive sleep apnea, and prediabetes. I started her on medication 1, and within 8 months, she lost nearly 20 pounds. I added medication 2, and over the next 8 months, she lost an additional 42 pounds. I started her on medication 3, and over the next year, she lost an additional 41 pounds. So in total, over a year and a half, she lost more than 100 pounds. Her BMI decreased from 42 to 25. Her weight decreased from 253 pounds to 151 pounds. She achieved 40% total body weight loss with anti-obesity medications. Her prediabetes resolved, and she no longer needed treatment for obstructive sleep apnea. With
Ma'am,
three,
you've reached your 3-minute mark. If you could just summarize, please. Thank you.
With 3 medications, she achieved her goals, and her story is not unique. These treatments have to be available and affordable for our patients. In summary, I ask that you give clinicians the opportunity to treat patients with obesity with all the available and safe and effective therapies, including anti-obesity medications. Let's make America a healthier place, and let's start with Connecticut.
Thank you, Doctor, for your testimony. And I know that the addition of the anti-obesity medications is a new addition to the bill from previous versions that we've considered in the past. Does insurance typically cover the medications, or is it really hit or miss?
Medicaid and Medicare do not. Private insurance payers, it's hit or miss, and it's a huge barrier. And for this patient, they covered the medicines, and she was able to achieve her goals.
And have there been cost-benefit analyses about the medication versus interventions versus other things that can be done? Is that, I don't know what the cost of medication is.
Yeah, that's a great question. And it's something that we've been asking for. I know it was mentioned this morning as well. So some of those studies are ongoing. And I think really the focus is down the line. So not even, 6 months or 2 years, but really lifelong. So if we help to prevent type 2 diabetes or prevent cardiovascular disease, what is the saving in terms of life as well as monetary cost? I can tell you that a lot of my patients who take these medications, they can come off of a slew of other medications. So they lose weight and they no longer need antihypertensive medications. They can come off their insulin. It's amazing and it's life-changing.
Yeah. Are there other comments or questions from members of the committee? Yes, Senator Anwar.
Thank you, Mr. Chair. Thank you, Dr. Jesterboff, for your testimony. These medications, what is the usual cost of those medications, and are these lifelong, or you are able to stop them after achieving goals?
Yeah, those are great questions. And also thank you for working with our residents at Yale. They love working with you. So the cost, it depends for the patient. If they're out of pocket, they can be hundreds of dollars, and some of them can even be thousands of dollars per month. So it's not affordable out of pocket for most patients. And that's not fair, right? It's not fair that some patients can pay for these and others can't. They should be available and affordable to all. In terms of needing to take them lifelong, yes, that's the case. So just like with any chronic disease, if you have high blood pressure, you need to keep on taking that medicine in order for your blood pressure to be normal. Same thing with diabetes and blood sugar. So why would we expect anything different of obesity? The goal is to decrease your body fat mass set point. So the medicines each decrease where your body wants to be in terms of how much it wants to weigh. So for example, if we start a medicine and a patient loses weight, if we take that medicine away, they're going to gain back the weight, just like their blood pressure would go back up if we took away their blood pressure medicine.
Good. Thank you so much. And I'm hoping that the insurance industry would recognize that they'll save more money by adjusting and management of some of these aspects. So
thank
you.
So much. Thank you. I was very happy to see this addition to the bill, which is why I'm here today. Thank you for your questions.
Thank you, Doctor. Other comments or questions from members of the committee? If not, then thank you for your testimony and your patience here this afternoon.
Thank you.
Next up, we have Gilbert Tartolino, followed by Jason Prevelich.
Excellent. Thank you very much, Senator Lesser and committee members. I appreciate your time. I'll be brief. I know it's been a long day for you. I'm calling in reference, or I'm here in reference to Senate Bill 1041, the healthcare sharing ministries. I've been a member of a healthcare sharing ministry, particularly Samaritan Ministries, who's been in operation for 26 years. I've been a member for 15 years, and I understand that legislation is being made because of some bad actors, and I would trust that the provisions in Senate Bill 1041 would not only protect consumers like myself, of course, against these bad actors, but also protect us who've been a part of a healthcare sharing ministry. And as this Samaritan ministry will be representatives will be coming on after me, they can let you know perhaps how many members are in Connecticut. There's other very reputable and honorable ministries that do this as well, not just Samaritan Ministries. And the costs have been tremendous. The service has been tremendous, efficient, cost effective. It would be a blow for our family for 15 years if they would not be able to operate here in Connecticut. And again, there's always, as our moms always told us, there's always a bad apple spoils the bunch. And we've been very pleased. The track record has been excellent, and we've been very pleased with the service that we've been getting through Samaritan Ministries. And I thank you very much for allowing me to speak on behalf of all of us who are involved in these ministries, these organizations, healthcare sharing ministries. Thank you.
Thank you, Mr. Tartolino. To your knowledge, is Samaritan the same as a company also known as Aliera?
No. No, I'm almost sure they're not, but I just heard recently of them. But I understand if Aliera is a profit organization that's posing as a healthcare sharing ministry, because I understand that there's been a company here in Connecticut that's been shut down in 23 states that posed as a healthcare sharing ministry. There's the problem. Samaritan's not posing at all. We are, and we are well pleased with our services. If you need any questions about how we operate, I'll be glad to answer those.
And just because you work for Samaritan, is that?
No. I'm a member.
Okay.
I'm a member of. Thank you for that question. Thank you very much. No, I'm a member for 15 years. No, I live in Waterbury, Connecticut.
Sure.
I'm not employed by them at all.
And how did you get connected with them?
Through a friend. Back in the 90s, I heard of them, but I didn't need to. My job provided it. I pastor now in Waterbury, and so it was very cost effective for my church. It was very cost effective for my family, and we wanted to represent our church family accordingly. So it was just word of mouth, and simply as that.
You previously had a traditional employer-sponsored health insurance, and this was your church opted into it as a more affordable alternative to health insurance.
That's correct. That's correct. Yes.
Okay. Thank you.
Thank you.
Any comments, questions from members of the committee? If not, thank you for your testimony.
Thank you, sir. Hope everybody has a great day. Thank you.
Thank you. You too. Next up, we'll have Jason Privilege, followed by Andy Grimm.
Esteemed chairs, ranking members, and members of the committee. Good evening. My name is Jason Privilege. I live in Fairfield, work at St. Mary's Hospital in Waterbury, and am past president and legislative affairs chair for the Connecticut Academy of Physician Assistants. First, I thank you for enduring such a long day and allowing us all the opportunity to bring forward our testimony. Please accept this testimony pertaining to Raise Bill 6626, an act concerning required health insurance and medical coverage, ambulance services, and cost transparency. In concept, we appreciate and support the intent of this raised bill, as it addresses a number of very important areas. However, as it is currently written, we respectfully ask for physician assistants, PAs, to be included in the newly added areas along with physicians and advanced practice registered nurses. As you're likely aware, PAs are licensed to practice medicine, work across all specialties and practice settings. PAs evaluate patients, diagnose disease, formulate and implement treatment plans. PAs do so autonomously every day while working in collaboration with physicians and the rest of the healthcare team. PAs are well educated and trained to perform such functions. Specifically, of House Bill 6626, Sections 25 and 26 address sections of statute that exclude PAs in regard to breast cancer detection. PA inclusion is similarly excluded in other areas of statute, and these areas have been vetted with stakeholders such as the Connecticut State Medical Society and the Connecticut Hospital Association, with unanimous agreement on the listed inclusions. The problem is inadvertently omitting PAs from such statutes is increasingly causing confusion to administrators, implying that PAs cannot perform a function that they otherwise should and could perform, simply because the PA is not listed. Such interpretation creates healthcare disparities by limiting access to care, as the patients are then forced to see other providers to obtain the services that they need. This inconveniences patients and physicians by placing additional burden on both, especially during these current times of the pandemic when healthcare is oftentimes harder to obtain than previously. So I ask that you please help improve the access to care that our patients deserve by including PAs as one of the providers that can provide the services named in this bill. And I thank you for your time on this matter and your dedication to the citizens of Connecticut.
And thank you, Mr. Privilege, for the testimony. I guess, are you talking about a underlying public health statute about scope of practice, or are you talking about specifically the insurance statutes that coverage?
Actually,
So typically we don't do scope. The reason I'm asking, and I have a lot of respect for PAs, I've gotten excellent care from them, but typically we defer. There's another committee, the Public Health Committee, that determines what the scope of a particular profession is, what a PA can do, what a PA can't do. This committee, we determine what insurance pays for. And so we try not to tell the public health folks what the scope is. Although Dr. Anwar is capable of practicing medicine, I'm not sure that the rest of us are. So that's the reason I was asking, is that this was an insurance, if there was something in the insurance statutes that limited the scope of PAs, because if that is the case, then that shouldn't be.
So no, to my knowledge, no. In fact, we actually have a bill raised within the Public Health Committee that addresses a number of inclusions for the PAs this year, including actually the sections that these two new additions are going into. However, it doesn't include these additions. These are now new areas. And as they're raised here, that's why we felt it pertinent to bring forward to this committee tonight, as this is where they're being presented. However, other areas we are looking to already have included, within this section already.
Okay, great, thank you. Any comments or questions from members of the committee? If not, thank you for your testimony.
Thank you. Have a good night.
You too. Next up, we have Andy Grimm, followed by Lauren Leclerc.
Thank you, Senator Lesser. Thank you, members of the committee. I appreciate your time, and I'm very impressed by your stamina. My name is Andy Grimm. I'm president of the Chicago News Guild Local, and for the last year, I've been working on a project for the News Guild, our international union, which represents about 16,000 journalists in the United States, as well as about 50 at the Hartford Courant. So I am here to speak in favor of Senate Bill 1043. You guys have already heard from some excellent experts in Fraser Nelson and Penny Abernathy. You'll be hearing from some folks that work at the Courant. So what I'd just like to share with you is some of what I have noticed over the course of my research in the last year. And it is exactly as Penny Abernathy said, that a successful newspaper can bridge the gap from the changing business model to the digital age if they have ownership that is trying, that is committed, that is mission driven. And there are examples that they've mentioned as well. The Boston Globe, recently the Salt Lake Tribune, where Fraser Nelson had once worked. So there are models out there, and the future for the Hartford Courant can be something along those lines. What you have in the other dominant business model in the trade are these large chains that are either saddled with debt, mostly from acquisitions and consolidations that generally harm news coverage, or they have a very extractive profit model. Alden Global Capital is the dominant shareholder in the Tribune Company, the parent company of the Hartford Courant. In an era when we lost about 50% of our the industry lost 26% of its journalists in a 5-year period from 2012 to 2017. During that same period at Alden Global Capital's newspapers, the decline was over 50%. So they cut jobs at a higher rate than folks in the industry. They extract profits. And what you would do with 1043 here is disincentivize that behavior. Tribune Company was paying out dividends instead of investing in its newsroom. Taking on additional debt is just cost. Gannett, the largest newspaper company in America, is currently spending all of its profits and laying off employees to meet the burden of a $1.8 million loan that financed a merger 2 years ago. So I'd also like to comment on the folks from the industry side that were talking about the government's role in deciding what the Hartford Courant does with its business. And I would say that the legislature has intervened in the long history of the Courant, and because they've seen a public policy benefit and a public good that was being served that would not be served as well. And I submit to the committee that legacy, it's one that we all enjoy and what everyone in Connecticut can benefit from. And so you can intervene, and there are ways to intervene by the legislature in certain industries. I am not sure how things work in Connecticut, but I would imagine that you cannot close an unprofitable emergency room in an underserved neighborhood if you run a hospital in this state. I would also note, I think I did the research correctly here, that you charge no sales tax on newspapers and periodicals. All of these are preferences that benefit the industry. And I think this would benefit both the long-term future of the Hartford Courant, and it's a long history.
When you've reached your 3-minute mark, if you could just summarize, please.
Certainly. So it would benefit both the citizens of Connecticut writ large and also help Tribune shareholders and the Tribune Company. So that all good.
Thank you, Mr. Grimm, for your testimony, and appreciate your passionate advocacy for the bill. And full disclosure, My dad, about 50 years ago, was a shop steward in what was then called the Newspaper Guild, different, not at the Hartford Chronicle. So are there comments or questions from members of the committee? If not, thank you very much for your testimony. Really appreciate it.
Thank you, folks. Appreciate it.
All right, next up we have Lauren LeClaire, followed by Chris Baxendale.
Great, thank you. Good evening, Senator Lesser, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Lauren LeClaire, and I'm an undergraduate student at Yale University. I'd first like to thank you all for your time and for allowing me to testify today. I know it's been a really long day for everyone. It's a pleasure to be here, and I'm honored to add my voice to the support for House Bill 6622, an act concerning prescription drug formularies and lists of covered drugs. The currently authorized practice, commonly referred to as non-medical switching, affords undue power to insurance companies, and it puts our state's most vulnerable citizens at risk. Countless citizens of Connecticut rely on constant and consistent access to their medications. As if living with illness and finding the correct treatment plan was not hard enough, members of our community are forced to live at the whims of the insurers. This practice results in stable patients being forced to switch medications or even to stop treatment due to these unanticipated costs. This issue isn't just theoretical. As drug prices continue to rise, more and more drugs are removed from coverage each year. In 2018, the citizens of Connecticut made their voices heard in an Alatrim survey, which reported 1/5 of residents find it difficult to afford prescriptions. And likewise, 20% made the incredibly difficult decision to either cut their dose in half or to not fill their prescriptions at all due to these cost concerns. As a New Haven resident, this bill hits close to home for me and my family as well. I have several friends and family members who rely on prescription drugs to survive, including my mother who recently battled breast cancer. Already tens of thousands of dollars in debt to various hospitals, my family would simply not be able to afford a cost-tier increase on her medicine, let alone know what to do if her prescriptions were removed entirely from a formulary. We need to value people like my mother, the brave folks who have submitted personal testimony, and the other citizens of Connecticut as we hold insurers accountable and end the bait and switch. Every member of our community deserves the right to health care, not just the rich or wealthy who can afford these mid-year price spikes. I ask the committee to please vote favorably on this crucial and necessary measure, and I thank you all for your time and consideration today.
Thank you very much, Lauren. Are there comments or questions from members of the committee? Well, thank you for your advocacy tonight. Is this the first time you've testified before the Connecticut General Assembly?
This is my first time, so thank you all for having me.
Terrific. You've done a great job. It's great to hear from you and great to see undergrads before us. Thank you. Take care.
Thank you so much.
Next up, we have Chris Baxendale. And then after Chris, I think we have Paula Rucker. We have a couple other people who are signed up between them, but they may have already gone.
Good evening. Senator Lesser, Representative Wood, Senator Wong, Representative Pavlik-D'Amato, and the members of the Insurance Real Estate Committee. My name is Chris Baxendale. I'm a licensed public adjuster and vice president of Connecticut Association of Public Insurance Adjusters, CAPIA. On behalf of our organization, I would like to offer comments regarding raised House Bill 6625, an act requiring the insurance commissioner to adopt regulations establishing continuing education requirements for public adjusters. We very much appreciate that you've raised this concept for hearing. This legislation is straightforward and designed to have regulations promulgated that establish the contours of continuing education program. The property and casualty sector of the insurance industry is complex and constantly changing. Continuing education should be required for public adjusters to stay current with the latest developments in policy change, law, technology, and importantly, ethics. We believe the public adjuster continuing education will benefit the Connecticut consumer. Our sister states, New York, Massachusetts, and Rhode Island, require 15 hours of continuing education for public adjusters every 2-year license term. In Massachusetts and Rhode Island, public adjusters continuing education is industry self-monitoring with no fiscal burden to the Department of Insurance. Every year, the CAPIA Board of Directors meets with the Department of Insurance. We repeatedly hear from the Department of Insurance the #1 complaint they receive on public adjusters is they sign up a claim and they do not file a detailed claim in a timely manner. CAPIA members are held to a strict code of ethics and conduct that addresses this issue. We believe ethics training within the continuing education will address this issue with public adjusters that are repeat offenders. We look forward to discussing this issue with you in further more detail and would appreciate your support for House Bill 6625. I would be happy to answer any questions you might have.
Thank you very much. Appreciate your testimony. Have you had the opportunity to talk to the Department of Insurance about this proposal?
We have. We've talked about it in the past, yes.
And do you have a sense of where their position is currently? I noticed that he didn't testify one way or the other on the proposal today.
I don't. I think indifferent. I don't. They not know if it was needed or not. We really kind of wanted to stress the fact that it really kind of addresses the bad apples and the problems that they were having. That was the biggest complaint we met with them before, is that public adjusters would kind of disappear. Certain public adjusters would kind of disappear. So we think that this would address that issue.
Got it. Other comments or questions from members of the committee? If not, thank you very much for your testimony today.
Thank you very much.
And for everyone's patience, this is a long hearing. All right, thank you. Next up, we have actually Rebecca Lurie from, and then after Rebecca, we'll hear from Paula Rucker.
Hi, thank you for letting me speak. My name is Rebecca Lurie. I'm a reporter at the Hartford Courant and the union chair of the Hartford Courant Guild, which represents 43 journalists at the newspaper. And
Rebecca, I'm sorry, is your camera on? I don't know if we require it, but I don't think we're getting it. Oh, there you are. Go ahead, I'm sorry.
Can you hear me now?
Yes, we can.
Apologies, sorry. As you've heard today, this bill would protect the public interest from Alden Global Capital, the predatory hedge fund that is poised to take ownership of the Courant. Since last spring, our union has been campaigning to find new, responsible, and civic-minded ownership to rebuild our staff and redouble our commitment to journalism. We've seen tremendous support from the community, and this bill sends one of the strongest messages we've seen yet, that Connecticut is in this fight to preserve local news. I submitted written testimony about the deep cuts our newspaper has experienced in the last year alone, including the permanent closure of our newsroom, the outsourcing of our news printing operation to Massachusetts, and the loss of 151 printing press jobs. Since last January, the Courant has also lost 20 newsroom positions through buyouts and attrition, including the jobs of 2 investigative reporters and editors who directed coverage of community news, breaking news, the Hartford Magazine, our opinion page, and features. We can't let this be the new reality of the Hartford Courant, and we can't stand by while a bad actor like Alden moves in for the kill. So if any members of the committee have any questions, I'm happy to try to answer them. And if not, I thank you for your time.
Thank you, Rebecca. And I'll note that the publisher of the Courant has wrapped himself and his representatives have wrapped themselves in the First Amendment, arguing that this is an attempt to trample on it. I note that the reporters don't seem to share that view. Do you believe this is a good faith attempt to save local news? It sounds like you do, but I just think that that's been the concern that we've heard here today, is whether or not this is an attack on the First Amendment or attempt to do what the legislature, I think, has done before, and step into to charter the current company.
Yeah, the journalists at the Courant, represented by the union, have no concerns that this act would infringe on our rights as a free press. As you've said, I don't see anything here trying to sway our coverage. It wouldn't work anyway. And really see here just an attempt to stop the destruction of local news. And so that's where we stand.
Thank you. Other comments or questions from members of the committee? If not, thank you for your testimony tonight.
Thank
you. Next up, we have Paula Rucker, followed by Katie Talento. Ms. Rucker, are you there? Oh, I think we see you.
Here I am. I think I'm here.
You're
Thank
here.
you guys for taking the thank you guys for taking the time to hear me today. I appreciate your time and I apologize for any background noise. I've had to leave my quiet office as the building's closed. I'm here to talk to you today about supporting SB 1007, the weight loss surgery for the morbidly obese. I have been dealing with this a good part of my life, and only recently have I looked into the ability to potentially have the surgery and working with Dr. Aronow's office. It has been a battle, and I've heard many people testify today, a couple of the doctors making comment that insurance companies have commented to them to have their patients stop being lazy, to exercise, to eat better. And another doctor commented how this is not necessarily a lifestyle choice. This is not a choice I've made to be like this and to be heavy set in my life. I have worked aggressively, especially the last 2 years, spending money in treatments, counseling. I've been paying for private and semi-private training, going to counseling, taking the medication. We cannot get my diabetes in check. We've made progress, but medication alone, diet alone, and exercise is not doing it. Reaching out to my employer and working with Dr. Aronow, my employer and my insurance company have chosen to decide that they know what's best for me over my doctor and myself. The battle has not been easy, and by no means having the surgery is not the easy way out. Just starting this process, I've already been to 3 doctor's appointments, had an upper GI, continuing on with counseling. I have diabetes checks. I have meal plans to make, meals to track. I have dietitian consults to do. And the surgery itself, coming out of that surgery, is months of rehabilitating myself, training myself to do things differently. I don't know anyone that volunteers to go in for surgery. I'm not going in because I want to lose weight. I'm going in because I want to be healthy and I want to live to a decent age. I want to be able to play with my grandchildren when I have them. This is not an elective thing for me. I have reflux very badly. The medication is not controlling. And I honestly had my diabetes in check until the insurance company said, hey, guess what? The medication you're taking is no longer in the formulary. So now, unless I want to pay an outrageous amount for medication, I've switched meds. In the 3 months in which I've switched meds, my A1C has gone from close to a 7, which is still not perfect, but it's good, to an 8.3. So exercise.
You've reached your 3 minutes. If you could just summarize your testimony, please.
I will, thank you. Exercise 3 times a week, including core training and weight training and eating right and tracking my food and my calories. That is not enough for my situation. So I really, truly hope you take into consideration all of the testimony you've heard today. This is not about losing weight. This is about becoming healthy. And I just want to thank all of you for your time and your consideration and looking into this law and hopefully getting something passed for all of us.
Thank you, Paul, for your testimony and for your patience today. It's so important to people who will benefit from to really appreciate it and need a lot for us. Representative Dathan has a question for you, actually.
Okay.
Thank you so much, Paula, for sticking it through today. And thank you for sharing your testimony. It's really heartfelt, and it's good to hear from people like yourself who, have been exploring this and really explaining to the committee that this is not a, quick fix weight loss regime that you're looking at. This is a full-on life-changing thing that people don't go into lightly. I think one of the things that is important to me when we look at the surgery is the kind of follow-up and some of the things that you address that you need to do post-surgery to be successful. in your situation, if this was covered by your insurance, but the follow-up care and the some of the regime things that you talked about weren't covered, would that change your approach at doing the surgery, or would it change any outcomes for your continued focus on what you need to do post the surgery to ensure its success?
Honestly, I don't believe anything would change. I'm going to the gym now. I'm paying a lot of money for private and semi-private training, trying to work with them on my eating habits. You know, what do I do? When is the protein drink right? What should I be eating? What should I not be eating? What should I eat before working out so that I have the stamina to get through the workout? The surgery in itself is the most expensive part. After that, it's really what you learn through the process. From the first meeting with Dr. Aronow, which was great. You're not drinking soda, you're drinking smoothies with natural sugar. How about we get rid of that sugar too? The guidance of his office, and I'm going to tell you, I've been on a weight loss journey all my life, but I met with him for the very first time last Thursday. I since had a support group meeting. I did a upper GI yesterday. I am on a track and I am determined. The only thing that will hinder that is the ability to cover the cost of it. I can make protein shakes. I can do smoothies. I can log my food for the rest of my life. But if I can't get the surgery and the medicines aren't working, it all is a waste of my time. And that's what it comes down to. I'm looking at a potential surgery right after my vacation. Well, in order to be approved by the dietary staff, I need to maintain for 3 to 4 months a certain level of eating and weight loss and learning and developing my future lifestyle. I'm going to do that while I'm on vacation. So if that means that I can't drink that glass of wine at night by the fire pit, and that I'm eating veggies and everyone else is eating chips and dip, then I'll be eating veggies on vacation. I am dedicated to getting this done. I'm 52 years old and I need to and want to be able to watch my grandchildren grow, and I want to be able to play with them. And I want to be able to not go to counseling and be constantly trying to raise myself up, because there's a stigma with being heavy. There's a stigma with being obese. And while there are other reasons I go to counseling, my self-worth is a part of that. I don't need to be skinny. I need to be healthy.
I'm so glad that you're focused on the health aspect of it, because, you know, I do think, you know, you probably spend, your insurance company probably spends quite a bit of money every month for your medications, and you're paying a lot for the out-of-pocket. Do you have any idea about what your medication would cost on an out-of-pocket basis?
The return on investment, just so you know, I do payroll and I work very closely with our benefits department, and I help to analyze our benefits from year to year. So I have access to some of the numbers. I have done the return on investment of the surgery. My company will see a return on investment in 1.5 years. My meds will go from 12 a day to potentially 9 a day. One of the reasons we have heard from our broker to us, who obviously they're guiding us in what we should do as a provider and to our employees, there is no guarantee that weight loss surgery will work. There is no guarantee that a stomach bypass will work. Well, you know what? There is no guarantee that my uncle going in for a heart valve transplant is going to work. There's no guarantee that he's not going to need open heart surgery 2 years later. We're working in a medical field. We're working in a world where, quite honestly, everything is against us. I'm affording to do all these things like the personal training and stuff. And now I'm also looking to find the money to not only do the personal training and have someone guide me who's educated, but now how do I afford all that really healthy food and on top of it save for a surgery?
Yeah.
At some point we tap out the funds, the bank goes dry.
Well, I appreciate you giving that insight, and I think it's definitely food for thought for the committee. So thank you so much, Paula, for your testimony.
And I appreciate your time, and I have submitted my testimony in writing with my contact information. Senator Anwar, I know you represent the area that I live in, so if there's anything I can do or you'd like to have further conversations, I am an open book if it means that we're able to become a healthier society.
Great. Thank you so much for your testimony. Thank you, Mr. Chairman.
Thank you, Representative. Other questions or comments from members of the committee? If not, thank you, Paula, for your testimony.
Thank you very much. Have a great night.
You too. Next up, we have Katie Talento, followed by Joel Noble.
Hello, thank you very much. I want to thank you, co-chairs Lesser and Wood, and the members of the committee for having us here. I am Katie Talento, and I represent the Alliance of Healthcare Sharing Ministries. We represent or work directly with the majority of the large CMS certified ACA defined healthcare sharing ministries in operation across the United States. Alliance member ministries serve more than 1 million members nationwide and more than 5,000 Connecticut residents in managing their healthcare expenses, and they have been faithfully serving for decades. My colleague Brad Nail submitted our written testimony earlier today regarding Senate Bill 1041, and I commend that to your attention. With my oral testimony, I'd like to address some of the concerns I've heard today and answer any additional questions you may have. Senator Lesser, you've expressed skepticism about the fact that ministries do not make a promise to pay and do not transfer risk. We do live in an insurance world, and it's sometimes hard to relate to a non-insurance faith-based model. But for some members of faith communities, the approach we take in healthcare sharing ministries is a wholly familiar one. You know, these communities, they often come together and provide meals to families with newborns and like yours. And we do schooling together and homeschool co-ops. In the healthcare sharing ministry model, we're morally obligated similarly, but not contractually obligated to one another. That said, the Alliance does support requirements for legitimate healthcare sharing ministries, combined with the recognition that these religious charities are not insurance. Now, not all organizations claiming to be healthcare sharing ministries are in fact healthcare sharing ministries. The ACA definition reflects the value of having a long-standing record of faithfully serving members. And that's why one of the elements of that definition, the federal definition, is that these ministries must have been continuously sharing since 1999. All the bad actors that have been mentioned today, including for-profit entities that reportedly have marketed so-called healthcare sharing ministry memberships, they're new organizations. It does suggest some wisdom and foresight in the ACA definition. States that have a safe harbor for legitimate healthcare sharing ministries from the insurance code based around the ACA definition have still been able to robustly go after these bad actors and have certainly done so. Actual healthcare sharing ministries are upfront with consumers and transparently describe to consumers how they're not insurance and what to expect in order to prevent confusion. We support robust transparency with the public and with our members, including notification and disclosure requirements that have been adopted by many states with our endorsement. The Alliance condemns any and all fraudulent and misleading tactics in the marketplace, including those for-profit entities masquerading as healthcare sharing ministries. As I talk to policymakers and regulators around the country, they almost always cite complaints and court cases related to for-profit entities and the nonprofit groups that those for-profit entities' leaderships have reportedly, allegedly started.
Ms. Talento, you've reached your 3-minute mark. If you could just please summarize your testimony.
Great, thank you. We're a little bit worried about some of the wording in the bill, that it might be overbroad and put some of our practices out of business in terms of we use paid staff and paid third-party vendors to administer, to negotiate bills. Legitimate ministries do this, almost all of them. So in closing, I wanted to mention that all the ministries we represent do share bills for COVID testing and treatment. I know that came up earlier. And also that we are neutral on the issue of commissioned vendors and licensed agents. So I want to make that clear. Healthcare sharing ministries may not be a fit for everyone. but they should continue to be an option for Connecticut residents who prefer this as their healthcare solution, as they are for the residents of all the other states. We're looking forward to working with you to achieve your important policy goals on this matter. Thank you very much. Happy to answer questions.
Yes, thank you, Ms. Talento, and appreciate your testimony and for clarifying some of the things that we heard earlier. I appreciate your attempt to distinguish the not-for-profit ACA compatible ministries from other ministries. I would not completely sold on the argument, though, that the only bad actors are necessarily these post 1999 for-profits. I have a constituent, for example, who was paying, this was covered in the news, was paying $500 a month for her health sharing ministry, and it is a not-for-profit. And she went to get a COVID test and wound up getting stuck with a $270 bill because they simply refused to pay for the cost of the COVID test. You know, I guess I would feel more comfortable if this were only in one particular segment, but I haven't gotten that strong sense. I guess if I'm going to try to phrase this in the form of a question, we've heard from a lot of folks today who purchased these products or sent money, started a relationship with a ministry by their own words in search of a cheaper alternative to insurance. And so would you say that this is, I guess, where would the, you know, if folks are looking for this as an alternative to health insurance, at what point does it stop becoming an insurance product? What's the sort of the bright line that we can look at to distinguish this from, you know, something that would normally be regulated by the Department of Insurance?
That's a great question. So I think a key distinguishing feature is that there's no transfer of risk. We're not pooling funds and assuming that risk onto the pooled funds. We're not entering into a contractual arrangement. We, you know, our existence is around religious exercise. And so, you know, I think you're right in that some people come for the affordability and they stay for the faith. Some people come for the faith and they stay for the affordability. Most people are there for both and appreciate both very much so. So I wanted to address something about what you mentioned with respect to the nonprofit organizations. It is true. It appears to be true based on the court documents that I have read. So I am no expert in these other entities. But what I have read in these court documents is that there are for-profit entities that whose leadership reportedly, allegedly, start or establish or spin off a nonprofit entity that they market allegedly as a healthcare sharing ministry. And so we would just argue these are not healthcare sharing ministries. One of the best ways to know if an organization is a legitimate healthcare sharing ministry is if they have a determination letter by the Centers for Medicare and Medicaid Services. They meet, you know, nothing is perfect. This process of getting a letter was never perfect, but you know, it does show that you meet the federal definition, and that is one effective differentiator.
Got it. Can just at the risk of putting one company on the spot, are you familiar with the Alliance for Shared Health?
I am somewhat familiar with reports about the Alliance for Shared Health. Yes.
Do you consider them to be a legitimate or an illegitimate health sharing ministry?
So I can't comment on whether they are or not. I do not believe that they would meet the ACA definition, but I don't want to speak for them. And they're certainly not a member of the Alliance of Healthcare Sharing Ministries. I do not believe that they're on the list of healthcare sharing ministries that have received CMS determination from the federal government.
Got it. Okay. Very helpful. Thank you very much.
Thank you.
Other comments, questions from members of the committee? If not, thank you. Next up, we will have Joel Noble, followed by Rory Wheeler.
Madam Chair, Mr. Chairman, and members of the committee, my name is Joel Noble, and I'm testifying on Senate Bill 1041, an act concerning healthcare sharing plans and healthcare sharing ministries. I'm here representing Samaritan Ministries, a founding member of the Alliance of Healthcare Sharing Ministries, and one of the largest sharing ministries among the over 1.5 million Americans using healthcare sharing. I've been blessed to have been serving with Samaritan in the healthcare sharing industry for nearly 20 years. For over 26 years, Samaritan Ministries has been serving its members as Christians bear one another's burdens through healthcare sharing, and that includes hundreds of individuals in Connecticut. We have over 280,000 members nationwide, and our members have shared over $2.3 billion for medical bills in our history. Congress recognized the value of this non-insurance approach to meeting medical expenses by granting members of healthcare sharing ministries an exemption from the ACA's insurance mandate. To our knowledge, no member of Samaritan Ministries has ever made a complaint to the Connecticut Department of Insurance, nor the Department of Insurance or any regulatory agency or consumer advocate in any state. However, in recent years, new sharing organizations have started and engaged in practices that concern those of us who have been operating healthcare sharing ministries for years. We applaud the sponsor's desire to prevent bad actors, including for-profit entities pretending to be healthcare sharing ministries, from tarnishing the important ministerial work we do. If the sponsor simply desires to prevent healthcare sharing ministries from using compensated or commissioned insurance producers, we would be supportive of that, as we believe that prohibition will not only help prevent consumer confusion, but prevent regulatory conflicts. However, SB 1041 goes far beyond that, and as written, would make operating any healthcare sharing ministry, including Samaritan Ministries, impossible to serve its Connecticut members, as it literally prohibits any person from receiving any compensation for participating in any aspect of the activities of healthcare sharing ministry. Section 2 of Senate Bill 1041 makes it unlawful for a healthcare sharing ministry to use paid staff to recruit or enroll members. It can be assumed that the DOI could interpret that drafted language of selling or soliciting as any activity relating to recruiting and enrolling members, including responding to an incoming phone call. Additionally, it makes it unlawful to use paid staff to administer a healthcare sharing plan. Since every staff member of every ministry is participating in the administration of a healthcare sharing ministry, Section 2 of Senate Bill 1041 would shut down every ministry in Connecticut as they currently operate in their form. Also, Section 2 affirmatively places healthcare sharing ministries under the insurance code. While healthcare sharing ministries engage in voluntary sharing and not contractual transfer of risk, they are not insurance. Healthcare sharing ministries are under the oversight and general regulation of both the IRS and attorneys general, since they are 501c3 charities. Healthcare sharing ministries, as ministries,
Mr. Noble, you've reached your 3-minute mark. If you wouldn't mind summarizing your testimony, thank you.
Thank you. So Section 2 does not use the term healthcare sharing ministry, but it broadly describes as coming within its prohibition an arrangement with the same charitable activities as healthcare sharing ministries. And in closing, I appreciate the opportunity to share our concerns with Senate Bill 1041 and look forward to working with the sponsor to fix the bill in a way that provides consumer protection while still protecting the ministries. I appreciate your time, and I'd be happy to answer any questions about Samaritan Ministries or healthcare sharing in general.
Thank you for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you very much for your time. Next up, we have Rory Whelan, followed by, I believe, Jim Yakubov.
Good evening, Senator and members of the committee. Thank you very much for this opportunity. I have submitted written testimony, so I assure you I'll be brief. My name is Rory Whalen. I'm the Regional Vice President of Government Affairs for the National Association of Mutual Insurance Companies, otherwise known as NAMIC. I would like to comment firstly on Raise Bill 1042. I don't think this is, I agree with the previous speakers who rightfully posited that a properly trained, properly resourced fire system, fire teams, is really a societal good. And therefore, that is something that the legislature ought to commit to in the annual budget process. I'd also say that, you know, the insured's property policy protects his or her financial security, but it also protects employees, customers, neighbors, etc. I think a better way to look at if you're not going the route where you want to enhance other ways of funding, is to look at the causes of fires. So why not put a surcharge on chemicals? Why not put a surcharge on heating equipment, electrical wiring? These are the main causes. I won't go down the line of Christmas trees and candles, but again, those are on the top 10 list of the causes of fires. I think when we think about a $7 surcharge for something that will necessarily, the cost of this equipment and training will increase year after year. So it won't be long before we're back here talking about a bill that increases it to $15, $25, $50. And then I will speak very quickly on the Raise Bill 1047 regarding climate change reporting mandates. NAMIC agrees climate change does affect the insurance industry, but I cannot understand why in this bill we are singled out amongst all of the other regulated industries that are affected by climate change. And I would reject the idea that insurance should stand alone in this type of reporting. And with that, I'm happy to take questions. But very quickly, I'll echo previous comments. Raise Bill 1044. I'm not sure if that's a task force charged with healthcare insurance, but if it is property and casualty, I would request an amendment to have industry representatives on that task force. Thank you very much.
Thank you, Mr. Whalen. And I think with respect to the last one, that is what is known in this building, at least, or the building we're virtually in, as a dummy bill. I don't know that too much.
Right.
Just with respect to your testimony on the climate change initiative, obviously, this committee oversees the Connecticut Department of Insurance, which oversees insurers, and I guess the bail bonds industry. We're not aware that the bail bonds industry is a major player in climate change. So if you were going to rope in, if we were to rope in other industries, I guess I'm trying to figure out what you're suggesting specifically.
Well, I mean, I would leave that to the legislature to decide, but it also presupposes that all insurers are the same, and they're very different in terms of their size, their geography, their investment strategies, and I don't think it would be an appropriate measure.
And am I sort of to read into your comments that you don't support the work of the NAIC on climate risk disclosure?
I think the work that they have done, it has been 10 years or so, and we are, members are cooperating and contributing, and I think that is the better, a national focus is the better route to go, whether that's through the NAIC or NICOIL or NCOIL for some model legislation.
Well, I think we're going to likely work with both organizations, but you had sort of indicated that you didn't think this was a specific issue for the insurance industry, so that's why.
Agreed. To be singled out, no, I don't think so. I don't think it's the proper place to start.
Well, I think we might respectfully disagree on that one, but I appreciate your testimony and would invite any comments or questions from members of the committee. If not, thank you for your testimony.
Thank you.
Next up, we have Jim Yacobellis, followed by Jennifer Violette.
Good evening, Senator Lesser and members of the Insurance and Real Estate Committee. My name is Jim Yacobellis. I'm the Senior Vice President of Government Relations at the Connecticut Hospital Association. It's my pleasure to be here this evening to testify on Senate Bill 1048, an act concerning reimbursements for certain covered health benefits. Before I get into my testimony, I just want to take a minute here and praise and applaud the hard work of all the healthcare professionals who have been working extraordinarily hard for the last year. As I like to say, they've been operating at a sprint, but really for the length of a marathon. And their hard work and dedication is something that we applaud, something that we are proud of, and something that we admire. Now I'd like to turn to Senate Bill 1048, which does two things. I've submitted more detailed testimony, but I'm just going to summarize it. It does two things. The first thing it does is it asks the Department of Insurance to set rates for A&M and E&M codes and drug infusion codes. So a form of rate setting for those types of services. Secondly, it asks the Department of Insurance, when it is doing its rate setting, to do it on a site neutral way. What that means is they will take the site out of their calculation, and notwithstanding whatever site the services performed at, whether a physician office, a provider-based facility, urgent care center, or ambulatory service center, it will be the same reimbursement. We are opposed to the rate setting aspect of this. When the state or federal government set rates, for example, in the Medicaid and Medicare program, as you've heard for years, they do not cover the cost of those services. Secondly, we are opposed to the site neutral aspect of the bill. We believe that the site neutral aspect is one that is problematic. For years, we have come in front of this committee and testified with concerns over site neutral proposals. And one of the things that we've talked about are the responsibilities that hospitals have in emergencies and emergency preparedness. And I think I can more easily simply describe what hospitals have been doing since March of 2020. We have been a critical foundational partner with the state of Connecticut in fighting this pandemic. We have expanded facilities, we have expanded capacities, we have created alternate care sites, we have set up countless COVID-19 testing facilities, and now we are a key component of the state vaccination program. This is different than any other healthcare setting, and reimbursement should recognize that. I thank you for my comments, and I'm happy to answer any questions.
Thank you, Jim, for your testimony. Are there comments or questions from members of the committee? If not, we let you off easy tonight.
Thank you. Everybody have a good night, and thank you for putting in all the time on this hearing today.
Thank you. You take care. Next up, we have Jennifer Violette, followed by Bonnie Hall.
Good evening, members of the Insurance and Real Estate Committee. My name is Jennifer Violette, and I'm here to show my support for House Bill number 6626, specifically for sections 3, 4, 16, and 17, which would seek to require insurance coverage for cochlear implant surgery, as well as the associated audiologic care. I will refer you to my written testimony pertaining to the facts and figures of hearing loss, as well as the cost effectiveness of treating hearing loss. Insurance companies provide stringent guidelines for determining medical necessity for cochlear implant surgery. One area where we see this pertains to single-sided deaf patients. I personally have experience with this scenario as I have a son who is single-sided deaf. He was diagnosed at the age of 2 with a mild hearing loss and was treated with a hearing aid. A year later, on his audiologic testing, it was determined that his hearing had degraded from a mild to a profound loss, thus rendering a hearing aid ineffective. Our only viable treatment option at that point was to pursue cochlear implant surgery. My husband and I traveled down to NYU to pursue cochlear implant surgery for him. He was deemed a good surgical candidate. However, our health insurance determined that this was not a medically necessary procedure. I worked over a period of several months with the surgical coordinator to try to overturn this decision. Finally, our insurance did overturn their decision just 2 days prior to his scheduled surgery. The surgery has dramatically changed his life. He went from being able to hear only a third of what is said on his affected side in a noisy environment to now, with the use of his processor, being able to hear over 80%. My son's experience has also helped me become acquainted with other parents of single-sided deaf children who have not been as fortunate as my family. The reasons cited for their health insurance is not approving their surgeries include age restrictions, the surgery being viewed as experimental, and the lack of medical necessity. There is a growing body of literature, however, that shows that there is a benefit to cochlear implant surgery in single-sided deaf patients. And in 2019, Medel's cochlear implant was approved for single-sided deaf and asymmetric hearing loss. Access to sound is not something that should be an option. It is a basic life function that is necessary to navigate the world and to communicate with others. This proposed bill can help the hearing impaired access the world through sound and dramatically improve their quality of life. Thank you for your consideration.
Thank you for your testimony tonight, and I'm glad to hear that your husband is doing well and that you were able to get it covered. Other questions from members of the committee?
Thank you, Jennifer. Thanks so much for coming out tonight. Next up, we have Bonnie Hall, followed by Arthur Helmuth. Is Bonnie here? Hey, Bonnie, I can see you talking. If you just unmute, we can hear you. Thank you.
Good evening, Chairman and members. My name is Bonnie Hall, and I'm from Westbrook, Connecticut, and I fully support Senate Bill 1007. I believe this bill would be a life-saving and/or life-extending opportunity for many people. I was morbidly obese and suffered from diabetes, high blood pressure, high cholesterol, and gastro reflux. I went to a presentation by Dr. Jonathan Aronow of Middlesex Health, where for the first time I had hope that there was a way to reverse my diabetes. Over the next several months, I went for a number of tests, and the results of all these tests were forwarded to my insurance company. My insurance policy did not include coverage for gastric bypass. I feel that the insurance company would be better served to cover this procedure rather than pay for a lifetime of complications from diabetes, heart disease, reflux problems, and associated obesity health problems. Dr. Aronow confirmed that my test results showed that I was an ideal candidate for gastric bypass, probably eliminating my diabetes, hypertension, and reflux problems. All supporting documentation was sent to my insurance company, and they denied and subsequently denied an appeal. My last resort, other than to pay out of pocket $25,000, was to appeal to the Connecticut Insurance Commission. The Connecticut Insurance Commission forwarded my case to an independent out-of-state third party for review. My appeal was supported by the findings of the third party, and the Connecticut Insurance Commission directed my insurance company to pay for the procedure. As a small business owner, I pay 100% of my insurance premiums, which is $1,800 per month for my husband and myself, for a $7,500 per person deductible policy. It would be virtually impossible for me to pay for this surgery out of pocket. I would have been relegated to a life of living with diabetes and hypertension, which was devastating for me as I watched my father suffer from diabetes for 35 years, his eyesight, suffering a heart attack and a stroke, and enduring amputations. Today, after 7 months after my surgery, I am free of all medications. I do not have diabetes. I do not have hypertension. I do not have high cholesterol, and I do not have reflux. I have lost 103 pounds, and I've gained amazing health. I wholeheartedly support this bill, and I thank you for your support as well.
Bonnie, thanks so much for coming and sharing the story, and congratulations on this journey. You should be really proud. Yep.
Thank you.
Do we have any questions from the committee? Great, Bonnie, have a wonderful night. Thank you.
You too. Thank you.
Arthur Helmus, Richard Riddle.
Good evening. Thank you, Representative Wood and Senator Lesser, and members of the Insurance and Real Estate Committee. I'm Richard Riddle, a dentist practicing in Connecticut since 1984. I've submitted written testimony, which you can read, but I will simply hit the high points in deference to your time. I'm currently the co-chair of the CSDA's Legislative Council. In that role, I'm tasked with helping or leading a group of volunteer dentists. We're trying to help our colleagues help their patients. This bill, House Bill 6589, which I support, so graciously put forward by Representative Candelora and co-sponsored by Senator Anwar, is designed to create transparency for our patients and help them avoid surprises. My colleagues, Dr. Lee and Dr. Yu, have already testified that this bill would basically specify the circumstances and the concerns about network leasing of dental plans. The key points in this bill are that it creates transparency for the patient. This legislation has passed in 20 states with similar language. We submitted the language endorsed by NCOIL, the National Council on Insurance Legislators, in its December 2020 meeting, and Delta Dental of New Jersey and Connecticut supported this bill when it was presented in New Jersey. The way this affects our patients is as follows. A patient presents with a broken tooth. We try to determine their coverage. They've presented a card with whom we have an agreement. We give a ballpark estimate of what will be needed to get them out of pain. We proceed with treatment, and it turns out the card they presented was that of a leased network, one with which we didn't even know we had an agreement. The coverage is not as favorable to the patient, and now we have a rift or a break of the doctor-patient relationship through no fault of the doctor or patient, but due to the lack of transparency on the part of the third-party carrier. The trust is broken and difficult to retrieve. The patient has had a big surprise, as has the doctor. This year, more than ever, this legislative session is trying to address the issue of transparency. I've been listening to this, and so many of the issues brought up before you today have to deal with transparency and making sure there are no surprises. And basically, I would like to say that we are willing to work with you in any way possible. And we even have more ideas on how to achieve the transparency. More importantly, I'm just thankful you took the time and are still here after all this time today. Thank you. If you have any questions, I'm happy to stay on and answer them. Thank you again.
Thanks, Richard, and thanks for taking your time to wait with us all day. Senator Anwar.
Thank you, Madam Chair. Thank you, Dr. Riddle, for your testimony. And we are hoping that this would be a common sense law. It's complex to understand, but it's pretty straightforward that the people who are providing the care are not getting paid, and the ones who are receiving the care actually end up paying more than they should. And this is because of some things that we can at least legislatively fix. So I thought I'd just thank you for your testimony.
Thank you so much, Dr. Anwar. We appreciate all the efforts that you've been doing on transparency.
Great. Next up, we have Thomas Burr, followed by Jonathan Aronow.
Yes, good evening, Representative Wood, Senator Lesser, and members of the Insurance and Real Estate Committee. As the Community and Affiliate Relations Manager of the Connecticut State Office of the National Alliance on Mental Illness, also known as NAMI Connecticut, I am testifying today regarding SB 1045, an act concerning step therapy, adverse determination and utilization reviews, and health insurance coverage for children, stepchildren, and other dependent children. Before I get into my testimony, I just want to say that I appreciate and echo Senator Looney's earlier comments this morning. And yes, I've been in and out listening to this all day. His testimony on SB 1045 as it relates to step therapy and the doctor-patient relationship and creating the presumption that treatment as ordered by a physician is medically necessary. NAMI Connecticut members know all too well that getting on the right medication regimen can be a long and challenging process, but getting the right medication is often what makes the difference between disability and stability. New advances in medications and their combination with other services and supports allows people with mental health conditions to lead healthy and productive lives. Psychiatric medications are not interchangeable, and providers must be able to select the most appropriate clinically indicated medication for their patients. While psychiatric medications may have similar effectiveness overall, they are unique in their mechanisms of action and affect each person and range of symptoms differently. Patients respond differently to different medications, and it often requires multiple trials and many months, if not years, to find an appropriate drug regimen to stabilize a person's condition. According to the NIMH, individuals have unique responses to psychiatric medications and need more, not fewer, choices. For people with serious and persistent mental illness or those with comorbid conditions, providers must be able to select from a full range of drug options to maximize treatment efficacy, minimize side effects, and avoid drug-to-drug interactions. Access to the full spectrum of psychiatric medications is an essential component of community-based care. Advances in medication and other services have enabled the care and treatment of serious mental illness to take place in the community, leading to a decreased reliance on inpatient facilities. Community-based services are less expensive for the state and its taxpayers than institutional care. People with a mental health condition who can't access the most appropriate, clinically indicated psychiatric medication experience higher rates of ER visits, hospitalizations, and utilization of other health services. Policies restricting access to medications have been shown in a variety of published studies to cause increases in hospitalizations, lengthier hospital stays, more emergency room visits, more outpatient hospital visits, and more physician visits. A study by Joyce West, PhD in general hospital psychiatry, analyzed Medicaid data from 10 states and found that psychiatric patients who reported problems with access to their medication visited the emergency department 74% more often than those who had no difficulties accessing medications. I'm sorry?
Your time is up. If you could please summarize.
Sure. So anyway, to summarize, these findings highlight the reasons why people with mental illness need to access a full array of treatment options to achieve the best health outcomes in a cost-effective manner. Attached to my testimony is documentation that lays out the business case with references and citations as to why step therapy is often harmful to patients and does not result in any net savings to either the state of Connecticut or any health insurance provider. So as far as we're concerned, NAMI Connecticut and our members are fully supportive of the elimination of step therapy for mental health and behavioral health conditions as outlined in Senate Bill 1045. So thank you so much for taking the time. It's been a long day, I know, and I appreciate your time and attention, and I will gladly answer any questions you might have.
Thanks, Thomas. Any questions from the committee? Senator Lesser?
Yeah, real quick, I actually have a question about a bill you did not testify on. And thank you for your testimony tonight. 6626 has a provision, at least maybe you did testify and I missed it, but
No.
About problem gambling. Is that already covered by our state's parity laws? That was a question I had about 12 hours ago, and I don't know if I got a clear answer to that.
You know, I don't know, to be honest with you, but can I get back to you? That was 6662, you said?
I think it's 6626. That's a giant mandate bill that covers a whole bunch of different things, but there's a section of it that.
Hey, y'all have a video or something?
All right, I'll look at that and I'll send you an email, Senator. I don't know off the top of my head.
Great, thank you.
Thomas, thanks for joining us. Have a great night.
Thank you.
Next up, we have Jonathan Aronow, followed by Evelise Correa. Jonathan, you're on mute.
That'll help. Thank you, members of the committee, for this opportunity to speak to you in support of SB 1007 regarding the health insurance coverage for obesity treatments. First off, I got to say, Senator Lesser, you've got the cutest baby ever. So let me dive in onto the factual stuff that I'm here to present. As I said, my name is Jonathan Aronow. I've been practicing bariatric surgery for 22 years at Middlesex Health, and I'm the director of their medical and surgical weight loss program. This is actually my 5th time testifying before this committee in an effort to obtain individuals access to bariatric surgery. This has been a recurring effort since 2006 and 2007, when legislation at that time was sponsored by Senator Joe Crisco and also then State Representative Chris Murphy, who both sponsored similar bills. In light of the testimony you've already heard through this very long day, I'll focus my testimony on Connecticut population data as well as cost effectiveness data regarding this proposed legislation. And I'd encourage you to review my written testimony for details regarding the literature and statistics that I reference. Currently, surgical weight loss is endorsed as life-saving and life-preserving by all major medical societies. Since 2006, Medicare and Medicaid have continued to cover bariatric surgery. In addition, large group employers can currently purchase a rider for bariatric coverage from third-party insurers. State employees and most municipal employees also have coverage. Many large self-insured businesses also carry the healthcare rider. Despite overwhelming evidence supporting these procedures, in this state, as opposed to every other state in the Northeast, bariatric surgery is excluded from the general policies of all private party insurers, including the index policies for the Affordable Care Act. Therefore, no self-insured individual or small group employer has access to bariatric surgical coverage, and as a result, there is a significant inequity to the access to these proven therapies, as my patient Bonnie Hall just spoke about. In my written testimony, I abstract data from recent published population data, employment statistics, and CDC data to determine that half of those individuals in our state with severe obesity have no covered treatment options. That's between 179,000 to 215,000 constituents that do not have insurance coverage for these proven treatments. This number is consistent with the 30 to 50% of patients that my colleagues and I are forced to turn away due to policy exclusions. Of note, current statewide surgical volumes per year hovered around 3,000 procedures annually. If a mandate were enacted, I'd project an increase in volume by an additional 1,000 to 3,000 cases per year. In regards to the cost effectiveness of these procedures, compared to healthy weight individuals, those suffering from obesity have substantially higher healthcare costs, prescription costs, and primary care costs. Obesity raises annual medical costs by over $2,741 per year. Lifetime medical costs.
Doctor, if you could just wrap up your testimony, you've reached your limit. Thank you.
Okay. I'll come back to the cost savings data with questions and answers. The bottom line of the cost savings is that after an initial buy-in, in about 5 to 7 years, we could be seeing $9 to $12 million of annual reduction in healthcare costs by eliminating obesity-related illnesses. And I'd like to highlight just 2 quick studies related to my testimony. New England Journal of Medicine published a large population study of 4,000 individuals, half of which underwent weight loss surgery and half were managed non-surgically. 16 years after the start of the study, there were 30% more deaths in the group that didn't receive surgery. And another paper I referenced in the study looked at the survival when insurance-related issues delayed or prevented access to surgical care. Over a 10-year span, they found a 3-fold increase in mortality in individuals who could not obtain surgical access. So the question I really want to ask today is not what is the cost of covering these procedures, but what is the cost if we do not? And again, I thank you for your time and patience for this very long day.
Yes, it has been a very long day, and we appreciate you sticking around to give your testimony for so long. Do we have any questions from the committee? Thank you very much for your testimony. I look forward to reading it as well. Evilise Correa, followed by Gregory Allard.
Okay, are you guys able to hear me?
Yes, we can hear you.
Okay, yes, I'm actually at a demonstration against HB 6462, but I am testifying in favor of SB 1045 and SB 1043. I believe it is a waste of time to have a doctor order medication or exam just for the next step to be to go to the next provider, to then go to the insurance who wants to re-verify what the doctor already ordered. Medical experimentation is basically what it is, at a cost savings that can cause schizophrenic breaks. It can, delay necessary treatment. And, people don't have time to sit there and play with different types of insulin or asthma medications. If something works, it works. Also, in regard to SB 1043, it is the Hartford Courant is the nation's oldest continually published newspaper and a historical symbol right here in Connecticut. It's older than the United States itself. In a time where there's been increasing mistrust of national news, local news outlets, according to studies and polls, are already more trusted than national news outlets. The Alden Global Capital is already responsible for job losses in Hartford by outsourcing printing to Springfield and laying off 1/3 of its reporting staff. The last thing we need during an economic recovery is more job losses and a less informed population. Also, in regards to HB 6622 and SB 1045, patient benefit managers, according to studies, drive up costs. Someone has to pay for a pharmacy benefit manager, and they do determine which pharmacies will be included in prescription plans and what they're willing to pay. So they're not able to really toss off the blame to pharmacies because they select the pharmacies based on price and what they negotiate with them. So,
Evelise, thank you so much for your testimony. Let's open it up, questions from the committee. Great, thank you so much for hanging out with us. It seems like you're very busy, so thank you. We appreciate it.
Oh, definitely. Very much.
Thank you. Next up, we have Gregory Allard, followed by Donna Pepe.
Good evening, Senator Lester, Representative Wood, and members of the Insurance and Real Estate Committee. My name is Greg Allard, and I am the president of the Association of Connecticut Ambulance Providers and the vice president of American Ambulance Service in Norwich. Thank you for the opportunity and all of your time throughout the day today. I have only been checking in. I can only imagine being part of the hearing as long as you have. My testimony today is regarding House Bill 6626. Our association supports sections 22 and 23 of this bill with a suggested amendment, but would oppose section 27 of the legislation. Sections 22 and 23 of the bill contains a requirement that medically necessary ambulance transportation be covered. However, due to the undefined nature of in-network level of cost sharing and what that means, we would request that be changed to the maximum allowable rate established pursuant to section 19A-177 of the general statutes. Connecticut already has rate protections in place that 48 other states do not. The Department of Public Health sets ambulance rates on an annual basis for us. We need to submit reports showing our costs and incomes, and from that, a fair and equitable rate is determined. We say that we're a controlled utility in that, much like other utilities whose rates are established by a governing body, EMS services need to justify ourselves by sharing a type of balance sheet application in order to get a rate increase. No application, no increase. Optimally, we would like the insurers to recognize this process in Connecticut and that it exists and that they pay the established rates and not try to negotiate reasonable and necessary rates, whatever they are. With regards to section 27, we oppose the language as drafted in subsection C2, which would require EMS providers to disclose potential costs to patients prior to transportation and receive written consent from these patients to provide such transportation. This is problematic for a variety of reasons. An EMS service who is a primary service area holder has an obligation to respond to all calls received through the emergency 911 system. It is difficult to know prior to a 911 response whether it will be classified as an emergency transport. We find that there are many people who believe that they call 911, the cost will be covered by the insurer. Unfortunately, that's simply not true. It is also highly likely that this provision would cause delays in hospital discharges, as it would require all non-emergency ambulance transports to obtain written consent. This would become burdensome for all hospital discharges, nursing homes, or other healthcare settings. Further, this could also negatively impact underinsured or uninsured individuals who may not have access to non-emergency medical necessary transports from the hospital. These individuals may just simply opt out for medically necessary transport due to costs. Ultimately, this will delay transport and care for many people in Connecticut. We urge you to amend sections 22 and 23 of the bill and strike section 27 from the bill. Thank you for the opportunity to provide this testimony, and I would encourage you to read my and my colleague Bruce Baxter's written testimony. Thank you.
Thank you, Gregory. We have a question from Representative Comey.
Sorry, signed off and I had to remember how to do it. Good to see you. Thanks, Gregory. So I had a couple constituents, and maybe there's another way to go around this sort of issue that we're not seeing. you know, the non-emergency transportation that the ambulance services provide, some constituents of mine have said that they were not aware of the charges they were trying to get from, you know, one long-term care facility to another facility or home or something like that, and the referral was to take an ambulance, and then of course they received that this was available to them, and then they received the bill at a later time and were shocked. Is there a better way to make sure that people understand that your services would not be covered under their insurance policies, and that perhaps there are better ways to get, say, a wheelchair from point A to point B, or if you're bedridden, things like that? I guess I'm trying to do a little, you know, deconstructing what the real issue is here.
Sure, and I think it's an educational piece on a lot of people's part. I think it's part the insured themselves understanding their policies and what's part of their policy, what's covered. It's part of the insurance company providing that education to that person. I think it's an understanding of, on the hospital's part, what that person's coverage is before they start making the call to us to figure out what that is. Typically, we're offering the service or doing the service and then figuring out what their insurance is after the fact. So we don't know ahead of time, typically, what their policy covers or whatever. We may get an insurance company name and an ID number or something like that in order to be able to bill the patient from the hospital, but we don't particularly know what their coverage is prior to. In some cases, we do get prior authorizations, but that doesn't necessarily mean just because we have the prior authorization number that we're going to get authorization after the transportation is put into place. So it is a very complex issue, and certainly be willing to sit at a table and have conversations with whomever to try and figure out the best process through all of that.
Representative Comey, are you done?
I'm sorry, again, unmuted. Yes, thank you. Okay, I appreciate the input and your willingness to work with us on that. Thank you.
Thank you. Gregory, thanks for staying with us late tonight. We appreciate it.
Yeah, no problem. Thank you. Good luck.
Thank you. Next up, we have Donna Pepe, followed by Adam Marchand.
Hi, can you hear me?
We can hear you. We just can't see you.
Yeah, unfortunately, starting the video, it says here, Zoom access your camera. I got to go into settings, but I would like to do a verbal if I can, just so I can get through this. I want to thank everybody for the opportunity to offer my support for Senate Bill 1007. My name is Donna Pepe, and I'm a Connecticut resident. I am a 52-year-old business owner, and I have been denied coverage for gastric bypass. I'm fortunate to be able to afford bariatric surgery, but there's so many people who cannot. Passing this bill will help so many that need bariatric surgery due to obesity issues and comorbidities. I would like to add that my mother died at the age of 65, weighing in at 400 pounds in 2005. If she was given this option, she may still be with us today. So I'm speaking for those who cannot afford this life-saving surgery. In 2008, I shattered my L1 vertebrae while horseback riding and needed spinal fusion. Prior to this accident, I was quite active, but I gained a tremendous amount of weight, and exercising always set me back. In 2017, I decided to get the gastric sleeve. I was denied by my insurance, so I paid out of pocket. I lost 75 pounds, but soon thereafter, I developed disc degenerative disease below my spinal fusion. As you may know, chronic pain can make even the simplest task hard to endure, let alone exercising. I've had numerous chiropractor visits, lumbar injections, and even an epidural. Nothing really seemed to help. I'm currently investigating alternative options to relieve the pain, such as spinal cord stimulation, but I've been told that an additional spinal fusion may be the best option. Needless to say, the constant lumbar pain has decreased my physical activity, and then my knee replacement slowed me down even more. In addition, I developed severe acid reflux and was told a small hernia has formed above the sleeve. I contacted my bariatric surgeon. He said the best solution to relieve the acid reflux and the hernia is gastric bypass. My insurance denied me immediately due to the exclusion in my policy. They would not even give us a case number. After several days of calling and speaking to numerous people at my insurance provider, I finally reached somebody who gave me the chance to submit my clinical data. I felt that if they heard my medical background, they would agree that the surgery would reduce, if not eliminate, future surgeries, etc., and save them money in the long run. They denied me again. I am currently in the appeal stage awaiting their response. I guess I don't give up too easily. I will find out soon what the appeal response will be, but I am prepared to pay out of pocket again because I know that it would eliminate a lot of health issues that could worsen if I did not get this surgery. Without the surgery, in time, I could very well become a burden to my family, increase my dependence on my insurance. Again, many others are not fortunate as I am. They will continue to suffer from comorbidities because they're unable to afford the surgery. Here are a few important benefits of the surgery for me and maybe others. Weight loss would decrease the tremendous daily back pain and eliminate possible future spinal fusion. It would eliminate acid reflux that without treatment could cause severe damage to my throat or worse, cancer. The medication that I take for the acid reflux could very well cause cancer as well. This is what I was told by my primary care doctor. Above all else, gastric bypass would provide me the healthy, active, independent life that I desire. My biggest inspiration is my 83-year-old father who is active, healthy, and thriving. And there is no doubt that with this gastric bypass that I could change my life, I could live a healthy life, and I can live past my mother at the age of 65. So there's no doubt that bariatric surgery could give somebody a second chance to live a healthy life and maybe even save their life. Please pass Bill 1007. Thank you for your time. Any questions?
Donna, thank you so much for your testimony and sharing your story. It really does help us hear it. So I want to thank you. Any questions from the committee? Great, Donna, thank you. Have a wonderful night.
Thank you.
Next up, we have Adam Marchand. Do we have any other people wishing to testify? And any comments from the committee? We'll be looking to have meetings next week, potentially Monday and Wednesday, and those will be posted this Friday. With that, I want to thank the staff for hanging out with us so long. Thank you to the committee members for great questions. And do we have a motion to adjourn?
And make a motion to adjourn. Sure.
Motion made by Representative Comey. Do we have a second?
I'll second it because I want to go with her on a journey.
All those in favor?
Aye.
Aye. Opposed? And we are adjourned. Thank you. Have a wonderful night, everybody.
Thank you. Have a great night.